don't know. And I would like to speak 2 words about NIMA and how and when we were formed and what is the exact role of integration and what is the exact role of National Integrated Medical Association. Right from the Vedic era, that is 5000 years BC, Indian systems of medicine, mainly Ayurveda, has been mainstay of native medicine in India. We all know this, correct? In the 18th century, British people came to India under the name of East India Company. British people brought Western medicine to India. They established allopathic medical colleges in various parts of India. We Indians realized the urgent need for preservation of national socio-cultural heritage, including Ayurveda. And from there stemmed that we have to nurture, that we have to protect Ayurveda and everything which is having origin from India. From there the concept of nurturing Ayurveda and everything related to India started. Many national leaders like Pandit Jawaharlal Nehru, Moraji Desai, Mahatma Gandhi ji has also supported integration. So whatever we are doing today at NIMA, the pioneers or from where it has stemmed, it has actually stemmed from the time when India was ruled by the British. Today we are practicing in our OPD. We have a routine, correct? And we have forgotten that all these things which are easily available to us, but these are the continuous efforts of the people who have made it possible for us. And that is the exact aim of National Integrated Medical Association, to preserve our rights so that we can practice without fear, so that there are no medico-legal problems, so that the judiciary system and all the laws and reforms, those are also done correctly. We will start with the Ganesh Puja in 2-3 minutes. Okay? I request all delegates to be seated. I will continue with my talk on integration. So there is also a landmark judgment case. Okay? I would like to tell about that. Nowadays, I'll tell you one thing before that. Ki whenever we are practicing normally, until the time we don't have any complications, till the time everything is going smoothly, we never think about, integration, association, what all these things mean, correct? But when something arises, some medico-legal complication arises, or someone says that you can't do this, you can't do that, at that time we feel that we are lonely, we are alone. And we don't have any knowledge of the law or what is in our favor, what is not in our favor. That is where NIMA comes in. If you're already associated with the National Integrated Medical Association, you are aware of all these things. You know that you are not alone. If anything arises, there is a team of people who are behind you. I would like to tell you one thing, that National Integrated Medical Association is not there only in Mumbai. We have multiple branches. We have branches in each and every state, and we have branches outside India also. We as Ayurvedic doctors, we should be aware of all these things, because when we are in practice, we need to know all these things. We cannot just, read and just do the OPD and come back home. At National Integrated Medical Association MDB branch, like today, we arrange conferences from time to time so that all of the people in our fraternity can update and upgrade their knowledge. That is the main motive, or I'll say the main aim behind attending these conferences or behind even organizing these conferences. So I would like to tell you about one landmark judgment, and then we will immediately start with the Ganesh Puja. So judgment of landmark Supreme Court case Mukhtiar Chand versus the state of Punjab and ORS in 1998. INSC 491 has also upheld the legality of Section 2 of Drugs and Cosmetic Rules 1945 and Government Notifications Order under the above said rule within the scope of power. This judgment supports integration. This is very important. We all should have details of these things, and if you don't have, you can reach out to any of our NIMA MDB members, and we would be happy to provide you such judgments, all the GR which you require in clinical practice. So this judgment supports integration and further says in concluding degrees in integrated courses is on the same plane. Integrated courses is on the same plane as much as if any state act recognizes their qualification as sufficient for registration in the state medical register. So when in our laws also it is there that we are at the same plane. So, and this definitely motivates us, and when we have this knowledge, it definitely does wonders when we practice. So this was a short intro which I wanted to tell about integration and National Integrated Medical Association. I hope you found it very insightful, and now we will start with the Ganesh Vandana, but for that I would like to invite all our managing committee members, subcommittee members, and obviously the conference committee members to be seated on the first and the second row of this auditorium. For the people coming now in the auditorium, I would like to tell them, kindly put your lucky draw receipts or tokens in the lucky draw boxes which are present at the back side of the auditorium. Kindly note this, because after the first lecture is done, we are going to start with the lucky draw. So if you have not done that, kindly do that. So we'll start with the Ganesh Vandana in just 2 minutes. Thank you so much.
Yeah. I would really say to everyone for sparing your wonderful Sunday morning today, and we assure you that it's going to be really a fruitful one. The reason today is, today we have a versatile galaxy of speakers. We have covered speakers from all strata and fraternity. Like, we have oncologists, we have gynecologists, we have cardiologists, we have IVF specialists. And what's very important is that the lectures which we have chosen are something which is going to be very helpful to us in our daily clinical practice. Something which we can imbibe, learn, and take home a message along with that. Sometimes the lectures are like, oh, people are just sitting, getting bored. No, it's going to be a session where we will be having sparking thoughts from all our esteemed speakers in the talk. Of course, Dr. Prajakta has spoken. Thank you, everyone. And you all look wonderful in this feta. It's beautiful to see you all. We are just wanting few more people to come, and we'll start. Of course, nothing begins without the Ganpati Pujan and Dhanvantari remembrance. So in 2 minutes we would be starting. Thank you so much. And just a quick...
फॉर्मेलिटीज के लिए निकला हुआ स्वागत नहीं है, ये दिल से निकला हुआ स्वागत है. गुड मॉर्निंग ऑल डिग्निटरीज, delegates, teachers, colleagues, friends, and all lovely souls who are gathered here on this Sunday morning. Let me introduce myself. I am Dr. Prajakta Patil. I am the Organizing Secretary of NIMA MDB's 36th Annual Medical Conference. NIMA MDB, that is National Integrated Medical Association, Mumbai District Branch. So now we will start with the Ganesh Vandana, but before that I would like to say something. Today is just not an ordinary Sunday, because today we made a conscious decision that we are not going to be curled up at our homes, but we are going to attend this conference. We are going to gain immense clinical knowledge. We are going to meet our batchmates and teachers after a very, very long period of time. And definitely, we are going to make new memories which are going to be with us for lifelong. So, before we begin any auspicious occasion, as you all know, we pray to Sukhakarta, Dukhaharta, Ganpati Bappa. To lead us in Ganesh Vandana, I would like to invite our esteemed dignitaries onto the stage, our respected mentor, Dr. Dubewar sir, Dr. L.G. Yadav sir, NIMA MDB President, Honorable President, Dr. Narendra Tripathi sir, our dynamic conference chairman, Dr. Prasad Pawar sir, IPP Dr. KV Phadatare sir. I request the dignitaries to kindly come forward on the dais and kindly start with the Ganesh Vandana. Hey Vignaharta, we all pray that each and every one present today over here gains immense clinical knowledge and our conference becomes a grand success. I would request everyone to be prepared as we are now going to start with the Ganesh Vandana. I request everyone, we can fold our hands and we will all seek divine blessings from Lord Ganesh, Ganpati Bappa. I request our Secretary, NIMA MDB, Dr. Vavar sir, President Dr. Narendra Tripathi sir, and all the dignitaries, our Scientific Chairman, Dr. Namdeo Thorat sir. Everyone kindly be seated. And I would like to invite our first esteemed speaker for today, Dr. Dubewar sir, to kindly grace us for this occasion. Women's Forum President, Dr. Rajni Yadav madam. Everyone kindly join your hands. Thank you, sir.
Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada
We are starting with the first lecture now, very soon. Kindly tell your friends who are in the breakfast area to kindly come in the auditorium. Everyone be seated. So what better way to do Shubharambha than to seek blessings from Lord Ganesha? I hope Lord Ganesha blesses each and every one of you, not only for today, but forever. And whatever clinical insights or whatever dreams you have regarding your profession, I hope they are fulfilled. So, now after the Ganesh Vandana, shall we start? I am not hearing anything from you. Shall we start? Yes. So, what better way to start than to do some शेरो शायरी? तो बोलिए दोस्तों, थोड़ी शेरो शायरी हो जाए? I am not hearing you. Thank you, thank you. नीमा MDB की महफिल है ये और हर स्पीकर है एक सितारा. साइंस क्लिनिकल ट्रायल और विजन का ये जश्न है बहारा. थैंक यू. फ्रॉम क्लिनिक्स टू कटिंग एज लैब्स, नॉलेज का है ये नज़ारा. AI वैक्सीन या जीन थेरेपी, हर सेशन है एक सितारा. क्लिनिकल ट्रायल्स की कहानियाँ भी है और डेटा का है सारा सच. रोबोट स्कैन्स और AI टूल मेडिसिन का बदला है चेहरा सारा. सो वेलकम टू दिस महफिल ऑफ नीमा MDB, जहाँ हर पल है कुछ न्यारा और ऑडियंस में बैठा हर डॉक्टर है हमको प्यारा. थैंक यू सो मच. So now I would request everyone to kindly stand, kindly rise for the national anthem. Could we please have the national anthem?
जन गण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे, तव शुभ आशीष मांगे. गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
जय मातरम. Thank you so much everyone. So now, finally we are starting. So today's agenda is a feast of learning. I am thrilled to present to you a power-packed lineup of 14 distinguished speakers from diverse specialties, from orthopedics to cardiology, from oncology to gynecology, from ophthalmology to pediatrics, from transplant surgeons to spine surgeons and many more. Along with a feast of knowledge and learning, we have made sure to serve you with delicious and hearty meals throughout the day. To keep your spirits and mind refreshed, we have made sure to keep tea and coffee available to you the entire day. But that's not all. थोड़ी तालियां तो बजाइए. और अभी थोड़ा मुस्कुराइए, क्योंकि अब लकी ड्रॉ की बारी आई है. So let me tell you how the lucky draw works. After each lecture, we are going to take 3 lucky draw winners, and the prizes are going to be amazing. After every lecture, we are going to take 3 winners, and we have a bumper lucky draw prize, which I am not going to reveal right now. Because it is the ultimate prize, I can just say the doctor who will win that bumper lucky draw would be the luckiest. That is one thing which I can say. So, let the PPTs play, let the gifts sway, and let the lucky draw steal the day. So now, we are going to start with the first lecture. I hope you had delicious breakfast and you are all ready and set to listen to the first lecture, because we are going to explore the ever evolving and very, very interesting field of oncology. So the topic is cancer prevention and screening. I am deeply honored to introduce our very first speaker, Dr. Dubewar sir. Sir has completed MBBS from Srimati NHL Municipal Medical College, Ahmedabad, followed by DNB in Internal Medicine. He then pursued DM in Medical Oncology from the esteemed Tata Memorial Hospital. In 2024, Sir successfully cleared MRCP, that is Membership of Royal Colleges of Physician Specialty Certificate Examination from United Kingdom. Sir is also certified by the European Society for Medical Oncology. Sir served as an ad hoc assistant professor in the Department of Medical Oncology at Tata Memorial Hospital from December 2020 to 2023. Currently, Sir is a distinguished medical oncology leading the Ghatkopar Center at the Indian Cancer Center. We are truly delighted and privileged to have such a wonderful speaker with us. It is a great honor and privilege for me to welcome our first speaker, Dr. Dubewar sir. Big round of applause. We begin with now for the chairpersons for this esteemed lecture, we begin with the highly respected Dr. Rajendra Khatavkar ma'am. Ma'am has completed BHMS and DNHE and is a dedicated family physician with a profound interest in health and nutrition. With an impressive experience of more than 35 years, Ma'am continues to inspire everyone through her practice at Airoli. Thank you so much, ma'am, for being with us. Namdeo Thorat, ma'am, a stalwart in the fields of cosmetology and trichology with a remarkable career spanning over 20 years. Ma'am currently practices in Ghatkopar, and her unwavering dedication to the field has been a source of inspiration for many. So now, with great respect, I request Dr. Dubewar sir to kindly start with the first lecture on the topic of cancer screening and prevention. Thank you so much, everyone. Yeah, just one more announcement. Those who have registered for the paper presentation, kindly note that you have to go in the auditorium on the first floor. So anyone over here for paper presentation, you are required over there. Okay? Thank you so much.
So, very good morning to everybody. First and foremost, thank you so much for the NIMA team for giving us this opportunity to work with NIMA team to make this event a grand success. Make this event. I am Dr. Deep Vora. मैं एक मेडिकल oncologist हूँ. I am a part of a group called Indian Cancer Treatment Center. And I am leading the घाटकोपर Center as of now. आज जिस टॉपिक पे हम बात करने वाले हैं, it is for all of us as a medical fraternity what we owe to our patients, because cancer prevention is much more important than treating a cancer patient, and that is we will see why it is important, is it important, and how should we do it. If time permits, I would like to go on to the screening part also, which is also very important part, if time permits. Yeah. So I am also a consultant medical oncologist at Hiranandani Hospital, Powai, as well as Zainova Shelby Hospital in Ghatkopar. And let us start our today's talk. I am audible till in the end, right? Yeah, thank you. So, is cancer prevention really necessary? Is it a actual public health problem? अगर कैंसर प्रिवेंशन करना क्यों ज़रूरी है? Is it a major public health problem? अगर है तो कौन लोग हैं जो इसके लिए ज़्यादा रिस्क रखते हैं ताकि हम उनके ऊपर कुछ प्रिवेंटिव स्ट्रेटजीज अप्लाई कर सकें. इफ़ देर इज़ एनीथिंग, कुछ हम कर भी सकते हैं क्या कैंसर को कम करने के लिए? कैंसर का इंसिडेंस वी आर सीइंग नाउ राइट एंड लेफ्ट. Initially, maybe 10-20 years ago, in a village there will be 10 patients who are suffering from cancer, and now what we are saying is each and every family is having at least 1 or 2 patients of the cancer. So there is definitely something going on, and whether we can actually do anything to prevent it. If we can do it, if we can prevent the cancer from happening, is there something which we will get benefit of anything? So these are all the things I am going to talk about, and the last and most important thing is, do we really need to discuss about prevention? Is prevention really necessary? India में आज की डेट में जो भी expenses in medical field हो रहा है वो सब secondary prevention, that is called as treatment. एक बार disease हो जाता है उसके बाद उसको treat करने के लिए हो रहा है. Prevention is something which is very before that, and whether it actually helps or not, this is what we are going to discuss. So first and foremost, to know whether it is a major public health problem or not. कैंसर इतना ज़्यादा एक्चुअली बड़ा है कि नहीं बड़ा है, हम सबको इसके बारे में डिस्कस करने की ज़रूरत है कि नहीं है. वी नीड टू नो व्हाट इज़ द इंसिडेंस एंड मोर्टालिटी. सो दिस इज़ वर्ल्ड डेटा. इन 2022 there are 2 crore new cases of cancer diagnosed हो रहे हैं every year, and out of them 1 crore patients are dying because of cancer. कैंसर की वजह से डेथ हो रहा है इन लोगों का. If we talk about India, 14 लाख न्यू केसेस एवरी ईयर डायग्नोस होते हैं इन इंडिया कैंसर के, एंड उसमें से 9 lakhs पेशेंट्स आर एक्चुअली डाइंग. एंड I personally feel these numbers are also very less. There will be so many patients जिनका registration भी नहीं हो रहा है, जो proper treatment भी नहीं पा रहे हैं. Numbers will be very high. But very important and striking feature here to see is that these are the most common 5 cancers of India. और अगर आप देखोगे मोस्ट कॉमन मेल फीमेल मिल के सबसे ज़्यादा जो कॉमन कैंसर इन इंडिया है वो है ब्रेस्ट कैंसर. Second most common is lip and oral cavity cancer, cervical cancer, lung cancer, esophageal cancer. If we talk about all of them, very important thing is ये सारे के सारे कैंसर या तो preventable है. If we remove some risk factor from our community, ये सारे या तो preventable है या तो early detectable है. Early detectable is also very important because you can try almost 80 to 90% of patients क्योर करने के लिए व्हेन यू डायग्नोज देम अर्ली. सो दैट इज वाई ब्रेस्ट कैंसर हम अर्ली डिटेक्ट कर सकते हैं, लिप ओरल कैविटी वी कैन प्रिवेंट, सर्वाइकल कैंसर वी कैन प्रिवेंट एज वेल एज डिटेक्ट अर्ली, lung cancer, esophageal cancer, again risk factor related cancer. So there is so much we can do. 5 most common cancers of India are either preventable or easily detectable early, and still we are not able to do that. Majority of our patients today are still metastatic stage 4 वाले patients हैं. So there is a big role we all have to play in reducing the cancer burden from the country. ये हो गई आज की बात. व्हाट अबाउट टुमारो? कल बेटर होने वाला है कि खराब होने वाला है? दिस इज एस्टिमेट्स ऑफ WHO एंड व्हाट इट सेज इज फ्रॉम 2020 टू 2040 नेक्स्ट 20 years में द नंबर ऑफ न्यू केसेस 20 million से 30 million, that is 1.5 टाइम इंक्रीज होने वाले हैं. द नंबर ऑफ डेथ्स बिकॉज ऑफ कैंसर 10 millions टू 16 millions, अगेन 1.5 टाइम्स इंक्रीज होने वाले हैं. सो इट इज गोइंग टू बिकम अ मेजर पब्लिक हेल्थ, इट हैज़ ऑलरेडी बिकम अ मेजर पब्लिक हेल्थ प्रॉब्लम वर्ल्ड वाइड इंक्लूडिंग इंडिया, एंड इट इज गोइंग टू गेट वर्स. सो येस, डेफिनेटली वी हैव टू डू समथिंग अबाउट कैंसर प्रिवेंशन. फॉर दैट वी नीड टू नो प्रिवेंटिव स्ट्रेटेजी किसको अप्लाई करना है, देन ओनली वी कैन अंडरस्टैंड कैंसर को कैसे प्रिवेंट किया जा सकता है. सो हु इज एट रिस्क, दैट इज द मोस्ट इंपॉर्टेंट क्वेश्चन, एंड हाउ मच इज द रिस्क. एज पर WHO वर्ल्ड वाइड 1 in 3 people is going to have cancer during their lifetime. This is the numbers we are talking. 1 in 3 मतलब इस ऑडिटोरियम में बैठे हुए 3 में से 1% को भी कैंसर होने का चांस बहुत ज़्यादा है. 1 in 3 पेशेंट. इफ़ यू टेक अबाउट ओनली 0 to 75 years of age, 1 in 5 इज गोइंग टू हैव अ कैंसर. द इंपॉर्टेंट थिंग इज नेक्स्ट पॉइंट, हु इज एट रिस्क, किसको रिस्क ज़्यादा है. द प्रॉब्लम इज एवरीबडी इज एट रिस्क. द रिस्क इज इंक्रीजिंग एवरी डे. But the most important thing here is it can be reduced by almost 30 to 50%. 50% तक के कैंसर्स को हम या उसके वजह से होने वाले डेथ को हम प्रिवेंट कर सकते हैं if we try to do something about it. So that is where we need to know risk factor. अगर हमें पता होंगे तो हम डिसाइड कर सकते हैं कि क्या रिस्क प्रिवेंटिव स्ट्रेटजीज अप्लाई करना है. दैट्स वाई वी नीड टू नो कैंसर क्यों होता है. कैंसर क्यों होता है ये हम जानेंगे तो ही रिस्क फैक्टर्स के लिए हम कुछ कर पाएंगे. सो कैंसर इज अ इटियोलॉजी, वी ऑल नो नाउ. कैंसर जेनेटिक म्यूटेशन की वजह से होता है. हमारे हर एक बॉडी में हर एक सेल एवरी सेकंड 1 में से 2, 2 में से 4, 4 में से 16 हो रहा है. ड्यूरिंग दिस ईच डुप्लीकेशन देर इज़ अ चांस के कुछ एरर हो जाए. डीएनए डबलिंग में रिपेयर में कुछ प्रॉब्लम हो जाए. देर कैन बी एरर. नाउ नॉर्मली आवर बॉडी हैज़ मैकेनिज्म्स इन प्लेस जहाँ पे वो डीएनए रिपेयर भी कर सकते हैं एवरीथिंग. बट अल्टीमेटली आउट ऑफ ऑल दिस म्यूटेशंस रिपेयरिंग ऑल दिस हैपनिंग, देर विल बी सम म्यूटेशन जो रह जाता है which cell has a advantage, survival advantage over the other cells. That's why that cell keeps growing and it becomes a cancer. ऐसे ही cancer बनता है. So ultimately it is a genetic mutation that leads to a cancer. What we need to know is why this genetic mutation occurs. ये mutation क्यों होते हैं. If we see the risk factors, there are intrinsic risk factors जिसके बारे में आप कुछ नहीं करते हैं. there are random errors while DNA replication जो हो रहे हैं. there is random errors, majority of them are corrected, some of them cannot be corrected और उसकी वजह से हो सकता है. now there is nothing much, this is unmodifiable risk factor. there are partially modifiable risk factors like our age. the more you age, there is a higher chance of cumulative mutations accumulation in our body. So there is a, while you age, there is a chance के कैंसर होने का रिस्क बढ़ सकता है. there is genetic susceptibility, hormones, growth hormones, inflammation, all these things. Majority of things, these are not in our hand. We are going to age. We have controlled infectious diseases, we are controlling cardiac diseases, so we are going to age more now, and there is inherent risk with that also. Most probably these are also not in our hands and we are not going able to do something to do about this. But the next important point is exogenous risk factors. Exogenous risk factors में है radiation, chemical carcinogen, tumor causing viruses, our lifestyle, our nutrition, all these does also affect our body and ultimately lead to cancer, and these are modifiable risk factors. This is where something we can do. What we need to know is how much is this impact of these modifiable risk factors in the community when cancer happens. Again, WHO data says global cancer death attributable to any risk factor. कोई भी risk factor की वजह से जो भी death हो रहा है world में because of cancer, how many cancers are there जिसमें कुछ reason है जिसको हम correct कर सकते थे. And the answer is 45% of global cancer deaths. 44% डेथ्स जो हो रहे हैं उसके लिए कुछ ना कुछ मॉडिफाइबल रिस्क फैक्टर प्रेजेंट रहता है, विच कुड बी मॉडिफाइड, विच कुड बी प्रिवेंटेड, और वो डेथ को हम प्रिवेंट कर सकते थे. बट स्टिल 44%. एंड माइंड यू, इसमें उन्होंने इन्फेक्शंस एंड यूवी रेज इंक्लूजन नहीं किया है. इन्फेक्शन अगर लेने जाएंगे इंडिया में, HPV इन्फेक्शन, हेपेटाइटिस इन्फेक्शन से जो भी कैंसर का डेथ हो रहा है, दैट इज ऑल्सो देयर. इफ यू आर गोइंग टू इंक्लूड दोज, द नंबर इज गोइंग टू गो अप टू ऑलमोस्ट 50% ऑल्सो. सो 1 in 2 deaths because of cancer is because of something which is preventable, and definitely we need to do something about it. I am going to skip this slide, but the So next point is, I mean, whatever we have learned so far is, it is a major public health problem. Everybody is at risk, but the risk can be prevented, and there are 50% of deaths which can be prevented अगर हम कुछ strategies अपनाएं तो. Now we are going to talk about primary prevention. What is primary prevention? There are three types of prevention: primary, secondary, tertiary prevention. Primary prevention means जो disease के बारे में आप prevent करने का सोच रहे हो, उसके लिए जो risk factor है, वो risk factor को ही आप prevent करो. There is no disease at all, still you try to do something so that the disease बनना ही नहीं चाहिए body में. That is called as primary prevention. Whatever we do once your body has a cancer, एक बार cancer body में बन गया, उसके बाद हम early detection करें, early surgery करें, early treat करें, this all comes under secondary prevention. But उसमें everything will be involved, your finances, your emotional stress, your social stigma, everything will be involved. और एक बार कैंसर डायग्नोस हो गया तो वो सब करना ज़रूरी है, लेकिन अगर वो कैंसर होने ही ना दे, दैट इज़ द बेस्ट वी कैन डू. Sadly, in India, even national health programs are also focusing only on secondary prevention as of today. Nobody is talking about primary prevention. Western world actually has done much better over last 20 years. They have changed their risk factors. Cigarette smoking se baat le lo, tobacco usage se baat le lo. They all have done so good things that they are actually working. Primary prevention is the prevention जो least costly है. It is least costly. You just need to give information in different ways. It is most जो माइंड में बैठ जाता है ऐसा है, और उसमें कोई भी खर्चा नहीं इंक्लूडेड है. बट स्टिल वी आर नॉट टॉकिंग अबाउट दिस, एंड वी नीड टू स्टार्ट टॉक अबाउट प्राइमरी प्रिवेंशन नाउ. सो लेट अस टॉक अबाउट प्राइमरी प्रिवेंशन. मेजर्स दैट कैन बी टेकन टू लोअर द डेवलपमेंट ऑफ कैंसर. कैंसर होना ही नहीं चाहिए, उसके लिए जो हम कर सकते हैं उसको प्राइमरी प्रिवेंशन बोलते हैं. ओके, प्राइमरी प्रिवेंशन कहाँ पे एम करते हैं? व्हाट आर वी ट्राइंग टू डू? वी आर ट्राइंग टू चेंज द बिहेवियर. टोबैको यूज, अल्कोहल कंजम्पशन, डाइट, वेट, फिजिकल एक्टिविटी, इन्फेक्शन प्रिवेंट करना, एनवायरमेंटल एक्सपोजर कम करना, ऑल दिस थिंग्स कैन बी डन फॉर प्राइमरी प्रिवेंशन. इससे कुछ भी फायदा होगा क्या? प्राइमरी प्रिवेंशन करने से कुछ भी फायदा होगा क्या? यूरोपियन गाइडलाइन का डेटा है 100% ऑफ सर्वाइकल कैंसर, गर्भाशय का मुख का जो कैंसर बोलते हैं हम, 100% ऑफ सर्वाइकल कैंसर कैन बी प्रिवेंटेड. होना ही नहीं चाहिए. दिस इज, इंडिया इज वन ऑफ द मोस्ट कॉमन कंट्री जहाँ पे सर्वाइकल कैंसर होता है और उसकी वजह से डेथ भी होता है. इंडिया इज वन ऑफ द मोस्ट कॉमन कंट्री इन द वर्ल्ड विच इज 100% प्रिवेंटेबल. Lung cancer 90% cases can be reduced, oral cavity 90% cases, esophageal cancer these are the same cancers which are most common in India so far. Cervical cancer, lung cancer, oral cavity cancer, esophageal cancer. So we can do so much, and all these cancers can be prevented if we apply proper preventive strategies. So let us talk about these preventive strategies one by one. फर्स्ट एंड फॉरमोस्ट, कभी भी कोई भी कैंसर रिलेटेड आप रिस्क फैक्टर के बारे में बात करोगे, फर्स्ट एंड फॉरमोस्ट ऑलवेज विल बी टोबैको, आइदर इन स्मोक्ड फॉर्म और इन चूएबल फॉर्म. टोबैको एट्रीब्यूटेबल डेथ्स वर्ल्ड वाइड, नॉट ओनली कैंसर, टोबैको की वजह से जितने भी डेथ होते हैं वर्ल्ड वाइड, द नंबर इज 8.7 मिलियन डेथ्स बिकॉज ऑफ टोबैको अलोन इन द वर्ल्ड वाइड. सारे कैंसर, सारे डेथ रिस्क फैक्टर्स को एक साइड ले लो, टोबैको एक साइड ले लो, टोबैको इज मोर देन ऑल ऑफ देम. इफ वी टॉक अबाउट टोबैको रिलेटेड डिजीजेस, बॉडी का हर एक ऑर्गन को डैमेज करता है टोबैको एज अ रिस्क फैक्टर. आइज से लेके कोई भी ऑर्गन ले लो, वहाँ पर वो डैमेज तो करता ही है. कार्डियोवास्कुलर रिस्क फैक्टर्स, पल्मोनरी COPD हो सकते हैं, देर आर सो मेनी रिस्क फैक्टर्स. बट ईच एंड एवरी ऑर्गन ऑफ आवर बॉडी हैज़ इंक्रीज रिस्क ऑफ कैंसर ऑल्सो. हर एक ऑर्गन का आप कैंसर होने के लिए जो रिस्क फैक्टर देखोगे उसमें सबसे पहले ऑलमोस्ट ऑलवेज टोबैको ही रहेगा. सो ऑलमोस्ट ऑल ऑर्गन्स ऑफ आवर बॉडी हैज़ इंक्रीज रिस्क ऑफ कैंसर. देर आर सम विच हैव मेनी fold increase, but there are almost all organs of the body. If you see the list, nose, oral pharynx, larynx, खाने का नली, that is esophagus, बोलने का पेटी, that is larynx, lung, liver, stomach, kidney, all organs have increased risk. And WHO says tobacco causes more preventable deaths than any other risk factor combined. So it is very important to understand. How will we tell our patients why it is important to stop using tobacco? You have to tell them what are the benefits of quitting tobacco. You have to show this slide actually. Literally you can show this slide कि ये benefits है tobacco use बंद करने का. Within seconds आपके heart rate BP normal होना चालू होता है. Within 1 year आपका heart attack आने का risk कम हो जाता है. Larynx ओरल केविटी का कैंसर रिस्क 50% तक कम होने के लिए और जाता है. द पॉइंट इज जो आज बंद कर देंगे टोबैको, क्विट करेंगे आज भी, स्टिल फॉर नेक्स्ट 5 years देयर रिस्क इज गोइंग टू बी मच मोर देन जनरल पॉपुलेशन. बट एटलीस्ट द रिस्क स्टार्ट्स कमिंग डाउन एंड बाय 5 years इट बिकम्स 50%. बाय 20 years लंग कैंसर कम होने का रिस्क कम होने के लिए, नॉर्मल पॉपुलेशन जैसा होने के लिए, इट बिकम्स ऑलमोस्ट 20 years आफ्टर यू क्विट tobacco. So whenever you do it, as early as possible you should do it, and then only you can reduce the risk of developing other diseases as well as cancer. Mainly tobacco related cancers will be oral cavity, nose, pharynx, larynx, lung, esophagus, stomach, and many more. So these are all the benefits that we are going to get. Are we doing anything? Yes ma'am. Sorry ma'am. 5 minutes. Sure ma'am. So next is, as a world level, I mean at India level, what we can do is there are something, but at individual level we all know there are national guidelines on this. There are 5 A's and 5 R's which can do, assess everything and all. There are national guidelines on this. Please try to do this. These are not your patients. These are patients, relatives, normal people. उनको ये समझाना ज़रूरी है कि why we need to do this. Okay. Next, most important is alcohol. ये सारे कैंसर्स होते हैं अल्कोहल की वजह से. इवन लाइट और मॉडरेट ड्रिंकिंग ऑल्सो कैन कॉज कैंसर और हार्ट डिजीज. कोई बोलेगा मैं तो बहुत कम अमाउंट में ले रहा हूँ, दैट इज ऑल्सो स्टिल ओके टू कॉज यू कैंसर. द रिस्क स्टार्ट्स एट 0 एंड इट इंक्रीजेज प्रोपोर्शनेटली. सो देर इज नो लिमिट. WHO क्या बोलता है? नो लेवल ऑफ अल्कोहल कंजम्पशन इज सेफ फॉर आवर हेल्थ. वी हैव टू स्टॉप डूइंग दिस ऑल टुगेदर. ओबेसिटी, बहुत सारे लोग सोचेंगे ओबेसिटी से भी कैंसर हो सकता है क्या? यस, इट इज प्रूवन to cause cancer. Postmenopausal breast cancer is more common in obese people. Colorectal cancer, endometrial cancer. So these are the BMI and waist circumference ratio that we need to keep. Basically obesity को control करना बहुत ज़रूरी है. It ultimately leads to a better health, which leads to lesser chances of developing cancer. Physical activity से cancer कम हो सकता है क्या? Yes. It is known कि there are some 10% reduction in risk of development of cancer when we do regular physical activity. Cervical colon cancer, endometrial cancer, ये सब का risk कम होता है. How much is required? There is no upper limit. जितना ज़्यादा करोगे उतना better है, but usually recommended जो cardiovascular के लिए भी हम बोलते हैं 45 minutes at least 5 days a week should be sufficient for this also, but it should be done. Diet is very important. Diet से cancer prevention होता है क्या? You will hear this from all the places. ये diet से ये होता है, ये diet से ये prevent होता है, ये diet से वो होता है. Frankly speaking, there is not a single type of diet where there is a direct relationship between the diet and the cancer. We have not proven it so far. And there is no such one type of diet जो prevent करता है या तो cancer करता है. But there are some hints nowadays. Slowly hint मिलते जा रहा है. In general, plant-based diet is much better for general well-being, general health promotion as well as cancer prevention. Red meat and processed meat. Processed meat is actually grade 1 WHO carcinogen, which is known to cause cancer in humans, which is known to cause cancer. तो ये सब चीज़ें यूज़ करना कम करना चाहिए. Processed meat के लिए WHO का recommendation है, there is no recommended serving. It should not be there in our diet. Red meat, it should be in moderation. So these are the things that we need to take care. Low fruits, low vegetable diet से ये सारे cancers का risk बढ़ता है. And whole grain और लो फाइबर वाले डाइट से कोलोरेक्टल कैंसर का रिस्क बढ़ता है. सो डाइट शुड बी रिच इन फ्रूट्स, रिच इन वेजिटेबल्स, रिच इन होल ग्रेन्स एंड लेग्यूम्स. लिमिट हाई कैलोरी डाइट्स, हाई कैलोरी ड्रिंक्स, हाई फैट डाइट्स, वो सब कम करना है. प्रोसेस्ड मीट नहीं ही लेना है, रेड मीट कम करना है to prevent all these things. Next, very most important thing I would like to discuss is infection. 2 minutes now. Infection, this is very important. I would like to complete this infection portion for sure because there are some infection जिसकी वजह से भी कैंसर होता है. I would like to highlight 2 of them, hepatocellular carcinoma and cervical cancer. Cervical cancer के बारे में बोलना बहुत ज़रूरी है. ग्लोबली 3 वैक्सीनेशन डोज लेने से ये कैंसर को हम 100% प्रिवेंट कर सकते हैं. द यूजुअल एज ऑफ गिविंग दिस वैक्सीनेशन इज 9 to 14 years ऑफ एज टू बोथ मेल एज वेल एज फीमेल चिल्ड्रन. सिर्फ फीमेल को देना नहीं है, मेल एज वेल एज फीमेल को देना है. 9 to 14 years ऑफ एज तक देना है. यू कैन गो अप टू 45 years ऑफ एज, बट द बेनिफिट गोज डाउन. मैक्सिमम बेनिफिट इज फ्रॉम द 9 to 14 years ऑफ एज और बिफोर द स्टार्ट ऑफ सेक्शुअल एक्टिविटी. सो बिफोर दैट वी नीड टू गिव दिस. 14 साल से नीचे में दे रहे हैं तो 2 ही डोज देना काफ़ी है. 14 साल से ऊपर में देते हैं तो 3 डोज देने पड़ते हैं. द सीरो कन्वर्जन रेट इज 100%. Important to note is 1 in 5 cancer diagnosis, cervical cancer happens in India, and 1 in 4 death from world from cervical cancer happens in India. So there is too much for us to do in this regard. Lately government of India ने भी कैंसर प्रिवेंशन फॉर सर्वाइकल कैंसर पे फोकस किया है. इट मे बिकम अ पार्ट ऑफ यूनिवर्सल इम्यूनाइजेशन प्रोग्राम. डॉक्टर सीतारमन ने भी अपने पार्लियामेंट स्पीच में भी ये बताया हुआ है, बजट के स्पीच में. बट इट विल टेक टाइम. बिफोर दैट वी नीड टू हैव आवर ऑल पेशेंट्स बीइंग वैक्सीनेटेड फॉर these things. These are not patients, these are their children, relatives, sisters, all these patients are going to be there. So this is very important. 100% seroconversion is there, and there is no risk of any major side effects. Some local pain, some fever will be there, which can be managed easily by paracetamol or something. So this needs to be given. Other risk factors I am not going to talk about. India में ज़्यादा common नहीं है. The conclusion is the doctor of the future. This is given in 18th century. The doctor of the future will give no medicine, but will interest his patients in the care of human frame, in the diet, and in the cause and prevention of the disease. From prevention, somehow we have gone to secondary prevention only, but we need to do much more about cancer prevention as a primary prevention. Take home message: fast. अब टोबैको बंद करना बहुत ज़रूरी है. अल्कोहल कम करना ज़रूरी है. वेट रिडक्शन इज़ वेरी मच इम्पॉर्टेंट. फिजिकल एक्सरसाइज वेरी इम्पॉर्टेंट. Eat plenty of fruits and vegetables. Protect your skin. One important thing which could not be covered was family history. Family history of cancer is very important, where we can do something about it. And take vaccination. Tell your patients, their relatives, to take vaccination for hepatitis B. तो हम anyways दे देते हैं. It's okay. I'm finishing work. So vaccination for HPV is also very necessary. Okay. I am Dr. Deepwara from Indian Cancer Treatment Center. We have all these daycare centers. Ultimately our motto is to give affordable cancer care to each and every patient of whoever reaches us. And because what we believe is no patient should not get any treatment because of their finances or any other reasons. So we have all these centers in Vashi, Panvel, Kalyan, Dombivali, Sayan, Dadar, Ghatkopar, Santa Cruz, Goregaon. We have all these centers in place. And if there is anything else, any questions, I'm ready to take. Thank you so much.
Thank you so much. Our first speaker, Dr. Dubewar sir, for the great lecture. Kindly give a big round of applause. It was truly a pleasure to listen to you, sir, and you provided valuable clinical insights which we all are going to use in our OPDs from tomorrow itself. May I now invite our chairperson, Dr. Rajendra Khatavkar ma'am and Shailesh Thorat ma'am, to kindly come forward and felicitate our esteemed speaker, Dr. Dubewar sir. Now Dr. Prasad Pawar sir, our conference chairman, would like to speak a few words about ICTC, that is Indian Cancer Treatment Center.
सुस्वागतम. सगळ्यांचं पोट ब्रेकफास्ट वगैरे झाला आहे? अरे आवाज नाही येत. मराठीमुळे फेटे आणि आवाज येत नाही. येतोय ना? तर आजचा हा सुवर्णमय सोहळा होण्याच्या बरोबर आपले जे फर्स्ट स्पीकर आहेत आदरणीय दीप सर, ICTCची पूर्ण टीम आणि दीप सर सरजी ICTCची पूर्ण टीम आणि दीप सरांनी केलेले गणेश पूजनने आजचा हा सोहळा अगदी सुंदर होणार आहे. लेक्चरही पहिले सुंदर झाले, त्यामुळे सगळ्यांच्याकडून एकदा टाळ्या झाल्या पाहिजे दीप सरांसाठी, ICTCसाठी. वर्षानुवर्ष विनंती आहे की ICTC असंच आम्हाला सहकार्य करो निमाला, आणि तुम्ही आमच्या संगती असंच पहिलं लेक्चर देऊ एवढी विनंती करतो आणि थांबतो.
I would now request our esteemed speaker, Dr. Dubewar sir, to kindly felicitate our chairpersons, Dr. Rajendra Khatavkar ma'am and Shailesh Namdeo Thorat ma'am. Kindly give a big round of applause. Sir, kindly don't go. Give a big round of applause, Dr. Rajendra Khatavkar, ma'am. So, अभी थोड़ा दिल थाम के बैठिए, तैयार हो जाइए, अपना डेलीगेट नंबर को चेक कीजिए, बिकॉज पहले लकी ड्रॉ की बारी आई है. सो I would request our speaker, Dr. Dubewar sir, to kindly do the honors. Now the first lucky draw winner, let me first tell you before we reveal the winners. Sir, just wait. The first lucky draw winner would be receiving the first gold coin. Who is going to be lucky? So, with immense pleasure, delegate number 291, Dr. Anita S. Do we have? Congratulations, ma'am. Ma'am, kindly be seated. We will be giving your lucky draw gift after all the lectures are over. Kindly don't leave the auditorium till then. I would now request Dr. Dubewar sir to take the second lucky draw gift. And the gift is for wristwatch. Let's see who will get. The second lucky draw gift goes to delegate number 617, Dr. A. Chaudhary, Dr. Abdul Chaudhary. Congratulations. Let's take the third lucky draw winner. And the third lucky draw winner will get headphones, that is earphones. Let's see. Most congratulations to number 438, Avinash Tiwari. Do we have Dr. Avinash Tiwari here? So we will be taking the next one. Kindly take. We have Avinash Tiwari over here. Okay, very good. So with this, we will conclude with the first lecture and the first lucky draw. Thank you so much, our speaker, Dr. Dubewar sir, and Dr. Rajendra Khatavkar ma'am, Shailesh Thorat ma'am, for the wonderful chairpersons. Thank you, Prasad Pawar sir, our conference chairman.
So only one message I want to give. As a community physicians, you all are going to be the first point of contact for all our patients. Please try to tell them importance of prevention of cancer, especially vaccination and tobacco quitting. Thank you so much.
Thank you, sir. Yeah, thank you. Hey, come on. Sir.
So now, don't rush out when the lecture gets over because things are just getting started. Congratulations to all winners, and those people who have not won, we have 13 more lectures and 13 more chances, and also the bumper lucky draw which is remaining. And those who would be present in the auditorium, only those people will win the lucky draw. So don't rush out of the auditorium. जो यहाँ है वही समझ पाएंगे ये बात, हर पंक्ति में छुपा है अनुभव और सौगात. So thank you. सोचिए मत कि कुछ मिस नहीं होगा. यह मंच है, यहाँ हर क्षण अमूल्य होगा. Thank you so much everyone. I request everyone kindly to be seated. We are now getting ready for the next lecture. Kindly have their seats. Thank you. So after exploring the interesting world of oncology, we are now moving to a very interesting field of heart and lung transplant surgery. I take immense pleasure to introduce the chairpersons for this session, I would like to invite Dr. Deven Naik sir and Dr. Niketan Zorpe sir to kindly come on the dais. Big round of applause for our chairpersons. Come on, audience. Now the topic which we are going to take in the second lecture is a very interesting and a unique topic. The topic is aortic surgery. Yes, the topic is aortic surgery, and I take immense pleasure to introduce a very talented, dynamic and dignified personality, Dr. Sanjeev Yadav sir. Sir is going to present on this topic because sir has more than 8,000 surgical experience. Sir has performed more than 8,000 surgeries on the heart and lung with international standards. This is a very, very big thing. And sir has pioneered uterus transplant in India. Sir has also pioneered heart-lung transplant in Maharashtra and Western India also. Sir is the director of Child Care Hospital Vashi, Vashi Hospital ICU, Varsha Parekh Maternity Hospital. So with this immense clinical experience, I am really honored that this is the speaker and this is the lecture that we are going to present before you. I would now like to request our chairpersons. Just a second. Our first chairperson is Dr. Niketan Zorpe sir. Sir is an ex-RMO of Podar. Sir has also worked as Deputy Superintendent, and sir is working as a government medical officer at Podar currently. The next chairperson is Dr. Deven Naik. Sir is a member of the managing committee of NIMA MDB, and sir has immense clinical experience, and we are honored to be here with sir. I would now like to request Dr. Sanjeev Yadav sir to kindly come on the dais and kindly start with the lecture.
F7 दबाने का पड़ेगा. डुप्लीकेट करना. नहीं इकडे नाही आलं. इकडचं गेलं. आलं ना. आलं. ठीक है ना. Good morning. Thank you, NIMA, Thank you, Dr. Tripathi. Thank you, Dr. Phadatare and Dr. Thorat for giving me this opportunity. I am Dr. Sanjay Yadav, attached to Gleneagle Hospital as a lead heart-lung transplant surgeon. Today we are going to discuss about aortic surgery. Most of the hospitals or cardiac surgery, cardiothoracic surgical centers where aortic surgery and heart-lung transplants are performed, these centers are considered as quaternary care centers. And so there are various parts of aorta, as you all know, that aortic root, sinuses of aorta, ascending aorta, arch, descending aorta, abdominal aorta, and each part of the aorta has specific diseases or specific issues which are very serious and need to deal in time. So I am going to discuss few aortic surgeries which are considered as quaternary care surgeries like heart-lung transplants. And these aortic surgeries required specific training. Nowadays, as you know, all cardiac surgeons are not doing lung surgeries. Like that only, all cardiac surgeons are not performing aortic surgeries as well. So this is aortic root and ascending aorta aneurysm, which is commonly seen in Ehlers-Danlos syndrome, Marfan syndrome, very commonly seen in Marfans, and annulo-aortic ectasia. And you can see there is a large size of aortic root as well as ascending aorta. And the usual treatment for this is a very big surgery in the field of cardiac surgery called as Bental's operation, aortic root replacement and implantation of coronary arteries. So this is the aortic root and ascending aorta is replaced with a prosthetic graft made up of Dacron material, and you can see the heart is standstill, and this is a conventional cardiac arrest surgery with bringing temperature of the brain to around 18 to 20 degrees Celsius if you require to replace arch as well along with the ascending aorta. So this is another video of ascending aorta. So we have seen the root enlargement. Now this is a ascending aorta replacement above root. Only the ascending aorta is affected and there is a large dilatation of aorta. ते बघून असं वाटतंय की ते enlarge आहे, पण if you really touch this, it is extremely thin walled. आणि many a times घाई गडबडीमध्ये जर थोडासा जरी टच झालं तर ते फुटण्याची शक्यता असते. And जर फुटलं तर there is death on table. There is no other complication in such kind of surgeries. Now this is further beyond aorta, that is arch, and you can see there is a large aneurysm in the arch of the aorta beyond subclavian artery, involving some portion of subclavian artery as well. And we have done what is called as aortic debranching operation and catheter endovascular aortic stenting. This is a sort of a combined team approach by cardiothoracic surgeon, cardiologists and intervention radiologists. This we have done along with an intervention radiologist. Aortic debranching म्हणजे aortaच्या ज्या branches आहेत त्याला ascending aorta पासून दुसरे grafts द्यायचे blood supply. You can see I have already placed 3 grafts. One is subclavian artery, one is common carotid and one is innominate artery. And then ligate all these branches at the base where they attach to the arch of aorta and place a stent. You can see the 3 branches, 3 grafts going to the 3 branches of the arch of aorta. And I am attaching grafts. Now, after the debranching, we have placed a stent through the femoral artery. The purpose of debranching is to keep a blood supply to the brain alive, giving new branches to the brain vessels. And you can see a stent placement in the arch of aorta, part of the ascending aorta, proximal to innominate artery. The complete stent is placed, and this is the post-op video which suggests now the brain has got a different blood supply from the ascending aorta and the aneurysm is disappeared. Previously, we used to do open surgeries for arch of aorta aneurysm, and which requires getting the temperature of the brain to 18 degrees Celsius. And in this situation, there is a high chances that chances of brain getting damaged because of hypothermia and ischemia. So this is a new hybrid kind of a procedure where interventional strategies can help us to get rid of this kind of arch aneurysms. This is an abdominal aortic aneurysm. You can see the renal vessels above, and there is a large aneurysm which involves infrarenal aorta, common iliac arteries, and you can see there is a lot of calcium in that segments as well. We have again used endovascular aortic stenting, interventional strategies to place a pyjama graft and a straight graft on the left side. And you can see after placing, there is no aneurysm in the abdominal aorta. Previously, we used to operate with open surgery by opening abdomen, clamping aorta just below the renal artery, replace the aorta with a bifurcation graft and join those bifurcation graft to both common femoral or common iliac arteries. Extensive approach, and usually these patients are very old with multiple morbidities, diabetes, hypertension, kidney issues, brain issues, strokes. And in these patients, probably this is a better, less invasive approach than open surgery. This is another example of aortic surgery. So there is a massive spectrum of aortic surgery, and you can see in the cath lab, what is called as TAVI or tower, a transcatheter valve, aortic valve implantation was going on, and in this situation, the valve was displaced and came back to abdominal aorta while pulling down the valve, and it has damaged the abdominal aorta in a massive 5 मिनिटांमध्ये तो पेशंट एक्सपायर्ड झाला. The patient was become breathless, restless, and sudden cardiac arrest. Once we revived in cath lab, intubated, and got him into the operation theater. And within 10 minutes, we opened his abdomen, got control of the aorta, and opened aorta to see that green color python sheath is broken, and the valve has impinged into the aortic valve. It's extremely dreadful complications of TAVI. And this is the retrieved valve from the abdominal aorta. आणि 2 महिन्यानंतर त्याचे आम्ही स्टँडर्ड aortic valve replacement पण केली, and he is doing very well. So he was very young, 62 years of age, and most of the doctors across nowadays, जसं angioplasty झालं की slowly angioplasties were initially developed for single vessel disease, आणि आता ट्रिपल वेसल, लेफ्ट मेन जे ॲक्च्युअल सर्जिकल इंडिकेशन्स आहेत त्याच्यामध्ये पण सर्रास अँजिओप्लास्टी केल्या जातात, विच सायन्स डझंट ॲडव्होकेट ॲक्च्युली. इट हॅज नो सर्वायवल बेनिफिट पुटिंग 4 स्टेंट्स, 5 स्टेंट्स, 6 स्टेंट्स, एस्पेशली इन लेफ्ट मेन अँड ट्रिपल वेसल डिसीज. तर तसंच टावी आणि टावरचं होतं, एस्पेशली क्लिनिकल सिच्युएशन लाईक कंट्री लाईक इंडिया वेअर रेग्युलेशन्स आर नॉट appropriate. The classical indication for TAVI or tower is age more than 75 years of age, severe kidney issues, lung issues, heart issues, previous CABGs. असे पेशंट्स असतील की 85 वर्षे, 86 वर्षे आणि त्यांना मल्टिपल कोमॉर्बिडिटीज आहेत, त्यांच्यामध्ये ओपन हार्ट सर्जरी करणं रिस्की आहे. अशामध्ये यू कॅन यूज टावी, ज्यांना ॲओर्टिक व्हॉल्व रिप्लेसमेंट लागणार आहे त्याच्यामध्ये टावी और टावर कॅन बी डन. All scientific data across the world shows surgical aortic valve replacement has much better, superior results than TAVI. आणि सगळ्यात महत्त्वाचं काय तर TAVI valve हा बायोप्रोस्थेटिक valve आहे आणि तो कोणाचा 1 वर्षामध्ये डिजनरेट होईल, कोणाचा 5 वर्षात डिजनरेट, कोणाचा 3 वर्षात डिजनरेट होईल. तर if you use that valve in a younger population, 60 वर्ष 62 वर्ष, तो it is going to degenerate early. Younger patients मध्ये valve जास्त लवकर degenerate होतो. आणि तो जर फेल झाला तर what next is again TAVI, and what next तो परत फेल झाला तर what next is surgery, and in that the surgery will be a Bentals operation, aortic root replacement, what I showed you as a first slide. So it's a dreadful complications, and TAVI should be selected appropriately, and it should be a combined decision rather than a single physician or cardiologist decision. It is always taken across the world along with a surgeon, cardiac surgeon combined, which is called as a heart team. We have done a huge number of TAVIs in multiple hospital, in Apollo hospital as well, and we are doing it regularly in clinical hospital. So these are types of TAVI valves. The left one is Merrill, right one is Edwards Sapien valve, and various femoral arteries you can go through subclavian artery, you can, from the apex of the left ventricle also you can do TAVI. This is a picture of a descending thoracic aneurysm. We have seen ascending aorta, root, arch. Now this is a picture of descending thoracic aneurysm, and it's a huge aneurysm in the descending thoracic aorta. And again we have done with endovascular stenting, which is commonly known as TEVAR. And previously again, 10 years back, we always used to open this patient through thoracoabdominal incision, take control above and below the aneurysm, and replaced with a graft, which is a standard surgery. And if nothing fits, or if TEVAR fails, the stenting, endovascular stenting fails, that's the only option we have. Adult coarctation aorta, हा एक पेशंट होता, अगेन एक यू कैन सी आर्च and there is a coarctation segment, congenital coarctation of aorta. He is an adult patient. हा दूसरा पेशंट होता आमचा adult coarctationचा. You can see subclavian artery, subclavianच्या पुढे एकदम coarctate segment आहे, आणि this is a congenital anomaly. And this is another third patient where patient with coarctation in childhood, they have played a coarctoplasty by placing a stent by a pediatric cardiologist. And you can see there is no flow across the stent. The aorta is completely blocked. And in this situation, we have done an open surgery with a coarctation with a left subclavian artery to descending thoracic aorta graft. This is a Dacron graft, and blood flow will come from subclavian artery to the descending thoracic aorta. This is another saccular aneurysm of thoracoabdominal. Now, आपण अजून खाली गेलो आता, thoracic aorta to thoracoabdominal aorta. This is again aneurysm of thoracoabdominal aorta, and we have done open. So this is quite an old patient, and we have done open surgery of thoracoabdominal aorta aneurysm repair. You can see a graft sutures inside that aneurysmal wall, that full sac which is open, which is aneurysmal sac. Now these are few cases of Stanford A. Debicki aortic dissection is an emergency, and dissection म्हणजे actually intima and part of media फाटून त्याच्यामध्ये सोडा लुमेन तयार होतं, आणि ब्लड ट्रू लुमेन मधनं aortic wall मध्ये जायला लागतं, and it forms a false lumen into the aortic wall. So this is aortic dissection, Stanford type. You can actually see the dissected flaps in the aorta. हे बाकी बाहेरचं जे bifurcation आहे pulmonary artery, वरची aorta आहे, आणि त्याच्यामध्ये dissected flaps you can see. On that side also you can see a pseudolumen in the जे white आहे radio opaque, that is true lumen, black आहे ते pseudolumen आहे. तर त्याच्यामध्ये actually clot आहे, and this is an extremely serious complication. And if you don't treat, the death is imminent. So again, this patient had undergone CABG plus ascending aorta replacement and coronary implantation. We have done bypass, means heart-lung machine was used in this, and we have cannulated axillary artery and femoral artery. This is aortic aneurysm segment on table, and this is an opened aortic aneurysm you can see the huge amount of clot inside, intramural clot, and excised, after excising blood clot, you can see the picture. And we have done a classical Bentals operation in this. And patient was extubated on post-op day 1. This is another Stanford type A, DeBakey type 1 aortic dissection. These are extremely risky surgeries, and this is how they look on CT angiogram. There's the dissected segments, and we have done aortic root replacement, ascending aorta replacement with composite valve conduit, Bentals operation with so this is intraoperative pictures, and this is replaced with a valve and Dacron conduit. So descending thoracic aorta leading to aortoesophageal fistula. So patient was having thoracic aneurysm, descending thoracic aneurysm, which was impinging into the esophagus, and patient presented with hematemesis. And on investigation, we found that a patient was having descending thoracic aneurysm, and the gastroenterologist has taken a biopsy of that hematoma in the esophagus on scopy also, which is a very dangerous act. Luckily, nothing happened, and it was a clot which he has taken biopsy from. And on investigations, it was a huge descending thoracic aneurysm, and we did it with a Tiwari. Thank you, 5 minutes. This is another, this is a descending thoracic aneurysm stained graft.
Sir,
Yeah.
4 minutes. 4 minutes left.
Yeah.
Yes.
2 minutes.
Yes.
So I'll just skip few. This is again aneurysm. I'm skipping pulmonary endarterectomy is another quaternary care surgeries, and a lady we have done it pulmonary endarterectomy. I'll show you the photographs of this. This is a huge clots from the pulmonary arteries, and the results. This is again a subclavian artery aneurysm. So these are all types of aortic surgeries, extensive aortic surgeries. We have pioneered heart-lung transplants in Western India and pioneered uterus transplant in India. And we have done around 73 heart-lung transplant, India's first 2 uterus transplant, 150 kidney transplant surgeries, and experience of more than 8,000 heart-lung surgeries. So this is the billboard which was kept in Fortis Mulund Hospital, where we have done Maharashtra's first successful heart transplant, and the press conference, and this is a newspaper article of India's first uterus transplant. We did back-to-back 2. This is the baby delivered out of uterus transplant, Asia's first baby delivered out of uterus transplant that we have done in Pune. And this is 1 year survival of that baby, and this is a recent picture of that baby. So we have achieved milestones in medical history. I am the only surgeon in the world who has done heart, lung, kidney and uterus transplant up till now, and pioneered heart lung transplant for almost 40 crores of patients in Western India, and pioneered uterus transplant for 140 crores of people in India. So there was an article for organ transplant in Times of India. There's another article. So I would like to tell you all as a doctor that this is our patient Fayyaz, and he was non-affording guy. We did completely free heart transplant for him. He was bedridden. 4 वर्ष तो bedridden होता. ते दोन्ही पाय असे सुजलेले होते एलिफंट सारखे. काम करत नव्हते. त्याची बायको वडापाव विकायची घरासमोर रायगड ह्याच्यामध्ये. 4 वर्षानंतर त्याचा हार्ट ट्रान्सप्लांट झालं. त्याचं म्हणजे शून्य खर्चामध्ये त्याचा आम्ही हार्ट सगळीकडनं पैसे जमा करून, आणि वॉज सो हॅपी. 4 वर्षानंतर हार्ट ट्रान्सप्लांट झालं. 3 महिने झाले आणि त्याला फॅमिलीला सपोर्ट करायचा होता, आणि तो ट्रक ड्रायव्हर होता, आणि तो ट्रक चालवत त्यांनी फोटो काढला आणि मला पाठवलं की 4.5 वर्षानंतर मी आज ट्रक चालवतो आणि माझ्या फॅमिलीला सपोर्ट करतो. ही वॉज सो हॅपी. अँड हा दुसरा पेशंट आहे. ही इज फ्रॉम चेन्नई, आणि आज 4 वर्ष झाली ही इज रनिंग मॅरेथॉन आफ्टर हार्ट ट्रान्सप्लांट. he was bedridden for 6 years and he is a CFO in Z Media. This is an exceptional result for heart lung transplants. आणि ही मुलगी आहे, ही जवळजवळ शाळा सोडली होती तिने, बेस ड्रायव्हरची मुलगी होती. हिला मी जेव्हा बघायला गेलो होतो रात्री 2 वाजता, मी करायला गेलो होतो दुसरं हार्ट ट्रान्सप्लांट, तर मला डॉक्टरने सांगितलं अरे या खूप पेशंट सिरियस आहे. मी तिला बघितलं दुरून तर एक्झॅक्टली शी वॉज डाईंग गॅस्पिंग. इंटेन्सिव्हिस्टनी सांगितलं, पिडियाट्रिक इंटेन्सिव्हिस्टनी की ही काय जगणार नाही आणि वी आर नॉट गोइंग टू इंटुबेट, कारण ती 6 वेळा ॲडमिट झाली आहे, त्याचा पैसे नाहीत खर्च करायला. तर बिकॉज ऑफ दॅट पिडियाट्रिक अनॅस्थेटिस्ट ही वॉज बिहाइंड की हिचं करू. अँड लकीली देर वॉज अ डोनर ऑफ 47 year फिमेल पेशंट इन फोर्टिस मुलुंड. तर त्या दिवशी आय हॅड कम फ्रॉम पुणे टू ऑपरेट फॉर अ सेकंड पेशंट हू इज कमिंग फ्रॉम गुजरात. पण वी डिड धिस गर्ल. आणि मी तिला लांबूनच बघितलं प्री ऑपरेटली, तेव्हा राजेश खन्ना कसा तो आनंद पिक्चरमध्ये शेवटच्या सीनमध्ये गॅस्पिंग असतो, एक्झॅक्टली शी वॉज गॅस्पिंग. आई वडील रडत उभे होते. आणि हर नेम इज सुहाना. आणि आता तिला जवळजवळ 7 वर्ष झाले आणि शी इज डान्सिंग. तिने व्हिडिओ पाठवला आहे. सो माझा एकच अपील आहे की डॉक्टर्स फ्रॉम महाराष्ट्र, वी हॅव वन ऑफ द बेस्ट ह्युमन रिसोर्स, बेस्ट इन्फ्रास्ट्रक्चर्स इन महाराष्ट्र, फर्स्ट स्टेट इन द country. We should start trusting or believing our own doctors instead of sending patients to Chennai and Hyderabad. Otherwise, we as a doctors fraternity, you, me, everybody will never grow. So this is a serious कळकळीची विनंती आहे समजा. And our day-to-day work is doing bypass surgeries, valve replacement. We do all beating heart bypass surgeries and with almost 100% result. And I've been doing at Apollo Hospital as the chief cardiothoracic surgeon and director of heart lung transplant. Now I am available at Gleneagle Hospital, Hiranandani Pavai, Somaya, Apollo Hospital, KDH, Kopar Khairane, multiple hospitals in Pune, Navi Mumbai and Mumbai. So thank you so much for giving me this opportunity.
Thank you so much, Dr. Sanjeev Yadav, sir.
Yeah.
Today, after listening to his lecture, we can just say that he's not just an amazing surgeon, he's such a wonderful human being. A big round of applause for sir. The person who was not employed for 4 years was back to his work. So he has not just done good to one person, but to the whole family. And with such kind of organ transplants, we have such new lease of life for everyone. The little girl, Suhana, dancing. Sir, really hats off for this thing. With the nitty-gritties and the precision they do the work, we really say salute to them. Can we have our chairpersons, Dr. Devin Nayak and Dr. Nitin Zorpe? Yes. To please felicitate us, sir. Thank you, chairpersons. It was a wonderful lecture. Yes. I would want our Sir, Sanjeev Yadav, sir, can you please felicitate our both chairpersons? Thank you, sir. After this wonderful lecture, जैसे बोला जाता है ना, बच्चे जब थोड़ा मन लगा के पढ़ते हैं ना तो उनको थोड़ी ट्रीट चाहिए. तो उसी हिसाब से निगाहें सबकी टिकट पर, डब्बे में वही राज है, किसका नाम निकलेगा वही तो ये अंदाज है. थैंक यू. सब लोग इतने अच्छे लेक्चर के बाद जागरूक है, बट ये जब मौका आता है ना तो सब लोग एकदम चौकन्ना हो जाते हैं. तो निगाहें टिकट पर. सर, 3 lucky winners for us today. And again, I would say the 3 lucky winners will be, the first one will be getting the gold coin. Yes. The first lucky number is 445. Unfortunately, the name has got, kind of the ink has got melted. 445, Charikar. Can't read out the name. Dr. Mangala. Dr. हाँ. Madam, number पे भी थोड़ा ध्यान रखिए. Dr. Mangala, do we have her here? Yes. Congratulations for the gold coin. Madam, you just have to be there. Sir, can we have the second lucky draw? It's the wristwatch. It's 575, Dr. Saili Pahurkar. Madam, are you there? If not, किसी और का नंबर लगेगा. Do we have 575? No. Sir. She's there? Yeah, she's there. Bad luck, guys. And the last one is 610. They have earphones. Dr. Salman Anwar Faruqi. 610. बहुत सारी गैंग आई उनकी तरफ से लग रहा है. Yeah. Yes.
Seema, give it to me.
You have to be well seated till the end. We are making a record of all the winners so that this is an incentive for you all to wait back till the end, you know. Yes. Yes. Sir. Sir, you have to hand it over to the chair speakers. Sir. A big round of applause. Thank you so much, sir, for sparing your time today. Thank you so much. Thank you. Now moving on to the next speaker, I would say, we have to continue with the galaxy of speakers. Our next speaker is esteemed Dr. Lakshmi Narendra Patil. She's a full-time neurologist consultant at Breach Candy Hospital, Mumbai. She has completed her graduation, post-graduation, and super specialty from Mumbai. She specializes in management of stroke, Parkinson's disease, dementia, and autoimmune neurological disorders. She is actively involved in academics and research with multiple publications and international presentation. Her topic today is acute stroke in the golden hour. How general physicians can save the brain. There is always an old saying, na? A stitch in time saves 9. So when we as general physicians have patients coming to us, maybe with high blood pressure or, high sugars, they will be first telling us, Doctor Sahab, what next? We have to be impromptu enough to take decision to save them and save their brain. So this is a very relevant topic for general physicians today. Now, the two chairpersons we have, can I call upon stage Dr. L.G. Yadav sir and Dr. Vishnu Bhavane sir? So please, we request your presence on the stage. Dr. L.G. Yadav sir has done his BSAM and MD. His specialty is Panchakarma and has 50 years of practice. He is ex-president NIMA Maharashtra, ex-president of NIMA Mumbai for 7 years, and ex-RMO RA Pudar College. Dr. Vishnu Bhavane sir. Dr. Vishnu sir is the professor and HOD Department of Prasuti Tantra and Stree Rog, B.R. Harne Ayurvedic Medical College and Hospital, Karau Vangani. He is a member Senate of Maharashtra University of Health Science, MUHS. Now, can I have ma'am on stage, Dr. Lakshmi Patil. Patil ma'am, over to you.
Thank you. Please. Good morning, everyone. Good morning, everyone. One of the important topics of stroke in golden hour. So today we are going to discuss what is stroke, its types, how to identify it, how to investigate and diagnose it, manage it, And what is the role of family physicians in the management of acute ischemic stroke? As we are aware, acute stroke is a focal neurological dysfunction which occurs suddenly due to disruption of blood supply to a part of brain, including the retina. So this is a new addition to the definition, that it's not just the loss of blood supply to the brain, but also the retina. It's a medical emergency, and to act fast here is utmost important. It is associated with mortality being one of the first 4 causes of death and high morbidity. In 2021 itself, there's more than 1.25 million new stroke cases recorded in India. And those who were treated were left with, more than 40% of them were left with disability. So here it is very important to treat the strokes in time to not only reduce the mortality but reduce the morbidity, because these patients may not go back to a normal life and add to the caregiver burden. There are 2 types of strokes. One, the ischemic stroke, where the clot reduces the blood supply to the brain, while the other, there is disruption of the blood vessel and leaking of the blood leading to the hemorrhagic stroke. The most common type being the ischemic stroke, accounting for almost 85% of the cases. And here, where therapies can reverse the stroke is much more important and awareness is necessary. Again, the ischemic strokes are of 2 types. It could be transient, that the blood supply is disrupted, but it reverses in less than 60 minutes and the patient becomes normal. While in the other type, the ischemic stroke, the brain damage remains and the neurological damage remains persistent. However, it is important to note that even if the patient has become normal, even a transient ischemic stroke is a stroke and requires a full workup as any other stroke would have required. And the most important part in the therapy is to identify the symptoms. And how do you do that? So stroke is a very dramatic event. The patient will usually say that they were fine about 5 minutes ago and suddenly develop symptoms of not able to talk, they develop weakness in the hands or inability to get up. And a very easy mnemonic to remember, be fast, an acute onset of imbalance while walking, sudden loss of vision or double vision, change, deviation of the face or drooping of the face, weakness in one of the arms, and slurred speech. And time is the most important part here. We have to act fast. And these symptoms, though helping us to screen the patients with strokes, few of the patients might get missed. So as a family physician, we should delve more into depths of the symptoms of stroke. And hence, we go into this diagram where we know that the areas of the brain are very specific. They are controlling very specific functions in the body. Like we see here, the frontal lobe is, in the red, is controlling our motor power and the speech, while the yellow parietal lobe is controlling our touch and pain sensations and awareness of the body. The area here is controlling the speech, while the occipital lobe is controlling the vision. And these areas have a very specific blood supply. The red area, the most of the frontal lobe, the parietal and the temporal lobe is supplied by middle cerebral artery. The yellow part is the frontal lobe and the parietal lobe supplied by the anterior cerebral artery, while the blue is the posterior cerebral artery. And knowing this helps us how to identify strokes early. So this is the famous and the detailed diagram of the blood supply of the brain, the circle of Willis. If you draw a line here, we can see the arteries lying ahead of this line are the anterior circulation, which entails the internal carotid artery, the middle cerebral artery, and the anterior cerebral artery, while the arteries posterior to the line are the posterior circulation stroke, including the vertebral arteries, the basilar, and the posterior cerebral arteries. We need to know this because blockage of this particular arteries will lead to certain cerebral syndromes and easy to identify them early. Like, a blockage of a middle cerebral artery would lead to a stroke this big on the brain, leading to a massive symptoms of contralateral, that is the opposite side of the brain, the body becomes weak, there's hemiparesis, there's loss of sensations, there'll be sudden inability to speak or understand speech, there may be visual symptoms, and smaller strokes can still lead to severe deficits. But the trickier ones are these. It's not always hemiparesis or loss of sensations on the one side or slurred speech. The patient can also come to you with just leg weakness. They can also come to you with just foot drop. However, an acuteness of these symptoms, if it has happened very soon, very suddenly, the suspicion of stroke should be high. Apart from hemiparesis, symptoms like suddenly not able to talk, suddenly becoming withdrawn, not talking to the family is also a symptom of stroke. Anything happening suddenly should raise an alarm that it's a stroke. And similarly, strokes from the posterior cerebral artery, the patient may not get hemiparesis. It is something beyond that. The patient have visual symptoms, they developed acute memory impairment. आता ते बोलत होते, थोड्या वेळाने तुम्हाला लक्षात आता आपल्याला ॲड्रेस आठवत नाही आहे, लोकांना ते ओळखत नाही आहेत, वस्तू अशी वाकडी तिकडी वापरतात, त्यांना वस्तू वापरता येत नाही आहे. These are all symptoms of stroke if they occur suddenly. And the trickier ones are these. Acute onset of vertigo, which may be not positional, associated with other symptoms, slurred speech, double vision. They have other symptoms like loss of sensations on the face, vomiting. Again, to point out, here again the symptoms may not, the hemiparesis, the weakness in the hands may not be very prominent, but sudden loss of ability to speak, swallow, and vertigo are also symptoms of stroke. So, high suspicion of these symptoms is very necessary. Once you have suspected a stroke, what next? Should the patient be referred to a clinic of the neurologist or a physician for management, or he should go to the hospital? The answer is no, they should not go to the clinic. Then what next? Should they be given aspirin? No, because we've seen that the strokes can be of two types. They could be bleeding type or the ischemic type where the clot is there. And aspirin is contraindicated in the bleeding type, and we'll also know why it cannot be given in the ischemic type as well. Do we give antihypertensive? Usually the stroke patient comes to you, the BP will be high. It may be 180, it may be 190. But no, you should not be given antihypertensives until and unless the BP is more than 200. So what do you do? Refer the patient to any hospital emergency? Again, no. The answer is you should be referring the patient to a stroke-ready hospital. So what is a stroke-ready hospital? So it is a hospital which has 24/7 stroke team who have trained specialists to identify the stroke symptoms and evaluate and do the further management. There is a hospital which has available CT or an MRI 24/7. They have facilities to do thrombolysis, that is give medications to dissolve the clot. And a procedure called mechanical thrombectomy either available in the hospital or they have protocols to transfer the patient to that higher center for further management. And why is it important? Because time here is very crucial, as time is brain. Every minute lost, the brain is losing almost 19 lakhs of neurons. Every 10-minute delay in administering the therapy causes loss of 2 months of healthy life in the patient. And if we treat these patients with thrombolysis in the first 60 minutes from the onset of symptoms, the chances of significant recovery, when I say significant, is complete reversal of the stroke, are very high in the first 60 minutes. And if we are able to reduce the time to thrombolysis, giving the medications by 15 minutes, we find that there's almost 10% increase in the improvement and the outcome in those patients. So you're making a significant difference in the life of the patient by referring them early. Once this is done, we need to confirm what type of stroke it is. So the most common modality of imaging the strokes is the CT brain. But let me reinforce here, doing the scan, just a CT brain without an angiogram for an acute stroke is an incomplete investigation. Any stroke which is suspected should have an angiogram done. So CT scan usually helps us to detect the hemorrhages, but it's not a very good modality to detect ischemic strokes because it cannot identify the changes in less than 6 hours on the CT scan. But however, saying that, it is very easily available. It is a faster modality. The CT scan done in 10 minutes. There's no claustrophobia. All the patients can undergo it. And angiography gives a better resolution here. And disadvantages is you can't pick up the brainstem stroke that we just discussed. And stroke mimics. Sometimes we are very well aware. Patients with low blood sugars, patient may having tumors or meningitis can still have symptoms which very well look like strokes. This cannot be picked up on a CT scan. And like we said, the small lesions which are in the brainstem cannot be picked up. And there's some radiation exposure. That's not very important here. MRI brain. It's a very useful and an preferable investigation for a stroke because it helps to detect the stroke very early, quantify it, the severity and duration of the stroke, the hemorrhage, there is some misconception that hemorrhages need to be first ruled out by CT scan. But no, we can just go ahead and do the MRI, because MRI itself can also distinguish from the ischemic strokes from the hemorrhagic strokes. So we need not waste time in doing a CT scan. Angiography. Even your chronic kidney patients who are not eligible to get contrast can undergo an angiography with MRI. So that's what the advantages here are. And it helps you to detect smaller strokes. So if patient has come with vertigo, पेशंटला चक्कर येते तुम्ही CT स्कॅन केला नॉर्मल आहे पण चक्कर जात नाही आहे कारण तो CT स्कॅन नॉर्मल आहे कारण त्यांनी डिटेक्टच नाही केलं स्ट्रोक कुठे होता ते सो दॅट्स वाय वी नीड एन MRI. And yes, hypoglycemia, tumors, meningitis, all this will be missed up there, which will be picked up on the MRI. And the advantages here is no radiation. But yes, we know that MRI is not available in all hospitals. It's not available 24/7 in all the hospitals. And the most important of all here, the therapy. The most important part in ischemic stroke is giving the thrombolytic or the thrombectomy therapy at early as possible. So you have two modalities of therapy, the thrombolysis, the alteplase and the tenecteplase injections, which are given intravenously, and thrombectomy. And the concept of golden hours. Because time is brain. The earlier we give the medication, the outcome is better. And if we delay the therapy, they are not eligible because we can give the thrombolysis only in the first 4.5 hours. After that, the risk of bleeding into the brain increases. And this is another reason that aspirin should not be given to the stroke patients, even if it's an ischemic stroke, because when they receive an eligible for thrombolytic therapy, there is increased chance of bleeding into the brain. Endovascular therapy, that is a mechanical thrombectomy, can be done from 6 to 24 hours. So even if it is more than 6 hours, we have not lost the window to treat the patients of stroke. They can be treated to up to 24 hours in certain cases, which can be screened. So like we said, 4.5 hours for thrombolysis, the two drugs that are available, and the first 60 minutes are crucial. And mechanical thrombectomy, who are eligible for it? The patients with large vessel occlusions like the internal carotid artery, the middle cerebral artery, and the basilar artery can undergo this procedure. In the first 6 hours is the standard window. But however, taking a judgmental call at each patient, this can be offered up to 24 hours. And it is only considered when the stroke is severe. So let us see how this is done. So here when the catheter is placed in the internal carotid artery, the wire is guided ahead across the clot into the distal blood vessel. A catheter is passed over the guide wire. And there are various devices called stent retrievers and aspiration. So this video shows us a stent retriever, which is like a mesh which goes and entangles into the clot and tries to retrieve it, as the name says. While there are other aspiration which have small suction devices which suck out the clot. And this immediately restores the blood supply to the brain. And how dramatic this video looks, that is the dramatic improvement you will see in the patient when they are on the table. So let us go into some live cases with this knowledge that we have seen. The first case, it was a 90-year-old woman. So age is not a contraindication to treating anybody with a stroke. If a patient is healthy, walking, talking, and having a healthy life, they are eligible for all therapies of stroke. So she had comorbidities, hypertension, ischemic heart disease. Her creatinine was also 3.5, though she was not on dialysis. She was hypothyroid. And she came in with severe stroke. Left side power तिची almost zero होती. त्यांना बोलता येत नव्हतं, dysarthria होता, face deviated होता. And we said, okay, 90-year-old, what more to do? But the family was very insistent, and we also offered all the therapies that are possible. We did the MRI. We can see this, there is a large stroke here. This whole white area is the stroke, while this is the normal brain. And we can see that the blood supply is completely cut off. We can't see any blood supply over here. So because she reported to the hospital within 25 minutes of the onset, she was eligible for the medication and she was given the thrombolysis. And this is her at discharge. We can't even make out which side the stroke was. She had RT placed for her feeding, which was also removed at discharge. And this is just 2 weeks after her stroke. So had this patient not reached the hospital or not offered thrombolysis, at 90 she would have left behind with these significant deficits. She would have remained bed-bound for rest of her life. And you know, a bed-bound patient is just a pool of another complications of bed sores, urinary infections and aspiration, and it's end of life. Plus it adds to the caregiver burden in terms of cost and time. So by offering this therapy, we are not only changing the life of the patient, but also the family around it. A second case, she was an 80-year-old woman with hypothyroidism. She again had similar severe left-sided hemiparesis, hemisensory loss, dysarthria, and hospital, she worsened even further. She became unconscious. We did her MRI, and her stroke assessment was into a severe category. But her MRI was very helpful in telling us that this is a very, very early stroke. The symptoms were there only for 20 minutes. Her brain was salvageable. So all this information we get on an MRI. And that is the insistence of doing an MRI in the stroke, because it can tell us what is the time of the stroke. It can be done from what is the area which is dead, what is the area that can be salvaged. All this information we get on an MRI. Again, we see here that the blood supply is cut off. And this black dot here tells us there's a big clot sitting here. And she received thrombolysis, but we know that this patient had a severe stroke. She's in the window period, and the clot is in one of the major vessels. So she was eligible for thrombectomy as well. And she underwent thrombectomy. So we can see here in the cerebral angiogram, we can see that cutoff which was seen on the MRI. The clot was retrieved, and the whole blood supply is restored. So this is what can be achieved. And this is her. 10 days after the stroke, she recovered within 24 to 48 hours. All her deficits were gone. She had to remain 8 days extra for her arrhythmia management. And this is her walking, talking at the time of discharge. So this is a life-changing therapy. And it is important because it is only eligible when the patient reaches the hospital in time. So that's where the role of the family physician is. You are the first point of contact. To identify the symptoms is very important. Refer to a stroke-ready hospital. Any hospital will not help the patient. You have to refer them to stroke-ready hospitals. So identify the stroke-ready hospitals around your clinics. Identify the neurologists which are involved in stroke management. Educate your patients not to take any aspirin, not to take any BP medications, and reach the hospital as fast as possible. And take-home messages for you all. Just a recap of what we have seen. Acute stroke is a medical emergency. Family physician is the first point of contact. Early referral to the stroke-ready hospital. Time is brain. The earlier we treat the patient, the better is going to be the outcome. Patient reaching the hospital in the golden hours is very crucial. And ischemic stroke is reversible. If they are treated in time, they can go back to almost normal life. No aspirin before reaching hospital. Thank you.
Thank you so much, ma'am, for such an enlightening lecture. कहा जाता है ना, दिमाग का नूर हो तो हर मुश्किल आसान हो जाती है, हर मुश्किल रास्ते पे भी मंजिल नजर आ जाती है. So thank you for taking care of the brain. Also very important announcement, we have our guest of honor, Dr. Raman, today with us. A big round of applause for having an esteemed guest amongst us. He is the Director of Ayush. Thank you, sir, for being with us today. And now, can I call upon stage Dr. Yadav, Dr. Vishnu, sir, to felicitate ma'am. Ma'am, please come over. So kindly felicitate Dr. Lakshmi. A big round of applause, doctors. Thank you, ma'am, for such a lovely, lovely lecture. Can we have... Thank you. Ma'am, can we have you to felicitate Dr. L.G. Yadav and Dr. Vishnu Bhavne, sir? Ma'am. Thank you, all the three dignitaries. Now again, jiska hame tha intezar. We have our next lucky draws coming up. Can we have ma'am? Ma'am, can we have the 3 lucky draws? Again, we keep reminding you, the first lucky draw is the gold coin. Oh my God, this is Dr. Nikitan Zodpe. 120. Sir, वापस आ जाइए stage पे. Second one, that is a wristwatch. Dr. Shama Faruqi. Ma'am, are you there? 574. Dr. Shama Faruqi. Is she there? Yeah. And third one, the earphone. Dr. Afroz Faruqi. Is it from the same family? Yeah, I think वो साथ में रखा तो साथ में नाम आ गया. Thank you so much. Thank you, ma'am, for the wonderful lecture. Thank you, sir, for being here. Moving on to our next speaker. Do I tell you who is the speaker? No. Let me have you guess. रीढ़ की हड्डी संभाल के रखिए जनाब. यही तो है हमारे शरीर की नींव. So any guesses? Yes. Our next speaker is Dr. Nikhil R. Bhatti. He is a spine surgeon. For him, I would just say that the spine stands tall, a pillar of grace, holding a journey in life's long race. So it's a privilege to introduce a surgeon who works at the very axis of human strength and resilience, that is the spine, with hands that bring relief to pain, with knowledge that restores mobility and gives people back their freedom to stand tall. So, this is going to be Dr. Nikhil Bhatti, and his topic today is going to be how spine surgeries have evolved from 9 inches to 9 millimeter. Can I be a little humorous right now? Normally we say size matters, the bigger the better. But here it's the other way around. The smaller, the safer and simpler. About sir. Dr. Nikhil R. Bhatti is a fellowship-trained spine surgeon who has done endoscopic and minimally invasive spine fellowships from reputed centers across the world. He has more than 20 years of experience of treating spinal problems and has performed more than 5,000 spine surgeries attached to multiple corporate hospitals in Mumbai and regularly featured among the best spine surgeons of Mumbai. He is also invited as a faculty for various national and international conferences. The two chairpersons today are, the first one is Dr. Rajni Vijay Yadav, and we have the second one, Dr. Arun Moite. Can we have both the esteemed dignitaries on the stage? Dr. Rajni Yadav. Welcome, ma'am. Dr. Arun Moite, sir. Dr. Arun Moite, sir. Dr. Moite. Dr. Moite.
His 10th lecture, in the sense of
the chairperson. No, the chairperson. We call upon Dr. Jaimala Prasad Pawar as the second chairperson. Dr. Rajni has done her BMS MD Dravyagun, and she has done her research diploma in yogic therapy, FIIM gold medalist Prakruti and Nadi. Also, what's her name? Ma'am, we have Mrs. Moite here. Yes. We call upon Dr. Nikhil. Ma'am, please be seated. Thank you so much. Can I have sir on stage for the lecture? Yes, sir. Over to you, sir.
Yeah. A very warm good morning to everyone. So let's just have a small technical check before we start. कशावरती चेक करू आधी हे प्ले करायला लागेल कुठेच नाही आहे
4 नंबर आला प्ले कर बघू प्ले कर
इंजेक्शन दिला आणि एक महिना झालेला विचारला आणि मी हे मला 1 महिन्यामध्ये 100% बरं केलेलं आहे तुम्ही
इनक्रीज लॅपटॉपचा आवाज वाढवतोय
आवाज हो
बस
फुल करू एक मिनिट
आता परत
कमरेचा त्रास होता चमक भरायची नंतर मला तो
Okay. Yeah, so once we are done with the all technical checkups, then I think we should proceed with the talk. Right. So I am Dr. Nikhil Arbatti, a consultant spine surgeon, and I would first like to thank NIMA, to the chairpersons, to the delegates, and to all the people who have come here for giving me an opportunity to present my talk. My forte of doing spine surgeries is basically minimal invasive endoscopic spine surgeries, and as madam had already introduced, how we have now progressed from doing something which was maximal to going to small and more minimal, and how we are achieving more safer and precise outcomes through it. So this is what my talk is going to be about. So just to have a क्यों इधर क्यों नहीं आता ये कनेक्टेड तो है ना हाँ कनेक्टेड है हे आता आलो काय आलं तिकडे ते ना Yeah, so basically we used to do a lot of our spine surgeries previously through an open incision. We knew that we had laminectomy, we had an open discectomy and all those procedures which we used to do. But output तो दिया ही हुआ ना कैसे तो कनेक्टेड ही है बट ये जब क्यों नहीं आ रहा लेकिन डिस्प्ले में जाओ शो नेविगेटर डिस्प्ले मतलब कुठला जाऊँ ये विंडो फंक्शन आता है डिस्प्ले का फंक्शन किस में करूँ बोलो कुठला डिस्प्ले हां कुठला करायचा HDMI हां काय करायचं कुठला हे एक सेकंड काय करायचं मिरर तर केलं आहे ना थांब एक हे करायला लागणार आहे प्ले केल्यावरती होईल पण हे असं काय प्रॉब्लेम
There's an announcement. Dr. Seema, of course not me, has lost or misplaced her, scooty key. Plus, there were some 4 clinic keys. So if anybody happens to get it, you can give it backstage. We can just hand it over to Dr. Seema. She really looks worried.
HDMI से currently mirroring है ना चेंज करूँ एक्सटेंडेड डिस्प्ले कुठलं करतो विंडो और ॲप
So doctors, how have you been enjoying the lectures till now? I hope it is really wonderful and lovely, and all topics. I mean, it's such a thing of pride to have doctors doing so many innovative things, you know. Initially, people had so many inhibitions about a spine surgery. Nahi, you know, there was a thing, even if anybody in my family would have been there, कि नहीं paralysis हो जाएगा. And now with this keyhole surgeries, the pain has completely gone. People are so relieved, you know, with the pain. The nerve compression is kind of solved. So really, truly, it's an evolvement to spine surgeries when it truly says from 9 inches to 9 mm. Sorry for some technical glitch. Along with the feast of fiesta, we have lovely sumptuous meals also today. And of course, lovely lucky draws have been completely kind of, you know, going on. So dil tham ke baithiye jana. Thoda sa apne mobile mein jaak lijiye jab tak ye chal raha hai. So you have the time to kind of, you know, have a look in your mobile. And then again, with attention on the, you know, speaker. I would definitely, since, you know, we are having a little time, I would definitely talk about ma'am. She is supposed to be, you know, बोला जाता ना कि कहीं पे भी हो, women are on the forefront. So thank you, ma'am. You know, your NIMA Women Forum has been an example of woman power and woman empowerment. जहाँ पे भी बोलो, it is, you know, woman का डंका. We need to have a little patience. We all love patience in our clinic, but a little patience here. We don't want people to go out. Of course, चाय पी के 2 मिनट में आप वापस आ जाइए, क्योंकि तुम्हारे लिए, सबके लिए, आप सबके लिए lovely lecture ready है. This is the sound when we have some esteemed dignitaries amongst us. I think it's all done and said. So over to you, sir. Thank you, sir.
Sorry for the delay. I'll try to cover up. Yeah, so just going ahead with the introduction of myself. And I would like to say that what we are now doing in spine surgeries has progressed tremendously. We are able to do surgeries, all kinds of surgeries, from the cervical to the lower back, as I'm going to show in my presentation, from a very small keyhole incisions. In fact, sometimes we can do it less than 9 mm also. So just to highlight, this was how we used to do some of the spinal surgeries earlier. We had an open laminectomy or an open discectomy with that kind of scar mark. To the right hand side, if you see, that is what the kind of instrument that I am using for most of my cases. That's an endoscope, and that is the incision. That's just a one stitch, and that is a discectomy, the same kind of discectomy which would have taken something like a, say, 4, 5, 6 inches scar before. This is what we have progressed. And just to show you, this is that same lady who she has undergone a discectomy. This is the day of surgery in the evening, able to mobilize by herself, getting up, going about in the hospital bed. So this is what we are able to provide now. Now, this involves a lot of things. It's not just that I'm saying that we are doing a smaller incision, that means that we are getting this outcome. What is needed to make spine surgery safer and better was, first of all, pain management after the surgery. We all know that the main phobia that patients had for surgery was it pains after the surgery. I don't want to undergo it because the first 24 to 48 hours after surgery is the most nerve-wracking for them. We have had that done very well now. We are more precise and we tackle the problem very accurately. We know what we need to do and how we need to do. And it is less morbid and more direct. We are not going to fiddle around doing unnecessary normal tissues damage. It is basically targeting the area where needs to be operated. And thus it becomes cosmetically appealing. And how have we achieved that? So it becomes now we are having a very patient-focused treatment. It's not like a generalized treatment that anyone who requires a spine surgery requires one surgery or two surgeries. We have multiple number of surgeries available to give, from endoscopic, minimal invasive, biportal and all. And we are using technology. Why we are using technology? Because we know that the anatomy of every individual varies. As we say that the outcome of every patient varies, that is because the anatomy varies. So that is why we are using technology to understand the internal anatomy and how we can get the outcome better. We are using the technology to make this environment safer for operating. We don't want any patient, like earlier they had the phobia, even now some patients have, after spine surgery I won't be able to get up, some kind of nerve will get paralyzed, I will not be able to walk, my brain will not be working. So we are making that more safer. We are trying to make the patients realize that no, this is not something that is going to happen. In fact, this is less than 0.01% chances of getting a nerve or a damage or a paralysis. And we have various tools that will help us in guiding and performing the surgeries. Post-surgery outcome and post-surgery management is very individualistic. We don't give like a common thing, not like a government hospital sometimes where you give some same protocol for all patients. We have a very individualized protocol. In fact, we see every patient what painkillers or what medicines he can tolerate before surgery and post surgery, and those are given it. So this gives a very good outcome. So just to highlight what all surgeries we are doing, it's a basically minimal invasive spine surgery. This is the first thing that we have started doing. This was started about 8 to 10 years before that I am doing. It's now progressed to more further than what I'm doing right now. And how we have evolved into doing minimal invasive surgery? Because of the equipments, if you see on the right hand side, and the microscope. The microscope was the most awesome development that had been done. It was invented about 35 to 40 years ago in the US, but the more use of it has been happening in India for the last 20-25 years, with the neurosurgeons using it more frequently, and now spine surgeons are routinely using it for all their spine cases. In fact, for the minimal invasive spine surgery, this is the basic fulcrum for doing all your surgeries. We have these equipments. If you see all these equipments, these are very small. In fact, the diameter of these are just about say 1.5 centimeter or 1.2 centimeter or 1 centimeter. These are the diameters, and there are various depths. So we can reach to even a very thin patient, or we can reach to an obese patient who may be weighing something like 150 to 160 kgs. So even those we can do it with these instruments. Just to highlight you how the surgery is done. So this is how we start a minimal invasive spine surgery. This is myself operating. We have done a small incision, and then we are putting this various instruments to reach to the area. So these are the small dilators. If you observe, the other highlight is, while I'm doing all these steps, there is hardly any bleeding or any blood loss which is coming. So there is hardly any muscle which gets trapped in between or anything which obstructs your way, because we know the exact path from where we need to reach. So we have confirmed what type of dilator we need. We just put this particular instrument. This instrument is docked over the area where I need to operate. And this is basically a single surgeon which needs to do. My assistant and my fellows are there, but they are at presently, I would say, mere spectators for this kind of surgery. And once you fix this, this is all fixed, and that's how it. So through this equipment, I'm now going to do the surgery. And what is the kind of surgery we do? This one. So if you see, this is where I'm going to do a simple lumbar discectomy, a disc prolapse. So we use a burr. So this burr is something which is going to cut the bone, but not going to cause any bleeding. Earlier, if you know that if any bone is cut, there should be some amount of bleeding or some amount of blood loss. But while using this burr and under the microscope, this is the kind of vision I am seeing, and this is the vision that everyone in the OT can see. This is highly magnified. And the surgeries that we do, it goes, I'll just show you. Yeah. So when we come here, if you are able to see, that is the nerve root, the spinal cord. You can say we are just trying to locate where is the slip disc portion. And with the help of microscope, we know that how much is it we can push the nerve behind. We are just trying to slightly take away the nerve, and that is the slip disc portion, if you can see in the middle. It's the one which we need to take it out. So that is the one which is pressing on the nerve and which is causing compression and symptoms of pain and all. Yeah. So that is, we are trying to take it out. If you see, sorry. Yeah. So with the help of small instruments, you can just, some amount of bleeding, even if it happens, we know where it is coming from and you can easily stop that. So this is how the kind of surgery we are doing for a minimal invasive surgeries. We are doing a disc prolapse surgeries, we are doing a decompression, even fusion surgeries. The next, what I'm doing since last 2 years, 2.5 years, is the endoscopic spine surgery. We all know that nowadays gallbladder or even hernia and even your stone surgeries are done through small scopes, laparoscopes. So even the spine surgery has come to a level where you're doing all kind of disc surgeries, decompressions through an endoscope. An endoscope works same like what a laparoscope works, but it's only a single instrument. We don't require any insufflation of any carbon dioxide. A small tube which goes into the site where the surgery needs to be done, and under the camera we are just seeing. So that is the camera vision, and that blue color what you're seeing is the disc which needs to be taken out. We are taking it out. So this is what we are seeing in the camera. That first incision which I showed, it's a single stitch surgery. We take only a single stitch. That's only one stapler that we need. This endoscope is just 6.7 mm in diameter. That is what is going to be the incision on the patient. And under the camera, we know where we have reached. We have seen under the X-ray and all, and we are just removing the disc pieces. And what is the outcome? This is it.
21 मुझे स्लिप डिस्क था L4 L5 में, तो प्रॉब्लम्स बहुत थी कि मैं उठ बैठ नहीं सकता था, ज़्यादातर बहुत ज़्यादा प्रॉब्लम्स है. एंडोस्कोपिक ऑपरेशन कराया जो कि सक्सेसफुल भी था, और उसके बाद अकॉर्डिंग ऑपरेशन के बाद मतलब 1 महीने बाद ही मैं चल फिर सकता था और एकदम प्रॉपर हो गया था.
This is a 21-year-old. This is 1.5 months after his surgery. We have started him on the routine activities that he needs to do. Right. So now we have gone from doing a simple discectomy decompression. We know that we are able to do it with a minimal invasive approach or an endoscopic approach. But we also need to do surgeries where we are putting screws or we are putting implants and where we are fusing it. How are we doing that? That also we have progressed to doing through a small incisions where we are not cutting at all any normal structures. And these are the various ways to do it. It's called an O-lift, L-lift, D-lift. So these are ways to perform the fusion. If you see, this is how the patient is positioned. We make a small incision that will be about 1.5 inches or about 3 to 3.5 centimeter. And through that, we are going to put the entire screw and that cage, make sure that the patient gets a complete correction of the spine. So that is how the X-ray appears. So this patient had a scoliosis of the spine, and that has been corrected with that implants. And that has been done through a small side incision, not even in the back, but it is in the side, that is on the abdomen area. And just to show you, this is the lady, she has undergone that surgery. This is 3 months after the surgery. She is doing her complete bending and all. She is a fisherwoman. And her daily activities involve going to the market and doing her day-to-day activities of lifting weights, sitting on the floor and doing. So this is the fusion that we achieve, and the incision is small. So we are able to say for a certain select patients that you will be able to get back to your entire normal activities. You can sit on the floor, you can bend, you can lift weights, and you can do all your activities. The other way is to do an L-lift. The L-lift is one where we go through the front. Again, in the front, this is where, if you know that where you make an incision for your Caesar or your laparotomy surgeries, we make a small incision same at that junction. That is also about 1.5 to 2 inches. That is about 3 to 4 centimeter. The other equipment that we use nowadays is a neuromonitoring. Now, when I say neuromonitoring, it's like an ECG of the nerves. We all know that whenever we have a heart problem or anything, the first step that the doctor advises is to get a chest X-ray and ECG. Now, this ECG says what is the rhythm of the heart. A neuromonitoring tells us what is the functioning of the nerves. So if you're doing any complex case, a case where a patient has been operated maybe once or twice before, and you need to decompress the nerves, or you need to correct the spine and make sure that there is no compression over this, we use this neuromonitoring very frequently now. And this has been done with the help of people who are there inside the OT. They monitor the nerves. So any problem which happens, any step which shows that the nerve is getting pinched or anything, it immediately tells us and we stop that step and go ahead with it. Just to highlight you, this is what we have done for a patient who had a problem at the base of the skull and the upper part of the neck.
Try karna. Very good.
17-year-old boy who had been operated 2.5 years before during a time of COVID. And this is after the surgery. He had been operated elsewhere. And this is after the surgery. This is how he presented to us. Not able to get up, not able to walk, having complete weakness in both all the four limbs. He was having difficulty in speaking and having difficulty in breathing also. This is what we have done. We have corrected the entire spine. We have made the spine alignment. And this is his surgery. This is his video 5 days after the surgery. Now this kind of complex where you need to correct the deformity, make sure that the nerve is completely free, there is no pressure remaining, happens with the help of these equipments. And this is the safety. He is now 4 months into surgery and is actively back into his college life. The other thing that we use is navigation. Now navigation is something we all know that suppose you want to go from South Bombay to North Bombay, you always use a GPS. Now the GPS tells you what is the direction you need to take and how much time it is. A navigation works similarly like that. It tells us where you need to reach, how you need to reach, and the pathway which is the best, which is not going to cause any damage to the normal structures. So we have now the O-arm, we have a computer navigation, we have robotic navigation. All these 3 steps are available. These help us in making the spine surgery very safer and very precise. Now I can put something like in this patient about 18 to 20 screws with the help of this navigation and correct the spine which was tilted on that side to make it completely straight without having any screw being misplaced or any screw which is touching the nerve or causing any irregularity. With the help of this navigation and neuromonitoring, you can achieve this kind of success. And last, what I want to say is pain management. Now, as I had said in the first, you need to make sure that the patient has a good post-operative pain, or even if the patient is someone who does not require a surgery, should have a good pain control. Now, we all go with the basic steps of giving him medicines and rest and some physiotherapy. But then, a lot of patients who have spinal problems require a better pain management than with these. So, you have patients who may have post-operative pain, post-chemotherapy pain. How do we manage them? We manage them with various kinds of blocks. These are totally non-invasive methods. In fact, these are the first line of treating pain. We have root block, facet blocks, epidural blocks, various other blocks. These are all done as daycare procedures. These do not require any admission. It's within 15 minutes to 45 minutes the entire procedure. The patient is completely safe during the surgery and can get complete relief of pain also. Just to highlight you.
MR काढल्यानंतर काय त्रास आहे तो समजलं तेव्हा माझा उपचार करण्यासाठी निखिल सरावी उपचार केला. त्याच्यात मला मानक्यात माझे इंजेक्शन दिला आणि एक महिना झालेला उपचाराला आणि मला 1 महिन्यामध्ये 100% बरं केलेलं आहे.
So this is 1 month after the surgery, 1 month after the pain management block that I have given to this patient, root block, and you can see that with his old merge is saying that is completely pain free. Now he has we don't require these people to come for regular follow-ups. We call them once in a year. They are almost completely pain free. They remain pain free for a very good period of time, and about 70 to 80% of slip discs or nerve compressions can be managed through this technique. The other one is vertebroplasty, kyphoplasty, stentoplasty. Now what is this? We know that osteoporosis is a silent killer. You get a lot of people who come after the age of, above the age of 50, 55, who have weak bones, who may have bones which may not be able to withstand the day-to-day activities, and especially ladies post-menopause, or who may have some patients who may have some onco treatment ongoing, they may have osteoporosis, and these lead to osteoporotic fractures. Now, osteoporotic fractures are the worst which present to you. The patient cannot move about, cannot get up very easily, and usually the age group is somewhere above 65. So having a 65-70-year-old at home who requires at least 24 hours some nursing care becomes very problematic in a city like Bombay. What we do is we do vertebroplasty, kyphoplasty or stentoplasty. This is where we are putting cement just through a small one incision without any stitches also. We put this entire stent into that fractured bone, and into that stent we put in cement. Now what we achieve through this stent and through the cement is, the cement gives a kind of heat and the stent gives kind of a rigidity that prevents the bone from getting collapsed and because it prevents the bone from getting collapsed and the heat gives a good kind of pain relief, the patient can be mobilized same day after the procedure. In fact, we discharge the patient same day in the evening after the procedures are done, and they can go home sometimes back to their activities, I mean their normal walking within the house within 8 to 10 days. So this is the kind of results that we can achieve with procedures like vertebroplasty, kyphoplasty or stentoplasty. So in short, what we can say in the last is, spine surgery is evolving. It is evolving, I would say, not in a decade, in every 5 years. It has evolved tremendously from where I started my training, where I was doing open surgeries, to now where I am doing endoscopic and minimal invasive surgeries with navigation and neuromonitoring. I have all the equipments with me myself, but it has evolved tremendously. We know that more knowledge and with more technical know-how, we can do more precise and more safer surgeries. Why we want to offer more safer and precise? Because there is a phobia of spine surgeries. People still somehow, they are not completely convinced. We know that there is a subset of patients who require surgeries, and if you can offer them these surgeries at the proper time and they opt for it, you can give a very good precise outcome from them. Outcomes are definitely more precise. Thus, it is very necessary for us to explain to the patients that what are the various technologies available. It's not like, okay, if I'm saying you require a spine surgery, it will be the same what everyone is going to do. You can undergo minimal invasive spine surgery, you can undergo endoscopic spine surgery, there are various ways to put screws, you can undergo complex surgery also, and the outcome can be more safer and precise for them. So it is very necessary for us to counsel the patients, and you as a family physicians also to explain to the patient that you should not have a fear of surgery if it is required and if the outcome is going to be precise. Thank you. So I think I finished in time, even if I started late.
Thank you so much, sir. It is very important to have perfect time management, and sir really made it up. And what he truly said is correct. The inhibitions what patients have is post-surgery, the pain and all. So I'm sure, we, when as family physicians are clear with our doubts, we can help our patients to understand more better. Thank you so much, sir, for such an insightful and wonderful educative lecture, sir. Thank you. Can I call upon both our chairperson to felicitate Dr. Nikhil, please, sir. A big round of applause for sir for his wonderful lecture. And seriously, science has evolved so well. Thank you, ma'am. Thank you so very much, ma'am. Sir, we would like you to felicitate our two chairpersons. Yes, sir. Yes, sir. A big round of applause once again. Yes. Yes, yes. I'll help you, sir. Yes, yes. This is for, yes, Rajni ma'am. She is also Rajni. There was this, identity crisis. When I called out, I should have said the husband's name. But anyways, we have the pleasure to have both Dr. Rajnis on this stage. Thank you, ma'am. Thank you. Over to the next speaker. Now, this lecture, first. Oh, how could I kind of miss on to the lucky draw? Sir, we are not allowing you to go. Sir, we can deal with the laptop later. We have our lucky draw right now. Yes, yes, sir. नहीं सर आपके लिए नहीं है हमारी ऑडियंस जो आपको पेशेंटली सुन रही है The first lucky draw, gold coin. Sir, you will have to do the honors to find out the name. Oh my God, we have Dr. Rajendra Khatavkar, sir. Oh, yes, sir. Yes, sir. आप उधर ही बैठिए, sir. Gold coin मिल गया. So next one is the wristwatch. Dr. Kusum. It's 48. The name is not very clear on the... Is it Kusum Bafna? It's 48. If she's not around, we move on to another lucky one. आप लोग सोचते होगे ना चलो अच्छा है नहीं है हमारा तो नंबर लगेगा. Yes, one more. I hope she doesn't come somewhere from the far. Dr. Kishan Kapte, 64. All double-digit numbers are coming. Oh, he's there. And the last one, the earphone. We have Dr. Vijay Shinde, 72. We have Dr. Vijay Shinde. Yes, sir. Yes, he's there. Thank you so much, sir. Thank you, sir. Over to our next speaker. Our next speaker is Dr. Bhupesh Patil. He is one person who, from the roots of primary care to heights of specialization, Dr. Bhupesh Patil has walked a journey of dedication, learning, and compassion, evolving from general physician to a consultant, inspiring so many of us, and so many doctors have joined him. बोला जाता है ना, एक चिराग से शुरू हुई थी रोशनी की राह, आज कारवा बना है, जगमगाता है जहां. He, along with him, has actually so many doctors joined him. So more about Dr. Bhupesh Patil. He is a physician and intensivist from Dhule, practicing since 2015. He is also the founder of Health OK Hospital, a medical startup which is already associated with more than 150 general practitioners across Dhule, Jalgaon, Nasik, Nandurbar district, and has recently even expanded to Thane. Welcome, sir. And where more than 30 doctors have joined his startup. Along with this, we have two chairpersons. Our two chairpersons for today are Dr. Arun Patil and Dr. Ankush Yadav. Can we have them on stage? Dr. Arun Patil and Dr. Ankush Yadav, sir. Yes. Welcome, sir. About Dr. Arun Patil, he is a BMS and a gynecologist with 40 years of experience practicing since 1977. 2014, he was the HOD, and in 2017, he was the principal of SMBT College, Igatpuri. He was a teacher in R.A. Podar College. He also plays mouth organ, harmonium. He's a national level player. You know, we doctors have so many talents, just not medicine, versatility at its core. We also have Dr. Ankush Yadav, sir, former head Podar Ayurvedic Cancer Research Institute, Worli, Mumbai, and National Research Institute for Ayurveda, Gwalior. CCRAS, Delhi Ministry of Ayush, Government of India, authored more than 60 books in Marathi, Hindi, and English, and more than 300 articles published in newspapers and felicitated by many awards. We have such esteemed doctors amongst us. Thank you, sir, for sparing your special time today. Can I have Dr. Bhupesh Patil on stage? Sir, over to you, sir. Sir, you are comfortable with this, whatever.
Yes, yes. Good morning, all. I am Dr. Bhupesh Patil. Good morning, sir. I am Dr. Bhupesh Patil, a physician and intensivist from Dhule. First of all, I would like to thank NIMA Mumbai for this great opportunity so that I can interact with all this lovely audience, our fellow doctors, colleagues, our general practitioners. My topic is little different. It's a journey from general practitioner to a consultant level practice. And I'm here to present my healthcare startup, which is Health OK Hospital, and I'm the founder of this healthcare startup. So, what is health? We all know. As a doctor, we all know what is health, a physical and mental well-being. But what should be an ideal healthcare system? Can we say that? Can we answer? It is a long unanswered question. What should be an ideal healthcare system? Healthcare system कशी पाहिजे हा एक मोठा प्रश्न आहे जो आपण बराच वेळा स्ट्रगल करतो आणि ती इम्प्रूव्ह करण्यासाठीच आपण अशा सीएमईज ऑर्गनाइज करतो की आपल्या सगळ्यांची क्वालिटी इम्प्रूव्ह व्हायला पाहिजे. सो हेल्थ केअर सिस्टीम कशी पाहिजे? इट शुड बी स्टँडर्ड, इट शुड बी एथिकल, इट शुड बी efficient, and at the same time it should be economical, right? What is standard healthcare system? Standard healthcare system means we all should follow standard, universally accepted medical protocols whenever we deal with our patients. So we always follow right from district place to taluka place, even at remote villages, we should follow standard healthcare protocols.
but that doesn't happen all the time. Even in metro cities, people struggle to follow standard healthcare protocols. Our healthcare system should be ethical. Ethical means what is required, जे पाहिजे तेच व्हायला पाहिजे. कॉस्ट म्हणजे साध्या भाषेत कॉस्टोकॉन्ट्रेटिसच्या पेशंटला टुडिको करायची गरज नसेल तर करायची गरज नाही. सो आवर हेल्थ केअर सिस्टम शुड बी एथिकल. तोही एक मोठा प्रॉब्लेम आहे जो होत नाही. ॲट द सेम टाइम आवर हेल्थ केअर सिस्टम शुड बी efficient. Efficient means we should improve the quality of health. We should improve the quality of lifestyle of our patient. पण काय होतं, पेशंट्स गोळ्या घेतात पण काहीच फरक पडत नाही, असं बऱ्याच वेळा होतं. सो आवर हेल्थ केअर शुड बी स्टँडर्ड, एथिकल, एफिशियंट अँड ॲट द सेम टाइम इट शुड बी इकॉनॉमिकल. इकॉनॉमिकल मीन्स इट शुड बी इझी ऑन आवर पॉकेट्स. आणि all over India, what happens as we go from district place to taluka place to villages and remote places, this standard, ethical, efficient and economical healthcare system is not followed. And surprisingly, even metro cities like Mumbai, Pune, Bangalore, people don't have an access. Our patients don't have an access to this standard healthcare system. In metro cities, economical healthcare system is a challenge. Ethical healthcare system is a challenge most of the time in metro cities, and even at the metro cities, standard medical practices are generally not followed everywhere. Okay, and that's why आम्ही हेल्थ ओके हॉस्पिटल हे आमचं स्टार्टअप घेऊन आलोय. आम्ही काय करतो तर हा लॅक्युना भरून काढण्यासाठी आम्ही डॉक्टरांसोबत आणि लोकांसोबत एकत्र येऊन काम करतो. आता ह्या हेल्थ केअर सिस्टीममध्ये प्रॉब्लेम काय तर डॉक्टर साईड्स प्रॉब्लेम आणि पेशंट साईड्स प्रॉब्लेम. पण आज आपण आता इथं सगळेजण डॉक्टर्स आहोत, तर आपण मेजॉरिटी डॉक्टरांना काय प्रॉब्लेम येतात तेच आपण डिस्कस करू. आपण सगळेजण इथं ऑल BMS आयुर्वेदाचार्यज आहात, राईट. मला एक प्रश्न आहे, आपल्यापैकी किती लोक आहेत जे प्युअर आयुर्वेदिक प्रॅक्टिस करतात? प्लीज रेज युअर हँड्स. प्युअर आयुर्वेदिक प्रॅक्टिस. फर्स्ट ऑफ ऑल आय वुड लाईक टू कॉंग्रॅच्युलेट ऑल ऑफ यू. पण हा नंबर असाच आहे की आउट ऑफ 100 5, 7 एवढेच लोक आहे जे प्युअर आयुर्वेदिक प्रॅक्टिस करतात. ओके, नो इश्यू. आता मला सांगा, आपल्यापैकी किती लोक आहेत जे ॲलोपॅथिक प्रॅक्टिस पण करतात? प्लीज रेज युअर हँड्स. प्लीज मोकळ्या मनाने सांगा. मला ते पाहिजे की तुम्ही सगळ्यांनी स्टँडर्ड प्रॅक्टिस करायला. सो जर का बघितलं तर आउट ऑफ 100 90% डॉक्टर्स जे आयुर्वेदाचार्य आहेत ते ॲलोपॅथिक प्रॅक्टिस करतात, राईट. ओके, आणि करायला पण पाहिजे कारण की दॅट इज अ नीड ऑफ टाईम. तर पण येस सर आय डोंट माइंड. येस दॅट्स व्हॉट आय नो सर, आय नो. Sir, I am not at all saying, I am welcoming everyone, but who are practicing Ayurvedic, pure Ayurvedic practice, I am. Yes sir, I know. My friends are Ayurvedic doctors. Okay, I will finish my topic. Okay. सर काय होतं आता जसं सरांनी सांगितलं तर आपण असं करूया, एक डॉक्टर जे माझ्यासोबत मी MBBS केलं, माझ्यासोबत माझे 2 बेंचमेट्स होते, आम्ही 3 चांगले बेस्ट फ्रेंड होतो. पण ते दोघं आयुर्वेदिक कॉलेजला गेले, पोद्दार, जे माझ्या नायर हॉस्पिटलपासून 10 मिनिटाच्या अंतरावरच होतो. सो वी आर स्टील बेस्ट फ्रेंड्स. तर मी आता इथं आयुर्वेदिक डॉक्टर बसले म्हणून त्यांच्याबद्दलच बोलतो. आपण एक जर्नी समजून घेऊ की काय होतं. जसं आपण फर्स्ट इयरमध्ये एंटर करतो इन आयुर्वेदिक colleges, main motto is to teach them Ayurvedic practice, and even then allopathic practices are taught. I am not saying it's not taught, पण ज्या लेवलला MBBS कॉलेजला आयुर्वेदिक प्रॅक्टिस MBBS allopathic प्रॅक्टिस शिकवली जाते त्या लेवलला ते होऊ शकत नाही, कारण की मेन मोटो इज टू टीच देम आयुर्वेदिक प्रॅक्टिस. आणि मग साहजिकच काय होतं की माझे जे मित्र होते त्यांनी हे शिकण्यासाठी आपण प्रायव्हेट सेटअप जॉईन करतो. आणि माझ्यापेक्षा 5 वर्ष आधी मी तरी इंटर्नशिपपर्यंत कुठे बाहेर जॉईन केलं नव्हतं, पण माझ्या मित्राने सेकंड इयरपासून एका ठिकाणी टू गेट अन एक्सपिरियन्स आपण प्रायव्हेट सेटअप चालू करतो. पण त्या प्रायव्हेट सेक्टरमध्ये आपण जे करण्यासाठी जातो ते खूप कमी वेळा होतं. मोस्ट ऑफ द टाईम जेव्हा आपण प्रायव्हेट सेटअप जॉईन करतो, आपली कामं असतात पेशंटच्या ऑर्डर्स टाकणे, दुसरं असतं लॅब सेंड करणे, लॅब ट्रेस करणे, थर्ड टाईम बऱ्याच वेळा पेशंट्सकडनं बिलिंग वगैरे आपण करतो, फोर्थ बऱ्याच वेळा लो जी सी एक्सप्लेन करणं हे आपल्या डॉक्टरांचं काम असतं. पण ज्या अपेक्षेने आपण जातो ते क्लिनिकल डिस्कशन खूप कमी होतं, खूप रेअरली होतं. जर का आपण 8 तास 10 तास तिथं काम करत असू, तिथून हार्डली ते ॲक्च्युअल क्लिनिकल डिस्कशन होतं. खूप कमी वेळा असं होतं की डॉक्टर्स आपल्याला सांगतात की या पर्टिक्युलर पेशंटला मी पर्टिक्युलर मेडिसिन का दिली. खूप कमी वेळा असं होतं की या पर्टिक्युलर पेशंटला त्या लॅबमध्ये अबनॉर्मल काय आहे ते मला पर्टिक्युलर सांगा, किंवा ECG बद्दल खूप कमी डिस्कशन होतात. आता मला एक प्रश्न आहे, आपल्यापैकी किती लोक डेली बेसिसवर CBC करून घेतात? CBC कम्प्लीट ब्लड काउंट ऑलमोस्ट डेली एव्हरीवन. ओके, मला आता एक प्रश्न आहे, आपल्यापैकी किती लोकांच्या क्लिनिक्समध्ये ECG मशीन्स आहेत? प्लीज रेज युअर हँड्स. ठीक, आता मला सांगा CBC आणि ECG दोन्ही एकाच लेवलचे इन्व्हेस्टिगेशन्स आहेत. दोघांची किंमत 300 रुपये 250 रुपये कसंच काहीतरी असेल. बोथ आर बेसिक्स. पण आपण CBC करतो, आपण ECG हार्डली करतो की नाही. म्हणजे मला ते इंटरॅक्शन अपेक्षित आहे की नाही. आणि जर का प्रश्न आम्ही जर अभ्यास केला आहे, परत 100 पैकी हार्डली 5 डॉक्टरांकडे ECG मशीन्स अवेलेबल असतात. आणि इट इज ॲक्च्युली अ बेसिक इन्व्हेस्टिगेशन. पण जसा ECG आला तो ECG न वाटता आपल्याला चक्रव्यूह वाटायला लागतो की जायचं काढायचं कसं ते माहिती आहे, काढल्यावर काय करायचं तो प्रॉब्लेम असतो. आणि अशा प्रकारे हा डॉक्टरांचा प्रॉब्लेम आहे, ज्यामुळे एक स्टँडर्ड एथिकल एफिशियंट आणि इकॉनॉमिकल हेल्थकेअर सिस्टीम आपण आपल्या पेशंट्सला डिलिव्हर करू शकत नाही. याच्यासारखे अजून बरेचसे उदाहरण आहेत, पण मे बी ECG आणि CBC का म्हटलं तर हे कॉमन आहे. मग नेक्स्ट आजार का आपण बघितला तर हायपरटेन्शनचे पण प्रोटोकॉल. आता मी काय असं नाही म्हणत की असंच होत असेल, पण मी ऑब्झर्व जे केले मी सांगितलं. हायपरटेन्शनचे प्रोटोकॉल स्टँडर्ड प्रोटोकॉल्स फॉलो होत नाही. बऱ्याच वेळा टेल्मिसॅटिन द्यायचं का मेटोप्रोलोल द्यायचं का ॲम्लोडेपिन द्यायचं, ह्याचं उत्तर कसं असतं, ह्या पेशंटला टेल्मिसॅटिन का तर मागच्या पेशंटला बीटा ब्लॉकर दिलं होतं म्हणून. जर का हस्बंडला टेल्मिसॅटिन दिलं असेल तर वाईफला द्यायचं नाही, कारण की त्यांना वाटतं डॉक्टर एकच गोळ्या दिल्या जातात. आणि हे का मी माझ्या डॉक्टरांसोबत मी खूप ग्राउंड लेवलला जाऊन काम केलं आहे. आपले हायपरटेन्शनचे प्रोटोकॉल व्हॉट शुड बी डन पेक्षा व्हॉट पेशंट थिंक्स वी शुड डू असं केलं जातं. आणि जी भीती हायपरटेन्शनची आहे त्यापेक्षा जास्त भीती तर डायबिटीजची असते, की पेशंटची शुगर जर का 275 325 असेल, एक गोळी आपण आरामात देतो नक्कीच, पण सेकंड मॉलिक्यूल ॲड करताना थोडंसं धाकधूक वाटते आणि पहिली भीती वाटते की हायपोग्लायसिमिया नको होऊन जायला. आणि मग साहजिकच हे पेशंट आपण बेसिक सुरुवातीच्या 1-2 गोळ्या देतो आणि नंतर मग जर का नाही आपल्या मनासारखं झालं किंवा रिझल्ट नाही आले तर हे पेशंट रिफर केले जातात. मला रिफरलाही प्रॉब्लेम नाही आहे. प्रॉब्लेम असा आहे की जर का मी 10 लोकांना सांगितलं की बाबा तुम्ही कन्सल्टंटकडे जा, ते जातील का सगळे? नाही, त्यातले 5 लोक जाणारच नाही आहेत. आणि ह्यामुळे हे लोक पण हेल्थकेअर सिस्टीमपासून दूर फेकले जातात. हा आपल्या डॉक्टरांचा प्रॉब्लेम मला पाहिला आणि तो सॉल्व्ह करण्यासाठीच आम्ही हेल्थ ओके सिस्टीम चालू केली. आता थोडंसं एक पॉईंट मी पेशंट साईडने बघतो की एक साधी गोळी, आता मी तर राहतो धुळ्यात, डिस्ट्रिक्ट प्लेस आहे, पण तिथून जर का 15 किलोमीटर 20 किलोमीटर 40 किलोमीटर जर का एखादा लोक राहत असतील आणि त्यांना कन्सल्टंटला दाखवायचं असेल तर सकाळी लवकर निघावं लागतं. 8 वाजता 10-11 वाजता OPD मध्ये येतील, 12-1 वाजता नंबर लागला तर ECG लॅब इन्व्हेस्टिगेशन करून डॉक्टर परत 3 वाजता कन्सल्टंटना बघतात आणि एक गोळी लिहून देतात, मे बी ती टेल्मिसॅटिन बीटा ब्लॉकर किंवा डायबिटीजची गोळी, आणि ती गोळी लिहून पेशंट परत येतो. नेक्स्ट टाइम सांगितलं असतं की परत पुढच्या महिन्यात दाखवा. पेशंट म्हणतात की सर इच्छा तर नक्कीच आहे, पण परत एक दिवस परत 2000-4000 रुपये खर्च करणं मला प्रत्येक महिन्याला शक्य नाही. आणि मग हे पेशंट डायरेक्ट 6 महिन्यांनी 8 महिन्यांनी मे बी 1.5 वर्षांनी होतात. का? कारण की दिस हेल्थ केअर सिस्टीम इज नॉट ॲक्सेसिबल टू देम, इट इज नॉट इकॉनॉमिकल, दॅट्स वाय पेशंट्स डोंट फॉलो. आणि हा दुवा भरून काढण्यासाठीच हेल्थ ओके हॉस्पिटल हे आमचं स्टार्टअप काम करतं. सी अनफॉर्च्युनेटली वी कांट सेंड ऑल कन्सल्टंट्स टू एव्हरी प्लेस. तालुका प्लेसला प्रत्येक ठिकाणी असेल तसं गॅरंटी नाही, विलेजेसला तर अजून पुढचे 10 वर्ष जाणार नाही आहेत. पण what we thought ki why not to upgrade and enhance the skills of all our general practitioners who are actually licensed general practitioners. So we always associate with authentic general practitioners ज्यांना गव्हर्नमेंटनेच परमिशन दिली आहे, ज्यांना ॲलोपॅथिक प्रॅक्टिस करायची परमिशन दिली आहे, असे BMS डॉक्टर्स, BHMS डॉक्टर आणि काही प्रमाणात BOMS डॉक्टर यांना त्यासोबतच हेल्थ ओके असोसिएट करतं. ज्यांना लायसन्स नाही अशा एकही क्वॅक डॉक्टरसोबत हेल्थ ओके असोसिएट करत नाही. दॅट्स आवर फर्स्ट पॉईंट. ओके, आता हे होतं कसं ते पण मी तुम्हाला सांगतो. तर नॉलेज शेअर करण्यासाठी पहिल्यांदा जे आमचे टॉपिक्स होतात हे इझिली समजतील, साध्या भाषेत समजून शकेल, इझी टू अंडरस्टँड, इझी टू एक्झिक्यूट असे आमचे प्रोटोकॉल बनलेले आहेत. आणि हे प्रोटोकॉल आम्ही आमच्या डॉक्टरांना सांगतो. आता हे लेक्चर्स ऑफलाईन पण होतात, ऑनलाईन पण होतात. आणि आमचे जेही आता 150 सेंटर्स चालू आहेत, तर प्रत्येक सेंटर्समध्ये आम्ही ऑफलाईन लेक्चर्स घेतलेत, ॲट द सेम टाईम ऑनलाईन सेंटर्स पण आहेत. जर का एखादं लेक्चर मिस झालं, जे कधी कधी होतं बऱ्याच वेळा, तर ह्या सगळ्या डॉक्टरांना एक ऑनलाईन प्लॅटफॉर्म आहेत त्याच्यामध्ये हे लाईफ लॉंग हे लेक्चर्स ते कधीही परत रिवाईज करू शकतात. मी गॅरंटी देतो आमचे प्रोटोकॉल इतके सोपे आहेत, रिव्हिजनची गरजच पडत नाही. पण नवीन लेक्चर्स येत असतात म्हणून आम्ही हे ऑनलाईन ॲप पण दिलेलं आहे. सो वी हॅव ऑनलाईन लेक्चर्स, वी हॅव ऑफलाईन लेक्चर्स, ॲट द सेम टाईम वी हॅव ॲन ऑनलाईन ॲप. आमचा जेव्हा डायबिटीज आणि हायपरटेन्शनचा टॉपिक होतो तेव्हा मला 100% माहिती आहे की ज्या लेवलपर्यंत सध्या प्रॅक्टिस होते आपले जनरल प्रॅक्टिशनर, ते त्याच्या 10 टाइम्स 15 स्टेप्स अहेड और 20 स्टेप्स अहेडपर्यंत त्यांचं स्किल वाढतात किंवा नॉलेज वाढतं. पण जर का पेशंट समोर आला आणि एखाद्याची शुगर 235 आहे, तर वाटतं ना की ही गोळी सरांनी तर सांगितलं डॉक्टरांनी की ह्या प्रोटोकॉलनुसार द्यायला पाहिजे. पण पहिल्यांदा सुरुवातीला जेव्हा आपण आधी डायबिटीजचे पेशंट असं हँडल केले नसतील तर थोडंसं धाकधूक वाटते. ॲट दॅट टाईम हेल्थ ओके हॉस्पिटल 24 तास बॅकअप पण देतो. सो आमच्या डॉक्टरांना OPD बेसिसवर पण बॅकअप मिळतं, डे केअर लेवलला पण प्रॅक्टिस करतात तेव्हा पण बॅकअप मिळतं. आणि कधी जर का कोणी IPD करत असेल त्याही लेवलला आम्ही त्यांचा बॅकअप देतो. सो लॉजिक इज जेव्हा डायबिटीजचे पहिले 10 पेशंट बघायचे आहेत तेव्हा थोडी धाकधूक वाटते की ही गोळी देऊ का नको. पण जेव्हा ते डिस्कस करून विचारलं जातं आपण सांगतो की सर गो अहेड. सो आफ्टर 10 or 20 पेशंट्स पहिल्या 2 गोळ्यांबद्दल डाऊट राहत नाही की अरे हे तर द्यायचंच आता काही कळत प्रॉब्लेम नाही. जसे तुम्ही आपोआप जाऊन पुढे 30 पेशंट 40-50 पेशंट हँडल करतात, पुढच्या परत 2 गोळ्यांबद्दल तुम्हाला डाऊट राहत नाही. ओके, अँड जेव्हा तुम्ही हेल्थ ओके असोसिएट होऊन 100 पेशंट बघतात, मला 100% माहिती आहे की डायबिटीजचे बरेचसे लूपहोल जे तुमचे राहून गेले होते इतके वर्ष शिकायचे ते सगळे निघून जातात. आणि दॅट्स हाऊ नॉलेज अँड एक्सपिरियन्स इज ट्रान्सफर्ड. इट्स नॉट ओनली वन टाईम लेक्चर्स, these are repeated lectures, easily to understand, easy to execute. We make sure की ते तुमच्यापर्यंत पोहोचले. We start from scratch, physical examination to advanced topic. आणि ह्या प्रत्येक गोष्टीमध्ये तुम्हाला बॅकअप दिला जातो. आणि मग जसे तुम्ही पेशंट बघत जाता तुमचा स्किल आणि एक्सपिरियन्स वाढत जातं. दॅट्स हाऊ वी डिलिव्हर स्टँडर्ड, एथिकल, एफिशियंट अँड इकॉनॉमिकल हेल्थ केअर सिस्टीम टू आवर पेशंट क्लोज टू देअर हाऊस. आता त्या जे पेशंट 30 किलोमीटर दूर डिस्ट्रिक्ट लेवलला जात होते त्यांना त्यांच्या घराच्या बाजूलाच जे ऑथेंटिक BMS डॉक्टर्स आहेत त्यांच्या थ्रूच एक हेल्थ केअर मिळत होती. जे पेशंट आधी रिफर केले जात होतात ते पेशंट रिफर कमी होतात. तरी कधी त्या स्कोपच्या बाहेर पेशंट येतात ते रिफर करायला हरकत नाही, ते कुठेही पाठवा. पण जोपर्यंत तुम्हाला मॅनेज करता येते बिलकुल मॅनेज करा. आणि ते मॅनेजमेंट करण्यासाठी हेल्थ ओके प्रत्येक स्टेपला तुम्हाला मदत करते. सो स्टँडर्ड, एथिकल, एफिशियंट हेल्थ केअर सिस्टीम is delivered to our patient through their trusted doctors who are and who will be practicing close to their house for next 30 to 40 years. And that's how we have improved. मागच्या 2 वर्षांमध्ये धुळ्यापासून हा चालू झालेला प्रवास धुळे, जळगाव, नाशिक, अमळनेर, मालेगाव, शिरपूर, दोंडाच्या करत रिसेंटली मार्चमध्ये ठाण्यापर्यंत पोहोचला आहे. आणि ठाण्यामध्ये पण ऑलमोस्ट क्लोज टू 30 डॉक्टर्स आमच्यासोबत जॉईन झालेत आणि त्यांना तो फरक दिसला आहे. आमचं नेक्स्ट विजन आहे मुंबई. कारण की मुंबईमध्ये आलं तर आम्हाला ऑल ओव्हर महाराष्ट्र जाणं सोपं आहे. मुंबईमध्ये जे लेक्चर्स होतील ते मोस्ट प्रोबॅबली जी नेक्स्ट बॅच असेल आम्ही दादरमध्येच कंडक्ट करू, कारण की दॅट इज अ सेंट्रल प्लेस, जे सगळ्यांना येणं सोपं आहे. माझं आग्रह असेल ऑफलाईन लेक्चर अटेंड करा. ऑनलाईन तर आहेतच, मला तेही गॅरंटी आहे की काही लोक ज्या ठिकाणी आम्ही पोहोचलो तिथेही लोक ऑनलाईन करत आहेत, पण जिथे जर का आम्ही पोहोचत असू तर तुम्ही ऑफलाईन लेक्चर्स अटेंड करा. याचे चार्जेस आहेत, नक्कीच त्याचे चार्जेस आहेत, बऱ्यापैकी आम्ही अमाऊंट घेतो त्याची अराउंड 30,000 to 40,000 आमचे चार्जेस आहेत. पण मी आज काहीच मागत नाही आहे. मी नेक्स्ट 1.5 month एक टॉपिक तुमच्या सगळ्यांसाठी घेणार आहे. येस सर, आय विल फिनिश. एक टॉपिक तुमच्यासाठी घेणार आहे, फिजिकल एक्झामिनेशन. त्याचे सगळे लेक्चर्स दादरमध्येच कंडक्ट केले आम्ही. त्याचा तुम्ही सगळ्यांनी फक्त तुमचा कॉन्टॅक्ट नंबर आमच्या स्टॉलवर द्या, म्हणजे आम्हाला ते सगळं कोऑर्डिनेशन करता येईल. चार्जेस ह्याचे फक्त 1,000 ते 1,500 रुपये असणार आहेत पुढच्या 6 सेशनसाठी. दुपारी किंवा रात्री किंवा समटाईम्स अर्ली इन मॉर्निंग तुमची ओपीडी प्रॅक्टिस न मिस करता आम्ही हे सेशन कंडक्ट करू. आणि 6 लेक्चर्स ऐकल्यानंतर फिजिकल एक्झामिनेशन हा टॉपिक कव्हर झाल्यानंतरच तुम्ही ठरवा की तुम्हाला हेल्थ ओके सोबत जॉईन व्हायचं आहे का नाही. ती 1,000, 1,500 किंवा 2,000 रुपयाची रिस्क असेल, मी नक्कीच म्हणेल की हा हे सगळे लेक्चर्स ऐका. ऑनलाईन ऑफलाईन दोन्ही अवेलेबल असेल त्यांच्यासाठी, आणि त्याच्यानंतरच तुम्ही ठरवा. आणि हेच प्रेझेंटेशन करण्यासाठी मी इथं आलो होतो. ॲक्च्युली आय वॉज एक्सपेक्टिंग मोर टाईम, पण जे मला सांगायचं आहे हेल्थ ओके हॉस्पिटल्स हे स्टार्टअप तुमच्यासोबत मिळून तुमच्या आजूबाजूच्या सगळ्या लोकांपर्यंत जे आमचं मिशन आहे टू डिलिव्हर अ स्टँडर्ड एथिकल एफिशियंट and at the same time economical healthcare all over India. We started with Maharashtra, we'll go beyond Maharashtra. Thank you. Yes sir.
हा माझ्या सर्वात जवळच्या क्लोजेस्ट मित्राच्या मुलाचा मित्र आहे. नंतर प्रत्येक पॅथीच्या लिमिटेशन्स आहेत. आणि आत्ता दुबेवार सरांनी तुमचं जे काही बोलणं झालं त्याच्यावरनं थोडंफार सांगायचं आहे. मी इंटिग्रेटेड बॅचचा स्टुडंट आहे. आयुर्वेदाच्या ट्रीटमेंटनं आमचे एक गुरु होते अंतरकर सर, त्यांनी मायस्थेना ग्रेव्हिस क्युअर केलेला आहे. आणि तो असा आहे, तो आजही हयात आहे, डॉक्टर देवरे. आणि त्यानं 200 गोळ्या कांपोच्या आणून ठेवल्या त्या सुसाईड करण्यासाठी. ही वॉज डायग्नोस्ड कन्फर्म. आणि त्यावेळेला त्यांनी सांगितलं, ते म्हटले मी 1-2 दिवस ग्रंथ चालतो आणि तुला औषध देतो. आणि त्यांनी कैशोर गुगुळ दिलं आणि तो 2 वर्षामध्ये ॲब्सोल्युटली नॉर्मल झाला. आजही तो आहे अगदी. आणि त्यांना सांगितलं माझा पुनर्जन्म झालेला आहे असा. एक अमिल कंठवार सर म्हणून नांदेडचे आहेत, ते युरेथ्रल स्ट्रिक्चर त्यांचे 3,000च्या वर पेशंट त्यांनी क्युअर केलेत. एक नवा पैसाही घेत नाहीत. आणि प्रोलॅक्टिन लेवल वाढलेले बॉम्बे हॉस्पिटलमध्ये कन्फर्म झालेलं 3 वर्ष ब्रोमोक्रिप्टिन घेऊन सुद्धा लेवल्स खाली येत नव्हते. त्यावेळेला पोद्दारमध्येच ट्रीटमेंट दिली. भल्लातक तैल नस्य आणि अद्रक स्वरस नस्य हे देऊन 3 महिन्यामध्ये त्यांच्या लेवल्स नॉर्मल झाल्या आणि कन्सिव्ह झाल्या. ही आयुर्वेदाची खासियत आहे. हां नाही, इव्हन युट्रेन ट्यूब ज्या ह्या असतात बंद असतात त्या उत्तर बस्ती देऊन त्या ओपन पण झालेल्या आहेत. अंकुश जाधव थोडं बोलतील, कारण
ह्याच्यावरती आता आयुर्वेदिक इम्युनिशन मेडिसिनवरती माझं पुस्तक पुढच्या आठवड्यात प्रकाशित होतं आहे. त्यामध्ये काही सफल चिकित्सा सुद्धा ज्या फार कॉम्प्लिकेटेड केसेस होत्या त्यांचं सुद्धा संपूर्ण मी डिटेल्स दिले आहे. आणि अंतर्गत सरांच्या अंडर मी होतं, त्यामुळे 60% फॉर्म्युले त्या पुस्तकात अंतर्गत सरांचे आहेत. अधिक काही माझे आहेत, कारण माझा शेवटी अनुभव वाढत चालला. पुस्तक पुढच्या आठवड्यात प्रकाशित होईल.
थँक्यू. नीमा कॉन्फरन्स. या शो सर.
मला एवढंच म्हणायचं की हेल्थ ओके तुमच्यासोबत टीम अप होतं आहे. मी कधीच तुम्हाला असं म्हणणार नाही की येस आयुर्वेदिक नक्कीच. मी उलट तुम्हाला तेच म्हणतोय की डोंट जस्ट stay at general practice level. We are going to take you towards consultant level practice. माझं एकच टार्गेट आहे की ज्या लेवलची प्रॅक्टिस मी माझ्या ओपीडी मध्ये करतो त्याच लेवलची प्रॅक्टिस. सी आय एम हिअर टू टीच यू ऑलोपॅथिक. सो ज्या लेवलची प्रॅक्टिस मी माझ्या ओपीडीत करतो त्याच लेवलची प्रॅक्टिस या प्रत्येक डॉक्टरने त्यांच्या ओपीडीमध्ये करायला पाहिजे. स्टार्टिंग फ्रॉम फिजिकल एक्झामिनेशन, फिवर पेशंट, डायबिटीज पेशंट, हायपरटेन्शन पेशंट, इयरली इमर्जन्सी. त्यासाठी हे लोक काम करते. आय एम नॉट हिअर टू कम्पीट, आय एम हिअर टू associate and team up with all your doctors. Thank you.
Thank you so much, Bhupesh Patil sir. As we mentioned earlier, that we're going to have actually a literal, exchange of such wonderful thoughts. This is a live example. We have our seniors who are so proud of the medicines we are using, and the results are wonderful. He has been, in his clinical practice. It's an inspiration for all of us. Thank you, sir, for actually kind of, talking about us. And I would like you to felicitate our speaker, Dr. Bhupesh Patil, sir. Arun Yadav, sir, and Arun Patil, sir. Can I have? It was wonderful. Exchange of thoughts is very important. Really proud of it. Sir, Yanna there, sir. Yes. A big round of applause for our esteemed speaker. Thank you, sir. Sir? Yes. So we want you to felicitate our two chairpersons. Yes, I'll hold this. Yeah. Thank you so much, sir. Yes, it's a platform where you meet people also. Now can we have truly deserving the stalwarts of medicine. Thank you, sir. Thank you for gracing the occasion today. Thank you, sir. Thanks. Sir, for the lucky draw, again. Can we have the lucky draw? Sir, you will have to do the honors of, pulling out 3 lucky draws. The very first one, yes. नहीं तो फिर ना couple जोड़ी में आ जाते हैं. Shake it. Yes. Let's find out the next lucky winner for the gold coin. We have 4. Initially we were, triple digit, double digit. Now it's a single digit, 4. We have Dr. Pradyot Chauhan. Is he there? Not there? I hope he's not gone for the chai to miss the gold coin. He's there. Oh, he showed his hand. Second one is the wristwatch. We have 498. Oh my God, a very dear friend of mine, Dr. Anup Sharma. Yes. And the last one is the headphones. 387, Dr. Rani Yadav. Ravi Yadav, Dr. Ravi Yadav. So one more, audience को एक और मौका मिला अपना लक आजमाने का. So that's 251, Raghunath Dangi. Do we have him? तालियां हो रही मतलब है तो डन डील समझू. Where is he? Can I have his hand over? He's there. All right. Thank you so much, sir. Thank you, sir. Thank you. Yes, sir. Now, it's not a break. As we said that we are going to be awaiting the most wonderful and awaited event of NIMA. Now, let's talk about people who have been working tirelessly, relentlessly from past 3 to 4 months. So now what we're going to have next is the unveiling of the Souvenir, the magazine. And along with that comes the welcoming of all our special guest of honor, chief guest. I would say that till we have all the arrangements, you all have to be seated on the chair, because what will be coming next is something, a souvenir, which is going to be a memory and actually an heartfelt thanks to whoever has worked so relentlessly for this function to happen. And that is the form, that is the souvenir. एकदा ना तुतारी निमाच्या souvenir साठी वाजवा. Yes, 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 definitely. वो तो बनता ही है. Big round of applause for that. Thank you. I would be requesting all the NIMA committee members who have been functional and responsible for this wonderful event to be there on the stage. We'll be calling each one of them, but please be there. The members have to be ready. We'll be calling them. Once their name is taken, they have to come on the stage. Lovely. We have the most esteemed Dr. Natarajan with us. A big, big, big round of applause for him. We have Dr. Narendra Patil sir coming over. Such a wonderful, इतना भव्य वेलकम हो रहा है इन लोग का और फेटे में तो ये लोग सब इतने सुंदर लग रहे हैं. They truly deserve this. कौन से गाने हाथ याद आ रहे आज ज़मीं पर उतरे कितने सितारे हैं. एक्चुअली वो अजीम और शान शहंशाह वाली फीलिंग आ रही थी when these people were coming. तालियां ना बैकग्राउंड में गूंजनी चाहिए because they are really worth deserving it. मुझे ना एक बार ऑडियंस की तरफ से एक बड़ा उद्घोष चाहिए. कैन आई हैव दैट? लेट्स गो फॉर जय नीमा. अ लिटिल लाउडर. ठीक है ठीक है, खाना खाने के बाद वापस बुलवाती हूँ तो पूरा जोश के साथ आएगा. Now it's time to truly put the hard work and efforts of all the NIMA members who have been tirelessly working continuously since last 3-4 months. It's time to unveil the Souvenir, the magazine. The person who really requires a big mention is Dr. K.V. Phadatare sir, immediate past President NIMA MDB Mumbai. He has been really working for this. A big round of applause for sir. कोई भी काम, कोई भी टीम हार्मनी के बिना तो नहीं चलती. ग्रुप में या टीम में एक हार्मनी और एक समझ होना बहुत जरूरी है. तो let me actually kind of speak out the names of whoever are responsible for this. Very first, of course, our very president, Dr. Narendra Tripathi sir, the dashing president of NIMA Mumbai. Dr. Mangal Vaval sir, NIMA MDB Honorary Secretary. Dr. Sanjay Musale sir, NIMA MDB Joint Treasurer. Dr. Prasad Pawar sir, Conference Chairman. Dr. Namdeo Thorat sir, Conference Scientific Chairman. Dr. Yadav, President NIMA Mumbai Women Forum. Now, I request, of course, Prasad sir has welcomed our dynamic president. Sir, we are very, very proud, and under you, NIMA has done really well. जैसे बोला जाता है ना कि कोई भी इमारत की नींव मजबूत होनी चाहिए, तो यही हमारी नींव जो बेस है. Now, along with it, we will be now the most prestigious moment welcoming our respected chief guest, Dr. Natarajan sir. He doesn't require any kind of introduction. The welcome will be done by Conference Scientific Chairperson Dr. Namdeo Thorat sir and Dr. Shailesh Thorat ma'am. Of course, It is an immense, immense honor and privilege to meet someone whose success is matched equally by kindness and simplicity. We are fortunate to have such a personality with us. We are waiting for Sir's entry. सब लोग ना अभी पीछे की तरफ देखेंगे जब उनकी अच्छे से एंट्री हो रही है. I am actually no one to talk about Dr. Natarajan sir. He's in, yes, there he is. A big warm welcome to our chief guest, Dr. Natarajan sir. A big round of applause. Doctors, we want that. It is such a privilege to have him with us, to share the dais with him. It's a privilege, it's an honor. He is a true luminary in the field of ophthalmology. It is our privilege and honor to welcome our esteemed chief guest, a personality whose achievements inspire and whose presence add grandeur to this occasion. He is a stalwart in the field of medicine with his unmatched contribution in ophthalmology. Just few lines about Dr. Natarajan. Welcome, sir. So kindly welcome, sir. So we welcome you on the dais, sir. Please, sir. Grace the dais with your presence, sir. A big, big, big round of applause for Natarajan, sir. Thank you, sir, for giving your precious time today. We are no one to speak anything about Natarajan sir, but Dr. S. Natarajan, Padma Shri awardee, is an ophthalmologist with 35 years of experience. He has performed over 60,000 exclusive vitreous and retinal surgeries. Dr. Natarajan has trained more than 68 vitreoretinal surgeons across the globe and has presented more than 1,500 invited guest lectures globally. He is considered an authority in vitreoretinal surgery in the world and is keenly involved in academics and research for the prevention of blindness. रोशनी देना कितनी बड़ी बात है. He is invited to teach as well, to speak in prestigious universities across the globe and is He is invited to teach as well as speak in prestigious universities across the globe, and his work has been published in hundreds of international journals. His achievements are Padma Shri by the President of India himself. A big, big round of applause. Thank you, sir. Thank you for being here. President of all ocular trauma societies in the world and pioneer in retinal surgery in India. Now, I would call our guest of honor. We will be calling our guest of honor today, Dr. Raman Mungralkar sir. We are deeply honored to have a towering personality whose journey epitomizes excellence, integrity, and inspiration. We want doctors to welcome Dr. Raman. Yes, a big round of applause for him. About Dr. Raman. Now, Dr. Raman, as we said earlier, is the director of Ayush Maharashtra State since 2023. He is BMS MD Ayurved Kai Chikitsa from Government Ayurved College, Wazirabad, Nanded. Born, now this is very important, born in an illiterate family, but with his dedication and hard work, he completed SSC from ZP School, Gungrala. So this is the start, you know, the education in illiterate areas. So sir, you have been actually an example for all students or children in your area. His academic, clinical research and administrative experience is more than 25 years. He is an associate professor, reader, Department of Kai Chikitsa, professor and head of Kai Chikitsa, R.A. Poddar Medical College, Worli, Mumbai. He was the Dean, Government Ayurved College, Jalgaon, in February 2022. He is the principal investigator of many clinical trials, guided many PG scholars, postgraduate guides, published many articles in scientific journals, delivered guest lectures in many seminars and conferences. I would request Dr. Yes. No, we first need to felicitate. Na? I would request Narendra sir to kindly felicitate our chief guest. First and foremost, since we have all on the dais, let's first remember the god of medicine. Let's have Dhanvantari Pujan and Dhanvantari Stavan right now. Can we have all the dignitaries on for the Dhanvantari Pujan, sir? Sir, it's a request. Kindly honor us. We want all NIMA, committee members are for the Dhanvantari Stavan. We have Dr. Divya Jyoti Bhide, who is going to have the Dhanvantari Stavan.
नमामि धन्वन्तरिमादिदेवं सुरासुरैर्वन्दितपादपद्मम् लोकेशरारोग्यमृत्युनाशम् दातारमीशं विविधौषधीनाम् शङ्खं चक्रं जलौकां दधममृतघटं चारुतोद्भिश्च्युतरुभिः सूक्ष्मस्वच्छादिरुद्यां शुकपरिविलसन् मौलिमं भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यं वन्दे धन्वन्तरी तं निखिलगदवन प्रौढदावाग्निलीलं सर्वेऽपि सुखिनः सन्तु सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखमाप्नुयात् ॐ शान्ति शान्ति शान्तिः.
Thank you, madam. Today जैसे मैंने बोला ना, बहुत सारे सितारे ज़मीं पे है. We also have with us the Dean of Poddar College, Dr. Sant. Welcome, ma'am. Dr. Sampada Sant, madam, Dean, Government Poddar Hospital College. Thank you so much. Can we have एक चीज मुझे बतानी थी डॉक्टर नरेंद्र त्रिपाठी सर और प्रसाद पवार सर के बारे में। जैसे बोला जाता है ना कि एक ने नीमा की नींव रख के जो इमारत खड़ी की वो है अपने नरेंद्र त्रिपाठी सर, और उसी इमारत को रंग रूप दिया हमारे प्रसाद पवार सर ने। इन लोगों की जो जेलिंग या हार्मनी है कोई भी सक्सेस के लिए बहुत जरूरी है। तो ये दोनों की जोड़ी के लिए अ बिग राउंड ऑफ अप्लॉज। सर, डॉक्टर नरेंद्र त्रिपाठी सर, आई वुड वांट नाउ यू to felicitate Dr. Natarajan sir. Sir, we want felicitate Dr. Natarajan sir. Yes, please come. Could I have a standing ovation for such? Yes, please, I would request everyone to get up. It's a token of love and respect for Dr. Natarajan sir. Wonderful. Nana, I would now request Dr. Prasad Pawar to felicitate Dr. Raman. बैठना नहीं है, बहुत सारे dignitaries है। Prasad sir, kindly felicitate Dr. Raman. Also, I want to mention here, sir, thank you so much, sir. Kindly be seated. Thank you, sir. We also have on stage along with us Dr. Rajni ma'am. Again, she doesn't require any introduction. She is supposed to be the president of NIMA Mumbai Forum and Women's Forum. Now, in every role, be it a leader, be it a healer, a thinker, or a change maker, women are always on the forefront. Sir, would you agree with that? Yes. So, now comes the most awaited thing today. Now we are going to have Dr. Narendra say a few words today and address the audience. Sir, please come over on the stage. You want this mic or this mic?
हेलो, आदरणीय मुख्य अतिथी श्री नटराजन सर व मान्यवर अतिथी श्री रमण सर व स्टेजवरील उपस्थित सर्व सन्मान व्यक्ती व डॉक्टर्स, माझे निमाचे मित्र परिवार, आपण सर्वांचा मी मनपूर्वक हार्दिक स्वागत करतो। आज या व्यासपीठावर निमा MDBचे अध्यक्ष म्हणून उभा राहणे ही माझ्यासाठी मोठा सन्मान आणि आयुष्यातील अविस्मरणीय क्षण आहे। निमा ही केवळ एक वैदिक संघटना नाही, तर ते आपला एक कुटुंब आहे आणि या कुटुंबाचं ध्येय आहे सर्वसामान्य रुग्णापर्यंत उत्तम, सुलभ आणि वैज्ञानिक आरोग्य सेवा पोहोचवणे। आपण डॉक्टर फक्त उपचार देत नाही, तर समाजाला विश्वास, आशा आणि आरोग्य बल देतो। त्यामुळे आपल्यावर एक मोठी जबाबदारी आहे आणि ही जबाबदारी आपण एकजुटीने पार पाडली पाहिजे। मित्रांनो, आजचा काळ बदलाचा आहे। आपण सण मिळून जर नवे विचार, नवी ऊर्जा, नवे ध्येय घेऊन पुढे पाऊल टाकले तर निमा अधिक सक्षम, अधिक प्रभावी और अधिक समाजाभिमुख होईल। दोस्तों, मंजिल वही पाते हैं जो साथ चलना जानते हैं। यासाठी आपला आजचा घोष आहे निमा परिवर्तन, आरोग्य आणि समाजासाठी नवा अध्याय। आपण सण मिळून या परियोजनाच्या प्रवासात खांद्याला खांदा लावून चालूया आणि प्रत्येक रुग्ण, प्रत्येक कुटुंब आपल्या समाजाला निरोगी बनवूया। शेवटी एवढंच इच्छुक सांगतो, एकतेच सत्य आहे आणि सेवेत खरा आनंद। धन्यवाद। आपका लाडका अध्यक्ष। जय हिंद, जय महाराष्ट्र, जय निमा।
जैसे मैंने बोला, प्रसाद सर और नरेंद्र सर की जुगलबंदी देखने के लायक है। नाउ आई वुड रिक्वेस्ट डॉक्टर प्रसाद पवार सर Sir, we would want few words from you.
सन्माननीय व्यासपीठ आणि इथे जमलेल्या सर्व ऐतिहासिक नेत्रदीपक गर्दी, आदरणीय नटराजन सर आणि आदरणीय रमण सरांना पाहण्यासाठी पण आलेली सर्व गर्दी आणि सर्व ISM डॉक्टरांना एक कॉन्फरन्स चेअरमन या नात्यानं या गर्दीसाठी मानाचा मुजरा करतो आणि विनम्रतेने हात जोडून नमस्कार करतो. मित्रांनो, वैद्यकीय क्षेत्रातील ज्ञानसंपादन करणं ही आपली परंपरा म्हणजे निमाची परंपरा नेहमी राहिली आहे. प्रत्येक वर्षी आपण कॉन्फरन्स करतो, प्रत्येक वर्षी आपण ज्ञान संपादन करतो, विविध क्षेत्रातलं नवीन नवीन अपडेट्स घेतो. परंतु त्याचबरोबर ही गर्दी इतकी आज महत्त्वाची आहे कारण कलियुग चालू आहे आणि कलियुगामध्ये हे काम, क्रोध, लोभनी जे ग्रासलेले जे समाजकंटक आहेत, ह्या समाजकंटकासाठी ही सगळी गर्दी गरजेची आहे. आजच्या काळाला लक्षात ठेवा. फक्त ज्ञान संपादन नाही तर आपली आजच्या काळामध्ये ही गर्दी दिसणं गरजेचे आहे आणि ती गर्दी आपल्यासारख्या ह्या संघटनेच्या वेगवेगळ्या कार्यक्रमातून आपण करतो. निमा पहिल्यापासून एक उत्तम अशी संघटनेचं एक उत्तम उदाहरण आहे आणि 1, 2, 4 वर्षापूर्वीची निमा नाही आहे. 77 वर्षापासूनची निमा ह्याच्यासाठी टाळ्या झाल्या पाहिजेत. 77 वर्षापासून ISM डॉक्टरांसाठी झगडणारी ही संघटना, काही लोकांना बऱ्याचपैकी निमाची ही माहिती नसेल, आपण काही वेळाने थोड्याच वेळात आपण ते व्हिडिओमधून पण अपडेट घेणार आहे. पण लक्षात ठेवा, पूर्ण देशामध्ये पसरलेलं हे जाळं 1257 शाखेचं आहे आणि महाराष्ट्रामध्ये 253 शाखेचं आहे. लक्षात ठेवायचं. 36 राज्यापैकी 26 राज्यामध्ये ISM डॉक्टरांना सांभाळणारे हे कवच कुंडल दिवस आणि रात्र ॲक्टिवेट असते. त्यामुळं निमा हे सर्वोत्तम आहे. यांनी कधीही कुठल्या ह्याच्यामध्ये ISM डॉक्टरच्या ह्याच्यामध्ये भेदभाव नाही केला. वेगवेगळी उदाहरणं आपण रोज बघतो. रोज एक नवीन राजकीय कोणतीही स्थिरता रोज एक नवीन दबाव टाकते. आपल्या क्षेत्रातली बरीचशी अपडेट्स आपल्याला मिळत नाही. म्हणून हे कॉन्फरन्सचा उद्देश फक्त एवढाच आहे की तुम्हा सगळ्यांना या गोष्टीचं अपडेट मिळेल. परवा आपल्या होमिओपॅथी बांधवाबरोबर सुद्धा मी आवर्जून सांगतोय, परवा होमिओपॅथिक बांधवांना सुद्धा आपल्या निमाने आयुर्वेदिकच्या सर्व डॉक्टरांनी सपोर्ट केला होता. निमा पाठीमागे उभं राहिली होती. त्यांच्या शेकडो डॉक्टरांना घेऊन मी स्वतः आदरणीय नरेंद्र त्रिपाठी सरांच्या अध्यक्षतेखाली आझाद मैदानावर होतो. सांगण्याचा हेतू फक्त एवढा आहे मित्रांनो, इथे ISM डॉक्टरांना एकत्र राहणं फार गरजेचं आहे. ज्ञान संपादन करणं, घर आणि प्रॅक्टिस हे आपलं आयुष्य नाही आहे. आता ह्या कलियुगामध्ये आपल्याला एकत्र असण्याची ताकद दाखवली पाहिजे. आपल्याला समाजाला कळवलं पाहिजे की आम्ही सगळे एक आहोत. फक्त आम्ही डॉक्टर्स नाही, स्टेथो ज्यावेळी आम्ही काढतो त्यामुळे आम्ही सामान्य लोकांना आम्हीही अधिकारासाठी भांडू शकतो हे आपल्याला सांगितलं पाहिजे. आणि हे आज गेलेलं आहे. सर, मी तुम्हाला आवर्जून सांगतो, ही फेटेची जी कल्पना होती ही माझी होती. मला असं वाटत होतं की बऱ्याच माझे मित्र येतात, बऱ्याच वेळा लांबून आलेले लोक आहेत, त्या लोकांना कधी आपण विचारत नाही, कधी दुर्लक्ष होतं, कधी मैत्रीमध्ये एखाद्या वेळी एवढं बर्डन असतं की त्याच्यामध्ये इकडे तिकडे नाही बघितलं. तर ते सगळं थांबवण्यासाठी त्यांचा सन्मान, तो प्रत्येकाचा सन्मान त्या पायरीवर होणार निमाच्या, हे करण्यासाठी फक्त आज सगळ्यांना फेटा बांधला होता. बऱ्याच लोकांनी फेटा बांधला आणि तुमचा सगळ्यांचा सन्मान झाला. ह्याचे समाधान आमच्या निमाच्या मुंबई शाखेला आहे. परिवर्तन म्हणण्यासाठी त्याच्या पाठीमागे बऱ्याचशा गोष्टी आहेत. परिवर्तन पाठीमागे बऱ्याचशा गोष्टी आहेत, बरेचसे कारण आहेत. आमच्यामध्ये सुद्धा परिवर्तन झाले, परंतु आता इथून पुढे निमा सगळ्यांसाठी असणार. सगळ्यात महत्त्वाचं म्हणजे मित्रांनो, कुणाचाही भेदभाव न करता ही चालणारी, ज्ञान संपादन करणारी ही आपली निमा वैद्यकीय क्षेत्रातलं एक उत्तम नाव आहे. या कवच कुंडलाला संगती घेऊन आम्ही निमा मुंबईची पूर्ण टीम, माझी कॉन्फरन्सची पूर्ण टीम, आम्ही सगळे प्रयत्न करतो. ह्यात काही चूक भूल झाली तरी माफ. आपल्यासाठी आज या कार्यक्रमासाठी उत्तम सगळे आले, फ्रेश आले, थोडीफार गडबड झाली, परंतु मी आवर्जून नटराजन सरांचं आणि रमण सरांचं हे करतो की आता रमण सरांची जी आणि नटराजन सरांच्या स्पीचमध्ये त्यांच्या गोष्टी त्या कळतीलच. पण एक कॉन्फरन्स चेअरमन या नात्यानं पुढच्या वेळी नक्की भेटायचं आहे. सगळे भेटाल ना? नक्की. अरे आवाजही नाही. धन्यवाद. एवढंच बोलतो. जय हिंद, जय निमा, जय महाराष्ट्र.
Thank you so much, sir. And now, the very, very, very important thing, the Lifetime Achievement Award. This is truly and such an emotional moment for me because today, the persona whom I'm going to call on stage has been my mentor. The first thing when I see him is bow down. His blessings mean the world to us. And today the Lifetime Achievement Award is given to Dr. Vikas Dubewar, sir. And along with him, I welcome Dr. Suchita Dubewar, ma'am. Please, please welcome both of them on the stage. Yes. Suchita ma'am. She's there. Thank you, thank you. Can we have all of us here seated? It is an honor to receive an stalwart of medicine, a visionary whose relentless service and excellence are truly recognized with Lifetime Achievement Award. Sir, can we have all of you seated, sir? Please, please, sir. There is something. I would just say one thing, especially about Madam Dubewar, ma'am. आपके बारे में मैम मुझे एक ही चीज बोलनी है, that today she has sacrificed her practice to look after the house. This is only possible when a woman stands strong behind a man. The man's success is because of her. Ma'am is going down on the stage. Ma'am, we want you. You have been functional for his progress and success. Now, 2 lines, though of course I am not worth talking anything about, sir. He has completed 45 years of practice. He is ex-dean of Yerla Medical College, from where I have passed out. It was a privilege to have him as our principal. He's an ex-guide for MD, PhD for MUHS Mumbai University and a vice president. He is the ex-secretary of prestigious Shivaji Park Gymkhana called as Cricketchi Pandari. He also defeated Sir Ajit Wadekar, sir. Such a big thing. He is the ex-founder, president of DAW, Doctors Association of Worli, trustee of Arya Samaj, Arya Vaishna Samaj. He is the president of BDD Chaul Dukandar Sangh, secretary of NGO Hope for Vidarbha Medical. He is a medical advisor for ex-CM, Mr. Sudhakar Rao Naik, sir. Now, our sir is just not limited to medicine. He has his versatile interest and इतनी सारी खूबियां हैं उनमें कि मैं क्या बयां करूं. He has written शायरीज and screenplays. In fact, आज के लिए तो मैं सर को बोलने वाली थी कि सर शायरीज में मुझे जरा help करो. Lovely book of collection he has. He's also produced movies in Marathi and Hindi. He is the now this is worth listening. He is the University Blazer holder for sport badminton. He got his PhD degree by MUHR at the age of 69 years. A big round of applause for sir. Hats off his zeal for education. One thing is there, what sir I had seen in 1993, in 2025, he is the same. Sir, you have stopped aging completely. You are the same energetic Dubewar sir, who's very strict from outside, but dil ke to itne naram hai, unki presence rahi na to tension gaya. So very proud to have sir here on dais, and along with me, I want Dr. Prasad Pawar to even express his feelings for sir. Can I have him here?
सगळ्यांचा मुद्दा म्हणून वेळ घेतोय. खरं म्हणजे मित्रांनो, मला विद्यार्थी दशेत आदरणीय दुबेवर सरांचा सहवास किंवा ज्ञान संपादन करण्याची संधी मिळालेली नाही आहे, कारण मी मुंबईतून नाही आहे. परंतु आता विद्यार्थी दशेतल्या सगळ्याच गोष्टी सर्वच त्यांच्या विद्यार्थ्यांनी इथं सांगितलेल्या आहेत आणि त्यासाठी मला काय अगदी दुर्दैवी म्हणायचं नाही आहे, कारण मी जे सरांकडून घेतलेलं आहे आणि सरांनी मला जे दिलेलं आहे त्याच्यासाठी कदाचित मी ईश्वराचे आजही आभार मानतो. त्याच्यामध्ये बऱ्यापैकी त्यांचं स्वभावदर्शन, प्रामाणिक आणि निस्वार्थ अशी क्रोधाची सरांचा रागीटपणा, रागीट चेहऱ्यावर आपल्या शिष्यावर जे मायाची झालर टाकतात सर, ते रूप बघितलं म्हणजे समोरच्या व्यक्तीला आणि तडपदार तलवारीमध्ये शब्दांच्या तोप डागणारे आमचे हे दुबेवार सर जेव्हा मित्रासारखे आमच्यामध्ये बसून गप्पा मारतात, मार्गदर्शन करतात, त्यावेळी खरोखर एक कौटुंबिक सुखाचा एक अनुभव येतो आणि आजही तो आमच्या सगळ्या निमा मुंबईच्या सहकाऱ्यांना जाणवते. मित्रांनो, नारळासारखे बाहेरून कडक असणारे आमचे सर, ज्यांच्यासमोर उभा राहायची हिंमत ही बरीच लोक करत नाहीत, असे नारळासारखे आमचे सर आतून खरंच एक मलाईसारखे सॉफ्टसुद्धा आहेत. माझ्यासारख्या असंख्य अशा ISM डॉक्टरांना एक आधारस्तंभ देणारे, एक डॅशिंगपणा देणारे, एक भीती घालवणारे, जनरल प्रॅक्टिशनरला खास करून मार्गदर्शन करणारे असे सर ज्यावेळी लक्षात येतात त्यावेळी ते कल्पवृक्षापेक्षा कमी नक्कीच वाटत नाहीत. सर्वात विशेष गोष्ट सांगतो आणि तेही सरांच्या परमिशननं सांगतो की ईश्वराने त्यांना दिलेले जे शरीर यष्टी सर 72 वर्षामध्ये अजून सरांची यष्टी अशी आहे की ना त्यांचं वजन वाढते ना त्यांच्या चेहऱ्यावरची गुंती सुरकुती हलते. माफ करा पण बोलावं लागतं, कारण याचं कारण काय आहे की मनात राहावे ना ते सर. कारण ज्यावेळी आम्ही रमण सरांना भेटायला गेलो होतो सर, आठवतं आहे का, आम्ही ज्यावेळी सरांना भेटायला गेलो त्यावेळी सरांनी पहिलं वाक्य दुबेवार सरांविषयी काढलं, अरे सर अजून पण तुम्ही तसेच की तसेच आहात. आणि मी तो विचार करत होतो की मी गेल्या 12 वर्षापासून निमामध्ये काम करतोय तर आमचे दुबेवार सर जसे आहेत तसे आहेत. त्यांची छोटीशी ती स्माईल आणि त्या 12 वर्षामध्ये आमचे केस आले गेले, परत हे जरा थोडंसं फेट्याचं जरा थोडंसं सहकार्य घ्यावं लागलं, परंतु सर तुम्ही आहे तसे आहात. हे आमचं सगळ्यांचं निमा मुंबईचं एक वेगळं रसायन आहे. हे इतकं मोठं रसायन आहे की यांचा जोश कमी होतोय ना यांची ऊर्जा कमी होते. आणि देवाचरणी एवढंच प्रार्थना करतो की हे रसायन पुढच्या 25 वर्षाच्या आमच्या निमाच्या कॉन्फरन्सवर अशाच पद्धतीचं बसलेलं असेल आणि डॉक्टर प्रसाद पवार असाच बोलत असेल. डॉक्टर नरेंद्र त्रिपाठीच्या साह्याने जेवढा दुबेवार सरांचा सहवास आला आहे त्याच्यामध्ये भरपूर सगळ्यात जास्त शिवाय मीच खाल्लेत. म्हणजे हेही तितकंच खरं आहे, परंतु त्यातनं जेवढं शिकलो आणि जेवढं बऱ्याच वेळा चुकलो तर पाय धरले आणि त्या पाया ज्यावेळी चूक मान्य केली त्यावेळी सरांचं प्रेम मिळालं, जे माया मिळालं, त्यात बरंच काही शिकायला मिळालं. मित्रांनो, हा आदर आपला सगळ्यांचा आहे. आपल्या ISM आणि वैद्यकीय क्षेत्रातील हे रसायन असे अनेक रसायन, परंतु आमच्यासाठी डॉक्टर दुबेवार सर हे एक माऊलीपेक्षा वेगळे नाहीत. मी पंढरपूरचा जरी असलो तर पंढरपूरच्या माऊलीबरोबर मी सर तुम्हाला खरंच माझ्या माऊलीच्या रूपात बघतो. तुम्हाला पुढील येणाऱ्या 25 वर्षाचा मी ग्वाही दिल्या, पण मी म्हणतो 50 वर्षसुद्धा तुम्ही ईश्वर तुम्हाला ते सगळं आयुष्य देव. आणि अजून एक गोष्ट महत्त्वाची सांगतो, जीवनगौरव दिलाय म्हणून सोडणार नाही. जीवनगौरव दिलाय म्हणून सोडणार नाही. काम आणि तुमची गाठ ही नेहमी घेत राहणार. निमा मुंबईची सगळ्या शाखेकडून तुम्हाला मानाचा मुजरा करतो सर. धन्यवाद. जय निमा, जय महाराष्ट्र.
Thank you so much, Dr. Pawar sir, for this wonderful expression of emotions. Now, can I request our chief guest, Dr. Natarajan, and our guest of honor, Dr. Raman, to felicitate Dr. Dubewar sir. A big round of applause, doctors. We have such stalwarts on stage. There is a whole constellation scene with so many stars present together. It is a very rare occasion to have so many esteemed dignitaries all together on stage. Thank you so much, sir. Sir, can I request you to speak few words, sir? Dr. Dubewar, sir. Sir, kindly come on the dais, on the stage. We are wanting to hear 2 words from you, sir. Sir, you'll be comfortable with this mic, this mic.
Yes. Okay. Good afternoon, everybody. When these people said that you will get this award, I said no, you give it to somebody. But they said no, we want to give you. So I could, Prasad and Naren, they said no sir, we want to give you only. I am thankful to them. Respected dignitary on dais, Padam Shri Dr. Natarajan sir, Dr. Raman sir, and my colleague, President, very means he is having lot of quality. So Narendra Tripathi and Secretary Mangal Vawal, Treasurer Musale sir, and Conference Chairman, Dynamic Person, Dr. Prasad Pawar. Organizing Secretary Prajakta Patil, Women's Forum President Dr. Rajni Yadav, Past President Dr. Phadatare sir. First, I am very much thankful all of you, even full team of NIMA, management committee members, conference committee members. You have given this award by auspicious hand of Dr. Natarajan sir and Raman sir. Actually, real rights of this award is not mine. It is my wife and family. Because if anybody want to do some social activities, you cannot give time, especially in our profession, doctor and practicing, and give time to the family. So my wife has sacrificed lots, my family has sacrificed lots. My wife Suchita, actually I dedicate this award to her. My children, even from childhood, I have not given them time, but these activities you must have seen now. So, Dr. Akshay Dubewar, radiologist, Karthik Dubewar, he is also event manager, my daughter-in-law Tanvi Dubewar, and of course, cream of my life, Ayan. They all of them, they sacrifice themselves because home problem, home management, I never look at that. All she manages and his children manages. That is a great part. That's why this real rights of this award is my family, Suchita and others, and my children. Few people think, even I used to think, when you will get a lifetime achievement award, means Buddha abhi real retire ho gaya. But after getting this award, I am feeling that I am not a 72, I am a 27-year-old. And I promise all NIMA team, all NIMA people, that up to the end of my life, I will work for a NIMA. And whatever activities are going on, I will continue. अभी मेरे को इधर से इशारा कर रहे हैं कि तुम्हारा टाइम बहुत कम है, लेकिन वक्त देखो कैसा बदलता है. एक वक्त था कि नरेन, सीमा पारी, क्रांति, ये जो स्टूडेंट थे मैं इनको बोलता था ज़्यादा बात नहीं करना. अभी इन्होंने मेरे को बोल दिया सर ज़्यादा बात मत करो, हमारे पास वक्त नहीं है. ये वक्त का तकाजा है, उम्र का मालूम नहीं. So I will conclude my speech within 2 minutes. For certain my memorable moment in my life while doing social work. First is that when I got elected in Shivaji Park Gymkhana, prestigious Shivaji Park Gymkhana, as a secretary against Mr. Ajit Wadekar sir. And after that I received call from Sachin Tendulkar, Praveen Amre, Shikhar Dhawan, Sandeep Patil, and best of the part of my life, late Hindu Hriday Samrat Balasaheb Thackeray. He has sent me the letter and phoned me that you congratulate me. That is my very memorable moment in my these social activities. And another memorable moment is that in the age of 69, I got awarded PhD degree from MEHS. So I will not, again, Kranti is our management, time management keeping. She is doing ishara, sir, jaldi karo. Abhi bol sakte ho, bacche nahi rahe. So I will conclude with one of my share written by me only. For all junior or even those who are not coming for social work and activities, चलोगे तो गिरोगे, फिक्र ही क्या है, राह में कांटे दूर है मंजिल, पर यारो है भरोसा तो फिर जिक्र ही क्या है. बस काम करते रहो, लाइफ ऐसे मस्त चला जाएगा. यही मेरा संदेश है. अगेन थैंक यू टू एवरीबडी एंड नमस्ते. धन्यवाद.
Thank you so very much. Good. Thank you, sir. Super. Thank you so much, sir. It was wonderful. It was such a pleasure to hear you. One thing you must have noticed, he has been such an humble and a modest human being that he has been giving credit to his better half. Now, when we talk about women empowerment, तो हमारी रजनी मैडम कहाँ पीछे रह जाएगी? She is the President NIMA Mumbai Women Forum. Can I call upon Rajni ma'am to speak 2 words? Thank you. She will be addressing us. Very proud for the women empowerment. Ma'am, over to you.
Good afternoon to all the dignitaries on the dais, my colleagues and the delegates. I, Dr. Rajini Sheila Vijay Yadav, the President of Women Forum, Mumbai District Branch, welcomes all dignitaries. The NIMA Women's Forum is a constitutional body of the National Integrated Medical Association. Especially for the gynecocentric problems, NIMA started Women's Forum in year 2006 with the hard work of Dr. Temburnikar, Dr. Ashutosh Kulkarni and Dr. Sadhana Kulkarni. Today, there are about 132 branches all over nation, which include 8 state-level branches and 124 district-level branches. Dr. Kumud Nagrar was the first president from Mumbai District Branch. Now, I am carrying this responsibility with Secretary Dr. Prajakta Patil and Treasurer Dr. Manju Yadav. On occasion of Environmental Day, we distributed medicinal plant samplings with the blessings of Aushadhi Sukta from the Atharva Veda to NIMA members. Dr. Nilaparna and Dr. Priya also celebrate as a part of it at Pune. On 21st June Yoga Day, Dr. Jyoti Bigwankar took a small workshop for practitioners how to relax in clinic on busy clinic schedule by easy yoga practices. General practitioners has a huge experience of treating and counseling the patient at different stages of diseases. Therefore, we decided that let practitioners have a words. First topic selected hypothyroidism, and general practitioners share their knowledge in different fields like Panchakarma, yoga, acupuncture and marma therapy. We share PPT of Hypothyroid and Yoga by Dr. Anita Sawant, the Divisional Secretary, Women Forum from the NIMA branch. Each Ayurvedic clinic must have one medicinal plant propagation as a token of gratitude to nature. This view in mind, we distributed Tulasi Bija to each conference delegate. As said, before being a medicine, it's a bija, seed. Please propagate it and be a part of our drive. Every clinic, one medicinal plant. We have to do a lot of work for us and for the society. Let us join on this mission. Thank you all NIMA Women Forum for and PST and Maharashtra Mumbai branch. Thank you.
Thank you Rajni ma'am for the lovely lecture. And now, जिसका हमें था इंतजार वो घड़ी आ गई. द अनवीलिंग ऑफ द सोवेनियर द मैगजीन. ये बरसों से चली आ रही परंपरा है, बट इसमें खास क्या है? इसमें हमारे दिल के इमोशंस है. वी हैव एक्चुअली कंपाइल्ड ऑल द इमोशंस एंड टुडे वी आर गोइंग टू अनवील आवर सोवेनियर. फॉर दैट आई वुड कॉल डॉक्टर नटराजन, डॉक्टर रमन, डॉक्टर दुबेवार टू अनवील द मैगजीन, द सोवेनियर टुडे. अ बिग राउंड ऑफ अप्लॉज फॉर दिस. ये जो है ना, हर एक जन का जो कंट्रीब्यूशन है वही ये सुवेनियर में मिलेगा. नरेंद्र पाटिल सर, प्रसाद पवार सर, प्लीज कम. Okay. We also have amongst us Dr. Ninad Sate sir, who's so busy capturing the moments here. He is the professor in Yerla Medical College. Ninad sir, we really call you over on the stage. Even we have, I will grammatically correct something. He was a professor of Yerla Medical College. Dr. Raman sir will be felicitating him. Thank you, sir. Yeah. We also call on stage Dr. Sampata Sant Madam, Dean of Government Podar Hospital College. Ma'am, can we have you? Prajakta ma'am, please do the honor. Felicitate madam. Ma'am, please come on the dais. So many esteemed people on the stage, all together. It's very rare. So don't you think that we're privileged enough to witness all their presence together in one go? Truly, abhi tak tutari ka time hai. Neelu, give it to Prajakta Patil. Prajakta ma'am will be doing the felicitation of Sampada Sant madam. अच्छा हां हां येस ओके डॉक्टर Also, one important announcement: Dr. Kavita Hande ma'am is a kind of writer for this book, and this book is specially dedicated to Dr. Dubewar sir by Dr. Ninad Sate sir. Wonderful! It is such a prestigious thing to have a book dedicated to you. And now I call Dr. Raman to say a few words to us. Sir, can I have you on the dais, sir?
नमस्कार. या मंचावरील पद्मश्री नटराजन सर, लाईफ टाईम अचीवमेंट अवॉर्ड भेटलेले दुबेवार सर, मावळते अध्यक्ष फडतरे सर आणि नियमाचे नवीन धुरा सांभाळणारे त्रिपाठी सर. मी जास्त वेळ घेणार नाही कारण आपलं अकॅडमिक सेशन चालू आहे. जास्तीत जास्त ज्ञान घेणार आहात. मी आता आयुषचा डायरेक्टर म्हणून आमची काय थोडीशी कार्य चालू आहे त्याबद्दल थोडीशी माहिती देणार आहे मी. की गेल्या 2.5 वर्षापासून मी आयुष डायरेक्टर म्हणून आहे. गेल्या 70 वर्षामध्ये आपल्याकडे आयुषच्या संस्था 6 होत्या आणि माझ्या आयुष 2.5 वर्षाच्या काळामध्ये 6 वाढून 12 झालेले आहेत गव्हर्नमेंटच्या. त्यानंतर आयुष म्हणजे आयुर्वेद ही पूर्वी कल्पना होती. तर आयुष म्हणजे आयुर्वेद नाही, तर आयुष म्हणजे आयुर्वेद, होमिओपॅथी, युनानी, सिद्ध हे सगळं सर्कल कंप्लीट करणं आवश्यक होतं. म्हणून शासकीय लेवलवर आयुर्वेद, होमिओपॅथी, युनानी, योग निसर्गोपचार हे सर्व महाविद्यालय शासकीय सुरू झालेले आहेत महाराष्ट्रामध्ये. त्यामुळे आयुष्य सर्कल पूर्ण करण्याचं भाग्य मला मिळालं, त्याबद्दल मी खरंच ऋणी आहे आपला. त्यानंतर आयुर्वेदाला किंवा आयुषला आता गेल्या 10-12 वर्षापासून अगदी प्राधान्याने आणि चांगल्या प्रकारे शासनाचा म्हणजे राज्याश्रय मिळालेला आहे. आणि एक अभिमानाची आणि आनंदाची गोष्ट सांगतो तुम्हाला की गेल्या 2 वर्षामधले महाराष्ट्र शासनाने आयुषसाठी 2300 कोटी रुपयाचं बजेटची प्रोव्हिजन केलेली आहे. त्यामध्ये प्रामुख्याने आपल्याला माहिती आहे आयुर्वेद पोद्दार संस्था म्हणजे मुंबईचं किंवा आयुर्वेदाचं हार्ट आहे. आणि त्या संस्थेमध्ये ज्यावेळेस ती संस्था निर्माण झाली तर त्यावेळेस इथं फक्त 50 ॲडमिशन होते आणि यातले बरेचसे आपण पोद्दारचे स्नातक आहात, विद्यार्थी आहात. आज तिथे 125 UG स्टुडंट, 75 PG स्टुडंट आणि बरेचसे PhD स्टुडंट असे जवळजवळ 1000 विद्यार्थी त्या ठिकाणी शिकत असतात. पण आपण ज्या काळात राहत होतात त्या काळापासून फक्त 90 विद्यार्थ्यांची तिथं म्हणजे सोय आहे वसतिगृहांची. आणि ही गरज लक्षात घेऊन महाराष्ट्र शासनाने 21 माळ्याची हॉस्टेल बिल्डिंग आणि 21 माळ्याची कॉलेज बिल्डिंग यासाठी 467 कोटीची तरतूद केलेली आहे आणि त्याचं टेंडरसुद्धा निघालेलं आहे. त्यामुळे लवकरच ते बांधकाम सुरुवात होईल आणि बांधकामसुद्धा एकदम समृद्धी किंवा कोस्टल रोडचे जे कॉन्ट्रॅक्टर आहेत मोठमोठे असे PWD न देता या मोठ्या कॉन्ट्रॅक्टरकडून आपण बांधकाम करून घेणार आहोत आणि फक्त 1.5 वर्षाच्या 2 वर्षामध्ये ते बांधकाम कंप्लीट होणार आहे. दुसरं एक बोलायचं म्हणजे इंटिग्रेटेड निमामध्ये नावच आहे की इंटिग्रेटेड, पण यातली इंटिग्रेटेड लोक फार कमी आहेत. मला वाटतं 74-75ची शेवटची बॅच इंटिग्रेटेड होती आणि त्यानंतर BAMS शुद्ध आयुर्वेदवाले असं ज्याला समजतो आपण, ते आपण BAMSचे लोक सगळे आहोत. जेव्हा इंटिग्रेटेड नंतर जी BAMS कोर्स सुरू झाला तर त्याचा अर्थ इंटिग्रेटेड म्हणजे ॲलोपॅथी मिक्स होतं आणि नंतर त्या ॲलोपॅथी नाही असं त्यामध्ये गृहीत होतं. तरी पण कालांतराने आपल्या BAMSच्या कोर्समध्ये बऱ्याचशा प्रमाणात ॲलोपॅथीचा समावेश करण्यात आला. आणि आपण नियमाचे कार्यक्रमाला बऱ्याच वेळा आपल्याला माहिती आहे की ॲलोपॅथी प्रॅक्टिस करताना ॲलोपॅथीचे जे लोक आहेत यांचा बराच विरोध झाला, बऱ्याच कोर्ट कचेरीपर्यंत झाला, सुप्रीम कोर्टापर्यंत केस गेल्या. आणि त्यानंतर नॅशनल कमिशननी आणि महाराष्ट्र शासनाने सुद्धा की आपण जितकं शिकलेलो आहोत तेवढं ॲलोपॅथी प्रॅक्टिस किंवा ती काही करण्याची परवानगी आपल्याला दिलेली आहे. पण यावरही आपण हुरपळून जाता कामा नये की सिलेबसमध्ये आपले आहे, आपण ते शिकतो. पण इंडियन मेडिकल काउन्सिलचा सगळ्यात मोठा आक्षेप काय आहे, तुमच्या सिलेबसमध्ये सर्व काही जरी असले तरी तुम्हाला शिकवायला कोण होतं. जोपर्यंत इंडियन मेडिकल काउन्सिलची मान्यता असलेले टीचर तुम्हाला जोपर्यंत शिकवत नाहीत तोपर्यंत हे प्रकरण अजूनही प्रकरण न्यायालय. आताच बघता तुम्ही होमिओपॅथीला जे ॲलोपॅथीची मर्यादित प्रॅक्टिस करण्याची परवानगी दिली आणि आत्ताच इंडियन मेडिकल काउन्सिलने मला वाटतं 1-2 दिवसामध्ये त्यांनी बंदची हाक दिलेली आहे. म्हणजे असे प्रश्न निर्माण होणार आहेत. तर हे निर्माण होत असताना आपल्याला आज आपण आता मला तुम्ही सांगितलं, बरंच एक जणांनी म्हणाले की आपल्याला मिळालं म्हणून आपल्यापुरतं समाधान करत नाही. इंडियन सिस्टम ऑफ मेडिसिनचे सर्वांना जर एकत्र ताकद दाखवणं आवश्यक आहे. आज होमिओपॅथीवाले संकटात आहेत, उद्या आपण संकटात जाऊ. पण आपण एकत्रित राहिल्याशिवाय आपण ही वस्तुस्थिती आहे की एक अजून मला तुम्हाला सांगायचं आहे याच्यामध्ये की इथिक्स जे आपण जे शिकतो त्याच पॅथीची प्रॅक्टिस केली पाहिजे, हे इथिक्सप्रमाणे सांगणं बरोबर आहे. की जर तुम्ही आयुर्वेद शिकला असला तर आयुर्वेद सोडून दुसरी का करता, होमिओपॅथी शिकले असलं तर होमिओपॅथी सोडून दुसरी का करता. आणि त्रयस्थ माणसाला बघितल्यानंतर हे बरोबर वाटतं की बरोबर आहे, तुम्ही जे शिकलात तीच करायला पाहिजे. जे तुम्ही शिकला नाही, ज्यातले तुम्ही तज्ज्ञ नाही, ती का करता. एक त्रयस्थ माणसाकडून ते बरोबर वाटतं. पण डॉक्टर म्हणा, वैद्य म्हणा, यांचं पहिलं कर्तव्य काय असतं. आपण आयुर्वेदाला ॲडमिशन घेतलो, आयुर्वेदाचा विकास करणे आपलं ध्येय आहे किंवा आपलं कर्तव्य आहे असे बरेच जण सांगतात. होमिओपॅथीला ॲडमिशन घेतलं, होमिओपॅथीचं करणं हे आपल्याला सांगतात आणि त्याचाच विकास करणं, त्या पॅथीचाच प्रोग्रेस करणं हे कर्तव्य सांगतात. पण नाही, वैद्य किंवा डॉक्टर म्हणून पहिलं इथिक्स आपला आहे रुग्ण. जो कोणता रुग्ण आलेला आहे त्या रुग्णाला दुरुस्त करणं, ट्रीटमेंट देऊन उपचार करणं हे पहिलं इथिक्स आहे. मग पॅथी कुठलीही असो. तर ह्या इथिक्सचा डोळ्यासमोर ठेवून आपल्याला माहिती आहे, आपण BMS असेल, BHMS असेल तरी जवळजवळ 90% वर लोकांनी शुद्ध प्रॅक्टिस न करतात, इंटिग्रेटेड प्रॅक्टिस करतात, ॲलोपॅथीची करतात, आयुर्वेदाची करतात, मिक्स प्रॅक्टिस करतात. आताच होमिओपॅथीच्या निमित्ताने बऱ्याचशा कमिटीवर मी होतो. कमिटीमध्ये करत असताना मिक्स प्रॅक्टिस का करता. आणि सेक्रेटरी वगैरे सुद्धा आपले कमिशनरसुद्धा मेडिकल पॅथीचे आहेत बरेचसे लोक, ते पण म्हणतात. आणि ॲलोपॅथीचे लोक, बहुतेक लोकांचा विरोध असतो त्यांना. तर असं का मागता तुम्ही की तुमच्या पॅथीमध्ये तुम्हाला प्रॅक्टिस करण्याची हे नाही का. तर त्यांना मी 2 वाक्यात बोललो त्यांना. सर म्हणलं हे खरं आहे की ॲलोपॅथीची प्रॅक्टिस होमिओपॅथी आणि आयुर्वेदवाले करतात, युनानीवाले सुद्धा. ॲलोपॅथीचे प्रॅक्टिशनर किंवा स्नातक ते आपल्याला विरोध करतात. तर त्यांना मी चॅलेंज केलं की अख्ख्या मुंबईमध्ये पर्टिक्युलरली 4-2 कॉर्पोरेट जर हॉस्पिटल सोडले तर या सगळ्या ICUमध्ये जाऊन पाहायचं की या ICUमध्ये जाऊन कुठले डॉक्टर तिथं ट्रीटमेंट करतात किंवा पाहतात ICUमध्ये. मी आज तुम्ही बाहेर जाऊन बघा म्हणलं 90%च्या वर सगळ्या ICUमध्ये आयुषचे डॉक्टर आहेत. मग त्यावेळेस तुम्ही विरोध का करत नाही. तिथं तुम्हाला MBBS मिळत नाहीत. त्यानंतर दुसरं त्यांना बोललो की ॲलोपॅथी तुम्ही सांगता आज अख्ख्या महाराष्ट्रामध्ये मला तुम्ही फक्त MBBS जनरल प्रॅक्टिस करणारे, MBBS जनरल प्रॅक्टिस करणारे मला 10 दाखवून दाखवा. एकही मिळणार नाही. अगदी कुठला चतुर्मातुर का होईना पण डिप्लोमा करून तो स्पेशलिस्ट असतो. म्हणजे जनरल प्रॅक्टिस करत नाहीत. म्हणजे सामान्य लोकांना कमीत कमी पैशामध्ये आणि जवळ ट्रीटमेंट करणारे, जनरल प्रॅक्टिस करणारे 99% हे आयुषचे डॉक्टर आहेत. जर आयुषच्या डॉक्टरांना ह्या जनरल प्रॅक्टिसमधून काढलं आणि आयसीयूमधून काढलं तर ॲलोपॅथी आज एकदम लुळी पांगुळी होईल. तर जनतेचा, नागरिकाच्या हिताच्या दृष्टीनं, आरोग्याच्या दृष्टीनं या आयुष डॉक्टरांना ही प्रॅक्टिस करू देणं किंवा याची आवश्यकता आहे आणि हे करण्याशिवाय पर्याय नाही. इथिकली तुम्ही काहीही गप्पा जरी मारल्यात तर वस्तुस्थिती ही आहे. आणि त्यानंतर त्यांना पटलं, जे होमिओपॅथीचा GR मागं घेतलेला होता त्यांनी स्थगिती दिली होती, त्यानंतर त्यांनी स्थगिती उठवली. तर याच नंतर मी तुम्हाला एक सांगतो अजून की आपल्याला जसं ते आता मागं म्हणालो मी तुम्हाला की ॲलोपॅथीचे टीचर नाहीत म्हणून अलाउड नाही. तर आपण जे आता सुरू केलो आहोत कॉन्फरन्स, आता आपण पाहतो कॉन्फरन्समध्ये मॅक्झिमम आपल्याला जे शिकवतात किंवा लेक्चर देतात हे मॅक्झिमम ॲलोपॅथीचे आहेत. पण याचं रेकॉर्ड मेंटेन करावं लागेल. फक्त होतं म्हणून तोंडीवरून चालणार नाही. उद्या कदाचित आज सुप्रीम कोर्टापर्यंत जावं लागेल कदाचित, असं असल्यानंतर तर हे गोष्ट सगळे हे रेकॉर्डिंग ठेवावं लागेल. यासाठी आम्ही एक ऑनलाईन CME पण चालू केलेली आहे. तर ऑनलाईन CME सुद्धा बऱ्याचशा 50% आसपास आपण ॲलोपॅथीचे लेक्चर त्यामध्ये ठेवत आहोत. अजून त्यातले बरेचसे कमी आहेत, अजून तज्ज्ञ लोकांचे त्यामध्ये करणार आहोत. तर तेही रेकॉर्ड आपल्याकडे राहणार आहे. ऑफलाईन जे काही आपले कॉन्फरन्स होतात त्याचेही रेकॉर्ड, म्हणजे उद्या चालून आपण हे यासाठी म्हणजे प्रयत्नशील राहिलं पाहिजे आणि तशी आपली तयारी पाहिजे आपली. तर जेवढं काही मला आज या प्रमुख कॉन्फरन्ससाठी प्रमुख पाहुणे म्हणून मला बोलवलात आणि 2 शब्द बोलवण्याची मला संधी दिलात त्याबद्दल मी आपले आभार व्यक्त करून माझे 2 शब्द संपवतो. जय हिंद, जय महाराष्ट्र.
Thank you, sir. It was such an enlightening lecture for people who need to know the struggle which we have and the unity. We all have to be together. The word what he said, that without us, they don't have any choice, we were everywhere. And sir, you have so nicely explained us all the things which have happened, the way we have come together, and we were and we will be always the winner because we are the best. A big, big, big clap. Thank you, sir, for the wonderful lecture. Now I call our chief guest, Dr. Natarajan sir, to say a few words. It's such a pleasure to listen to them all. Sir.
Namaskar, and thank you very much for respected dignitaries on this dais. Dr. V.D. Raman Gungarekalkar, our guest of honor, Dr. Narendra Tripathi, Honorary President, Dr. Mangal Vaval, Honorary Secretary, Dr. Naren Revar, Honorary Treasurer, Dr. Prasad Pawar, Conference Chairman, Dr. Prajakta Patil, Conference Organizing Secretary, Dr. Namdeo Thorat, Conference Scientific Chairman, Dr. Vijay Yadav, the President of the Women, and esteemed members of the National Integrated Medical Association, honored guests, and my dear colleagues. And a special thanks to the Master of Ceremony for giving a wonderful introduction to all of us.
Thank you so much, sir. Privileged to hear from you, sir.
Thank you. So, my dear colleagues, good morning. It's both a privilege and a profound honor to stand before you today as the chief guest of the 36th Annual Medical Conference organized by the Mumbai District Branch of NIMA. I would like to express my sincere gratitude to the organizing committee for this gracious invitation. And heartiest congratulations to Dr. Vikas Dubewar for the Lifetime Achievement Award. Congratulations to Dr. Ninath Sate and Dr. Kavita Sate for publishing a book in Marathi. I am a proud Mumbaikar and an Indian who started practice in the just a few meters away in Dadar in 1990 in Vikaswadi. And Vikaswadi, I used to call that, as I don't know how many of you know, the best private practice street is called Harley Street in London, where all the consultants of the big hospitals were practicing. And we had Dr. Palajani, interventional cardiologist, Dr. Anand Joshi, pioneer in arthroscopy, Dr. M.B. Agarwal, hemato-oncologist, myself as a veterinary surgeon, and late Dr. Sushil Chaudhary, anesthetist, were practicing in Vikas Wadi. Padma Bhushan, Dr. N.S. Lord, he got the Padma Bhushan in 2013 when I came because nobody was doing, only 3 or 4 of us were doing in whole India. Thanks to my mentor, Dr. Badrinath, who trained me and allowed me to come and work in Mumbai. So this is my Karma Bhumi, and I am here in Mumbai for 37 years. And I would like to begin by acknowledging the tremendous work all of you do every day, the dedication, skill, and compassion exhibited by all of you as healthcare professionals, whatever branch you are, the backbone of the health community. Today, we gather not just to discuss our accomplishments, but also to envision the future of healthcare in our beloved nation. And India, we are proud, between the age of 35 to 40, 65% of our population of 1.4 billion people live in India, and whereas in China, even though they have 1.4 billion, most of them are 70 plus. So I'm not against the old people, even I'm growing old, but I look young, but thanks to Chinese TI which I have regularly. So I think all of us have to work for health, and I think if you are fit, then only you can treat your patients well. So today, my suggestion is, and your theme is also excellent, one vision, one care, Parivartan for all. And I remember in 1989 when I went to Singapore, they had this slogan for Singapore, one country, one man and one vision. That means they had 4 official languages, English, Chinese, Malay and Tamil, but still they said we are all one, because even though they had 4 different groups, but they had we have 100 languages and we want this one vision. The theme of this year's conference, One Vision, One Care, Parivartan for All, resonates deeply with the current needs and aspirations of our healthcare system. It urges us to unify our efforts toward a common goal, holistic care that is accessible and equitable for everyone. Parivartan, meaning transformation, encapsulates the essence of what we must strive for in today's complex healthcare landscape. Change is not merely a buzzword, it is a necessity. Our world is fast evolving, and so too must our approaches to healthcare. We must redefine how we deliver care, ensuring that meets the diverse need of our patients. And I feel, yesterday I went to Ramakrishna Math hospital, that is the Ramakrishna Mission Hospital in Kar, and the Swami Vivekananda has made a beautiful rules in 1898. Ramakrishna Math will be headed by a monk, and Ramakrishna Mission will be, or the hospital will be headed by a MD doctor who is a Swamiji, and you can become a Swamiji before the age of 28, and we have a MD doctor who is now doing diabetes care, and his aim is to reverse diabetes. So he gave me a lot of things to change the diet. Instead of eating rice, wheat, eat vegetables and ragi and jawar. So I think all of us have to do something to prevent diseases. Even though we are doctors, we have to treat people. Anyhow, we have 1.45 billion people. How much ever you prevent, somebody will have some problem where we have to treat. So don't be afraid of preventing a disease. And this is what I am doing, that I want to diagnose diabetes from the age of, do the HB1AC, PP sugar, fasting sugar from the age of 35, and if they find diabetes at the age of 40, and that will be the 0 year of diabetic. And every year we should take a retinal photograph. Nowadays we can use the mobile phone and an infrared device and take a retinal photo, use an AI. So we don't need doctors to do screening, and that's my publication in JAMA. So I think it's important to prevent blindness, and I want every Indian to live healthily with good health and good vision. That means from the age of 40 till the age of 80, you should have good vision and good health, so that we don't have to go to hospital. And hospital will be for some diseases where, in spite of all the things we have, and we can imagine, we can save the money and have so many things good in life. So as we embark on this journey of transformation, it is crucial to emphasize the importance of integration healthcare, and that's what is your National Integrated Medical Group. And each healthcare professional, irrespective of specialty, plays a vital role in the continuum of care. We must break down the silos and foster an environment of collaboration across disciplines in integrated care. We harness our diverse expertise to create a more cohesive healthcare experience for patients. And I think you are doing a great job in this. By working together, we can enhance care quality and ensure that every individual receives comprehensive treatment tailored to their needs. However, the path to Parivartan is fraught with challenges: rising healthcare demands, inequalities in access to services, and the urgent need for mental health support are just a few hurdles we face. As a community, we must remain proactive in addressing this issue. An essential part of our transformation is education. As experienced practitioners, we must invest in the next generation of healthcare professionals. Our Lifetime Achiever Award is said he will work for the society, and we need people like us. I am also close to his age. I am going to be 68, but I travel all over the world to teach. Today, the previous speaker asked me, "Are you not tired of teaching? It is monotonous." I said, "No. Every meeting I go or every place I go, tonight I am going to Germany for 2 weeks, the students are different. And every year there are young students coming. And this week I am going to be with 40 eye doctors from entire Europe. And all of them are fresh and they all eager to learn, because India is doing excellent teaching in ophthalmology. I know in all branches we are doing, but in ophthalmology we are the number one in the world. And I think every ophthalmologist, we are proud of that. So I want that me as a teacher, first I want to teach our own Indian doctors. So we get a training center both in Vadala, and now I have started in Chembur and in Dharavi. So let us advocate for continuous professional development, mentorship and support for our colleagues, ensuring that everyone is equipped to face the complexity of medicine. So we in ophthalmology, from American Academy of Ophthalmology, learned something called Leadership Development Program, which talks about time management, interpersonal relation, how to use your secretary, how to use how to organize conferences, how to do advocacy with the government, how to take care of patients. So I suggest you should start leadership development program where you can pay my friends like Shivanandan, who talks on excellence, who was a former Director General of Police or any management person. The reason is all of us are good in medicine, but we are not good in other things which is important for life, and that is important for managing your own family as well as managing the patient. The life is made of 5 balls, and 4 are rubber balls, and 1 is family is a glass ball. So you all have to balance the family so that you don't drop when you do the juggling of balls, the glass ball has to be always caught somewhere, and the rubber ball you can drop. For example, work you can take off from 1 year, either because of sports or injury or disease, but you can come back and practice. So we should do leadership program. I hope the President and Secretary will incorporate that for all of you. And maybe in our ophthalmology we have kept 40 years as an upper age. The reason is we want to develop the doctors of 35 to 40. You have women's wing. In ophthalmology all over the world, we have a organization called YO, that is Young Ophthalmologists. In India, has the highest number of young ophthalmologists. So we have a society called Young Ophthalmic Society of India, and I was the chief guest last week. So you can have a young whatever name you can call, young NIMA, and you should have they have up to the age of 40. And so we must also embrace research and innovation as integral components of our practices, and the challenges we confront today can only be met with evidence. Where we have to incorporate vision, the research. So today I urge each of you to reflect on your role as champions of change. What can you do within your sphere of influence, and to support our theme, one vision, one care, Parivartan for all. So let all of us promise that together under this singular vision we can and will create a future where healthcare is not just a privilege for someone but a fundamental right for all. Thank you very much for your attention.
Thank you so much, sir. This moment today will be remembered by me lifelong. Such a humble, down to earth and a modest human beings we have here. They are very keen on spreading the knowledge. They want the medical ophthalmology specialty to continue, the legacy to continue. The zeal these doctors have at this age is Really worth a big, big round of applause. Traveling, teaching, and सबसे बड़ा गुरु और डॉक्टर वही होता है जो स्टूडेंट्स को सिखाता है, अपना जो भी है वो उनके साथ शेयर करता है. Sir, it was a true honor to have you, and all the doctors who have been trained from you are really very lucky. Thank you so much, sir, for this wonderful lecture. It was immense pleasure. Now I would be calling Dr. Sampada Sant Madam to just say few words. She is the Dean, Government Podar Hospital College. Ma'am, please come.
सर्वप्रथम आपल्या आयुर्वेदाचा आद्यदैवत धन्वंतरी देवतेला सर्वतः नमन. आदरणीय व्यासपीठ आणि माझ्यासमोर उपस्थित असलेले सर्व मान्यवर, आज मी म्हणे फर्स्ट माझी ऑपॉर्च्युनिटी असेल निमाच्या कोणत्या कॉन्फरन्समध्ये स्टेजवरती येऊन बोलण्याचा. हा माझा पहिला प्रसंग असेल. निश्चितच मला खूप आनंद वाटला. एका वेगवेगळ्या क्षेत्रामध्ये मला ह्या ठिकाणी येता आलं. निमाबद्दल मी स्टुडंट लाईफपासून ऐकते. प्रत्येक क्षेत्रामध्ये ज्या ठिकाणी अडचणी उत्पन्न होतात त्यावेळेस मला आठवतं माझ्या विद्यार्थी दशेपासून प्रत्येक ठिकाणी निमानी खूप मदत केली आणि त्या प्रसंगापासून आपल्याला मार्ग मिळालेला आहे. मी आज सर्वप्रथम आभार मानते मी विकास दुबेवर सरांचं सर्वप्रथम अभिनंदन. त्यांना आज जीवनगौरव पुरस्कार ह्या ठिकाणी देण्यात आला, कारण माझ्या जीवनामध्ये सुद्धा दुबेवर सरांचा खूप महत्त्वाचा रोल आहे. मला आठवतं माझं स्टुडंट लाईफ आणि मी जेव्हा PG कंप्लीट झाल्यानंतर जॉब ऑपॉर्च्युनिटीमध्ये होते, तर त्यावेळेस मी म्हणे आज ह्या पदापर्यंत मी जी आलेली आहे ना, ते मी फर्स्ट मी सरांना मी त्याबद्दल त्यांचं अभिनंदन मानेन. कारण PG होऊन जस्ट मी बाहेर पडली आणि जेव्हा मी जॉबसाठी सर्च होते लग्नानंतर त्यावेळेस YMTमध्ये पहिल्यांदा इंटरव्ह्यू द्यायला गेली. माझी शरीरयष्टी खूप बारीक, आता थोडी तरी मी बरी दिसते. खूप बारीक 36-37 किलोची मी ॲज अ स्टुडंट होते आणि रिजेक्ट केलं मॅनेजमेंटने की ये कुछ भी नहीं कर सकेगी. पण ॲज ए सरांचा माझा परिचय विशेष नव्हता, पण सरांना थोडा कॉन्फिडन्स होता की ही काहीतरी करू शकेल आणि सरांनी मला डेमॉन्स्ट्रेशन द्यायला लावलं आणि सगळ्यांना ते खूप छान आवडलं आणि मी आत्ता ह्या पदापर्यंत मी आली आहे. फर्स्ट मी श्रेय देईल दुबेवार सरांना ह्याच्या बाबतीमध्ये. आणि ह्या ठिकाणी माझे गुरुसुद्धा आहेत रामन सर. तर रामन सरांनी सुद्धा आता माझ्या स्टुडंट लाईफपासून त्यांनीसुद्धा मला शिकवलेलं आहे. पण आतासुद्धा मी डीन पदावर असतानासुद्धा जे काही पोद्दारसाठी जे काही प्राप्त होतं ह्या ठिकाणी त्यामध्ये सुद्धा रामन सरांचं खूप महत्त्वाचं जास्तीत जास्त श्रेय मी सरांना ह्या ठिकाणी देईन. अशा ह्या दोन्ही श्रेष्ठ गुरुवर यांच्यासमोर मी काय बोलणार, परंतु हा अतिशय सुंदर कार्यक्रम या ठिकाणी निमाच्या माध्यमाने या ठिकाणी होतो आहे. आणि मी आता NAMच्या कॉन्फरन्सला गेली होती दिल्लीला, तर इंटिग्रेशनचा विषय सुरू होतो. परंतु इंटिग्रेशन किती महत्त्वाचं आहे आणि किती महत्त्वाचं आहे आणि त्याचा आपल्याला किती उपयोग होईल ह्या ठिकाणी खूप साऱ्या गोष्टी त्या ठिकाणी चर्चेला आल्या. तर आपण शासकीय यंत्रणा असो किंवा निमाच्या माध्यमाने असो, आपण आपल्या आयुषला आपल्याला खूप पुढे न्यायचं आहे आणि त्या ठिकाणी आमचं जेवढं सहकार्य असेल किंवा आमची एवढी इन्व्हॉल्वमेंट असेल आम्ही त्या ठिकाणी निश्चितच पुढे असो. पुन्हा एकदा मी सगळ्यांचं अभिनंदन म्हणते आणि मला ह्या ठिकाणी बोलल्याबद्दल तुम्हाला सगळ्यांचे धन्यवाद. थँक्यू व्हेरी मच.
थैंक यू सो मच मैम. बोला जाता है ना कि मूर्ति लहान कीर्ति महान. What she was been told that you cannot do things, she really proved. Thank you so much, madam. And I feel so happy when every person has their thanks for my Dubewar sir. Thank you, sir. Thank you. It's such a great moment. So finally we come to end not of the lecture but the unveiling session. I hope everybody really liked it. Now, before we go on to the next lecture, you know what? 40 days prior this conference, we were all booked. People were wanting to come and join this conference. We came up with an idea that we'll have an YouTube link live, so many doctors can kind of, attend that. In fact, मैं तो अपने घर पे भी बोल के आई हूँ. I'm going to be on the stage, please watch me, that is what. And it is a wonderful opportunity. And how many people are online right now? It's 5,000 plus people with the audience here. Fantastic. Thank you so much for this lovely Overwhelming response. Thank you all the dignitaries for your precious time. Thank you so much. Every person has things to teach us and we will learn from them. Thank you, sir. We have 2 lectures, and after which, of course, Sumter's meal will be waiting for all of you all. So continue. Thoda sa patience, or we have 2 lectures, after which we will have lunch session at around 2:30. 2 o'clock. So we continue with our galaxy of speakers. We will provide you not with lunch, but even feast of knowledge. So over to Rajni ma'am for the announcement of next speaker. The speaker is also here. So ma'am, should we continue? Doctors, please be seated. It's not the interval time.
कडाडून नभात जशी ढगांचे वीज भाग करी कडाडून नभात जशी ढगांचे वीज भाग करी तशीच छेदे काळ जाला नजर तुझी ही टपोरी असे हे डोळे जे बोलतात द वन विच नेवर डाय द गिफ्ट ऑफ ब्युटी बाय पियर्सिंग देम हू परफॉर्म more than 20,000 cataract surgeries and 2,000 glaucoma surgeries is none other than Dr. Smith Bavaria. The today's lecture delivers recent advances in eye care. For this, I request the chairperson, Dr. K.V. Phadatare sir and Dr. Ishkelal Kanojiya on the dais. Dr. K.V. Phadatare, Dr. Ishkelal Kanojiya, please come on the dais. Dr. K.V. Phadatare, the immediate past president of NIMA District Branch, Mumbai. He is BMS with 43 years experience in general practice at Vadala. He is specialized in the acupuncture. Dr. Ishkelal Kanojiya, he is ex-medical officer Japata, offshore company USA, in early days and having experience of medical practice 35 years. Dr. Smith Bavaria, consultant ophthalmologist specialized in premium lens cataract surgery and anterior segment surgeries. He conducted highest number of transplant surgeries. Now, he is a full-time consultant at Aditya Jyot Eye Hospital, Vadala. I request Dr. Smith to come on the stage and deliver lecture on recent advances in eye care. Sir, please come. Doctor, you may be knowing that the Sushruta, the ancient Indian surgeon, is widely credited with the first description of cataract surgery around 6th century. Please carry out the next one.
Thank you for the very kind words. And first of all, before I start, I would like to congratulate and thank you, NIMA, for such a wonderful conference and such a wonderful organizing this day. As Madam mentioned that Sushruta was the first cataract surgeon in the world. Before I start, I would like to tell you one small story that the surgery done for the cataract by ऋषि सुश्रुत was called couching. Couching मतलब आँख के साइड में से एक छोटा सा शार्प निडल डाल के कैटरैक्ट को हम पीछे नीचे गिरा देते थे. That was like 6th century. 1500 साल मतलब 7000 साल पहले की बात है. अब आज के ज़माने में कोई काउचिंग करता है वो मैंने देखा है. So I was working in Africa for almost 8-9 years. And in today's world, still the couching is being done in Africa. That is the very poor scenario. So I have seen couching. मैंने ऋषि का सिर्फ फोटो देखा था कि ऐसे करते थे और मैंने लाइव देखा है कि काउचिंग कैसे करते हैं. आई एम नॉट सेइंग कि ये रॉन्ग थिंग है, अच्छी बात नहीं है, बट that's the scenario in the world, in certain areas in the world. So that was just the idea of that couching. And I have published that documentary of couching in American Academy, and we have won the best video presentation award, and it is available on YouTube as well as American Academy. How the couching is done in today's world. I know everybody is hungry, everybody wants to have some good lunch, so many lectures so far, so I will not take much time, I will not go too much into the science. I'll try to make it a simple presentation so that anybody can have any doubt or anything. We can keep that 2-3 minutes at the end so that we can have a discussion also. I have divided my presentation from basic to advancement, in between what is needed for the non-ophthalmologist if you get any emergency patient at your clinic, and also certain things which is the most advanced and possible things in today's world that we have provided to the world as a Agarwal's Eye Hospital group.
हो गया क्या? हाँ पण स्क्रीन ने प्ले झाले, डेस्कटॉप तो झालं का? So almost 1 hour with Dr. Natarajan, you can understand his energy and his enthusiasm. I am staying with him 24/7 in Aditya Jyot Eye Hospital. I feel very blessed that I am working under him. This is our Aditya Jyot Hospital. Now the President, His Excellency VP
CP Radhakrishnan ji inaugurated. So let's get back to the cataract thing now. That is the most commonest problem in the world when it comes to the ophthalmology. Most of the patient comes to us is basically having a problem with the vision due to cataract development. So this is how the cataract is when it is mature. But now in today's world, the scenario or the thinking is changing. When I say ki we treat diabetes to control the sugar from the first day when we diagnose it. Why? So that after the 10 years, 20 years, 30 years down the lane, we don't get the complication of diabetes in our vital organs. We don't wait for the diabetes to damage the organ and then treat it. We start treatment from very first day. The same thing in the cataract also now. We don't wait for the cataract to become this big and then treat it. Before 30 years, before 40 years, there were a lack of certain technologies. We used to do cut surgeries. Now it's a phacoemulsification surgery. So we want as a doctor to treat the cataract on a very early stage. We always emphasize that cataract should be done on an earlier stage, because when we use a certain amount of energy inside the eye to melt the cataract, we want to ensure that that energy doesn't damages the cornea, damages the other part of the eye. So cataract surgery is always recommended earlier, not when it becomes harder or bigger. So this is a normal vision. When a person has a certain amount of cataract, they will start developing a diminution of vision, or they will have a frequent changing of the glass prescription. Their contrast will go down. Now these all changes are so slow, everybody feels that his vision is or her vision is same. It has not reduced. But when we remove the cataract, then we get the actual vision or normal vision. So we always encourage the people to get rid of the cataract the earliest possible. So cataract everybody know, but all of you are, I mean, whatever the patients, when you send for the cataract surgery, they will come back to you and ask, sir or madam, kaun sa lens acha hai? That is the commonest question you will face on. So the cataract surgery के लिए जब हम cataract निकालते हैं, we replace the cataract with the intraocular artificial lens. ये जो artificial lens होता है, उसमें मोटा मोटा mainly दो category होता है. One is monofocal lens, second is a multifocal और trifocal lens. सब पूछते हैं कि which is better, trifocal में ये होता है, monofocal में वो होता है. So it depends on three things. What is the requirement of a person? उनका प्रोफेशनली, उनका डे टू डे एक्टिविटी में क्या रिक्वायरमेंट है. अगर हम मोनोफोकल लेंस डालते हैं, उनको दूर का सब कुछ क्लियर दिखता है, नज़दीक के लिए उनको चश्मा लगाना पड़ता है. इफ अ पर्सन इज ओके विद द ग्लास यूज, दे कैन ऑलवेज गो फॉर अ मोनोफोकल लेंस. Certain people doesn't want to use glasses in their daily activity, they can go for a trifocal lens. As a doctor, as an ophthalmologist, we always encourage for trifocal lens, not because of the cost issue. Cost की वजह से नहीं. I am focusing on the lifestyle changes that brings patient's life at comfort. For example, if I am operating a person at 60 years of age, and if I am putting a monofocal lens, the patient have to use glasses till the rest of this life. Let's say that patient stays और stay alive for next 30-40 years, means 30-40 साल तक उनको हमेशा डिपेंडेंसी रहेगा चश्मा पहनने का, because whatever we do, it's always one time, we can't change it afterwards. So as you grow older, your outside activity will go restricted, and your inside the house, reading, watching mobile phone or TV, all this activity will be more commoner than the outside activity. At 85 or 90, nobody is going to drive from here to Kulaba. They are more into the reading aspect, they are more into the near activity. So what we have to think is, what next after 10 years, 15 years, 30 years down the lane. And that's why we always encourage that person should go for a trifocal lens. Now सब मुझे पूछेंगे कि इससे ग्लेयर्स दिखता है, हेलोस दिखता है, इंटरनेट पे हम ये पढ़ते हैं, यूट्यूब पे ये रील्स देख लिया कि इसमें ऐसा दिखता है कि बाद में लाइट्स का प्रॉब्लम होगा. You have to understand one thing, in a 24 hours, we reduce 8 hours of sleep. Now 16 hours, in 16 hours, how many hours you are going to spend on the road? 1 hour or 2 hour hardly in the night time. For that you are compromising the full day का comfort. So you have to understand कि जो glares और halos दिखते हैं वो रात के 1-1.5 घंटे के लिए होते हैं. जब आप बाहर जाओ, जब आप घर पे होते हो तो there is nothing, I mean you don't see any halos or rings around the eye. So we always encourage the trifocality in the eye. This is today's world's demand, because nowadays everything is in our hand, mobile phone. At certain age you will be always, you are not going to read anything, you are just going to use mobile phone for the news, for the entertainment, for everything. Then why to compromise our comfort by using a chashma for rest of our life? That is how we see the cataract surgery in today's world. This is just a short video how the cataract surgery is being conducted. If you see, we don't give any anesthesia, we don't give any injection for the cataract surgery nowadays. We just use a simple topical drop, eye drop to numb the eye and finish the cataract surgery in hardly 7 to 8 minutes. Without any pain, without any discomfort, patient goes home and resume all the activity very next day. Whether it is using mobile phone, computer, TV, whether it is driving, whether it is to do exercise, even the cooking also can be done very next day. You can go near the gas and start cooking also. So I don't understand what is the restriction for cataract surgery if the vision is going down. You can resume even yoga and Sirsasana also within 2 days after cataract surgery. So there is no change in a daily routine if we undergo a topical phacoemulsification cataract surgery. So I'm just removing the front layer of the cataract, which is called capsulorhexis. Why I'm showing this video? Because this is the commonest surgery as an ophthalmologist we do every day. Every day, this is the common, I mean, sometimes they ask me, you don't get tired of doing the same thing every day and every hour you are doing same surgery. But every patient, every eye presents a different scenario. It looks same, it looks कि इतना smooth बटरी जा रहा है, but it is always a unique case when I operate in all the patient. So I am just releasing the cataract from all the adhesions with the water. Now this is a phaco probe, and we are using a kind of a ultrasound energy. We commonly use word laser, but it is a ultrasound energy that we use to melt the cataract. We break the cataract in a small pieces inside the eye. So we don't remove the cataract out, we just melt the cataract inside the eye and just absorb or suck it out. So this is how the cataract surgery, the phaco probe works inside the eye. And the patient is fully awake, there is no anesthesia, nothing. And you see in a few seconds the cataract is completely gone. Now the second most commonly thing which is in a day-to-day activity that we see is the चश्मा का नंबर निकालने का ऑपरेशन. सबसे पहला क्वेश्चन तो मुझे ही सब पूछते हैं कि आपने क्यों नहीं निकाला, कि आप चश्मा निकालते हैं लेकिन आप क्यों पहनते हो. So again, you know, there are certain reasons for refractive surgery. So मैं जब कोई पेशेंट हमको आता है तो हम उनको सबसे पहला क्वेश्चन यही पूछते हैं कि चश्मा क्यों निकालना है. Because that gives us as a doctor some idea कि what are the indications. Some patients will go for a cosmetic surgery कि मुझे अच्छा दिखना है. Some patient will come for the requirement of their job, जैसे आर्मी, नेवी, पुलिस, डिफेंस, उनको ज़रूरत होती है चश्मा, बिना चश्मे को विजन की. Some patient will come for a dependency purpose. So that is what as a doctor we look for. Someone has a 4 or 5 power का चश्मा, if I snatch the glasses from his eye, they can't drive home or they can't go alone home. So that is the dependency what we are removing. All eyes are not suitable for all the surgeries. We see the word, everybody knows the word LASIK surgery. So LASIK is the first surgery that was started almost 25-30 years back. Now the surgery has gone from LASIK to contour vision to the smile surgery to the silk surgery to the intraocular contact lens surgery as well. So any LASIK surgery or any glass removing surgery requires a thorough pre-operative check. सर्जरी करना सिर्फ 2 मिनट का काम है. So we spend at least 3-4 hours before choosing a person whether they are eligible for surgery or not. Not everybody is suitable for all the surgeries. So pre-operative workup, we analyze the cornea, उसका curvature कितना है, उसका thickness कितना है, width कितना है, height कितना है. All this we take in consideration to understand how safe the LASIK surgery is. So up to 7 or 8 power laser correction surgery can be done. If the power is more than that, the lens should be implanted inside the eye for the safety purpose. But yes, a surgery can be done for all powers. We have removed a medical student, the power of around 24 in one eye, 25 in other eye. So that is also possible. You can understand a person who has done the MBBS, now they are going for an internship and they are not able to see a single finger close to their eyes without glasses. So that's what the medical science has now grown into, ophthalmology has grown into. We could remove the lens inside the eye, fix the particular lens inside the eye, and then next day the power is 0 and 0, both eyes. And that person is now pursuing MD medicine. So, refractive surgery is good if the preoperative evaluation is done very well, if we are not skipping any steps, if we are not jumping ki we are taking assumptions ki aage jaake kuch nahi hoga. We need a proper thorough checkup before surgery. After surgery we can't do anything. So all the candidates who wants to go for surgery, they should go for a basic scan called pentacam. That's it. If the pentacam is done, everything is possible. Now, certain things I would like to just, for example, this is the cornea, if you can assume. So what we do in a basic refractive surgery is we create a flap on the cornea, we put the laser and we close the flap. This is a LASIK surgery. In a PRK surgery, if a person is not suitable for a LASIK surgery or flap surgery, और किसी को आर्मी में जाना है, पुलिस में जाना है, जिसको बॉक्सिंग या कुछ इंजरी का चांस रहता है, we don't create a flap, we just put the laser directly on the eye. That is called PRK surgery. It's the same laser we use for both, but the pattern is different. The smile surgery is we don't create any flap, we don't put laser on the surface, we just create a cheese slice inside the eye and remove the power out. That is the smile surgery. All surgeries have their own pro and cons. It all depends on who is suitable for what surgery. That's where somebody will come to us कि मुझे स्माइल सर्जरी करना है क्योंकि इंटरनेट पे हमने स्माइल देखा है, मुझे सिल्क सर्जरी करना है, मुझे ये कॉन्टूरा सर्जरी करना है. It is not how it works for every person. Every individual eye have their own specificity and that particular eye should be treated on their own rankings. So refractive surgery is safe if we have done a proper thoroughly eye checkup before surgery. Now another problem is a glaucoma. So glaucoma is nothing but the pressure of the eye which keeps damaging the back of the eye, which is optic nerve, which is connecting the eye to the brain. So the optic nerve carries all the signals from eye to the brain. Now that particular nerve is getting damaged due to consistently high pressure inside the eye. Only message I want to give you is after 40 years of age, anyone can have a glaucoma in their eye. But if you don't go to the doctor, if you don't check it, you will never understand that you have glaucoma or not. Because even I don't know whether I have glaucoma if I don't get my eyes checked, because there is no symptoms. There is no symptoms of glaucoma like आँख में दर्द हो रहा है, pain हो रहा है, दिखना कम हो गया. All thing comes when we have lost almost 70% of vision. And the only truth is like whatever we have lost, it cannot come back. So always the prevention is a better way of treating glaucoma, because as a doctor also we are holding in certain limitations. So the glaucoma evaluation is necessary, means every year eye checkup is necessary for all the person who are above 40. That's what I want to just message on glaucoma. Now, Dr. Natarajan also mentioned about that India is becoming a capital of diabetes, and the diabetes are having the most, we treat our kidney, we treat our heart, we treat our lungs or brain, whatever the problems we have related to diabetes. But I have seen a person having diabetes since 15-20 years and they have not checked their eyes even once. That is very, very, very surprising in today's world. Any person who gets detected with diabetes, every 3 months we do HbA1c, but every 6 months we don't do retina checkup. Because this is the place where we can see directly inside. We cannot see our kidney ki nikal ke dekh sakte hai ki kya problem hai. But we can see the eye. It's a window of the body. While examining the retina or examining the back part of the eye, we will understand what kind of damage the kidney is having, what kind of damage the heart is having, what kind of damage the brain is having at this point of time, without even doing any blood test. So any diabetic, newly diagnosed, retina examination is must. Depends on the findings of the ophthalmologist. They can have a yearly checkup or 6 monthly checkup, but that is mandatory. It is you, because diabetes patient will come to you for the treatment. You have to push the patient for the eye checkup every 6 months to 1 year. That is, we do HbA1c every 3 months, 6 months. Why not retina checkup? Because it's a normal, it's basic requirement for treatment of diabetic person. This is a changes of hypertension also inside the eye, hypertensive retinopathy. I don't want to go much in details. So when we talk about recent advancements in the ophthalmology, so if you see in the first slide, it's called corneal transplant surgery, but the entire cornea is not been transplanted. It's just the 10 micron layer inside the cornea is been transplanted. It is called pre-descent endothelial keratoplasty. So in that, we don't have a chances of rejection, very minimal chances of rejection after corneal transplant. The patient vision in just within 2 weeks will go to 100%. If you see, there is no suture even taken on the eye. So that is what we call PDEC, endothelial corneal transplant in the required patient for corneal transplant. So it's not like we entirely remove the cornea and put the new cornea now. It is just a certain layers inside the eye, we change it. Now the PDEC is invented at Agarwal's in India, and now entire world is using in their day-to-day life. The second thing what you are seeing is basically a pinhole pupilloplasty that I am going to give little more details in coming slides. Now for you, I want to emphasize on ophthalmic trauma a little bit. When we were discussing about having lecture, all the committee members emphasize on us ki how you can help the patient to go to the ophthalmologist. Please let me know before time is. So I'll just conclude more. I want to emphasize last few minutes on trauma. See, eye trauma is such a thing, that every person who is smoking, let's say, every person who is smoking will feel that मुझे कैंसर नहीं होगा, बाजू वाले को होगा. Every person has that scenario in their mind. Same thing for the eye trauma also. When we are playing, when we are doing some activities or any day-to-day activities, even our children are playing, we feel that our children will not get the problem, someone else will get. That is the scenario in eye trauma. Because most of the time this eye trauma is being neglected when we have a polytrauma patient. उनको बचाने के लिए बहुत मेहनत लगता है, लेकिन आई को हम भूल जाते हैं. So these are the few things that I want to convey today, especially for the non-ophthalmic medical professional. So immediate response is to understand whether the eye is been ruptured or not. That is the first thing. Once we do all our ABCDE of a normal trauma patient, immediately we have to see and understand whether the eye is involved in not. There are three types of injury. One is a blow injury. I mean, someone has put the fist on the eye or something has blunt trauma on the eye. Second is a cut injury. Some sharp object has gone inside. And third is a burn. Burns means chemical burn or like acid, some alkali material, चूना निकल जाता है सबसे ज़्यादा यहाँ पे हमारे peripheral areas में, rural areas में चूना आँख में चला जाता है. These are the burns. So these are the three commonest type of surgery we see. I mean, injury we see. So domestically in the house anything can happen. एक corner लग गया, किसी का टेबल का कॉर्नर बच्चों को लग गया. These are the domestic thing we see in a day-to-day life. Working in a certain profession, जो पत्थर तोड़ने का या मिस्त्री का काम जिसका होता है या कोई लोहे से काम करता है या वेल्डिंग का काम होता है, उनको वर्किंग प्लेस पे ज़्यादा होता है. फिस्ट फाइट, I mean trauma, assault, fireworks. As an ophthalmologist in India, we are now putting a PIL against the fireworks because we see a horrible fire injury every year in Diwali time. Vehicle accidents, sports, all the sports can have like ball sport. In India, is the commonest eye injury is the cricket ball injury. I won't go too much detail in the trauma, how it should be. At least take the vision if possible at your clinic when the patient comes. You don't have to have a Snellen's chart or anything in the OPD. You just go at least 3 meter or 6 meter distance and try to understand whether the patient is able to appreciate your hand and fingers or not. That will say that how the serious injury is at that point of time. Now, any injury comes like this. Do not try to open the eye forcefully. Do not try to put pressure on the eye because we don't know whether the eye is open or not inside. So never try to put pressure in certain cases where you are not able to see the eye actually when the lid is completely covered with the edema. See, the pressure is being given on that, but that is not recommended. Yeah. So before you refer to the patient to the ophthalmologist, history and mechanism of injury you should note. You try to understand what is the range of vision, vaccination status, whether patient is been given tetanus or not, and try to do a gentle examination. Always try to palpate all the bones because sometimes there is air or kind of a pressure giving tenderness on the bones because sometimes blowout fracture or the kind of a fracture on the rim of the orbit can also be very much harmful. Whenever any globe is open, do not try to put any eye drops or any ointment inside the eye. That is the first thing we have to understand. Do not put anything inside the eye. Just try to patch the eye with different materials. You see, you have all the options. कुछ भी लीजिए लेकिन eyes के ऊपर direct पट्टी लगा के कुछ मत लगाइए. You just have these are the commonest thing we can use to cover the eye before we send it to the ophthalmologist. Because we don't want any eye drop or any ointment or any gauze piece on the eye when the eye is open. And thoroughly wash the eye when the patient comes for the chemical injury. Just 3 or 4 liters of normal saline will make everything normal till you refer the patient to the ophthalmologist. Continuously, thoroughly NS ka pint on the eye. That is more than enough in a first response. Thank you so much.
Thank you, Dr. Smith Bavaria, for approaching to FECO and LASIK surgeries. I call the chairperson to felicitate Dr. Bavaria. I request Dr. Smith Bavaria to felicitate the chairperson. Now we have the lottery. Sir, yeah.
Announce the number.
48 number. Number 48.
Name.
नाव नाही आहे याच्यात.
दूसरा काढा. Take the name.
Number 13. 13. No.
Name.
नाव नहीं डाला है उसने. हो पण जे इथे असतील त्यांनाच मिळणार आहे.
गोल्ड कॉइन आहे काय?
नंबर 453 श्रीरंग कुंभार.
गोल्ड कॉइन आहे फर्स्ट. सेकंड रिस्ट वॉच आणि थर्ड ला
सेकंड रिस्ट वॉच 566 डॉक्टर दस्तगीर चौधरी. डॉक्टर दस्तगीर चौधरी. The third one earbuds Dr. Zambhekar 170.
सिरिन कुंभार फर्स्ट आहे ना.
हाँ. Cancer cannot be cripple love. It cannot shatter hope. It cannot conquer the spirit. Once you choose hope, anything possible. Our next speaker is one who give hope and make life possible. Dr. Rohit Pai, who is going to deliver a lecture on colorectal cancer updates. For this session, I call the chairperson, Dr. Prasad Samant and Dr. Bhagwan Gaikwad. Please come on the dais. Dr. Prasad Samant, Dr. Bhagwan Gaikwad. Dr. Prasad Samant is the Podarites with 35 years of experience in general practice. He is director of Sahyadri Pharmaceuticals Ayurved Manufacturing Company. He is the member of District Consumer Protective Forum. He is appointed by Government of Maharashtra as non-government member for Health, Food and Drugs. Dr. Bhagwan Gaikwad is a BMS having 29 years experience in the general practice and expert in the Kshara Sutra and Panchakarma. He is central government AMA. Dr. Rohit Pai is a consultant medical oncologist at Bantu Hospital, a visiting consultant, Nair Hospital and Medical Research Center. He is graduate at LTM Science Mumbai, MD Internal Medicine and DM Oncology at AIMS Delhi, DNB and MRCP from UK. He felicitated with more than 5 city level awards and 8 state level awards as MPO TISA Scholar Award. Recently, Dr. Sadanand Sardeshmukh sir in 420 case control study concluded that the rising prevalence in the colorectal cancer may be attributed by red chili, green chili and curd, owing to their ability to produce chronic inflammation. I request to come Dr. Rohit Pai to deliver a lecture.
Thank you very much. Thank you very much for the kind introduction. Thanks to NIMA for the opportunity to talk in this August ceremony. So I'll be talking about colorectal cancer, something which is not very commonly discussed. We usually discuss about lung cancer, breast cancer. They are sort of the more glamorous sort of malignancies, but colorectal cancer is something which we don't discuss very commonly. So I'll start. Next slide, please. So we'll talk about the basics. We'll talk about how common is colon cancer. We'll talk about the risk factors with special focus on diet and family history. We talk about the symptoms, alarm symptoms of colorectal cancer and early identification, rising incidence in the young, treatment and screening. And I am not going to bore you with long chemotherapy names, etc. It will be just the basics, how we identify and treat the patients. Next slide, please. So if you look at the anatomy, the colon starts from the cecum, and then you have the ascending colon, and then you have the transverse colon and the descending colon, the sigmoid colon, the rectum, and finally the anus. So right-sided colon means cecum and ascending colon, left-sided colon means the descending colon, sigmoid colon and the rectum. You have differences in prognosis depending on what area the tumor arises from. Right-sided colon actually has got a inferior prognosis as opposed to left-sided colon. Also the morphological appearance of the tumor, if you look at the right side, you have on the right side you are having a exophytic growth, and on the left side you are having this napkin ring growth where you can actually see that the lumen of the colon is sort of narrowed, and that is the reason you can have bleeding from these exophytic lesions, but the napkin ring type of growth might produce obstruction. So bleeding, obstruction might be the presenting symptoms of CA colon, and you can have various sort of morphological appearance of the tumor. Next slide, please. Colon cancer, another important thing is, it is preceded most of the times by a pre-malignant stage. So you are having a mucosal hyperproliferation, then you have a polyp which becomes a larger polyp with the accumulation of mutations, then it becomes a dysplastic polyp which is a precancerous lesion, then you have adenocarcinoma and proper malignant cancer. So you have benign to malignant transformation, and this might take 5 to 10 years. Because of this pre-malignant phase, colon cancer is one of those malignancies which is amenable to screening, because many of the cancers do not have a clearly well-defined pre-malignant. Se malignant kab hota hai pata nahi chalta, but colon cancer mein there is an evolution, and actually colonoscopy etc. can take care of these small polyps or large polyps and prevent them from being transformed to cancerous lesions. And this is the evolution of colon cancer, and essentially you can have an environmental, like we spoke about diet. This can produce a small mutation, but with the accumulation of mutations, you can have a small polyp transforming into a larger polyp and then proper invasive cancer. Next slide, please. So if you look at the staging of colon cancer, size of tumor per se does not matter. What matters is the depth of penetration into the bowel wall. So आप अगर right side में देख रहे हैं, you have stage 1, stage 2, stage 3. You are seeing that the tumor is penetrating deeper and deeper into the bowel wall. The end stage is associated with the surrounding lymph nodes being involved, or whenever you look at a colon cancer patient who has undergone surgery, at least 12 lymph nodes should be there in the pathological specimen for us to comment that the surgery has been adequately performed. Any lymph nodal involvement in colon cancer is stage 3. Any lymph nodal involvement, it is stage 3. Distant spread of colon cancer can happen to the liver, the peritoneum and the lung. Especially the rectal cancers can spread to the lung. What happens is, in the colon, most of the areas you have a portal circulation and the tumor first spread to the liver. But in the rectum, you have a portosystemic anastomosis. The superior rectal vein, inferior middle rectal vein, and tumors can bypass the liver and go directly to the lung. And rectal cancer agar rahega, you have to image the chest also while doing a staging. You have to do a CECT chest and abdomen. Most of us nowadays are doing a PET scan, but rectal cancer mein chest imaging is mandatory because of this characteristic of the rectal cancer to bypass the liver and directly spread to the lung sometimes. Next slide, please. What about the incidence? Most common cancer across the world and most common cancer causing death is lung cancer, very clearly. The third most common cancer, which is in terms of incidence, is colorectal cancer, and it is the second most common leading to cancer death. So it is a very important healthcare problem. Next slide, please. If you are looking at the Indian scenario, next slide, please. So if you are looking at the Indian scenario, colorectal cancer in males is the fourth most common among the new cancer diagnosis, and in females it is the fifth most common among the new cancer diagnosis. If you look at Globocan data 2022, in India, there would be around 14 lakh new cases of cancer per year and around 9 lakh deaths due to cancer. This is across the board, not just colon cancer. And what is most important is the second line. The risk of getting cancer in India, if you live up to age 75, is around 10%. 1 in 10 might develop a cancer. And the risk of dying with cancer if you live up to an age of 75 is around 7%. These are stark statistics. This is not something which we discuss, but this actually is reflecting how common is cancer in the country nowadays. And colon cancer is one of those important cancers which might be increasing in incidence. Next slide, please. What are the risk factors for colon cancer? Overweight, obesity, alcoholism, alcohol intake, smoking, excessive and processed meat and especially red meat, and low fruit and vegetable intake, lack of dietary fiber. This is very important. There have been hypotheses like spicy food, etc. also leading to a pre-malignant change in colon cancer, but these are the classical risk factors. Age more than 50 and family history are non-modifiable risk factors. Overweight, obesity, alcohol, smoking, diet, etc. you can modify, but age, family history you cannot modify. Also, there is certain association with certain other conditions like metabolic disorders like type 2 diabetes mellitus, inflammatory bowel disease like ulcerative colitis, because उसमें क्या होता है, you have repeated inflammation of the colonic mucosa, उसमें colonic mucosa gets destroyed and new mucosa has to form, and इसमें mutations get accumulated and you can get transformation to colon cancer. And ulcerative colitis वगैरह में you have a surveillance for colon cancer. इस normal population से भी ज़्यादा surveillance उनमें करना पड़ता है. There are certain protective factors like NSAIDs, which because they inhibit the prostaglandin synthesis, they can cause decrease in the size of the polyps or prevent polyp formation, and vitamin D may be protective for colon cancer. Next slide, please. Meat and cancer, very important. So this is a WHO sort of a tier list of carcinogens. So that tier list ranges from group 1, definitely associated with cancer, group 2A probably causes cancer, then group 2B, 3, 4, etc. 3 and 4 is not a cause of cancer, probably not a cause of cancer. अगर processed meat की बारे में बात किया जाए, so which is usually there in the buffet breakfast in 5-star hotels, salami, sausage, etc. Processed meats is meats which are being treated with chemicals, etc. to make them last longer. They are not fresh meat. Salami, sausages, hot dogs, bacon, they are group 1. Group 1 carcinogen according to WHO. Next slide, please. So you can actually see smoking has been included in group 1. So smoking के तरह ये processed meat को classify किया गया है by WHO. It is as bad to the health. Okay. Red meat is also bad. It is given group 2A. So red meat, excessive intake of red meat and processed meat is clearly classified as a carcinogen, and we should not be having that. So basically apna diet is also becoming westernized, and we should at least take care that these should not be a part of our diet. Okay, next slide please. What about family history? So you are having one picture here. This is a picture of a colon cancer colectomy specimen, and you are seeing multiple dots, you are seeing multiple polyps in this resected specimen of the colon. So there is a syndrome called familial adenomatosis polyposis. That means because of a genetic mutation, there is early onset of polyp formation, and you can have cancer in patients as young as 20 years, 25 years because of this inherited disorder. In such patients, what is done sometimes is a prophylactic colectomy, because unka risk of getting colon cancer is very high as compared to the general population, and 20-25 maybe the patient can undergo a prophylactic surgery और उसमें ये सब मिलता है pre-malignant polyps, because it is a inherited genetic condition with a very high risk of developing colon cancer. But this is not very common, okay? What is slightly more common is Lynch syndrome, जिसमें polyps नहीं बनते हैं. It is called hereditary non-polyposis cancer, जिसमें DNA repair genes, the pointer is not working, but this MSH2, MSH6, basically these are genes which repair DNA, and उसका अगर deficiency रहा तो you can have colon cancer, but not only colon cancer, other cancers like endometrial cancer, urothelial cancer, ovarian cancers, pancreatic cancer. So basically it is an inherited cancer syndrome. Polyp formation is not a characteristic in that sort of illness, but it is basically mismatch repair deficiency, DNA repair genes का problem होता है, and उसके वजह से you have increased risk of cancers developing. Next slide please. What are the symptoms of colon cancer? Obviously, it depends on whether it is on the right side, it is on the left side, whether it's an exophytic growth, whether it is a napkin ring sort of a growth, but essentially these are the common features or symptoms. You have blood in stools, which might be melena, but usually colon cancer is lower down, so it might be fresh blood. That is most important. So it might be hematochezia. Change in the shape of stool or caliber of stool because of napkin ring growth, caliber of stool might change. You can have altered bowel movement, alternating constipation, diarrhea. In rectal cancer, you can have a pseudo diarrhea because जो rectal cancer के cells के mucus produce करते हैं, that might cause a pseudo diarrhea. So that might be the presenting symptom. You can have abdominal cramping, discomfort, decreased appetite, unintended weight loss, and you can have signs and symptoms of distant spread. So अगर liver metastasis है, तो you can have a right hypochondriac pain, abdominal discomfort, lung mets है, you can have cough, respiratory symptoms, etc. But these are the symptoms. At early stages, colorectal cancers do not cause any symptoms. Please remember, that is why routine screening is important. तो जो polyp का phase है वगैरह, almost never you will have a symptom. This will be an advanced stage or a locally advanced stage जिसमें symptoms होते हैं. Next slide please. So this is one case which we discuss, which we can discuss. A 65-year-old businessman presented with fatigue. CBC showed hemoglobin of 8.5 gram per deciliter. Peripheral smear showed microcytic hypochromic anemia compatible with iron deficiency anemia. Other parameters, LFTs, RFTs were normal. He had no other comorbidities, not on any medicines except for occasionally taking laxative for constipations. What would you do next? So the clear-cut answer, like few of the audience members have also said, is a stool occult blood. So next slide please. Unexplained iron deficiency anemia in a male above 50 years of age, rule out GI cancer. That is the dictum. Male patient and male person, unexplained iron deficiency anemia, rule out GI cancer. Stool for occult blood, endoscopic evaluation is mandatory. Right? And ऐसा नहीं है कि it is always cancer. It can be a peptic ulcer or some ulcerative disease. Patient PPI aspirin ले रहा है, antiplatelet ले रहा है. Even though this patient did not have any history, that was included in the case vignette. But that can be something else. But first we have to rule out GI cancer. Occult blood भेजना है and endoscopic evaluation करना है. Occult blood also, एक simple occult blood से बात नहीं बनती. Usually we send multiple tests, probably 3 tests. And one more thing very important is when we are sending occult blood, we have to ask the patient to stop any iron supplementations for a week or so, because that might result in a false positive occult blood, because iron ही detect करेगा वो in the end occult blood का test. Okay, there are 2 kinds of tests for occult blood. One is the stool GOAC or the peroxidase test, which will look at the heme component, the iron component of hemoglobin, and the other is the immunochemicals testing, which looking at the globin component. वो ज़्यादा commonly available नहीं रहता है. अपने पास usually labs में peroxidase based testing रहता है. Next slide please. अगर वो ग्लोबिन वाला टेस्ट अवेलेबल रहता है तो उसमें आयन का कोई इशू नहीं है, बिकॉज वो अलग कंपोनेंट डिटेक्ट करता है और उसमें आयन रोकने की जरूरत नहीं रहती. बट जो नॉर्मल रहता है स्टूल फॉर ओकल ब्लड, उसमें आयन रोकना होता है. ओके, अनदर केस, एंड दिस इज 2 केस. 24-year-old मेल, नॉर्दर्न इंडिया रेसिडेंट, हैविंग ब्लीडिंग पाइल्स फॉर 1.5 years, underwent multiple treatment with topical agents in village hospital, developed pain while passing stool, for 6 months, only symptomatic treatment received, because usually in a young patient you think of anal fissure, you think of hemorrhoids. But what he presented actually with to Nair Hospital with abdominal pain, and his CT showed extensive hepatic and peritoneal mets due to a rectal cancer. And the patient is on palliative chemotherapy, 24 years of age. The youngest patient of rectal cancer I have seen, and again presented to Nair Hospital, is 13 years of age. So don't underestimate rectal symptoms in a young person. Agar persistent hai, please consider PR examination or a sigmoidoscopy. You can detect a rectal cancer sometimes. It is not always anal fissure or piles. It can be something else. So this is something which I would like the audience to take back. Next slide, please. Don't ignore rectal symptoms, GI symptoms in young people. PR examination, referral for sigmoidoscopy, important if persistent symptoms. Next slide, please. There is rising incidence of colon cancer in the young. Colon cancer का risk in 20 to 34 year के range में it's increasing by 90%, that is almost double. And rectum cancer 20 to 34 years old के range में जो लोग हैं 124%, more than double. So basically young adults may be colon cancer and rectal cancer is increasing. Do not ignore abdominal symptoms. Next slide, please. What about the tests which we do to prove the presence of cancer and to stage the disease? So essentially in colon cancer, if you are looking at blood tests, we do CBC, RFT, LFT. The most important tumor marker in colon cancer is CEA level. We can use it to determine the impact of our treatment in advanced cancer. अगर CEA 100 है, for example, treatment के बाद 50 हो रहा है, 10 हो रहा है, it is coming down, we can understand that our treatment is working. The second utility is pre-operatively CEA थोड़ा सा बढ़ा हुआ है, operation के बाद CEA normalize हुआ है, that means we are happy that the surgery has taken care of the disease, right? The other treatment test which we do is colonoscopy plus biopsy. So this you are seeing this camera. This is the most important test. The diagnosis is more often than not established by a colonoscopy. For rectal cancer, you do an MRI because rectum, जो pelvis में है, that is a very complicated anatomical space. In females, you have the uterus, the ovaries. In males, you have the prostate. And obviously, while doing a surgery, while planning a surgery, we need to have a very good resolution of the images. So rectal cancer mein you do a pelvic MRI with rectal cancer protocol. So that is the way you order the test. And you do a CT scan. And CT scan rectal cancer mein chest and abdomen ka karenge. CT scan normally distant metastasis detect करने के लिए utilize होता है, and here you can see to the right side, the bottom panel, you are seeing a liver which is studded with liver mets. Unfortunately, this is a stage 4 cancer. So CT, MRI, PET scan, can it be done? Yes, it can be done. Is it mandatory to do? No. Okay, it is not mandatory. You can get away with by doing a CT chest and abdomen also. Next slide, please. What about treatment? Surgery for colon cancer is the mainstay of treatment for curative early intent. So any patient from stage 1, stage 2, stage 3, उसका पहले surgery होता है. Surgical advances में stage 4 disease में भी surgery आजकल हो रही है, because if you have a limited hepatic disease, आप primary tumor का surgery करोगे, आप liver के metastasis का भी surgery करोगे, that can happen, and you can cure the patient even with stage 4 with limited metastasis. Non-invasive, minimally invasive technique like laparoscopic techniques are increasingly being used for colon cancer surgery. What about radiation? Radiation is not used in colon cancer because colon cancer का usually mesentery रहता है, वो हिलने वाला structure रहता है. But for rectal cancer, it has a very important role to reduce the local risk of recurrence. Rectal cancer में क्या issue रहता है? One is it is disease of the young, like I said, usually young patients में आजकल ज़्यादा पाया गया है. Secondly, the anatomy is very complicated. You have the prostate, you have the gynecological organs in females, prostate in males. उसमें तीसरा चीज़ है, rectal cancer is very close to the sphincters. तो rectal cancer का surgery के बाद most of the times you might require a permanent stoma, and that will compromise the quality of life. So rectal cancer के thought process में क्या क्या चीज़ रहता है? How it can be reduce the local risk of recurrence? How can we improve the surgical results? And number 3, can we avoid the stoma? Okay, so इसीलिए rectal cancer में many of the times you give chemotherapy and radiotherapy prior to the surgery to shrink the tumor so that we get a better result, and maybe sometimes have a sphincter sparing surgery and not result in a stoma. Okay, so that is the concept in rectal cancer. Radiation is a very important part of treatment, and that is usually given pre-operatively, operation ke pehle. Next slide, please. So limited liver metastasis can be resected out, and limited volume के liver metastasis अगर रहते हैं तो surgical techniques have improved and you can actually cure the patient even with a limited liver metastasis. I won't go too much into detail. Next slide please. Also कीमोथेरेपी जो कोलोन कैंसर में देते हैं ऑपरेशन के बाद, नॉट ऑल पेशेंट्स रिक्वायर कीमोथेरेपी. स्टेज 2 में मे बी अराउंड 20 to 30% रिक्वायर. स्टेज 3 में ऑलमोस्ट ऑल रिक्वायर. But usually it is capox or folfox, 3 to 6 months of treatment. Interestingly, colon cancer के curative intent chemotherapy में, adjuvant chemotherapy में hair loss नहीं होता है. So you do not have hair loss. You have other side effects like neuropathy. You have hand-foot syndrome, which is discoloration of the hands and the feet. But hair loss is not there. It may be combined with radiation in rectal cancer, and in stage 4 colon cancer, it is the major modality. Chemotherapy can be combined with targeted therapy, and sometimes you have immunotherapy which is coming up. So essentially curative intent में 3 से 6 महीने ऑपरेशन के बाद आप कोलोन कैपॉक्स या फोल्फॉक्स दोगे. I'll take 2 more minutes. कैपॉक्स और फोल्फॉक्स देगे, and palliative chemo stage 4 में you can combine it with targeted therapy. Next slide please. लिक्विड बायोप्सी करके एक चीज आपको बहुत सुनने में मिलेगी, दैट इज सर्कुलेटिंग ट्यूमर सेल्स और सर्कुलेटिंग ट्यूमर डीएनए, और कोलोन कैंसर में ये काफी यूज हो रहा है इन द वेस्ट. इसेंशियली अगर सर्जरी के बाद भी यू हैव सर्कुलेटिंग ट्यूमर डीएनए, यू हैव इंक्रीज चांसेस ऑफ रिलैप्स and you have to give chemotherapy to destroy those occult cells. There is a screening test also, colonoscopy वगैरह जिनको नहीं कराना है, Garden Shield करके, which is looking at the circulating tumor DNA in screening patients with colon cancer. Okay, so circulating tumor DNA liquid biopsy colon cancer में एक upcoming entity है. Next slide please. And you have targeted therapy, which I won't go into detail. ये सारे mutations के against you have targeted therapy which can be combined with chemotherapy. Next slide please. You have immunotherapy also coming up in a big way. Next slide please. And essentially, next slide please. Next slide. For rectal cancer, for example, there is a drug called dostarlimab, immuno-oncology. अगर ये MMR deficient है, जो लिंस सिंड्रोम का म्यूटेशन था, और हमने रेक्टल कैंसर में ये ड्रग दिया, यू कैन सी बेसलाइन में वो गंदा ट्यूमर है, पेट स्कैन में यू आर सीइंग दैट येलो स्पॉट, ऊपर तो ब्लैडर है, नीचे का एरिया, and you are seeing after 3 months it is almost normal, after 6 months it is completely gone. So without surgery, without radiation, you can preserve the organ. Rectal cancer में medical management, non-surgical, no stoma, no nothing. So this is something which is new in colon cancer. Next slide please. Scopy, colonoscopy, scanning and stool examination are the 3 ways we screen for colon cancer. Next slide please. So stool for occult blood, colonoscopy and virtual CT colography can be used. Next slide. Next slide. So last important is role of family history. ये last case है, मैम 1 minute. Newly diagnosed colon cancer patient 61 years came for adjuvant chemotherapy. फैमिली हिस्ट्री में फादर हैड डाइड ऑफ कोलोन कैंसर, डिटेल्स वर नॉट अवेलेबल. हिस्ट्री लेना बहुत इंपॉर्टेंट है. पेशेंट हैड अ ब्रदर एज 55 इयर्स ऑफ एज, वाज कंप्लीटली एसिम्प्टोमेटिक. लेकिन 2 पेशेंट हो गए 2 जनरेशन में, फादर को प्लस ये जनरेशन. ब्रदर वाज एनकरेज्ड टू अंडरगो स्क्रीनिंग कोलोनोस्कोपी एंड वी डिटेक्टेड अ proliferative growth in ascending colon. Biopsy showed an adenocarcinoma and imaging showed thankfully a localized disease. The patient was cured with surgery and now patient is also undergoing adjuvant chemotherapy. So important to ask the history. Next slide. I think I have come to the end. Thank you. So I would like to hand it back to the organizers if there are no questions. Thank you so much.
Hello. Thank you, Rohit Bhai sir, by delivering the good lecture on the colon cancer and updates. I request Dr. Patil, Saman sir and Dr. Bhagwan to felicitate Dr. Rohit Bhai. I request Dr. Rohit Bhai to felicitate the chairperson. And now the time for the lottery. For the first, the number for the gold coin is 450, Anil Jain. Anil Jain. For the wristwatch, Dr. D.G. Kadam, 158. Dr. D.G. Kadam. Dr. Shaheen Khan. 569 number. Dr. Shirish Lad. Dr. Praveen Yamgar. Dr. Praveen Yamgar.
Number
293.
Thank you, sir, for the lovely informative lecture. Our next speaker is Dr. Rahul Gupta. He has done his DM Cardiology, MD Medicine. तो ज़रा दिल थाम के बैठिए जनाब, आ रहे हैं दिल के डॉक्टर. Cardiac science today stands at the forefront of innovation, where complex angioplasties are performed with precision and safety. The mastery of valve intervention, be it repair or replacement, reflects how expertise and technology together are saving countless lives together. About Dr. Rahul Gupta, sir. He is presently working at Gleneagles Hospitals, Parel, Mumbai, as Director of Head of Cardiology and Structural Heart Program. He has been the lead cardiologist and head of his unit at Apollo Hospital, Navi Mumbai, and Director of Cardvam Advanced Heart Care Clinic. He has expertise in complex coronary interventions, and he is extremely passionate about getting new therapies and has developed expertise in structural heart disease interventions like TAVI, which is aortic valve replacement without surgery. He has done the highest number of TAVI cases in this area. A big round of applause for this. For the just two lines about the complex angioplasties which we are going to talk about. रगों में जब ट्रैफिक जाम बढ़ गया, कॉम्प्लेक्स एंजियोग्राफी ही ग्रीन सिग्नल दिखाए. दिल के दरवाजे जब ठीक से बंद ना हो यार, वाल्व एक्सपर्ट बना देता है नया ताला, दरवाजा शानदार. The two chairpersons whom I would like to call on stage is Dr. Jaymala Pawar and Dr. Sandeep Singh. Can we have Dr. Jaymala Pawar and Dr. Sandeep Singh on the stage? Over to you, Dr. Rahul Gupta.
Thank you for the kind introduction. Good afternoon, everyone. And can I have my slides, please? Okay, so let's begin with the newer frontiers in cardiology, and I would stop as and when the time gets over, because there is so much in the field of cardiology that I think half an hour session is not enough to discuss everything, but I'm going to go through because it's very interesting. Cardiology has become very interesting because it's dynamic and a lot of exciting technologies have come solving complex issues with minimally invasive procedures. And I think this awareness of latest drugs and devices in cardiology is of paramount importance because our patients are seeking help for their complex issues, and if we can offer them something which can relieve their symptom is fantastic. When to start, when to refer, all these are very important questions, and these frontier outcomes are changing lives in a big way. Now, if you look at the field of cardiology, it includes a vast topics. I am including only few of them. So what you are seeing is only few of them, whether it is heart failure, hypertension, diabetes, valvular heart disease, atrial fibrillation, CAD, lipid, calcific lesion, coronary syndromes. So these are multiple topics where there are latest advances which have come up, and these are common issues which we are going to face in our day-to-day practice. So all of us must be aware about these issues. So let's look into heart failure. You know, heart failure is one of the most common condition which we are going to see. The risk factors for heart failure is diabetes, hypertension, coronary artery disease, CKD, and all of this have become very common in our country. So you are going to see, and that too at young age. So we are getting heart attacks at 30, 25. The youngest patient which I treated few days back at clinicals was just 24-year-old. So these are the kind of people we are getting, and these are the people who are going to develop heart failure. So what do we do for these heart failure patients? We should know about the 4 foundational therapies, which include ARNI, SGLT2 inhibitors, beta blockers, and MRAs. We should include, so there can be a separate lecture for all this, but today I'm going to discuss about more latest modern medicine. So let me begin with a question, and if there are mics, people can raise hand and answer. Suppose you have a patient who come to your OPD. Now you are sitting in your OPD, busy OPD. His ejection fraction is 15%. ECG shows left bundle branch block. Now when the LBBB is there, the QRS will become broad. In RBBB and LBBB, the QRS will become very broad. LBB with QRS of 150 or RBBB with a QRS of 180. These are the patients whose heart is beating asynchronously, and therefore the EF has gone down. Now patient has tried medications are not helping. Can anybody answer what could be the treatment for this patient? CRT, fantastic. I think intelligent audience. So patients who have got LBBB, EF is on the lower side, CRT is something which can help. So CRT is a biventricular pacemaker. Now when we put a pacemaker, normal traditional pacemaker, one lead goes into the right atria, the other one goes into the right ventricle. Here the third lead goes into the left ventricle. Okay, so this is called as a biventricular pacemaker, and now we have conduction system pacing, which can also help, which can actually conduct, give the current to the left bundle directly. So what happens is the heart starts beating synchronously and the ejection fraction improves. So somebody coming to you with this kind of scenario, don't forget to advise them about the CRTP. They will be really blessing you because their quality of life will improve. So medications doesn't help everybody, and if they are not helping, just go and discuss them. Now, what is the biggest reason for death in these patients? Patients with low ejection fraction, what is the biggest reason for death? Arrhythmia, somebody said arrhythmia, correct. So sudden cardiac death is responsible for all these patients who are ejection fraction who is on the lower side. So you will get a phone call, patient was doing fine, no breathlessness, they were doing very well on the medications. When they come to your OPD, they are very happy, you are very happy, the patient is doing well, and one fine day you get a call that patient ne aankhein upar kar liya, and then suddenly patient collapse, frothy thing comes out, they have arrested because of the ventricular tachycardia or ventricular fibrillation. So if a patient is coming to you, he is asymptomatic, EF is less than 30%, and if he is at high risk of sudden cardiac death, what will be your advice? What will be your advice? So for low EF you advise CRTP. Now for patient doesn't have, QRS is not broad, and the patient is having low EF, you want to save their life. ICD, perfect. So the ICD is implanted in a chest, just like a pacemaker. So it can give shock. So it will keep on observing, and whenever there is a ventricular fibrillation, heart is beating fast, the ICD will give a shock and it will restore the rhythm. So these patients will just experience a little thud and they will become better. So learning is low LVF, less than 35% ECG, broad QRS. You can consider them CRTP, CRTD if medications are not helping. QRS is not broad, but want to prevent sudden cardiac death, AICD is the answer. So this is something which is advisable, because we are getting younger patients who can develop these heart problem, low EF, and we want to prolong their life, and this advice is very important even if they are feeling better. So you can do Holter monitoring to see rhythmic burden and all those things, what is the risk. Now let's go to a second question. 45 female comes to you with episode of syncope. On Holter test, ECG shows a long sinus pause with very low heart rates. Patient has been advised permanent pacemaker, but she doesn't want any cut on the chest. What can you offer to these patients? They come to you, they said pacemaker has been advised, but I don't want to go on a conventional pacemaker. She's a female, doesn't want a scar. So anything you have heard about latest things in this field? Have you heard about leadless pacemaker? Yeah, so these are leadless pacemaker. There are no leads, no cut, no incision. You should just know, see, everybody knows about the pacemaker, but you should also know that there is something called as leadless pacemaker. Now 2 companies are creating. There's also now with dual chamber capabilities, these pacemaker have come. And these are very minute, just like the size of the capsule. You can see less than 2 grams the Medtronic one. And you can implant this in about half an hour's time. Patient can go home the same day, femoral vein, no cuts, no incision, no scar. So this is this small. So this is one of the first cases in 2017 which I had done long back, and this is how it looks like in a real life case scenario. This was a 82-year gentleman with 6 sinus syndrome where I had put this pacemaker. Now let's look into so we have completed heart failure, few things now you know what to do. Rhythm management, latest pacemaker everybody knows, but leadless pacemaker is available. Now coming to the hypertension management. This is very important. We know so many drugs are there with high blood pressure, but suppose you get a 50-year-old male who comes to you with severe hypertension, BP always more than 140/90, even on 4 medications or multiple medications you have tried, patient is not tolerating medication, you give amlodipine, calcium channel blocker, you give diuretic, electrolyte imbalances, something or the other, you give ACE inhibitor, there is a cough. So we get these kind of patients whose BP are not controlled, but we should remember blood pressure high uncontrolled is like a silent killer. It's damaging your kidneys, heart, brain, eyes. You can have increased risk of stroke and intracranial hemorrhage, strokes, kidney failures. So what can you do for these patients who are uncontrolled on medication? Any ideas, any thoughts? Anybody knows about latest technologies which are available? Correct, fantastic. So for those who don't know renal denervation, you have to first rule out any secondary causes. So you rule out sleep apnea, you rule out non-compliance, you rule out white coat. Some people get hypertension when they come to the hospital in front of you sitting, so ask them to monitor BP at home. You can do a ABPM, 24-hour BP monitoring. So if you have ruled out, this is something called as renal denervation therapy. Now this is a kidney artery, and these yellow lines are the renal nerves, which are sympathetic nerves. They are hyperactive in about 70% of these patients who are uncontrolled hypertension on even multiple drugs. And you can go simply, as we do an angiography, you can take the catheter, and once you take the catheter, you just apply the radio frequency, just as we do radio frequency ablation. You see this catheter, about in an hour you complete the procedure, patient will get immediate benefit, and it's an always on effect. So your patient will have continuously lower BP or the normal side BP, or the medication required will come down, and again the longevity will increase, the complications related to hypertension will go away. So this is renal denervation therapy called as spiral therapy, which I just discussed. This is very like a plug and play. So this is how the catheter looks like. You enter the renal artery. This you are trying to enter the renal artery as you do the angiography. No known complications, and it get curves with multiple electrodes, and it emits energies. So it's emitting energy, and the BP effect you can get it immediately normal at that time. Now let's so this is about the latest in hypertension management. And coming to valvular heart disease management. Now there are a lot of patients who have got valvular heart disease. We have 4 valves in our heart: aortic valve, mitral valve on the left side, tricuspid valve, and the pulmonary valve on the right side. Most commonly you will see aortic and mitral valve disease patient. So suppose a patient comes to you, 75-year-old, he is willing to live and he has got a lot of energy, but he has got severe aortic stenosis. And this patient has been advised open heart surgery. They come to you for a opinion whether can we do something. So do you know any therapy which can treat these patients without open heart surgery? Yes. So this is how there are 2 kinds of valve. One is a self-expanding valve. This is the aortic valve, and you remove the catheter, it expands. On the right side is a balloon expandable valve, and you put the balloon expandable valve. You just open it with the balloon, and this is self-expanding valve, and the valve starts functioning 1 hour patient will, the procedure will be done. Next day you can discharge the patient, or at the max 40 days. Just like an angiography, angioplasty, you don't need to give general anesthesia. It can be done under local anesthesia and mild sedation. So this is the latest advancement. Now another question, 25-year-old patient, mitral valve prolapse. Mitral valve prolapse is a congenital condition where the mitral valve is not closing properly. It can lead to leakage, and in some people it can lead to leakage, severe mitral regurgitation. Now she's a model, ideally severe MR, symptomatic, she will need a open heart surgery. Replacement or repair has to be done with open heart surgery. Now she's a model and she doesn't want any scar on the chest. What are the options for this patient? Anybody? Mitra clip, fantastic. Anything else? So mitra clip is one, or the other one is a robotic, very small incision, mitral valve repair, which can be under the breast line, and they can do it with the surgeons who do robotic surgery can do with the simple device. Mitra clip is done by us as a cardiologist. So this is how the valve is leaking. If you can see, this valve is leaking, and this is the device which is available. This we do it on the cath lab. These are a lot of screws. You go from the femoral vein, you enter the left side of the heart, and this is how the clip looks like. So you open up the clip. Now this is the mitral valve which is leaking, and you want to clip this mitral valve. So you enter, you find out where the leakage is coming out, you go in that direction down, and you adjust the clip, you close the clip, and patients, so it becomes Spider-Man eyes or owl eyes. You can see the single orifice has been covered into double orifice, the clip has been applied, and normally it is done for patients who are not eligible for surgery. And in rare cases, we had done for a 25-year-old, therefore I put this example, where she was absolutely not willing and she said, I don't want this scar at all. Then you can do in extraordinary circumstances, but usually open heart surgery and repair and replacement is the way for these patients. But you can always offer this mitra clip, especially those who are not eligible for surgery. We had done for a 80-year-old doctor, general practitioner himself, who had severe MR, suffering, heart failure, EF 15%, and they get wonderful results and they start becoming better. Similarly, severe TR. This was a doctor's mother who had severe TR. Now, severe TR will lead to swelling over the feet, hepatic congestion. Initially, it was thought that she had got cirrhosis of liver and liver was, LFTs were deranged, and then we evaluated, we found there is a severe TR. Now, she was a 35-year-old lady. It is difficult to do the open heart surgery. She was somehow managing, and then we offered her something called as trick valve. There is a tri clip also like mitra clip, and then there is a trick valve. So trick valve is a surgery where you apply one valve into the SVC. See, SVC is draining all the upper side blood into the right atria, and IVC is draining into the lower blood into the right atria, which goes into the right ventricle through the tricuspid valve. So you put two valves at SVC. This is that SVC. Just you unfold, you open it up, and then you do it in the IVC in the same way, and these valves starts functioning. The impact of the leakage of the tricuspid valve goes down. This was this lady which I was talking about. This is a severe TR. All the blue color is a severe TR. You can see on the right side, IVC is huge. It is 22 millimeter. It is congested. It's not collapsing. So all her body is edematous because of this congestion. And then we did this. So this is a real life case scenario where we put this valve. This is the IVC valve, and the first day itself she started doing good. So this is about the valvular management. Pulmonary, aortic, mitral, all these valves in an appropriate patient after a heart team discussion along with the CVTS surgeon, we take a decision. It's not that you send this patient to me for a mitra clip. If the patient is eligible for surgery, we will send for surgery. If the patient is not a candidate for surgery, we will do a mitra clip. So we always have a heart team discussion. It's not that I am telling you all this, that means all patients have to be referred for this. Anybody whose age is less than 65 needs a aortic valve replacement, we would do a surgical aortic valve replacement rather than a transcatheter aortic valve replacement. Yesterday we admitted a doctor's mother who was for TAVR, and when we did the angiography there was a critical circumflex lesion. Yesterday, she is still in clinicals today. I'm going to meet her after this session. So now when I did the angiography, critical circumflex. Now we discuss what is a better idea, SAVR, surgical aortic with CABG versus TAVR with angioplasty. So that discussion is on. So it's not that she had paid 18 lakhs, but still we have stopped and we are going to discuss in the heart team what is going to be good for this patient. Now coming to atrial fibrillation. atrial fibrillation is the most common arrhythmia in the elderlies. Now, what is the dangerous part about the atrial fibrillation? Can anybody tell what is the most dangerous part about the atrial fibrillation? Why it needs attention, deserves attention? It can cause stroke. Fantastic. And stroke is very disabling. See, people can live with heart attack. They can have little low ejection fraction. They can walk and they can do their work. They can do the sitting job. But if you are crippled with stroke, then you are debilitated, you are dependent, and you are nervous and frustrated because you can't do your routine job at all. And atrial fibrillation is one thing which you can prevent your patient from this stroke. These are all unseen dangers because the patient looks all right. Patient comes with atrial fibrillation, you palpate and then you find out. So in clinical examination, see, many a times when the medical officers or my nurses or technicians, they take the pulse and BP at the center where they are getting history noted, I always still palpate their pulses because irregularity may not be picked up on the BP machine or the pulse ox. So you have to palpate. If you find it is irregular in your old patient, do an ECG. ECG shows atrial fibrillation, irregular rhythm. You can calculate their Chatsworth score, which is available online. Usually more than one, they will need, what will they need? Blood thinners. But what is the danger of blood thinner? So atrial fibrillation can cause stroke. Stroke prevention needs blood thinner like anticoagulation. But what is the danger with the blood thinners? Bleeding. So you give blood thinner, stroke is prevented, develops a bleeding. Now, if you have elderly patient who are at risk of falling or who are at high risk of bleeding, if they have atrial fibrillation, you want to treat in such a way कि सांप भी मर जाए और लाठी भी ना टूटे. तो क्या करेंगे पेशेंट के लिए? सांप पकड़ लेंगे. तो कैसे पकड़ेंगे वो सांप? कैसे? Have you heard about LA appendage closure? So we can solve. Now what happens is majority of the clot, this is the right chamber is on the right side of the screen is the LA, and this is the LA appendage. The LA appendage is where the clot forms. Okay, so whenever the patient is in atrial fibrillation, the blood pools down into this LA appendage. So this is the LA appendage, and because it is not contracting, it will form a clot. Now this clot has formed. This clot is now come out from the LA, goes into the aorta. If unfortunately it goes into the brain, this patient is going to get stroke. Now if you don't want the risk of, if the patient is at high risk of bleeding, advise them LA appendage closure. So no risk of bleeding because of the anticoagulation and no risk of the stroke because you will be able to close. So you go from right side to the left side through a transeptal puncture, you take the wire and then you can actually put the device over here. This is the LA appendage closure device, and then patient will not need anticoagulation. Just antiplatelet is enough, and after 3 months even antiplatelets are okay. So these are fantastic therapies. You can benefit your patients. They are coming in a dangerous way, in an unseen way. The only way is your advice and your commitment and confidence in the therapies that you can advise your patient. This is available. Now the most important part, the coronary artery disease, the number one killer worldwide, number one killer in India for sure. We are seeing younger patients with heart disease. We are seeing triple vessel disease in a younger patient. But along with hypertension, diabetes, coronary artery disease, we are also seeing CKD. Now if a patient comes to you, patient has suffered an NSTEMI, you do a creatinine is 2. Now patient has been advised angiography. Now the biggest fear amongst the physician, family physician, general physician, cardiologist, everybody is that if we give an angiography, if we do an angiography, the creatinine can rise. Okay? So what to do in this scenario? What can be done? But angiography is important. But there is a risk of needing a dialysis with the contrast-induced nephropathy. So have you heard about zero contrast or ultra low contrast angiography and angioplasty? So actually you can do angiography in about 2-3 ml, 6 ml dye, 8 ml dye through a biplane cath lab. Like for example in clinicals we have a biplane cath lab where we can do the angiographies in about 3 to 6 ml, 5 to 6 ml. And we can complete the angioplasty. This was a complex case of angioplasty. This I did a live case demonstration. where I did the complex angioplasty with the usage of IVUS by using only 6 to 8 ml dye. So even with high creatinine of 4 in this patient, we could complete the angioplasty. This is how the IVUS and OCT looks like. These are the images. If patient has multi-vessel disease, some cardiologists are saying angioplasty, some are saying bypass surgery, some are saying only medical management. What will you advise? This is a very valid question. People say, एक डॉक्टर ये बोल रहा है, एक डॉक्टर ये बोल रहा है, एक डॉक्टर ये बोल रहा है, तो क्या करना चाहिए? So this is there is a technique called as FFR. You can actually assess the severity of each blockages by passing a wire, and you can know whether this patient will need a multi-vessel angioplasty, multi-vessel bypass, or the bypass surgery, or it can be left on medical management. So there are innumerable examples. And I think you have heard about marathon runners dying and of heart attack, so-called relatively younger, healthier, and patients who were advised bypass but still doing fine. So this is something called as lipid core burden index. You can study through near infrared spectroscopy. This is a Mokoto IVUS. This is again the latest technology. I will not go into the detail. I think I have only 1 minute available. So I will end over here, and with the only one thing, with this last case where the 85-year-old female who was advised, who was suffering critical triple vessel disease, calcified, EF 15%, nobody willing to take the risk, the relatives not ready to take the risk. Then finally I did a Impella assisted angioplasty. Impella is the smallest heart pump in the world. You put that Impella and then you can do a complex angioplasty using a calcium debulking strategy. So thank you very much, and I hope it was interesting. So that you can guide your patients properly, that it is no hope or hopeless case where nothing can be done. With the selectively chosen team and technologies, we can handle these. All these comes with a cost, but I think it can give a new lease of life to our patients. So thank you very much, and for having me here.
Thank you so much, sir. This was an incredible knowledge feast, isn't it? सबका पेट भर गया है, बट हमें आज जो नॉलेज फीस्ट मिली है वो किसी बड़े फीस से कम नहीं है, राइट? एंड सर एक्सप्लेन दिस टॉपिक विद सच अ ब्यूटीफुल एंड क्लियर मैनर दैट ये दिल मांगे मोर, सर. And thank you, sir, for sharing your expertise and enriching your understanding with such clarity and passion. So I now take this opportunity to respectfully invite our esteemed chairpersons, Dr. Manju and Dr. Jaimala ma'am, to kindly felicitate our distinguished speaker, Dr. Gupta sir. A big round of applause, please. खाना खा लिया है, अभी शुगर लेवल्स हाई होने चाहिए. तालियां चलती रहे तो भी चलाएं. Thank you so much. I now request our chairperson, speaker, to kindly felicitate. Mic is not on. Hello. Okay. Hello, am I audible? Yes. So I now request our respected speaker, Dr. Rahul sir, to kindly felicitate our two chairpersons. यहाँ पे भी तालियां चल जाएगी. Yes. Thank you so much, sir, and thank you both the madams. Yes. So I request Rahul sir to stay there, and now we are going to have what? Lucky draw. Yes. So 3 sir, you have to choose 3. नीचे से निकालो. Okay. Who's the luckiest one post lunch? It is Dr. Rajeshwini Khatavkar, madam. Please come, ma'am. 062. Yes, so the most lucky one is she is having a gold, she has won a gold coin. We can have a round of applause for her as well. And now moving on to the second one, Dr. Ravina Bhoir. 295. Dr. Ravina, oh, congratulations, ma'am. And third one, he is Dr. Basavraj Patil, sir. Basavraj Patil, sir. आहेत का? आहेत. परत आले सर. तुम्ही तिसरा विनर आहात सर. तिसरा प्राइज जिंकला आहात तुम्ही. Very good. Thank you so much, sir. Okay, the number 112. And now let's dive into another ocean of knowledge. Are you ready? Yes, very good. The topic is the approach to persistent fever in pediatrics. They say बच्चे भगवान का रूप होते हैं, pure, delicate and deserving of the best care we can offer. When a child presents with persistent fever, it's not just a clinical challenge. It's a call for compassion, clarity and timely action. So let's approach persistent fever not with panic but with purpose. To illuminate this important topic, I now take the pleasure in inviting our distinguished clinician and speaker, Dr. Sadanand Shetty sir, to the dais with a warm and heartfelt round of applause. Please, a big round of applause for sir. Sir, please. So I would like to introduce him as Dr. Sadanand Shetty sir is a practicing pediatrician and neonatologist since last 15 years. He has completed his MBBS and from JJ Hospital, Mumbai, and his post-graduation from Sir HN Hospital, Mumbai. He is attached as a visiting consultant to SRCC Hospital, Surya Hospital, and Apollo Hospital. His specialties are his interests are in neonatology and difficult pediatric cases which require hospital care. He has a team of approximately 10 pediatric super specialties. His vision is to serve the society and make affordable health care for all respective of their financial status. With this vision in mind, his team has ventured in a multidisciplinary center with the state-of-art facilities by the name Vashi Hospital and ICU. So, let's take a moment to warmly welcome sir.
Good afternoon everyone. So today, without wasting much time, we will start our discussion about fever. Now the topic is fever, which may seem very simple. कि fever तो हम लोग हर patient में देखते हैं, इतने सारे patients अपने पास आते हैं, तो fever के बारे में
Very sorry to interrupt this. I would like to invite our chairperson. I'm very sorry, sir. Very sorry. Dr. Prakash Gag, sir, and Dr. Chandrakant Gadkari, sir. Please come on the dais, sir. They both are veterans in their respective fields. Please have a seat, sir. And I would like to introduce them. Dr. Chandrakant sir has completed his BMS and started practicing since 1990. I was not even born then, and has an impressive 35 years of experience as a practicing general practitioner. He has worked as medical officer in R.A. Poddar Government College and Bharatiya Vidyapit, Pune. Dr. Prakash Ghak sir has completed his BMS and has an extensive experience in practicing as a general practitioner for past 23 years. Salute to you, sir, and very sorry and thank you for coming. Thank you. You can continue, sir.
Yeah. So we were talking about fever. तो आप सबको लगता होगा कि fever तो common symptom है, इसके बारे में नया क्या बताएंगे? But there are many new things which are coming up, and जैसे time जाता है, we should be updated. क्या नया आ रहा है? So earlier, whenever fever patients used to come in pediatrics, हम लोग सिर्फ पैरासीटामॉल नहीं, मेफिनेमिक एसिड देते थे, आइबुप्रोफेन देते थे, कॉम्बिनेशंस ऑफ मेफिनेमिक एसिड देते थे. बट सिंस लास्ट 2 years, the only drug of choice is paracetamol. Mefenamic acid has had many reactions, and so it is literally not used by pediatricians. Now, if you see any pediatrician's prescription, you will not see mefenamic acid in it. So my take-home message when you go to your practice again from tomorrow is that avoid use of mefenamic acid, whichever brand you are using, whichever combination you are using. Instead, you prefer paracetamol, and if paracetamol is not helping at all, then in severe cases you may consider ibuprofen. So that is the first take-home message. Also, fever is a symptom and not a disease in itself. Again, every time there is fever doesn't mean it is bacterial infection. It could be viral, it could be malaria, it could be typhoid, it could be TB. When fever persists beyond 7, 10, 15 days, it could be inflammatory response of the body. Like during COVID, many children, they generally didn't have much COVID infections. But 4 to 6 weeks after COVID fever, they would have inflammatory changes. And these changes were seen as MISC syndrome, multisystemic inflammatory syndrome in children, which used to cause Kawasaki-like disease, which used to cause coronary aneurysms, एंड फीवर वुडंट सेटल एट ऑल. तो उन बच्चों में IVIG, उन बच्चों में स्टेरॉइड्स देना पड़ता था. सो दैट वाज द इन्फ्लेमेटरी रिस्पॉन्स. मोस्ट ऑफ द टाइम्स इट इज हार्मलेस. पेशेंट को हम लोग बोल सकते हैं कि बुखार अपना दोस्त है, बट कब दोस्त है? पहले 2-4 दिन के लिए. अगर ज्यादा लंबा रहता है तो बुखार अपना दोस्त नहीं है. अगेन इफ अ 6 month old बेबी इज कमिंग टू अस, वी कैन नॉट टेल द पेरेंट अरे बुखार अपना दोस्त है, कुछ टेंशन मत लो. एनी चाइल्ड बिलो 1 year वी शुड बी वेरी अलर्ट कि बुखार इसमें क्यों आया है. और अचानक उसमें बुखार बढ़ के चाइल्ड में थ्रो कन्वल्जन, चाइल्ड में थ्रो सीजर्स. meningitis, meningoencephalitis is very common in this age group, wherein the immunity is lesser. Otherwise, those babies who are immunocompromised, who are on any drugs, inme it could be an indicator for severe infection. So now, why fever occurs? Mainly fever occurs to rebalance the thermostat so that the pyrogens, जंतु जो है उनको दबाने के लिए बुखार आता है. We should recognize what are the indicators of serious illness. अब बुखार तो सब बच्चों में आता है. पेशेंट आपके पास ओपीडी में आ रहा है, मम्मी बता रही है 2-3 दिन से बुखार है डॉक्टर साहब, तो कुछ सीरियस है क्या? सो व्हाट आर द मार्कर्स विच विल टेल अस दैट बच्चा सीरियस है? तो वी शुड आस्क देम कि बाबा 2 बुखार के बीच में, सपोज 10 बजे सुबह बुखार आया है, वापस बुखार रात को 7-8 बजे आ रहा है, तो ये 2 बुखार के दरमियान बच्चा कैसे था? दोपहर में 6 बजे, दोपहर में 3 बजे 4 बजे तक बच्चा खेलता होगा, मस्ती करता होगा, खाना खाता होगा, तो दैट इज नॉट अ सीरियस फीवर. बट अगर बच्चा सुस्त है, सोया है, उठ ही नहीं रहा है, बच्चे को दम लग रहा है, बच्चा एकदम मलूल है, तो वो तकलीफ है. तो दैट इज अगेन अ इंडिकेटर ऑफ सीरियस इन्फेक्शन. अगेन वी हैव टू आस्क सिंपल क्वेश्चंस टू रीच अ क्लिनिकल डायग्नोसिस. ऑल्सो वी नीड टू नो व्हाट आर द बैक्टीरियल इन्फेक्शंस एंड वी नीड टू लोकलाइज दोज बैक्टीरियल इन्फेक्शंस. अभी फॉर एग्जाम्पल अपने पास बहुत बार पेशेंट्स आते हैं, वी लोकलाइज, चलो थ्रोट पेन है, अभी थ्रोट एग्जामिनेशन करते हैं, बहुत रेड है, थ्रोट कंजेस्टेड है. So in such patients, I would request and I would ask you that not to use Cefixime. Cefixime जो एंटीबायोटिक है, कोई भी ब्रांड का ले लो, that should be used in infections which are below diaphragm. जो डायफ्राम के नीचे इन्फेक्शंस है उनके लिए यूज कीजिए. जो डायफ्राम के ऊपर है उधर Cefixime प्लीज यूज मत करना. This is the second take home message which I want you to take away from here. Cefixime please do not use in upper respiratory infections, in tonsillitis, even though some companies may claim कि हमने CV के कॉम्बिनेशन में दिया है, हमने इसके कॉम्बिनेशन में दिया है, बट नो, दैट इज नॉट द ड्रग ऑफ चॉइस. बाकी आप कोई भी एंटीबायोटिक यूज कर लीजिए जो आपके पसंद का है, एमॉक्सक्लेव है, एजिथ्रोमाइसिन है, दूसरे कोई भी एंटीबायोटिक है विच यू कैन यूज, बट नॉट Cefixime. हाँ, अगर लूज मोशंस हो रहे, ब्लड है मोशंस में, देयर यू कैन यूज Cefixime, यू आर जस्टिफाइड. अगर यूरिनरी ट्रैक्ट इन्फेक्शन है, देयर यू कैन यूज Cefixime, बट नॉट इन अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शंस. Again, getting a provisional diagnosis is important. And when, which drugs should be used? As I said, mefenamic acid is to be avoided, ibuprofen is to be avoided, paracetamol is the drug of choice. If at all, if you feel it is not responding at all, then go for ibuprofen. Now, why does fever occur? Basically, it is an immune response of the body. It occurs because of pyrogens. These pyrogens try to maintain the thermostat. Or how does it help? तो फीवर क्या करता है? WBC, इम्यूनोग्लोबुलिन, न्यूट्रिएंट्स, ये सबको नजदीक लाता है एंड इट ट्राइज टू किल द इन्फेक्शन व्हेन इट कैन हार्म. जब फीवर एकदम हाइपरपायरेक्सिया में जाता है 104, 105, दैट टाइम इट कैन कॉज टिश्यू डैमेज एंड एट टाइम्स इट कैन कॉज सीजर्स. देन सीजर्स में लीड टू हाइपोक्सिया. सो सच केसेस शुड बी वरीड अबाउट. हाउ डू वी रिकॉग्नाइज वेदर इट इज सीरियस और नॉट? नाउ दैट इज वेरी स्पेसिफिक क्लिनिकल एग्जामिनेशन. अगर बच्चे को बहुत ज्यादा बुखार है बट हाथ पैर ठंडे हैं, इसका मतलब बेबी इज गोइंग इनटू शॉक. हाथ पैर ठंडे, मम्मी मदर बता रही है कि अरे बच्चे का बदन गर्म है, सर गर्म है, पर हाथ पैर तो बिल्कुल ठंडे है. सो दैट मीन्स पेशेंट इज गोइंग इनटू सर्कुलेटरी कोलैप्स. तो ऐसे पेशेंट को आपको ओपीडी में ट्रीट ही करना नहीं चाहिए. हम लोग भी ओपीडी में ऐसे पेशेंट को ट्रीट नहीं करते. यू इन्वेस्टिगेट, सी व्हाट इज द कॉज एंड रेफर फॉर एडमिशंस. नाउ फीवर नीड्स टू बी डॉक्यूमेंटेड. बहुत बार पेशेंट बोलते हैं सर 2 महीने से बुखार है, बट बुखार मतलब क्या? वो सोचते हैं कि बुखार है. डॉक्यूमेंटेड टेम्परेचर इज नेवर अबाउ 9900. सो दैट इज नॉट फीवर. मतलब उन्होंने बोल लिया और हमने मान लिया, ऐसे नहीं होता. सो वी शुड एजुकेट देम टू डॉक्यूमेंट द फीवर. वापस, इफ दे आर यूजिंग एनी टेम्परेचर, इट इज बेटर टू एनी थर्मामीटर, इट इज बेटर टू मेजर इन द एक्सिला. कभी कभी मर्क्यूरी थर्मामीटर दे विल पुट इन रेक्टम, दे विल पुट इन ओरल कैविटी. दैट इज रिस्की इन बेबीज, इन चिल्ड्रन. So we need to educate them how to measure the temperature, which thermometers to be used. Now high fever is basically more than 102. So analysis of onset, duration and progress is more important. Generally viral fever first day में ही बहुत ज़्यादा से बढ़ेगा. बैक्टीरियल फीवर, इट कुड बी बैक्टेरियमिक मतलब जनरलाइज सेप्सिस, और इट कुड बी एट पिन पॉइंट एंट्री, जैसे टॉन्सिलाइटिस है, जैसे सीरस ओटाइटिस मीडिया है, किसी का पस ड्रेन हो रहा है ईयर से, तो ऐसे कंडीशन में हम लोग सोच नहीं सकते अरे नहीं वायरल है रुको, इधर तो हमको एमॉक्सक्लेव कॉम्बिनेशन देना ही है. अगेन मलेरिया वी नो द फोकस. अभी रिसेंटली वी हैड अ 27 old day baby, दैट बेबी हैज वाइवैक्स पॉजिटिव मलेरिया, तो इसमें वी हैव टू यूज आर्टिसुनेट कॉम्बिनेशंस, कोई ऑप्शन है ही नहीं. इम्यून मीडिएटेड फीवर्स, बहुत बार एज वी डिस्कस्ड अबाउट इन कोविड, पोस्ट कोविड इन्फेक्शन में जो इन्फ्लेमेटरी फीवर्स थे, कनेक्टिव टिश्यू डिसऑर्डर्स है, सिस्टमिक ऑनसेट जुवेनाइल अर्थराइटिस, ये सब इम्यून मीडिएटेड फीवर्स होते जिसमें फीवर चलते रहेगा अनलेस यू यूज इम्यूनोमॉड्यूलेटर्स. So acute fever is less than 7 days, subacute is 7 to 14 days and chronic is more than 14 days. अभी वायरल और बैक्टीरियल इन्फेक्शन में हम लोग क्लिनिकली कैसे डिफरेंस देखेंगे. सो जनरली वायरल इज हाई एट ऑनसेट, जनरली 3-4 दिन के बाद बच्चे का बुखार कम हो जाता है, 2 बुखार के बीच में बच्चा खेलते रहता है, मस्ती करते रहेगा. जनरली इट इज डिसेमिनेटेड, मतलब थ्रोट पेन भी होगा, लूज मोशन भी होगा, वॉमिटिंग भी करेगा, एक सिस्टम में लोकलाइज नहीं कर सकते. वेयर बैक्टीरियल इन्फेक्शंस यू कैन लोकलाइज, कान से पस आ रहा है, ब्लड में पॉटी में ब्लड जा रहा है, यू कैन लोकलाइज इन केस ऑफ बैक्टीरियल इन्फेक्शन. एंड वायरल इन्फेक्शन में क्या हिस्ट्री मिलेगी टिपिकली कि घर में सभी बीमार है सर, घर में मम्मी को भी बुखार है, बच्चे को भी बुखार है, पापा भी 4 दिन पहले बुखार से बीमार थे, तो सच फैमिली हिस्ट्री विथ मल्टीपल पीपल इन्वॉल्व सजेस्ट वायरल इन्फेक्शन. दिस इज हाउ क्लिनिकली वी कैन डिफरेंशिएट. Now when does pyrexia from normal fever of 3 to 4 days move to pyrexia of unknown origin? When it crosses about 3 weeks on OPD basis or about 1 week in hospitalized patient, we call it as PUO, pyrexia of unknown origin. मतलब एडमिटेड पेशेंट है फिर भी 7 दिन में कुछ पता ही नहीं चल रहा है क्यों फीवर आ रहा है, सब कुछ टेस्ट करा लिए, मलेरिया करा लिया, टाइफाइड करा लिया, डेंगू करा लिया, एक्सरे, सिटी स्कैन, यूएसजी एब्डोमेन, एवरीथिंग हैज बीन डन, everything is coming normal, still we don't know. So such fever could be inflammatory fever. Now we have to evaluate the risk. कौन से बेबीज रिस्क में है फीवर के. सो एनी चाइल्ड, इधर मैंने 6 months मेंशन किया है बट आवर कट ऑफ शुड बी 1 year. 1 साल के नीचे कोई बच्चा है जिसको फीवर कंटिन्यूअस आते रहा है 3 दिन 5 दिन 7 दिन, सच पेशेंट शुडंट बी बेस्ट. कोई मालनरिश बच्चा है, वेरी पुअर न्यूट्रिशन, कोई इम्यूनोसप्रेस बच्चा है who is on steroids, who is on anti-cancer drugs, who is on other therapies, so these patients are at high risk and they suddenly can worsen. Again, appearance of unanticipated new symptoms, suddenly severe abdominal pain starts, suddenly vomiting starts, these changes or these danger signs shouldn't be missed. एकदम extremities cold हो गए, oliguria, anuria हुआ, so these patients should be monitored well. Now clinically how we will know viral infection, malaria, bacterial infection will have high fever. इंटरफेब्राइल पीरियड में बच्चा अगर सिक है तो दैट सजेस्ट बैक्टीरियल इन्फेक्शन. अगर रिस्पॉन्स पैरासिटामोल का बहुत अच्छा है सो दैट सजेस्ट नॉन वायरल कंडीशंस. अभी मलेरिया का फीवर एकदम रिदमिक नहीं होता क्लिनिकली. नाउ दिस इज अनदर इंपॉर्टेंट स्लाइड which tells us on the basis of neutrophil counts, on the basis of hemoglobin, on the basis of polymorphs, how bacterial infection can be separated from other infections. Here we are discussing about bacterial infection, systemic inflammatory disease, viral infections, typhoid fever, TB or chronic infections, malaria and leukemias. Now if you see in bacterial infections, polymorphs are raised but platelets are generally normal. Platelets are not affected generally in bacterial infection, whereas in inflammatory diseases platelets generally keep on increasing. 3 lakhs, 4 lakhs, 6 lakhs तक platelet जाएंगे. Whereas in viral infection, WBC count may be on the lower side, platelets may be on the lower side. Again, if it is malaria or dengue, platelets are severely affected. Typhoid fever में WBC count may be still on the lower side. And leukemias, all the 3 cell lines are involved. Sometimes all the 3 cell lines may not be presented together. 1 या 2 cell line affected होंगे. So which fever needs to be treated? Generally fever is a friend, but initial 5 to 7 days. 1 हफ्ते तक बुखार तेज आ रहा है 102, 103, so we cannot counsel the patient, अरे बुखार तो अपना दोस्त है. No. First 2-3 days we can say, okay, fever is a friend. Now how does one control fever? Only and only paracetamol. Then if at all you want to step up, Now mefenamic acid is not generally recommended. Pediatricians are not using them. So you also try to avoid. If at all you want to use the second line, you may consider ibuprofen with due risk. Which drugs are appropriate? Use paracetamol, rarely ibuprofen, and no other drug. That's why I have stressed this slide again. Because earlier mefenamic acid was rampantly used. But now since last 2 years, we are not using it at all. In which clinical situations we will not wait and watch? जनरली कोई 1 साल के नीचे का बच्चा है, ईयर वी हैव मेंशन्ड 3 months, बट आप लोग ओपीडी प्रैक्टिस में 1 साल के नीचे के बच्चे के लिए भी वी विल नॉट टेक अ रिस्क. बेटर टू इन्वेस्टिगेट एंड फाइंड द कॉज ऑफ फीवर. इम्यूनोकॉम्प्रोमाइज्ड चाइल्ड एंड malnourished child. So now we will talk about cases. A 3-year-old child with fever, onset is high, response to paracetamol is good. 2 बुखार के बीच में बच्चा खेल रहा है, मस्ती कर रहा है, ट्रेंड इज इंप्रूविंग, फीवर धीरे धीरे कम हो रहा है. So what is your diagnosis in this? What do you feel could be the common symptom, the cause? Any one of you? Yes, very good, viral. Cold and cough is there, the diagnosis is viral fever, very nice. Again another scenario, 4-year-old child has fever for 3 days, was afebrile, first 3 days received cefixime, after 3 days, 4th day again fever recurs. Onset is high, response to paracetamol is good, interfebrile period again child is playful, yeah, fever is rhythmic, trend is improving. Accompanying symptoms, there is some body ache. What could be our differentials here? Anybody? So this could be the phase 2 of fever, wherein the onset is moderate to low. Initially there is good response to fever, and interfebrile period later, after day 3, day 4, after cefixime is started, child is not playful and dull. Initially first 3 days child was okay, but after 4th, 5th day child becomes dull. Now we cannot tell about the trend, but later on day 4, day 5, abdominal pain starts and there is puffiness around the eyes. So here we are talking about the complications of viral fever or maybe dengue-like infection, wherein capillary leak starts and it may present in such way. Initially बुखार आएगा, फिर 2-3 दिन के लिए बच्चा अच्छा है, फिर 4th, 5th, 6th day से वापस वर्सनिंग शुरू होगा. So another child, 5-year-old, fever with 3 days, onset is high, response to paracetamol is not good. घड़ी घड़ी 4-4, 3-3 घंटे में फीवर आ रहा है, interfebrile period, patient is not playful, trend is worsening, and child has severe pain while swallowing. So what are our differentials in this case? Tonsillitis. In tonsillitis, severe bacteremic infection, this could be the case. Now there is another child, 6-year-old, fever since 5 days, onset is low onset. Initially there is response to paracetamol, but after day 3, day 4, response is less. I am going little fast because I want to finish all the scenarios. So initially child was playful, but later becomes dull. Again fever is rhythmic, trend is worsening. Now accompanying symptoms, if child is breathless, you can localize to respiratory system. इधर बच्चों का कंडीशन देखिए, you have to localized. अगर breathing issues हो रहा है तो that could be respiratory symptoms. You could take an X-ray. If there is severe pain, flank pain, abdominal pain, you could localize it to UTI. Clinically we can localize. जनरलाइज पेन बता रहा है, कहीं पे भी दुखता है, बीच में ही खाना खाने के बाद दुखता है. एंट्रिक फीवर कैन प्रेजेंट इन दिस वे. So these could all be the differentials. We have to keep it as wide open. एक स्पेसिफिक डायग्नोसिस नहीं. 5-year-old child fever since 1 week, high onset, response to paracetamol is there. Interfebrile period में child is playful, rhythmic fever, no, pattern is not rhythmic. Trend for all the 7 days child has fever. Accompanying symptoms, later you can see that there is pallor and fatigue. So what we could think, malaria. Malaria is causing hemolysis. That's why now the patient is having pallor and fatigue. Also clinically you may find liver and spleen. Malaria classically presents with liver and spleen. Now 6-year-old child with fever since 14 days. अभी ये 14 days का documented fever हो रहा है. पहले 3-4 दिन एक डॉक्टर के पास जा रहा है, फिर अपने पास आ रहा है 5-6 दिन. Still child wants, the parents wants OPD basis treatment. So here my request would be, after 7 days, any hospital, ऐसे ही नहीं कि मेरे पास ही भेजो, any hospital of your choice, but refer the patient for admissions. My cutoff which I would suggest for you as a take home message from this lecture is 5 से 7 दिन आप या कोई भी पीडियाट्रिशियन या कोई भी प्रैक्टिशनर 5 से 7 दिन ओपीडी बेसिस पे ट्रीट करो. जब 7 दिन के ऊपर फीवर जा रहा है तो प्लीज डू नॉट ट्रीट ऑन ओपीडी बेसिस. एडल्ट में चल जाता है, दे गिव अस टाइम, But in pediatric practice we have seen, suddenly they worsen. ऐसा ही नहीं कि 8वें दिन वर्सन होगा या 10वें दिन वर्सन होगा. But if we miss something, suddenly they may worsen. तो 5 से 7 दिन आप कट ऑफ रखो, 1 हफ्ते के ऊपर बुखार जा रहा है, investigate them, send to hospital of your choice and involve a pediatrician of your choice. So the response to paracetamol is good. Interfebrile period में child is not playful. Again this is very important. 2 बुखार के बीच में बच्चा कैसा है? अगर 2 बुखार के बीच में बच्चा खेल रहा है, मस्ती कर रहा है, एक्टिव है, तो टेंशन कम है. अगर 2 बुखार के बीच में बच्चा सुस्त है, खेलता नहीं, सोते रहता है, तो दैट इज अगेन अ रेड फ्लैग, बैड साइन. नाउ हाउ इज द ट्रेंड? ट्रेंड इज फीवर इज कंटिन्यूअस. सो अकम्पनिंग सिम्टम्स, चाइल्ड इज टायर्ड, पेल, हैड सीवियर बॉडी एक, पुअर एपेटाइट. हियर वी मे थिंक ऑफ ल्यूकेमिया. ल्यूकेमिया में और क्या मिलेगा? हिपेटोस्प्लीनोमेगली वुड बी देयर. आप पेट देखेंगे तो एकदम पेट फुला हुआ होगा. इफ यू टच लीवर, बड़ा लीवर, स्प्लीन भी एट टाइम्स इज पल्पेबल. लिम्फ नोड दिखेंगे, एट टाइम्स दे कम करे टॉन्सिल से लगता है, टॉन्सिल से लगता है, बट दैट इज ऑल सर्वाइकल lymphadenopathy. We have had patients wherein we have picked as early as 7-10 days, wherein child was treated for cervical adenopathy with amoxiclav pediatricians के पास. But when we saw other lymph node, तो inguinal lymph node भी palpable है, इधर भी palpable है, axillary lymph node. अगर multiple lymph nodes palpable है, then our antennae should be up कि कुछ अलग होगा. तभी we should do CBC. CBC alone will tell us high WBC, platelets may be low. Now when we talk about another case, 10-year-old child with fever since 3 weeks. अभी ये fever थोड़ा लंबा चल रहा है, onset is high. But my suggestion would be that after 7 to 10 days, better to admit and then investigate. And pediatrics may be, I am a pediatrician, but I have 10 subspecialists, super specialists who are working with us. So we don't feel shy to take their help. Whenever we feel नहीं, ये और उसको आईडी स्पेशलिस्ट लगेगा, उसको पीडियाट्रिक ऑर्थो लगेगा, पीडियाट्रिक सर्जन लगेगा, पीडियाट्रिक कार्डियोलॉजिस्ट लगेगा, ऑल स्पेशलिस्ट्स आर देयर, पीडियाट्रिक ऑफ्थैल, एंड ऑल दी स्पेशलिस्ट आर एसोसिएटेड विथ अस. So earlier the trend was not the same 15 years back when I had started the practice, but since last 5-10 years we are getting the help of super specialists even in pediatrics at our center. So interfebrile period mein patient is playful, 2 fever spikes, the trend is same even after 3 weeks. Now gradually accompanying symptoms develop. There is pains in the joints, small joints, rash along with fever. So now here you can think of systemic onset juvenile arthritis. That is also not very rare. 11-year-old child with fever since 1 month, onset is low, responsive to paracetamol, interfebrile period child is sick, not active. अभी ये important है, question which you should ask in your OPD, 2 बुखार के बीच में बच्चा कैसा होता है? अगर 2 बुखार के बीच में बच्चा खेल रहा है, मस्ती कर रहा है, एक्टिव है, तो आपको ज़्यादा स्ट्रेस लेने की जरूरत नहीं है, we have time. But if parents tell you कि नहीं, 2 बुखार के बीच में भी बच्चा सुस्त है, खा ही नहीं रहा है, खेल ही नहीं रहा है, तो फिर हमको डरने की बात है, then better to investigate completely. That is an important clinical marker. Rhythmic, yes, fever is rhythmic, and the pattern is same all along the 30 days. Every day child is having fever. So here in this case there is weight loss, there is cough, progressively increasing history. Again there is a history of TB contact, Cox contact. Now recently I have a patient in Chembur. उसका right lung दिखेगा ही नहीं, पूरा white. Yeah, I think so. Fever is our friend. The disease causing fever needs to be recognized. We should know कि क्यों fever हुआ है. Above up to 100 fever is our friend. If it crosses 100 then it becomes 4. Madam, time है. Yeah. So the only drug which I would ask you to use is paracetamol, and paracetamol can be given 4 to 6 hourly. If you are using it 4 hourly, 10 milligram per kg per dose. If you are using it 6 hourly, 15 milligram per kg per dose. If at all you want to use the second drug, now it is no longer mefenamic, but it is ibuprofen. So that also important take home message I want you to give. Generally we don't start antibiotics, but if you can see the focus, अभी इधर से serous otitis media है, पस आ रहा है, तो of course we need to start. If you can see tonsillitis, of course we need to start. Malaria है तो anti malaria देने ही पड़ेंगे. So ऐसा नहीं कि avoid ही करना है antibiotic. Maybe initial first 1-2 days we can avoid. So provisional diagnosis is possible even without physical signs. No fever doesn't mean no bacterial infection. बहुत बार ऐसा है कि fever भी नहीं है, एंटीबायोटिक शुरू कर दिया. Initial 2-3 days we can avoid antibiotics. So before we proceed, any questions from your end? Since we have time other than questions, I would like to tell you that we are taking help of about 8 to 10 super specialists who are with me in our pediatric practice. I am practicing at Vashi and at Chembur, at Vashi Moralwar Child Care Hospital and at Chembur Varsha Parekh Maternity Hospital, and I am also attached to all corporate hospitals like Surya Hospital, like SRCC Hospital, like Apollo Hospital. So there we have almost 10 super specialists, pediatric super specialties I mean. We have pediatric cardiologist, we have pediatric nephro, we have pediatric ID. So all these people we can involve whenever we feel that cases are difficult. Any questions from the audience? I think the session was informative and helpful. Thank you.
Thank you so much, sir, for such a wonderful session. And I think the takeaway home message that we all are going to take is not to use cefixime in upper respiratory tract infections. Thank you so much, sir. And we will definitely remember all the key points which you have taught today in today's session. I would now request our chairpersons, Dr. Prakash Ghak sir and Dr. C.B. Gadkari sir, to kindly felicitate our speaker, Dr. Sadanand Shetty sir, for delivering a wonderful lecture. Kindly give a big round of applause. I would now request our speaker to do the honors of felicitating our chairpersons, Dr. Prakash Ghak sir. Kindly keep the round of applause going. And our second chairperson, Dr. C.P. Gadkari sir. Thank you so much. As you all know, now it is time for the lucky draw. ये दिन है कुछ खास, prizes एकदम first class. Thank you. जो बैठे ऑडिटोरियम में लास्ट तक, उन्हीं के हाथों में होगा ताज. So shall we take the lucky draw for this session? Are you all ready? Yes. So kindly do the honors.
Dr. Shalini Mishra. Dr. Shalini Mishra. Ticket number 418.
Congratulations, Dr. Shalini Mishra. You have won a gold coin. Now the second lucky draw for wristwatch, and the lucky winner is
Dr. Pritam Chaugle. 184. Serial number 184.
Congratulations, Dr. Pritam Chaugle. Now the next lucky draw is for headphones, and the lucky winner is
Dr. Chirag Shah. 547.
Congratulations, Dr. Chirag Shah. So with this, we end this lecture and the lucky draw. But don't worry, we have lucky draw after every lecture. And don't forget that we have the bumper lucky draw prize, which would be given after all the lectures are over. And those people who are not getting lucky draw prizes, don't get disappointed, because each and every one of you is going to get assured gifts from ourselves, because we wanted to make you feel special even though you win the lucky draw or you don't win the lucky draw. Thank you so much. So now I'll start with the next lecture. So moving towards the next lecture, क्योंकि ये दिल मांगे मोर, हर बीट की एक कहानी है, हर पेशेंट है एक किताब, कार्डियोलॉजिस्ट होते हैं लाजवाब, दिल से काम करते हैं और ईसीजी से करते हैं प्यार. तो चलिए शुरू करते हैं दर्द दिल का हाल. So first of all, I would like to invite our esteemed chairpersons for today's session, and we have with us a very senior practitioner and a mentor, Dr. Maurankar sir. Kindly come forward on the dais. And second, we have a very experienced and a senior practitioner again, Dr. V.T. Shah sir, kindly come on the dais. Please give a big round of applause because these are legends. It is truly an honor to have you both with us today, sir. Now I would take the opportunity to introduce our next speaker, Dr. Nitin Bote sir. Sir is an interventional cardiologist and has an experience of over 12 years. Sir has completed MBBS from RSCM Government College, MD General Medicine from Sassoon Hospital, Pune, DM Cardiology from JJ Group of Hospitals. Sir has performed more than 2,500 angioplasty surgeries and sir has expertise. Yeah, that is a really big thing. And sir has expertise. The special expertise is in doing complex angioplasties and also doing other procedures, that is pacemaker implantation, PDA, that is ductus arteriosus implantation, so on and so forth. Sir is a senior consultant and interventional cardiologist and also the head of department at KJ Somaya Hospital. Sir, it is our pleasure to have such an eminent speaker with us. The topic is also very interesting because we all know that cardiac diseases are on the rise these days. So the topic is what's new in worsening heart failure management. So I know that this is going to be an awesome lecture. I would now like to invite Nitin Bote sir to kindly start the lecture.
So good afternoon everybody. Well, first of all, congratulations to NIMA for organizing such a wonderful conference. My association with NIMA is for the last 36 years, since '89, when Dr. Raut was the president and conferences were started. And every year I see that the quality of conferences are increasing. Not just because of the pink fetas which you are wearing today, but quality and the attendance, the dedication and eagerness to learn new things, and NIMA organizing that. There are other conferences also in the town which are held every year, but to hold a conference in a limited budget and give the best is what I think NIMA has specialized in. That is one. And secondly, regarding Dr. Nitin Bote, I would like to say that he is one of a young, energetic cardiologist, available 24/7 and very good at his work. And more important is he's humble, down to earth. So if I have any problem anytime, I'm busy in some other lab, and if I have a patient somewhere, I call him, Nitin, can you please attend? He will never say no. So that's his quality. Then the third thing now I want to say is about the topic which he is going to say is about heart failure. So as practitioners, you should know that there are two things in cardiology which is very common. One is blockages, heart attacks, bypass, angioplasty. The other now is heart failure. दम लागणे हे सर्वात common symptom. So as the growing population is there, and as diabetes, hypertension, COPDs, everything are increasing, dam konala lagat nahi. And one of the most important thing is that when they don't walk at all, samjatas nahi. When they start walking or they have to run around or climb 2 or 3 staircases, unusually on some day they feel breathless. And that's the time when they say that, oh, today I had been there, normally I don't go, but I climbed 4 staircases, I had to stop in between, or at the end of it, I had to sit for 10 minutes, then you know something is wrong. So heart failure is very common. You have to just apply your mind and be attentive to what patient is saying and then try and evaluate. So he is going to talk about this and the new things in what heart failure is. So I hope you gain by this experience and his lecture, and I wish Dr. Nitin Bote, please go ahead.
Thank you everybody. I am Dr. Nitin Bote. Good afternoon everybody. First of all, a big congratulations to NIMA, Tripathi sir, Phadatare sir for organizing this much crowd and so much crowd outside the hall. मतलब इतना हॉल होके भी जगह नहीं है, मतलब ये बहुत बड़ा सक्सेस है. ओके. सेकंड, my mentor Dr. V.T. Shah sir, and basically he is guiding me since I practiced. I started my practice around 12 years back. I first called sir कि कहाँ सेटल होना है, क्या करना है, जो यंग कार्डियोलॉजिस्ट के मन में रहते डाउट वैसे, बट सर हैज़ गाइडेड मी एंड सर हैज़ हेल्प मी टिल नाउ लाइक अ फादर, यू नो. सो विद दिस इंट्रोडक्शन, एक निगलेक्टेड टॉपिक है जैसे हार्ट फेलियर. अभी आपने किसी को भी बोला कार्डियोलॉजिस्ट मतलब क्या, तो एंजियोप्लास्टी, ब्लॉकेजेस, ज़्यादा से ज़्यादा बाईपास और उससे ज़्यादा हाइपरटेंशन. हार्ट फेलियर मतलब बहुत निगलेक्टेड टॉपिक है. हार्ट फेलियर आपके पास कब आता है, जब लास्ट पेशेंट को सांस बहुत ज़्यादा फूलता है, पैरों में सूजन आता है. तो हार्ट फेलियर के बारे में बहुत कम हम जानते हैं. सब जो भी जानते हैं लैसिक्स. हार्ट फेलियर का पेशेंट आया तो सबसे पहले देने का लैसिक्स देंगे, उसके बाद उसका इडिमा थोड़ा कम होगा, देन व्हाट, देन रेफर टू अ कार्डियोलॉजिस्ट. सो टुडे वी विल बी डिस्कसिंग अबाउट हार्ट फेलियर. सो दिस इज इंट्रोडक्शन. अभी हार्ट फेलियर में देर आर 3 टाइप्स अभी करंटली, मतलब लेटेस्ट गाइडलाइंस के हिसाब से. अभी हार्ट फेलियर का जो डेफिनेशन है वो 2D इको के हिसाब से होता है. कोई भी पेशेंट का आप 2D इको करोगे, अगर उसका इजेक्शन फ्रैक्शन लेस देन 40% आता है तो हेप रेफ में आता है, मतलब हार्ट फेलियर विथ रिड्यूस इजेक्शन फ्रैक्शन. मतलब उसका 2D इको में पंपिंग है लेस देन 40% और उसको साइंस और सिम्टम्स ऑफ हार्ट फेलियर प्रेजेंट है. सेकेंड आता है हेप मिड रेफ, मतलब जो भी मिड रेंज में आता है वो, जिसका इजेक्शन फ्रैक्शन 41% टू 49% है. और थर्ड है हेप पेफ. पेफ मीन्स प्रिजर्व्ड इजेक्शन फ्रैक्शन, मतलब जो पेशेंट को हार्ट फेलियर के सिम्टम्स है, साइंस है, लेकिन 2D को ऑलमोस्ट नॉर्मल है, मतलब उसका 2D को में पंपिंग मोर देन 50% है, वो आता है हेप पेफ, मतलब हार्ट फेलियर विथ प्रिजर्व इजेक्शन फ्रैक्शन. क्लासिकली उनमें क्या रहता है कि रेज एलवी फीलिंग प्रेशर रहता है, वो हम डिस्कस करेंगे. सो ये 3 बहुत इंपॉर्टेंट टर्मिनोलॉजी है जो फ्यूचर में बहुत ज़्यादा यूज होने वाले हैं. सो प्रिवेलेंस ऑफ हार्ट फेलियर. अभी इंडिया का पॉपुलेशन बढ़ रहा है, बहुत सारे एल्डरली पॉपुलेशन है. सो हार्ट फेलियर इज गोइंग टू ऑन राइज, बेसिकली इट विल बी इंक्रीजिंग, क्योंकि एजिंग पॉपुलेशन है और अपना जो सर्वाइवल है एमआई के बाद. पहले क्या होता था, एमआई के बाद सडन कार्डियक डेथ का चांसेस बहुत ज़्यादा रहता था. अभी नया टेक्नोलॉजी, एंजियोप्लास्टी के जो नए मेथड्स आए, उसके कारण हार्ट अटैक आने के बाद पेशेंट का सर्वाइवल बढ़ गया है. तो सर्वाइवल बढ़ने के बाद जैसे पेशेंट एल्डरली होते जाता है तो हार्ट फेलियर का कॉमन चांसेस बढ़ते रहता है. अभी इंडिया में बोलेंगे तो 1 to 2% अडल्ट इज बेसिकली अफेक्टेड विथ हार्ट फेलियर, दैट इज 10 million people. Heart failure is higher in urban versus rural. Age, it is most common in adult more than 65 years of age. Men's have got slightly incidence higher as compared to women. बट वुमेंस में मॉर्बिडिटी ज़्यादा है, मतलब मॉर्टेलिटी ज़्यादा नहीं, लेकिन वुमेंस में सिम्टम ज़्यादा रहते हैं. अगर वुमेंस को हार्ट फेलियर होता है तो उसमें सिम्टोमेटोलॉजी बहुत ही ज़्यादा रहता है. तो 5 year मॉर्टेलिटी. अगर आपके पास कोई भी पेशेंट हार्ट फेलियर के पास आता है, जैसे कार्डियोलॉजिस्ट के पास, 5 साल के बाद उसका 50% मॉर्टेलिटी है. एंड इट इज़ अ लीडिंग कॉज ऑफ हॉस्पिटलाइजेशन अमंग एल्डरली पीपल. मतलब इंडिया की पॉपुलेशन अभी बहुत ज़्यादा है एल्डरली, तो इट इज़ अ लीडिंग कॉज ऑफ डेथ एंड हॉस्पिटलाइजेशन. सो ये बहुत इंपॉर्टेंट फिगर है, याद रखो. 1,33,663. ये मैं नहीं बोल रहा हूँ, एक रजिस्ट्री बोल रहा है. कोई भी हार्ट फेलियर का पेशेंट अगर एडमिट होता है तो द कॉस्ट ऑफ एडमिनिस्ट्रेशन इज लाइक 1 lakh, more than 1 lakh rupees. So this is according to the Manipal Heart Failure Registry. So during initial admission कोई भी हार्ट फेलियर का पेशेंट एडमिट होता है तो 5 days तो रहता ही है आईसीयू में 2 दिन वार्ड में स्टेबल होने के लिए, और उसके बाद 1 दिन डिस्चार्ज होने के लिए. So it causes a significant financial burden to that patient, to that family. So what are the causes of heart failure? ये बहुत इंपॉर्टेंट स्लाइड है. फर्स्ट इज IHD, हार्ट अटैक के बाद पंपिंग कम होने का चांसेस रहता है, तो हार्ट फेलियर होने का चांसेस रहता है. सेकेंड हाइपरटेंशन के कारण भी हार्ट फेल हो सकता है. अगर बहुत ज़्यादा बीपी बढ़ता है तो हार्ट फेल होने के चांसेस बढ़ते हैं. थर्ड इज वॉल्यूलर हार्ट डिसीज, यंगर फीमेल्स जिसमें माइट्रल स्टेनोसिस आपने सुना होगा, रोमैटिक हार्ट डिसीज, एओर्टिक रिगर्स्टेशन, एओर्टिक स्टेनोसिस, ये सब डिसीजेस कैन लीड टू हार्ट फेलियर. Fourth is cardiomyopathy. Cardiomyopathy means there are various cardiomyopathies: ischemic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy, amyloid disease. These can cause heart failure. अरिथमिया, अगर पेशेंट का हार्ट रेट बहुत देर तक ज़्यादा है, जिसको हम बोलते हैं टैकीकार्डिया इंड्यूस हार्ट फेलियर. टैकीकार्डिया होने से क्या होता है, हार्ट का पंपिंग कम होने के चांसेस रहते हैं, हार्ट का फीलिंग कम होता है. इवन ब्रैडिकार्डिया, अगर लॉन्ग स्टैंडिंग हार्ट रेट लो है, जैसे कंप्लीट हार्ट ब्लॉक, उसमें भी हार्ट फेलियर होने का चांसेस रहता है. देन पेरिकार्डियल डिसीज, कंस्ट्रिक्टिव पेरिकार्डाइटिस. कंस्ट्रिक्टिव पेरिकार्डाइटिस मीन्स हार्ट है, उसके बाजू में पेरिकार्डियम है, अगर हार्ट एक्सपांड ही नहीं होगा तो हार्ट फेलियर का चांसेस बढ़ेगा. देन हाई आउटपुट स्टेट, लाइक जिसमें हार्ट बहुत नॉर्मल है, हार्ट में कुछ भी प्रॉब्लम नहीं, लेकिन फिर भी हार्ट फेलियर होता है, जैसे एनीमिया, HB कम है, थायरोटॉक्सिकोसिस, बेरी. देन पल्मोनरी हाइपरटेंशन, इट कैन लीड टू हार्ट फेलियर. देन अमीलॉइडोसिस, ग्लाइकोजन स्टोरेज डिसीज. एंड लास्टली पोस्ट कीमोथेरेपी, अगर कोई भी पेशेंट को कैंसर हुआ है, उसके बाद कीमोथेरेपी दिया गया है, रेडिएशन दिया गया है, उसके बाद ऐसे कुछ चेंजेस होते हैं हार्ट में, दैट कैन लीड टू हार्ट फेलियर. So what is the pathophysiology? Basic physiology is heart failure is due to decreased cardiac output and increased filling pressure. हार्ट मतलब एक पंप है, जो पंप क्या करता है, ब्लड पुश करता है. अगर पंप फेल हुआ तो ब्लड आगे नहीं जाएगा, तो कार्डियक आउटपुट कम होगा. तो पंप फेल होने के बाद पंप रिलैक्स भी होता है, जो फीलिंग प्रेशर बढ़ता है. देन सिंपैथेटिक नर्वस सिस्टम, मतलब हार्ट रेट बढ़ा तो हार्ट फेल होने का भी चांसेस बढ़ता है. Then ventricular remodeling, chronic compensation, and lastly जब हार्ट फेलियर बहुत ज़्यादा बढ़ता है तो पल्मोनरी कंजेशन होता है, सिस्टेमिक कंजेशन होता है. मतलब सबसे पहले पानी लंग्स में जमा होता है, उसके बाद पानी पूरे बॉडी में जमा होता है, एंड लास्टली इट लीड्स टू डिक्रीज परफ्यूजन. सो क्लिनिकल फीचर्स, सिम्टम्स ऑफ द हार्ट फेलियर, ये तो आप सबको पता होगा क्या सिम्टम्स है. डिस्निया, फटीग, इडिमा, रेज जेवीपी, रेल्स मीन्स क्रेप्स ऑन द ऑस्कल्टेशन, हिपेटोमेगाली. वो स्लाइड देखिए, 64% में शॉर्टनेस ऑफ ब्रेथ है, इट इज द मोस्ट कॉमन सिम्टम्स ऑफ हार्ट फेलियर. सेकेंडली इज फटीग, जल्दी थक जाते हैं पेशेंट, इट इज कॉमन सिम्टम्स ऑफ हार्ट फेलियर. 50% ट्रबल स्लीपिंग, एक इंपॉर्टेंट सिम्टम है जो हम मिस करते हैं कि पेशेंट जब सोते हैं तो उनको खांसी आता है. बहुत सारे लोग हार्ट फेलियर के पेशेंट खांसी के लिए चेस्ट फिजिशियन, मल्टीपल फिजिशियन को मिलते हैं, लेकिन वो डायग्नोस नहीं होता है. उनका क्लासिकल यही सिम्टम रहता है, जब भी पेशेंट सोता है तो कफ आता है. देन डिफिकल्टी इन एक्सरसाइजिंग, मतलब पेशेंट एक्सरसाइज नहीं कर पाता. सो दीज आर द स्टेजेस ऑफ हार्ट फेलियर. हार्ट फेलियर स्टेज 1 मीन्स पेशेंट को रिस्क है बट नो स्ट्रक्चरल डिसीज एंड नो सिम्टम्स, मीन पेशेंट को कुछ भी सिम्टम नहीं है, पेशेंट को कुछ भी साइंस नहीं है, लेकिन ही इज एट रिस्क. Stage B, that means patient has got structural disease but no symptoms. Stage C means patient has got structural disease but he is symptomatic. And stage D means last stage, that is refractory or end stage heart failure. So what is the diagnostic work of हार्ट फेलियर? मतलब हार्ट फेलियर का पेशेंट आपके पास आएगा तो आप क्या क्या करोगे? सबसे पहले बेसिक लैब CBC, जिसमें आप एनीमिया देखोगे, अगर HB कम है तो एनीमिया कैन कॉज हार्ट फेलियर. देन किडनी फंक्शन, दैट इज क्रिएटिनिन, अगर क्रिएटिन ज़्यादा है तो रीनल फंक्शन डिरेंज है, उसके से भी हार्ट फेलियर हो सकता है. इलेक्ट्रोलाइट, मतलब सोडियम पोटेशियम ऊपर ज़्यादा है क्या. थायराइड फंक्शन टेस्ट, इंपॉर्टेंट टेस्ट ये है एंटी प्रो BNP टेस्ट. अगर आपके पास पेशेंट जिसको कफ है, दम लगता है, आप पता नहीं कर पा रहे हो कि ये चेस्ट के वजह से है या हार्ट के वजह से है, तो एंटी प्रो BNP नाम का एक सिंपल टेस्ट है, वो कर लो. अगर एंटी प्रो BNP ज्यादा है मतलब वो कार्डियक है, अगर एंटी प्रो BNP नॉर्मल है मतलब वो चेस्ट के वजह से दम लगता है. देन ECG में आप रिदम देखोगे, टैकीकार्डिया है, ब्रैडीकार्डिया है, वो देखोगे. देन कंडक्शन एब्नॉर्मलिटीज। सबसे इंपॉर्टेंट टूल है आज के ज़माने में 2D इको। आप कोई भी पेशेंट हार्ट का फेलियर से अगर सस्पेक्ट कर रहे हो तो आपको 2D इको करना जरूरी है। क्यों? वो मैंने पहले 3 स्लाइड बताए थे, हार्ट फेलियर विद रिड्यूस्ड इजेक्शन फ्रैक्शन, मिड रेंज इजेक्शन फ्रैक्शन एंड प्रिजर्व इजेक्शन फ्रैक्शन। देन यू कैन डायग्नोस MS, MR, AR on 2D echo. Then cardiac MRI. Cardiac MRI is the last step. Then we can do angiography also. Because of blockages, patient can develop heart failure. Then right heart catheterization in selected cases. मतलब जो patient को आप heart transplant suggest करने वाले उसमें हम catheterization कर सकते हैं। So clinical management. हार्ट फेलियर के 4 पिलर्स है। कोई भी पेशेंट को अगर हार्ट फेलियर के लिए ट्रीटमेंट देना है तो WHO, ACCHA ने 4 ड्रग बोले। फर्स्ट इज AC इनहिबिटर्स, ARB और अर्नी, मतलब इन जनरल वाइमाडा, सिडमस आपने सुना होगा, वो बहुत इंपॉर्टेंट पिलर है। सेकेंड इज बीटा ब्लॉकर, एनी बीटा ब्लॉकर इज अ पिलर इन हार्ट फेलियर। थर्ड इज MRA। व्हाट इज MRA? इट इज मिनरलोकॉर्टिकॉइड रिसेप्टर एंटागोनिस्ट। आपने अल्डेक्टोन सुना होगा, स्पाइरोनलैक्टोन, वो MRA में आता है। फोर्थ इज SGLT2 इनहिबिटर्स, डापाग्लिफोसिन, एम्पाग्लिफोसिन आपने सुना होगा, जो डायबिटीज के लिए यूज होते हैं। इनिशियली जब वो ढूंढे गए थे तो डायबिटीज में यूज करते थे। दीज आर द 4 पिलर्स ऑफ हार्ट फेलियर। मतलब कोई भी हार्ट फेलियर का पेशेंट आपके पास है तो these 4 drugs should be there unless contraindicated in his prescription. First is Arni, second is beta blocker in tolerated dose, third is MRA and fourth is SGLT2 inhibitor. Okay? Then in short mechanism, अगर हम Arnis देने वाले how they act, they will cause vasodilation, they will inhibit RAS, that is renin-angiotensin pathway. एक इंपॉर्टेंट ट्रायल है दैट इज कॉल्ड एज पैराडाइम ट्रायल, जो ट्रायल में एनालेप्रिल वर्सेस अर्नी कंपेयर किया गया था और लास्ट उसमें पता चला कि अर्नी कॉजेस डिक्रीज इन हार्ट फेलियर मॉर्टेलिटी एंड इंक्रीजेस द सर्वाइवल रेट। सेकेंड इज बीटा ब्लॉकर। बीटा ब्लॉकर सबसे पुराने ड्रग्स है, मतलब अटिनोल, नेबियोलॉल, कार्बिडोल, बहुत दिन से हम यूज करते हैं। दे विल डिक्रीज द सिंपैथेटिक नर्वस सिस्टम एक्टिविटी। सो मेरिट ट्रायल है, मेरिट नाम का ट्रायल में पता चला कि मेटोप्रोलोल इज सेफ, कार्बिडोल इज सेफ। थर्ड इज MRA। MRA में क्या होता है कि अल्डोस्टेरोन एक हार्मोन है जो हार्ट पे एक्शन करके रीमॉडलिंग करता है। इट विल ब्लॉक्ड बाय MRA रिसेप्टर, so it will prevent remodeling of the heart. RAILS is a trial name in which we studied spironolactone. It decreases the mortality. Then emphasis trial is it studied eplerenone and it decreases the CV events. Last is neo drug, SGLT2 inhibitors. ये ड्रग जब सबसे पहले ढूंढे गए थे वो डायबिटीज के लिए ढूंढे गए थे। बाद में उनको पता चला कि डायबिटीज के साथ इनका मैकेनिज्म हार्ट पे भी है। हाउ दे एक्ट? दे कॉजेस डायूरेसिस, दे डिक्रीजेस कार्डियक मेटाबॉलिज्म एंड DAPA-HF trial, it is a landmark trial for dapagliflozin. It showed that it decreases the heart failure mortality, morbidity, hospitalization. Emperor trial, Emperor means empagliflozin का जो landmark trial है वो, उसमें पता चला कि हार्ट फेलियर के इवेंट्स कम होते हैं। एंड अपना सबसे पुराना और सबसे इंपॉर्टेंट डोज लैसिक्स, डायबिटिक्स। आपके पास कोई भी पेशेंट आए हार्ट फेलियर का, अगर ये 4 पिलर्स आपके पास नहीं है, आपको याद नहीं है, तो लैसिक्स दे दो। लैसिक्स से क्या होगा? यूरिन आउटपुट बढ़ेगा, डायलिसिस होगा एंड इट विल गिव सिम्टोमेटिक रिलीफ फॉर हार्ट फेलियर पेशेंट बाय कॉजिंग फ्लूइड रिडक्शन इन द बॉडी। एंड ट्रायल, उसमें बहुत सारे ट्रायल है, बट लैसिक्स का एक इंपॉर्टेंट चीज याद रखिए, इट इज ओनली सिम्टोमेटिक बेनिफिट, इसमें मॉर्टेलिटी बेनिफिट नहीं है। ये लॉन्ग टर्म ज़्यादा दे नहीं सकते क्योंकि लैसिक्स से इलेक्ट्रोड इम्बैलेंस हो सकता है, हाइपोटेंशन हो सकता है। सो अभी मैंने बताया 4 पिलर्स, लेकिन ये चारों पिलर्स का भी साइड इफेक्ट हो सकता है। अगर आप अर्नी दे सकते तो इट कैन कॉज हाइपोटेंशन, इट कैन कॉज कफ, इट कैन कॉज वर्सनिंग रीनल फंक्शन, मतलब क्रिएटिनिन थोड़ा बढ़ सकता है, इट कैन कॉज इंक्रीज इन सोडियम। देन बीटा ब्लॉकर्स में फटिक भी बढ़ सकता है, इडिमा हो सकता है, इट कैन कॉज ब्रैडिकार्डिया अगर हमने बहुत ज्यादा डोज दिया तो। MRA दिया तो हाइपरकैलेमिया हो सकता है। एंड SGLT2 इंपॉर्टेंटली आप याद रखो, इट कैन कॉज जेनाइटो यूरिनरी इन्फेक्शंस, इट कैन लीड टू हाइपोग्लाइसेमिया, इट कैन लीड टू डिहाइड्रेशन। These are the side effects of the 4 pillars of the heart failure. So device therapy. What is device therapy? मतलब अगर हार्ट फेलियर का पेशेंट आपके पास है, आपने ये चारों पिलर दिए हैं, लेकिन फिर भी ही सिम्टोमेटिक, देन कंसिडर डिवाइस थेरेपी. मतलब ड्रग देना है फिजिशियन का काम, डिवाइस थेरेपी है कार्डियोलॉजिस्ट का काम. उसमें हम कार्डियोलॉजिस्ट क्या क्या कर सकते हैं? ICD, that is intracardiac defibrillator, then CRT, that is cardiac resynchronization therapy, then LVAD, that is LV assist device. So what is ICD? ICD prevents sudden cardiac death. ICD में हम लोग क्या करते हैं? That is battery which is placed in the sternum. Then उसमें लीड रहता है जो सबक्लेवियन वेन के अंदर जाता है, and it prevents causing recurrent ventricular tachycardia. By preventing recurrent VT, it can prevent sudden death. So this is ICD. ICD का जो ट्रायल था उसका नाम था मैडिट ट्रायल, जिसमें मॉर्टेलिटी हाई रिस्क पेशेंट में कम हुआ था. Then CRT. CRT is nothing but it is a pacemaker type of device. It improves ventricular synchrony. How it improves? So some people with heart failure, मतलब हार्ट फेलियर जिन को है उनका आपने ECG किया, अगर लेफ्ट बंडल ब्रांच ब्लॉक जिसमें है LBBB, वो लोग उसके लिए एलिजिबल है. उसमें CRT क्या करता है? दोनों मतलब एक राइट वेंट्रिकल, एक लेफ्ट वेंट्रिकल, एक राइट एट्रियम को पेस करता है, साइमल्टेनियसली पेस करता है. उसके बाद क्या होता है? जो बंडल ब्रांच ब्लॉक है वो रिवर्स हो जाता है. सो बंडल ब्रांच ब्लॉक जो ECG में दिख रहा है आपको, वो रिवर्स होता है. उसमें क्या होता है? कंट्रोल सिंक्रोनाइजेशन होता है. सो आफ्टर पुटिंग CRT डिवाइस just beneath the collarbone, there are 3 wires which are in the heart. It can improve the function, it can improve the mortality, it can decrease the readmission. So LVAD is nothing but a bridge to transplant. मतलब जो पेशेंट बहुत ही सिम्टोमेटिक है, उसका बहुत दवा देने के बाद भी कुछ नहीं हो रहा, उसको हम हार्ट ट्रांसप्लांट बोलने वाले, उसके लिए LVAD है. ये LVAD डिवाइस है. उसमें एक वायर रहता है, एक पंप रहता है, उसमें बैटरी रहता है, एक कंट्रोलर रहता है, जिसमें हम हार्ट का जो पूरा काम है वो असिस्ट डिवाइस के द्वारा कर लेते हैं. सो नॉवेल थेरेपीज, एक नया ड्रग अभी लॉन्च हुआ है वेरिसोगट. रिसेंटली इट हैज शोन बेटर रिजल्ट्स विथ विक्टोरिया ट्रायल. ये मतलब वेरिसोगट कॉम्प्लीमेंट्स अदर GDMT. मतलब आप लोग 4 ड्रग दे रहे हैं फिर भी हार्ट फेलियर का सिम्टम्स कम नहीं हो रहा है, देन वी कैन ऐड दिस मॉलिक्यूल. इट इज कॉल्ड एज वेरिसोगट. इन एडिशन टू एर्नी, बीटा ब्लॉकर, SGLT2 inhibitors, this verisogurt, it facilitates action of all 4 pillars. It acts on cyclic guanylyl cyclase pathway. It will decrease myocardial stiffening, it will decrease hypertrophy, it will decrease remodeling, it will decrease fibrosis, it will decrease renal fibrosis, it will increase renal blood flow, it will decrease the vasoconstriction, it will act on endothelium. So अभी पहले हम बोलते थे 4 pillars, अभी 5th pillar ऐड हुआ है. It is called as verisogurt. वेरिसोगट का इंपॉर्टेंट मैसेज है कि इट विल हैव लेस हाइपोटेंशन, बिकॉज ये बीपी के ऊपर कुछ भी काम नहीं करता है. सेकेंड, अगर आपने अर्नी दिया, लैसिक्स दिया, MRI दिया तो क्रियाट बढ़ने का चांस रहता है, पोटेशियम बढ़ने का चांस रहता है. बट वेरिसोगट कैन बी यूज्ड इन रीनली इम्पेयर्ड पेशेंट इन EGFR अप टू 15 ml. मतलब जो CKD 1, 2, 3 उनमें हम यूज कर सकते हैं. थर्ड इज verisogurt does not cause any electrolyte imbalance, like hyperkalemia. So according to the data from CSI registry, 25% मतलब अपने इंडिया में जो भी हार्ट फेलियर के पेशेंट है उनमें से सिर्फ 25% पेशेंट को GDMT मिलता है, मतलब गाइडलाइन डायरेक्टेड मेडिकल थेरेपी. सो वी हैव टू इंक्रीज दिस रेशियो, मतलब 25% इज वेरी लेस नंबर. जीन थेरेपी, मतलब कोई भी हार्ट फेलियर पेशेंट को हम जीन थेरेपी बोल सकते हैं, जिसमें हम मायोकार्डियल रिपेयर दे सकते हैं, स्टेम सेल थेरेपी कर सकते हैं. बट इसमें ट्रायल्स ऑन गोइंग है, ये अभी तक प्रूवन नहीं है, वेल प्रूवन नहीं है. सो लाइफस्टाइल मैनेजमेंट सबसे इंपॉर्टेंट है. पेशेंट को बोलना आपको कि वजन कम करो, सॉल्ट रिस्ट्रिक्शन करो, फ्लूइड रिस्ट्रिक्शन करो, एक्सरसाइज करो, स्मोकिंग अवॉइड करो, अल्कोहल अवॉइड करो, बिकॉज even after giving drugs, if patient is not changing his lifestyle, you cannot control heart failure. मतलब पेशेंट आप ग्लासेस दे रहे हो, पेशेंट पानी ज़्यादा पी रहा है, आप अर्नी दे रहे हो, पेशेंट सॉल्ट ज़्यादा खा रहा है, ऐसा नहीं चलेगा. Unless until he improves his lifestyle, you cannot defeat heart failure. To defeat heart failure, patient has to modify his lifestyle. Prognosis. अगर हार्ट फेलियर आपने बहुत जल्दी डिटेक्ट किया, जैसे NYHA क्लास 1 या क्लास 2 में है, तो वी कैन ऑब्वियसली इंक्रीज द सर्वाइवल. सो प्रोग्नोसिस इज बेटर व्हेन डिटेक्टेड अर्लियर. क्लिनिकल टेकअवेज बेसिकली मेडिकेशन, डिवाइस, लाइफस्टाइल इंटरवेंशन, ये 3 पिलर से हार्ट फेलियर में. थैंक यू. इफ एनी क्वेश्चंस विल डिस्कस.
Thank you so much, sir, for the wonderful lecture. And as expected, the lecture was very power-packed. And I think the audience agrees. Do you agree? Yes, the audience agrees, sir. Thank you so much, sir. I would now request our chairpersons, Dr. Mavrankar, sir, and Dr. Vitisha, sir, to kindly felicitate our speaker, Dr. Nitin Bote, sir. We are going to have 3 legends in one frame. Kindly give a big round of applause, everyone, for the wonderful lecture.
Three cheers for NIMA.
Yes, definitely. 3 cheers for NIMA. Hooray! 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 And now I would request our speaker, Dr. Nitin Bote, sir, to kindly felicitate our chairpersons, Dr. Mavrankar, sir, and Dr. Vitisha, sir. Kindly cheer on, everyone. Thank you so much. And as you all know, it is again the time for the lucky draw. So check your delegate coupons because you might be next. We never know. So shall we start with the first prize of the gold coin? Who is excited and who wants the gold coin? No one is excited? Yes.
मेरा नाम आ सकता है.
सर आप हो ही गोल्ड, आपको क्या गोल्ड कॉइन दे. सर वाओ. सो डॉक्टर नीता वाघमारे, डेलीगेट रजिस्ट्रेशन नंबर 352. हार्टिएस्ट कॉन्ग्रेचुलेशंस डॉक्टर नीता वाघमारे मैम. You have won a gold coin. The second gift is for wristwatch. Let us see. And esteemed chairperson Vitisha sir is going to say.
Dr. Pradnya Samant.
Delegate registration number 638. Dr. Pradnya Samant, do we have? Areva, congratulations. I would now request senior personality Dr. Mavrankar sir to take the third lucky draw gift, which is for headphones. And the winner is
255. 255.
So unfortunately on this lucky draw, the name is not written, only the number is written 255. So you are the winner of the headphones. Thank you so much, chairperson and speakers. He has not written the name. Kindly come towards the dais and someone will note down your name. Delegate registration number 255. Yeah, thank you.
Please.
Now, as you all know, we are taking lectures one after the other, and I would like to switch the gears, and now I would like to talk in Marathi. Just give me a moment. आदरणीय त्रिपाठी सर, जे आपले नीमा MDB चे ऑनरेबल प्रेसिडेंट आहेत आणि आपले कॉन्फरन्स चेअरमॅन डॉक्टर प्रसाद पवार सर यांनी हे डिसाईड केलं होतं की आपण आपले जे लेजेंड्स आहेत त्यांना आपण एक मानाचा मुजरा देणार आहोत. म्हणजे आपण जे व्हॅलिडेटरी फंक्शन असतं एकदम एंडिंगला तेव्हा आपण त्यांचं फेलिसिटेशन करणार होतो आणि आपले जे बंपर लकी ड्रॉ गिफ्ट्स होते ते त्यांच्या हस्ते आपण देणार होतो. बट वी अंडरस्टँड की काही लोकांना काही कारणास्तव किंवा बिकॉज ऑफ इमर्जन्सी त्यांना ते एंडिंगपर्यंत थांबता नाही येते, तर एक शॉर्टमध्ये क्विकमध्ये आपण एक फेलिसिटेशन फंक्शन आता घेणार आहोत. सो आय वुड नाव लाईक टू रिक्वेस्ट our Honorable President, NIMA MDB, Dr. Narendra Tripathi sir, to kindly come on the dais. And also, I would like to invite our conference scientific chairman, Dr. Namdeo Thorat sir, to kindly come forward on the dais. Also, I would now like to request our Secretary, NIMA MDB, Dr. Mangal Vavar sir, to kindly come forward on the dais. Now I am going to announce the people whom we are felicitating. I would now like to request Dr. Anita Kukre ma'am, NIMA Women's Forum State President, to kindly come forward. Please give a big round of applause because these are the people, these are legends who are working for NIMA tirelessly and they have given it all for the organization. And if we don't felicitate them today, then I think that would not be the correct thing. So we have Dr. Anita Kukre ma'am, NIMA Women's Forum State President. Kindly come ma'am. I would now request our President Dr. Narendra Tripathi sir, Secretary Dr. Mangal Vavar sir, and Scientific Chairman Dr. Namdeo Thorat sir to kindly felicitate Dr. Anita Kukre ma'am.
पुढे जाओ सर सर थोड़ा आगे जाओ पुढे या ना सर आगे जाओ.
Kindly give a big round of applause. Next we have Dr. Anil Patil sir. Sir is co-web designer NIMA Central. Kindly come forward sir. After that we have Dr. LG Yadav sir, ex-president NIMA Maharashtra State and co-op member of NIMA MDB. LG Yadav sir. LG Yadav sir, it is an honor to be here with you sir. And I personally have learned a lot from you. I would request our conference chairman, Dr. Prasad Pawar sir, President, Dr. Narendra Tripathi sir, Secretary Dr. Vavar sir, Namdeo Thorat sir, Scientific Chairman, to kindly felicitate LG Yadav sir. I would like to remind everyone that don't leave the auditorium because we have lectures remaining, we have lucky draw remaining after each lecture, and don't forget, those who have got the lucky draw, if you leave now, you will not get the lucky draw. You have to wait until the last lecture is over to be eligible to win the gifts. Next, I would like to call Dr. Rajendra Khatavkar sir, Legal Cell in Charge, NIMA CC. Dr. Rajendra Khatavkar sir, I have also learned a great deal from you, and sir has a very sound medico-legal knowledge which we all can use. Give a big round of applause to Dr. Khatavkar sir. I request Dr. Prasad Pawar sir, Dr. Narendra Tripathi sir and Mangal Vavar sir to kindly felicitate Dr. Rajendra Khatavkar sir.
इंटिग्रेशनचा टोटल कायदे तज्ञाचा आधार डॉक्टर राजेंद्र खटावकर.
Yay! Jai NIMA, Jai NIMA. Yes. Next we have Dr. Vijay Mane sir, Joint Secretary NIMA CC. Kindly come forward sir, Dr. Vijay Mane sir. It is an honor for us. Dr. Vijay Mane sir is so hardworking and sincere, and sir is always motivating to his students and everyone he meets, and we are really honored that sir is here with us. Thank you so much, sir. Give a big round of applause to Dr. Vijay Mane, sir. I would like to request Dr. Prasad Pawar, sir, Mangal Vavar, sir, Narendra Tripathi, sir, Namdeo Thorat, sir, to kindly felicitate Dr. Vijay Mane, sir. Yeah. Next, I would like to invite Dombivli NIMA PSC, that is President, Secretary and Treasurer. Kindly come forward. Dombivli NIMA PSC, President, Secretary and Treasurer. I would now also like to request Dr. Sanjay Musale, sir, to come forward to felicitate Dombivli NIMA PSC. We are so honored and we feel lucky that we have the support of the neighboring NIMA branches, and it is always a give and take, and we are really happy for the efforts and all the programs which Dombivli NIMA branch always does. Give a big round of applause to the Dombivli NIMA branch. This is a very big day for us, and we are all gathered here under the roof of NIMA, and we all stand together very tall with NIMA at our backbone. Next, I would like to invite Thane NIMA PST, Thane NIMA President, Secretary and Treasurer. Kindly come forward. Do we have Thane NIMA PST with us? Give a big round of applause to Thane NIMA PST. I would request Dr. Narendra Tripathi, sir, Vavar, sir, Prasad Pawar, sir, Namdeo Thorat, sir. I would also like to request Dr. Rajni Yadav, madam, President NIMA Women's Forum, to kindly come forward. Next, I would like to invite Kalyan NIMA PST. Kindly come forward, Kalyan NIMA PST. I personally follow all the programs conducted by Kalyan NIMA PST, and I am really happy that we have you here with us. I would now request Dr. Sanjay Musale, sir, Prasad Pawar, sir, Dr. Rajni Yadav, madam, sir, to felicitate Kalyan NIMA PST.
Madam Impa.
Thank you, I would also like to invite Vasai Virar NIMA PST to kindly come forward, and I would like to invite Dr. Shailesh Tambe, sir, to kindly come on the dais.
Listener Association.
Vasai Virar NIMA PST, do we have them with us?
Maharashtra.
I would like to invite Dr. Dhopte, sir, Vice President NIMA State, to kindly come forward.
Association.
Dr. Dhopte, sir. Next, I would like to invite Dr. Tushar Suryavanshi, sir, ex-President NIMA Maharashtra. Do we have Dr. Tushar, sir? Next, I would like to invite Dr. Anita Sawant, madam, who is leading NIMA Women's Forum. Kindly come forward, ma'am. I have spoke to ma'am on WhatsApp and calls, and we have very great and lengthy discussions, and we have lot of plans regarding Women's Forum, and most of the plans is the mastermind of Dr. Anita Sawant, ma'am, and we are really honored to have you with us, ma'am. I would like to request our dignitaries to kindly felicitate Anita Sawant, ma'am. Kindly give a big round of applause.
Insurance Medical Practitioner Association.
Thank you, ma'am. I would now call upon IMPA PST to kindly come forward. Do we have IMPA PST with us? IMPA PST, do we have? Yes. Kindly come forward. I would like to request Dr. Bhagwan Gaikwad sir to kindly come forward. Give a big round of applause because we are felicitating all the legends who are working great in their fields and who are making a difference by their everyday work. So kindly give a big round of applause. And ma'am is also a proud winner of the gold coin. Also, I would like to invite Dr. Safekar sir and Safekar ma'am to kindly come forward. Dr. Safekar ma'am, do we have Dr. Safekar ma'am? Kindly come forward. I would request our conference chairman, Dr. Prasad Pawar sir, Dr. Gaikwad sir, Dr. Vawar sir, Dr. Namdeo Thorat sir, Dr. Shailesh Tambe sir, Dr. Narendra Tripathi sir, and Dr. Sanjay Musale sir, and Dr. Yadav madam to kindly felicitate Dr. Safekar ma'am. It is an honor to have you here, ma'am. Thank you for coming. Please. Kindly give a big round of applause.
कॉपी करून दिला नाही हां हे बघ दिलेलं आहे त्यात काय नसेल ना हे काय नसेल तर असं करायचं
Thank you so much everyone for coming, and with this we will now end the felicitation function and we will immediately start with the next lecture. Thank you so much everyone. I would now like to call upon Dr. Amita Kukre ma'am, NIMA Women's Forum State President. She is going to guide us as to regarding the work of NIMA Women's Forum, and I'm sure that it will inspire everyone. Dr. Amita Kukre ma'am, the stage is yours. Thank you.
धन्यवाद मॅम. मी वुमन्स फोरमबद्दल तर काही जास्त सांगणार नाही आहे. सर्वप्रथम आपलं आराध्य दैवत धन्वंतरीला नमन करते. आपण सर्व निमासाठी इथे जमले आहात. निमा वुमन्स फोरम ही या निमाचीच एक उपशाखा आहेत. 2006 साली साधना मॅमनी या वुमन्स फोरमची स्थापना केली आणि आज संपूर्ण भारतभर या वुमन्स फोरमच्या शाखा पसरलेल्या आहेत. त्यातल्या त्यात महाराष्ट्रात तर खूपच जास्त. या वुमन्स फोरमतर्फे वर्षभर संपूर्ण महाराष्ट्रामध्ये विविध कार्यक्रम घेतले जातात. मग ते शैक्षणिक असू दे, सांस्कृतिक किंवा सामाजिक कार्यक्रम, अशा तिन्ही स्तरावरती आज वुमन्स फोरमतर्फे विविध कार्यक्रम घेतले जात असतात. यावर्षी मे आणि जून आणि जुलै या 2 महिन्यामध्ये आम्ही एक मेगा प्रोजेक्ट केलेला, तो म्हणजे मेडिसिनल ट्री प्लांटेशन. त्या प्रोजेक्ट अंतर्गत आम्ही संपूर्ण महाराष्ट्रामध्ये जवळपास 600 ते 650 मेडिसिनल प्लांटची लागवड केली. हा आमचा प्रोजेक्ट एक मोठा प्रोजेक्ट होता. त्यानंतर वुमन्स फोरमतर्फे आणखी एक मोठा प्रोजेक्ट हाती घेतलेला आहे आणि तो म्हणजे निमा डायरी, निमा दैनंदिनी 2026. या डायरीच्या अंतर्गत इंटिग्रेटेड ॲप्रोच इन जनरल मेडिसिन या शीर्षकाखाली आम्ही वेगवेगळ्या विषयांवरती माहितीसुद्धा देणार आहोत. त्यामध्ये हायपरटेन्शन, ॲक्यूट MI, डायबेटीस मेलिएटस, ANC मॅनेजमेंट, IV फ्लुइड मॅनेजमेंट, ल्युकोरिया यासारख्या विषयांवरती सविस्तर आणि अद्ययावत अशी माहिती या डायरीद्वारे आम्ही आपणापर्यंत पोहोचवणार आहोत. हे जे विषय आहेत ते आपल्या रोजच्या प्रॅक्टिसमध्ये येणारे आहेत. अशा वेळी कोणते मेडिसिन वापरायचे, कोणते नाही, अथवा ॲक्यूट MI किंवा ॲनाफायलेक्टिक शॉकचा जर का पेशंट आपल्याकडे आला तर आपण तो आपल्या OPDमध्ये कशा पद्धतीने मॅनेज केला पाहिजे याविषयी सविस्तर माहिती असणार आहे. म्हणजे ही डायरी आपल्या टेबलवर असलीच पाहिजे असं प्रत्येकाला वाटलं पाहिजे या दृष्टीने आम्ही या डायरीची योजना केलेली आहे आणि ती अद्ययावत करण्याचा आम्ही प्रयत्न करणार आहोत. तेव्हा माझी आपणा सर्वांना विनंती आहे की आजच या डायरीसाठी आपण ऑनलाईन रजिस्ट्रेशन करावं, कारण हा आमचा पहिलाच प्रोजेक्ट आहे आणि ती आपल्या सगळ्यांना अतिशय उपयुक्त असणार आहे. तेव्हा माझी आपणा सर्वांना विनंती आहे की आपण नक्की या डायरीचं रजिस्ट्रेशन करा. धन्यवाद.
नहीं मैं तो उनके हाथ से ले रहा था, ये जवाबदारी आप क्यों टाल रहे हो?
Thank you so much for this lovely lecture. It is wonderful to have the NIMA with its so many branches and all the members, kind of getting felicitated. It's always nice, ये जो प्रथा है ना awards की, is because of two reasons. One, for what they have been doing, so they should feel acknowledged, and second, to make them strive a little better. So it is always wonderful to felicitate all the people who have been putting in so much of efforts. Next speaker, we have now Dr. Viraj Nevrikar. He is an oncologist. He will be touching a very sensitive topic today, and I would say even a practical one. He is going to talk about the economics of cancer. The word cancer itself is so dreadful, it can scare the patient and the families. But cancer care is not only a health challenge, but also an economic burden that affects patients, families, and entire society. So, when investing in prevention and early detection is not just life-saving, but also cost-effective. So, it is very important to pick it up early. Oncology has given a ray of hope to so many cancer patients. जैसे बोला गया ना, जिंदगी से लड़ाई है, हौसलों का सहारा है, ऑन्कोलॉजी के हाथों में नया सवेरा प्यारा है. So more about Dr. Vijay Nevrikar sir. Dr. Vijay Nevrikar sir has done his MD Medicine and DM Medical Oncology from prestigious All India Institute of Medical Science, New Delhi. He has 10 years of experience of treating complex cancer patients and has many international publications. He is attached to multiple corporate hospitals like SL Raheja Hospital and Shushruta Hospital, and is the director of Indian Cancer Treatment Care. His special area of interest is advanced immunotherapy, targeted therapy, and affordable cancer treatment. That's why the lecture, The Economy of Cancer. I would also call our two chairpersons, Dr. Vijay Mane sir and Dr. Sheila Kolad sir on the stage. Can we have Dr. Vijay Mane sir and Dr. Sheila Kolad ma'am on the stage? Over to you, Dr. Vijay Nevrikar. Can I request the chairpersons to come on the dais, please? Do we have Vijay Mane sir and Sheila Kolad ma'am? I would like to call Dr. Jaimala Pawar. Ma'am, please come on the dais. Dr. Jaimala Pawar. We welcome you, ma'am. Dr. Vijay Mane sir, I just saw him going, but I guess he's relaxing. So what you?
Special thanks to NIMA and to all of you present today, especially post lunch session. I'm really glad you all are here. Generally people aren't there. So the thing is that as said, that I'm going to talk about economics of cancer. I was just going through the entire list of the day and I realized it has been academically very heavy sessions. So now we won't really be talking a lot of about academics and about treatment and about latest care and other things. I would keep it simple, something that affects all of us, something that all of us can understand. So when any of you in your practice would be having a patient who got diagnosed with cancer, that they have two important questions. First is, क्या मैं बचूंगा? And second is, क्या मेरे पैसे बचेंगे? Right. So about the bachunga part, my colleagues from ICTC, Dr. Rohit and Dr. Deep have briefed a lot about developments of oncology and the way to prevent it. I will talk about the money part of it. So my goal here is that at the end of my presentation, you should have an idea of why cancer care is costly, number one thing. Number two thing, why cost of cancer is something that we all should be concerned about. And number three, how we at Indian Cancer Treatment Center daycares are breaking the barriers scientifically to bring down the costs. So let's start. So first of all, the problem when I talk with a subjective topic like this is that a lot of people feel that what I am telling is just a subjective assessment or just writing an essay. So let me tell you that I have personally gone through a lot of proper evidence-based articles published in various medical journals. So when I came back from Delhi after completing my oncology, I was armed with a lot of knowledge and I was all charged up, I will treat patient with the latest treatment and so on and so forth. But then when I started the practice, I realized that patient didn't have money for even doing a simple CT scan. And then that got me thinking that, which way can I modify the entire onco practice so that I can deliver the care to the patient. And hence I went through these all number of articles just to make a solid base. So what I am telling here is not just an essay or just not what I feel, but it's backed by data. So first of all, what Lancet says that treatment of cancer has become a major reason for indebtedness for patients belonging to poor families. The poor become poorer due to the expensive cost of diagnosis and treatment. Modern technology has brought in changes, but it remains inaccessible to a lot of patients because of the cost. So first of all, let's start from a macro thing, that is at the national level, how much money are we spending on health? As you can see that European countries have almost 8 to 9% of their GDPs allotted to health. India has only 1%. But more important than that is what has been the per capita expenditure of health in India. It was around 621 rupees in 2009-10 and this is a 2016 data. It has almost doubled in 7 years. So now you can, in 2025, you can anticipate it to be something like 3,000 per person per year. This is the average expenditure out of pocket. So COVID was a time that we realized about how health can affect finances. A lot of, because of the lockdown, a lot of financial burden was inflated. And we thought that probably that will help increase the expenditure on health, but unfortunately, as a percent GDP, the expenditure was much lesser. Another problem in our country is the private-public disparity. India is majorly reliant on private healthcare system. This would interest all of us because we are private healthcare system. 58% of the hospitals in country are privately owned and 80% of doctors serve at these hospitals. It's also safe to assume that 80% of the doctor by large include cream of the cream of Indian healthcare. So 70% of urban and 63% of rural households depend upon private hospitals where the cost of healthcare services are usually much higher. So a major problem of this is that all the onus of the treatment comes on the private healthcare. And that's why I am standing here and talking. If we had 100% government health, then my entire lecture would have been meaningless. So what is the solution here? A common person will simply say two things. One is a health insurance, another is government schemes. So let's have a look at it. So government schemes. Schemes offered by government have many limitations. ESIS and Rashtriya Swasthya Bima Yojana only provide a cover of around 30,000 for a family. Entire ESIS has only 5 hospitals in the whole of Delhi. So it's quite inadequate. State-wise, a lot of schemes are there. I will talk about MJPJY scheme which is there in Maharashtra, and I myself at few places was a part of this scheme. So what is the problem with this scheme? Why can't this scheme address the issue with the cancer? First of all, there is a cost limit of only 5 lakhs. Let me tell you, MRP of a PET scan is 25,000. That is the MRP. Of course, we can get it done at a lesser price, but MRP is 25,000 just to begin with. Right? I am not talking about the treatment part at all. Cost limit 5 lakhs. Second is availability issues. In our proper Bombay, I don't think there is a single hospital in entire South Bombay and suburban Bombay which gives MJPJY Yojana. Okay? The hospital I used to go was in Mira Road. Second is that latest targeted and immunotherapies are not covered. I won't blame government for that. We'll come to it later why it is not covered, but the fact is that the latest blockbuster drugs are not covered in those schemes. And wait time for approval. I have had many patients who chose to take treatment at my daycare because the paperwork and the entire procedure was getting delayed. So let's talk about the private health insurance schemes. Half of the patients are not even aware in India that there are private insurance schemes. Less than 5% coverage we have of the private insurances. And almost 1/3 of the cancer patient, in spite of having private insurance, end up spending more than 50,000 rupees out of pocket expenditure in spite of having private insurance. Again, let me tell you, most of us don't have an insurance of more than 5 lakhs. And if you go to a big corporate hospital, you lose all the 5 lakhs before you can even start the cancer treatment. And I will come to that part also later. So even private health insurance is not the solution. So at a government level, why do we lag behind? See, over a period of so many decades, I won't say that government has done nothing. But you have to understand this, that our problems were of a different nature. We used to combat TB. We used to combat infant mortality. We used to combat HIV. And entire government machinery was channeled on that. So, of course, we have had a tremendous success in those rates. We have managed to overcome a lot of those challenges. But in the entire process, the cancer prevention and cancer treatment took a backseat. Right now, we are catching up, but we are having more of a vertical programs like MJPJY Yojana and all, rather than the more horizontal ones where PET scan is also done, surgery is done, radiation. So, it's right now in the very inception stages. Right, so this is the major reason that India never really faced a cancer challenge. It is doing the way it is doing now. It is also interesting to look at the prevention, and the treatment part. The best way to look at the Western countries, that obviously they didn't have to deal with the problems that we had to deal, but they almost had a 20% decrease in the premature mortality in 15 years because of the measures that they took. Low income countries saw a reduction of only 5%. So a good measures taken at a national level, at a state level, at a government level can help reduce the mortality of the cancer. So coming to it, that why am I discussing cancer? There are so many neurological diseases also which are very costly, but we don't really bother. Why is cost somehow important in cancer treatment? Because India is now facing and probably going to face a literal epidemic of cancer. It is the second leading cause of death and disability around the world. More people now die of cancer than from all cases of AIDS, TB and malaria put together. In developing countries, around half of the new cancer patient and 2/3 of cancer related deaths now happen in developing countries. 1 in 10 Indians will develop cancer during their lifetime. This is a WHO report. It is also very interesting to learn that once upon a time, we used to never hear cancer in poor patients. We used to hear TB, malaria, cancer cases we used to hear in Bollywood stars, in big industrialists. You know that this actress has a cancer, this actor has a cancer. Poor people used to have TB and leprosy. But now the things are shifting. Now poor people in India are getting hit by cancer. And why? Because once again, there is a lot of tobacco consumption at a lower socio-economic group. More than 50% of world smokers live in 3 countries of China, India and Indonesia. Around 164 million users of tobacco are there in India itself. Oral cancer is one of the commonest cancer. It is caused by tobacco. And who eats tobacco? Not the rich people. Again, it's the poor who chews tobacco and then ends up having oral cancer. And I have not yet found, I've rarely found a oral cancer patient who has enough money to afford the treatment, because they don't belong to that class. Again, the same thing, this is all, it has been published in Lancet, what I just told you. So, the summary is that emergence of new technologies and treatment for cancer coupled with rapid rise in cases means cancer care is rapidly becomes unaffordable to majority of population. Okay, now it is interesting. A cross-sectional study was done in government hospital. Again, I am repeating, not private. Government hospital. And in it was found that majority patients have to sell off property and borrow heavily to keep treatment going. There is almost 50% of household have a member with cancer patient experience catastrophic spending, and 25% of the people are driven to poverty because of the healthcare cost in a government hospital. Why? Because one person is not able to work. Along with that, another person is not able to work. They have to travel to other city. They have to spend a lot of other charges also apart from the actual treatment. So now coming to the core problem, that what is it that inflates the cancer cost? It is drugs. Let's first understand that, of course, not to say that hospitals and doctors have their own charges also, but by and large it's a drug. The latest drugs are extremely costly. The blockbuster drugs are extremely inaccessible to the patient, and I will just give you a glimpse of what these costs are. There is a drug called as olaparib. It's an oral tablet. Okay, right now the patent has gone, so its cost has come down to 18,000 a month. But around few months back, the cost was 1.75 lakh per month. You know, and that is with PAP, that is with patient assistance program. 1.75 lakh per month. Pembrolizumab, it's an immunotherapy drug. Its current cost is around 2 lakhs for 100 milligram per month. And it has to be taken every 3 weeks, so cost goes to around 4 lakhs per month cost of immunotherapy drug. Nivolumab, another drug, again 2.38 lakh cost per month, and this treatment will go on. You know, osimertinib, it's a oral tablet. And mind you, all these drugs are blockbuster drugs. These are drugs which are having a proven tremendous benefit. I am not pointing out rare new drugs जो के market में आना बाकी है or something like that. No. Osimertinib, for instance, has increased the average survival of lung cancer from 1 year to more than 5 years. It's just a oral tablet. More than 5 years it has increased the survival. Just oral tablet once a day. Cost is 2 lakh per month. 2 lakhs per month. You know, so this is the cost that we are dealing with. And just understand the interesting part of it, that there was a drug called as palbociclib. That drug used to cost around 1.3 lakhs per month. It was an oral drug for metastatic breast cancer, which has increased its survival to more than 5-6 years. Once the patent was gone, the next month that drugs cost, you know what the cost of that drug is today? 2,000 per month. It has come down from 1.3 lakhs per month to 2,000 once the patent has gone. And even on 2,000, it means that the companies are making a profit. So you can imagine what the innovator brand, whichever had launched it, the kind of killing money they made out of it. So now this is another, I can inflate any figures and give, but as I told you, I will remain factual here. So this is the Economic Times article. So cost of chemotherapy, what they have mentioned is around cost per cycle is around 80,000, and average cost of 10 cycles are 8 lakhs. No blockbuster drug in it. This is cost of a normal chemotherapy drug. कोई इम्यूनोथेरेपी टारगेट थेरेपी नहीं है. Now I will just give you, because I also go to corporates, I have my own daycare center, and I go to smaller nursing homes also. So I will just give you a brief idea what is the cost of cancer today. So for breast cancer, 8 cycles of chemotherapy are required. Cost of one cycle in a corporate hospital is roughly around 40,000. For colon cancer, we give a chemo regimen called as Folfox. 12 cycles are required. Cost of one cycle is 45 to 50,000 rupees. 6 cycles of paclitaxel carboplatin we give for ovarian cancer, again 30 to 40,000 per cycle. 6 cycles of cisplatin we give with radiation, around 20,000 per cycle. Do you know the cost of cisplatin drug for which we take 20,000 per cycle? The cost is 800 rupees. This drug is just 800, costs just 800 rupees. But corporates are charging 20,000 for it. Same goes for other chemo drugs also. Now, of course, I will come down to it that at what cost we give at our centers. But the problem is same. We are focusing on numbers. But this is the cost of average cancer treatment. Now, again, as I told about targeted immunotherapy, I already mentioned average cost 1 year with all the schemes that they provide is 10 lakh rupees only for medicines. 17 cycles in 10 lakh rupees plus the cost of administering medicine is different. So this is the level at which we are talking. Radiation therapy, again 1 to 2 lakhs, 3 lakhs depending on what the radiation type you are taking. So now the game that is being played, now this coming few slides are very important. Now what game is being played about cost and drugs? You know, I will try to explain it through an example of immunotherapy. So immunotherapy are type of latest drugs, and they are some cancers such as kidney cancers, lung cancers, liver cancers. They are the frontline treatment, and they are blockbusters. They have improved the survival like anything. Cost of immunotherapy drug is around 2.5 lakhs per cycle, and you have to take around 17 to 24 cycles a year. You know, so you can understand what the cost range I am talking about. So now in 23rd WHO meeting on essential medicines held in September 2021, importance of immuno-oncology drugs was recognized, but because of their high cost, they were not listed as essential medicines. This is another trick. Why should WHO not list it as essential medicines? Because once they list it, then it becomes a moral duty on the companies to reduce the cost. They aren't doing that, although they recognize that they are essential medicines. Now, much of the research that led to development of immuno-oncology drug was publicly funded. You need to understand that in US where the research was done, a lot of it was done by US government. So it was a public money, it was not a company's money. But then reward should have gone to the people, but in case it hasn't. Now ESMO, that is European Society of Medical Oncology, has quoted this. It is ironical that Nobel Prize was given to investigators whose research led to development of the immuno-oncology drugs. Yet they are not available to most people in low and middle income countries who might benefit. Now this parallels the HIV saga. What happened was that in the initial part HIV drugs were very costly. And which continent had maximum HIV cases? Africa. And they were not affording. So what use was developing HIV drugs when the people who need it the most are not able to buy it? So this is similar to it. Cancer epidemic is hitting the low economic countries, and immunotherapy, and they are the ones who are not able to access immunotherapy. At the largest cancer hospital in India, only 155 of 10,000 eligible patients received immuno-oncology drug from 2015 to 18. Out of 10,000 people who should have got immunotherapy drugs, only 150 could afford it. So you can understand that how badly it is out of our reach. So that's the first part. Now the solution to this. Here you will understand what is being done at a level that we are not able to understand. So there was this ESMO article. Again, I am completely quoting ESMO article. None of it is my old mind's imagination. So what happened was that nivolumab is an immunotherapy drug. The dose recommended is generally 2 to 3 milligram per kg. So what happened was that in a phase 2 study, they used different doses of the drug. So they used 0.3 milligram per kg, 2 milligram per kg and 10 milligram per kg every 3 weeks. And then they found that overall survival of the patient remains same. So let us say a patient weighs 50 kgs. तो एक को मैंने दिया 15 मिलीग्राम डोज, एक को मैंने दिया 100 मिलीग्राम डोज, एक को मैंने दिया 500 मिलीग्राम डोज, and all three had same survival. So what did they do? Smartly, in the phase 3, they went for 3 milligram per kg dose or 240 milligram dose every 2 weeks. So what happens is that approval WHO gives on phase 3 trials, not on phase 2. So phase 3 के लिए उन्होंने डोज लोअर डोज लिए ही नहीं, उन्होंने एक ही डोज लिया 240 मिलीग्राम पर केजी एवरी 2 वीक्स. सो दैट इज 15 times the lowest effective dose. That's what they did and they got a approval on that. तो आज अगर मैं मेडिको लीगली देखूं, आई विल हैव टू गिव 240 milligram dose to patient, although I can give him even 20 milligram, that will be equally effective, but I cannot because that's the approval has come for 240 milligram. Why? Because low dose उन्होंने यूज ही नहीं किया. Similar evidence is also available for pembrolizumab, where 1 milligram per kg was also enough. So, but in trial they had taken 2 milligram kg every 3 weeks. So Canadian agencies did blood levels of drugs, a blood level of immunotherapy, and they found that irrespective of the dose and frequency, blood levels of immunotherapy drugs were same. And they also have prolonged half-life. So instead of 2 to 3 weekly interval, we can even give it at 4 to 6 weekly interval. Again, this is said by European Society of Medical Oncology. So now let us see that if even phase 2 data is a data. So phase 2 data has said lower dose. So what do I do? Let us say I go with the data of 0.3 milligram per kg or 0.5 milligram per kg. Then what happens is, let's see. Then the cost reduction, if I use the WHO approved dose versus low dose, cost reduction is almost 93%. And जहाँ पे मैं एक पेशेंट ट्रीट करता था, I can treat 14 patients if I use the lower dose, which is also phase 2 is also data. No one can challenge me on that. This table shows that. Even if let us say कि survival benefit is only 90% instead of 100, but still I can, if I am treating 14 more patients overall, I will go much. So I will just go fast. Time is same thing for pembrolizumab. The weight has been calculated in form of the European weight and not Indian. What they did, one thing is that pembrolizumab immunotherapy used to come in 50 milligram vial also. वो vial ही गायब कर दिया. अभी you have to buy only 200 milligram dose. 50 milligram का vial ही गायब हो गया market से. They completely took it back once they realized people are doing this. So I'm coming to the last part. So at ICTC, how are we able to beat these prices? So first of all, where we don't have blockbuster drugs, we have brought down the cost of chemotherapy. Our average cost at our place can range from 8,000 to 15,000, and even at that price we are making profit. Even at that price we are keeping up with our referral commitments. Even at that price we are able to stay profitable while making it affordable for the patient, because we are working on numbers. As I said, we have around 1,000 chemos per month. So we are able to cover it. We practice as a group, so we have a better negotiating power with pharma for a more cheaper drugs. We have our own foundation and we have tie-up with Siddhivinayak and Mother Trust also. Last part, how do we bring down the cost of immunotherapy? Either we go for low dose immunotherapy, which has trials from Tata backing it, or we go for vial sharing. Simple, one vial is used in 3 patients. And trust me, patients are very matured. They do understand if you tell them that they are going to get a best drug at a lower price only if they are able to share it with others, and we take all sterile measures while we do that. However, corporate hospitals do not allow us to do that. So I go to a lot of corporate hospitals, I am not going to name it, but they do not allow this policy. They say that this is not recommended, so we won't allow that. But the reality is what we all know. So that's how we fight, and our entire daycare system is working towards making it affordable while keeping the quality of the care same. I hope entire NIMA association supports us in this of a humanly endeavor. Thank you.
Thank you so much, sir. It's always when we hear about cancer, we talk about treatments, but never the economies of it. So it is very essential to know, because it has always been a really tough thing on patients' pockets. So thank you so much, sir, for such enlightening lecture and kind of getting us awareness. I would call upon the 2 chairpersons Dr. Pawar and Dr. Sanjay Musale sir to felicitate our speaker. Sir, please come. Yeah. Jai Mala Pawar madam, Sanjay Musale sir, please do the honors to felicitate our great speaker. It was really a wonderful lecture. Yes. Can we request our speaker, Vijay sir, to felicitate our two chairpersons here? Dr. Jaimala Pawar and Dr. Sanjay Musale sir. Thank you for your valuable time here. Thank you. And now, the interesting thing, the lucky draw. So you're not allowed to go because with your lucky hands, we are going to announce the 3 winners. कहते हैं ना किस्मत का जादू है लकी ड्रॉ का रंग, हर दिल में है उम्मीद उसे होने ना दो भंग, जब तक लास्ट लेक्चर लास्ट ड्रॉ नहीं निकलता संभाल के रखो अपने टिकट. द फर्स्ट गोल्ड कॉइन विनर. Yes. $494 Jyoti Goswami. It is Jyoti Goswami. Is she there? She left. Bad luck. Gold coin. Abhi raat ko neend nahi aayegi that I lost onto the gold coin. Yes, sir. We'll have to pull out another one. Can we have? Yes. Dr. Archana Gurate. 182. 182, yes, she's there. You are the gold coin winner. The second one, 185, Dr. Shraddha Mane. 185, Dr. Shraddha, oh, she's there. And the last one, the earphones. Here there is no number, but there is a name. Can I announce the name? It is Dr. Prajakta Patil. Oh yes, mil gaya earphone, yes.
Thank you, thank you.
Yes, yes. See, she's so happy to come here. We've not called any winners, but here we have.
Thank you so much, everyone. Thank you, madam.
She was very smart. None of us put our, kind of thing, but she did not get the note. She's written a name and put. Good one, but you truly deserved it.
So,
Thank me, I was the one.
Yes, yes. Thank the lucky
thank you, sir. Thank you, sir. Thank you, everyone. And I'm really happy. Thank you so much. Thank you so much, sir. Now we are going to continue with the felicitation program. Just a second. Actually came very impromptu for the lucky draw. So let me just get the script. So now we'll continue with the felicitation program. For that, I would like to invite our Honorable President, Dr. Narendra Tripathi, sir, Secretary, Dr. Mangal Vavar, sir, Conference Chairman, Dr. Prasad Pawar, sir, and I would like to invite Dr. Ashutosh Kulkarni, sir, President, NIMA CC, to the dais. I would like to invite Dr. Vikas Dubewar, sir, on the dais. And also the winner of the Jeevan Gaurav Award. I would like to invite Dr. Vinayak Temburnikar, sir, NIMA Central, immediate past president, to the dais. I would now like to invite Dr. Suhas Yadav, sir, past president, NIMA Maharashtra State. I would like to invite Dr. Raju Tatewar, sir, president, Maharashtra State. And the entire PST and the team of Maharashtra NIMA kindly come forward. I would request our scientific chairman, Dr. Namdeo Thorat, sir, to kindly come forward. Kindly give a big round of applause, everyone. I would now like to invite Dr. Ram Barute sir, Vice President of Doctor Association of Worli. Dr. Ram Barute sir. I would also like to invite Women's Forum PST, NIMA CC to kindly come forward. Next, I would like to invite NIMA Bhiwandi CC PST, Dr. Rashid Syed sir, Dr. Abdul Salam sir, Dr. Anjum sir. Kindly come on the dais. Kindly give a big round of applause, everyone. We have Dr. Ram Barute sir on stage with us. Sir is the Vice President of Doctor Association of Worli. Kindly give a big round of applause. Thank you so much. Next we will have NIMA Bhiwandi City PST. Kindly come forward. Dr. Rashid sir, Dr. Abdul sir and Dr. Anjum sir. Kindly give a big round of applause. NIMA Bhiwandi City PST. NIMA Bhiwandi City is a very active branch and they regularly organize very amazing programs, and we are really honored to have NIMA Bhiwandi City PST with us. I would like to request our mentor, Dr. Dubewar sir, NIMA MDB President, Dr. Narendra Tripathi sir, Conference Chairman Dr. Prasad Pawar sir, Scientific Chairman Dr. Namdeo Thorat sir, Secretary Dr. Mangal Vawa sir to kindly felicitate NIMA Bhiwandi City PST. Next I would like to call NIMA Gramin PST. From NIMA Gramin I like to call NIMA Gramin Bhiwandi. I like to call Dr. Rajesh Dahapute sir. Kindly come forward. Next I would like to call NIMA Shahpur PST. Do we have NIMA Shahpur PST with us? Next also I would like to call NIMA PST of Vada Taluka branch. Kindly come forward. Next I would like to call upon NIMA PST of Badlapur branch. Next NIMA PST of Ulhasnagar branch. Kindly come forward. NIMA PST of NIMA PST Ulhasnagar branch, Badlapur branch, Vada Taluka branch, Shahpur branch. Kindly come forward. Kindly give a big round of applause because we have people who are working. So we have over here from NIMA Bhiwandi Taluka branch, we have dignitaries. Kindly give a big round of applause because these people are working at the periphery where reforms are definitely needed. I would like to call upon PST of Meera Bhainder branch. Kindly come forward. Next also I would like to call upon PST of Navi Mumbai branch to come forward. NIMA PST of Meera Bhainder branch are coming towards the dais. I would like everyone to give them a big round of applause. Meera Bhainder branch is a very active branch and I see their posts and activities every day and I get inspired by their work. I would like our mentor Dr. Dubewar sir, Dr. Prasad Pawar sir, Dr. Narendra Tripathi sir, Dr. Mangal Vawa sir, Dr. Namdeo Thorat sir to kindly felicitate Meera Bhainder branch of NIMA. Do we have PST of Navi Mumbai NIMA branch with us? Then kindly come forward. Next, I would like to call Dr. Swapnil Shirsat sir, Joint Secretary, NIMA Maharashtra State. Dr. Swapnil Shirsat sir. Next, I would like to call Dr. Nikam sir, Vice President, NIMA Central Council. Do we have Dr. Swapnil Shirsat and Dr. Nikam sir? is there as a representative from NIMA Shahpur branch. So kindly give sir a big round of applause for accepting this on the behalf of NIMA Shahpur. Next, I would like to call Dr. Sopan Kharche sir, Treasurer NIMA Maharashtra, to kindly come forward. Dr. Sopan Kharche sir. Thank you so much everyone. As you all know that we had conducted paper presentations parallelly in the morning, and the paper presentations were going on the first floor. And I have with me the winners for the paper presentation. So kindly be ready. The first prize, so we have divided this into two categories. First would be the poster presentation and second would be the paper presentation. We had overwhelming entries of more than 70 students, and I think this is a very big thing, and a great work has been done by the paper presentation team. From the team, I would like to call upon Dr. Rutuja Gaikwad ma'am, Dr. Pradnya Kapse ma'am, and Dr. Vijay Mane sir, because they have worked tirelessly and scrutinized and conducted the paper presentation so nicely of all the students. And thank you so much ma'am. And Dr. Pradnya ma'am and Rutuja Gaikwad ma'am are my teachers, and I know them very well. And I really feel honored that I am over here and I'm sharing the same stage with you ma'am. Thank you so much. So the first winner for poster presentation, first prize goes to Dr. Joyati Goswami. So this decision is taken by the entire paper presentation team. I would now request our Pradnya Kapse ma'am and Rutuja Gaikwad ma'am to disclose the second winner for poster presentation. I am giving the mic to Rutuja Gaikwad ma'am.
Poster presentation, first prize, as Prajakta already told, Dr. Joyati Goswami ma'am. Congratulations ma'am. And second prize, Dr. Roshni Dubey, KG Mittal Ayurved College. रोशनी केजी मित्तलची पीजी.
So we have Dr. Roshni, who is the second winner of poster presentation from KG Mittal Ayurvedic College. Congratulations Dr. Roshni. Please come. Till then, we will announce the winners of the paper presentation, and for that, I would allow Dr. Pradnya Kapse ma'am to do the honors.
Good evening all. It is our pleasure to announce the results for paper presentation. All students, there were approximately more than 100 papers. The students who are fantastically and very nicely presented the all research papers in the halls, and they have taken the efforts to present it well. So I congratulate all the students. लेकिन किसी को पहला किसी को दूसरा आना ही है. So this is the result in front of you all. And college wise we have distributed. So from Sion College the prize is going to Dr. Bhagyashri Patil. Dr. Bhagyashri Patil.
We have Dr. Bhagyashri Patil.
First prize of paper presentation, it goes to Dr. Bhagyashri Patil, as she has scored the most. Is she there? No?
Do we have Dr. Bhagyashri Patil? I think we should move towards the next.
The second prize goes to Dr. Iram Ansari, KG Mittal Ayurved College, Mumbai. Dr. Iram.
Next.
And third prize goes to Dr. Aarti Nadar, R.A. Podar Ayurved Medical College.
Third. Congratulations, Dr. Aarti Nadar.
Dr. Aarti from R.A. Podar Ayurved Medical College.
Congratulations, Aarti. I know you personally and I know how hardworking you are. You deserve it. Give a big round of applause for the hardworking students. Kindly announce the next entry, ma'am.
Third na? Aarti Nadar third na?
She has come. Kindly announce the fourth winner, ma'am.
And the last winner is Dr. Preetika Rajan from Yerla Medical Ayurved College, Navi Mumbai.
Congratulations. Kindly come forward on the dais. Kindly give a big round of applause to the paper and poster presentation winners.
So congratulations to all students for their hard work and good luck.
They have done a great job of presenting awesome papers and posters, and I know how much hard work it takes to prepare these things. I would again like to thank our paper and poster committee, that is Dr. Rutuja Gaikwad ma'am, Pradnya Kapse ma'am, Sheila ma'am and Vijay Mane sir for smoothly conducting the paper and poster presentations. Thank you ma'am. We are now going to start with our next lecture in the next 2 minutes, so kindly be over here. After this is over, immediately we are going to start with the next lecture, so kindly don't leave the auditorium. And don't forget that we have bumper lucky draw prizes which are remaining, and we have more lucky draws after every lecture also, including gold coin which you already know. I would now invite the next comparer to continue from here. Thank you so much everyone.
Thank you, Prajakta. Our next speaker is Dr. Shushma Mandwa. She is a gynecologist and an obstetrician. Her special interest or her specialty is in IVF and fertility treatment. Her topic today is recurrent pregnancy loss. Few lines about ma'am. She is the founder and director of Nurture IVF and Fertility Solutions at Vashi Hospital, Navi Mumbai, and holds acclaimed qualifications including MRCOG, MS in Obstetrics and Gynecology, and advanced fellowships in reproductive medicine, minimal excess surgery, and masters in IVF from UK. With consistently high success rate in IVF treatments, Dr. Shushma is known for her compassionate, evidence-based approach to managing even the most complex infertility cases and high-risk pregnancies. She is also deeply committed to holistic care, integrating nutrition management as a key pillar of reproductive health. Having served at top institutions like Sir H.N. Reliance Foundation Hospital and Breach Candy Hospital, and as a proud member of ISAR, FOGSI, and the World Association of Laparoscopic Surgeons, she brings unmatched expertise to every patient's journey. पहले के ज़माने में ना बांझ होना तो एक ताना था. It was actually a taboo, but not anymore. Rightly said. Advances in IVF have transformed dreams into reality, offering hopes to countless couples struggling with infertility. जहाँ था खालीपन, वहाँ आई आनंद की किलकारियाँ. IVF ने दिया खुशियों की कहानियाँ. So this is for Dr. Shushma Mandwa, and our two chairperson here are Dr. Vinod Yadav and Dr. Nilparna Khedkar. Now, Dr. Vinod Yadav will definitely require a special mention here. I'll come to it. First, his achievements I would talk. He's a BMS. He's a general physician. He has experience of 25 plus years of practice, practicing since 1999 at Vashi, Navi Mumbai. He is successfully practicing, oh yes, and he has also contributed to medical awareness programs and community health initiative. You know, doctors, today, what we have been seeing on the screen, the concept, the visualization, the idea is all his baby. I want a big, big round of applause for Dr. Vinod Yadav. You all have been seeing this, making it magnificent. It's always a better thing to have a visual outlook more than hearing. So this credit goes to him and his son Aman Yadav. There is seated. Boy, congratulations to you and kudos to you. Along with that, my second chairperson is Dr. Nilparna Khedkar. She is a senior panel consultant doctor at Diabetic Free Forever Clinic. She has been practicing from 25 years at Thane, Pune and Mumbai. She provides one-stop solution for lifestyle disorders like diabetes, thyroid, rheumatic arthritis, PCOD and many more. Her hobbies are reading, music, exploring holistic healing power, so many things. Can we have Madam on stage? Over to you, Shushma ma'am, for the wonderful lecture.
Good evening, all. It's very good to see a lot of people sitting at this time since morning. I'm Dr. Sushma and I'm directly diving into my topic, which is recurrent miscarriages. So this is a very common OPD which we encounter on daily basis in our OPD. So let's continue. So firstly, in my talk today, I would address what is the definition of recurrent miscarriages. I will tell you what are the causes and how to investigate the cases, how to manage each cause, and what will be our take-home messages and when to refer to a higher specialist center. So firstly, recurrent miscarriage is a very significant reproductive health issue. We all know that. And it affects almost 1% of the couples who are trying to conceive. And it carries a lot of psychological and social impact. It's very, very difficult to counsel these patients who come with recurrent miscarriages. So coming to the definition. So what exactly is a recurrent pregnancy loss? So the definition says if the couple is losing their pregnancies consecutively for 3 times, then we can label the couple as a recurrent pregnancy loss couple. Which means if the patient had a pregnancy in between a miscarriage or after a pregnancy, then it is not a recurrent miscarriage. It will be called as a sporadic miscarriage. So today we are talking about a pregnancy which has been lost for almost 3 times consecutively, which means recurrent pregnancy loss. We are not talking about a sporadic miscarriage. Okay, I want to highlight this. And this is divided into early and late. Early is, we all know, it is less than 12 weeks of gestation, and late is which is beyond 12 weeks of gestation. So as I mentioned, the instance is 1% in almost all the couples who are trying to conceive. So this 1% is in couples who are facing infertility issues. Recurrent pregnancy loss, 1% is not in the total population. Recurrence risk increases with each miscarriage. That means the second miscarriage is higher when there is a first miscarriage. And we all know predominantly the primary factor is the advancing maternal age. So what are the causes? So we have many causes, but I want to list out the predominant causes, which primary evaluation should be done at every center. So firstly, when we have a case of recurrent pregnancy loss, firstly our thought process should start like this. First, let's think about the genetic causes. So parental chromosomal arrangements. So usually it is said that if there is a structured chromosomal balance between the couple, then there is no miscarriage in almost 85% of the cases, which means there is a live birth in those pregnancies. So when there is structural imbalance, only then there is a miscarriage. So we have sporadic chromosomal abnormalities also in the embryo, and this particular genetic cause accounts for 2 to 5% of the recurrent pregnancy loss cases. So secondly, we have factors, anatomical causes and endocrine factors. So anatomical, we all know, the most commonly we see is the septate uterus and the bicornuate uterus. There are many other Mullerian anomalies which we find, but the most commonly seen in cases of recurrent pregnancy loss is with septate and bicornuate. So it's very important to evaluate this, and the mode of evaluation would be ultrasound. We all know that. Which ultrasound and why to do it, I'll come to it later. Next is fibroids. We all know that. Other causes like intrauterine additions is very important to evaluate. Again, what sonography has to be done, I'll come to it again. Endocrine causes, it's very important to rule out thyroid disease, diabetes, and hyperprolactinemia. It's not mentioned in the slide. And PCOS obviously has to be evaluated. What are the other immunological and thrombophilic factors? We have thrombophilias which are inherited and acquired. Acquired causes are the main culprit for recurrent miscarriages than inherited. So when we say inherited thrombophilias, the protein C or protein S deficiencies, antithrombin deficiencies, all of these are usually culprits for the second trimester recurrent pregnancy loss, which is very less percentages of RPL. Firstly, acquired causes have to be ruled out. That means antiphospholipid syndrome or SLE in some cases. These are acquired causes. So this is the main culprit for placental thrombosis and obviously the other complications in pregnancy as well. So the unfortunate thing in recurrent pregnancy loss is more than 50% of the cases, even after thorough investigations, we do not find a cause why the miscarriages are happening, and these are put into unexplained causes. And in these cases, all we do is reassurance and refer to a higher center for embryo evaluations. So it means that they have to consider going for an IVF. So let's elaborate what investigations has to be done and when the investigations have to be done. So firstly, it's written karyotyping. So is it necessary for every couple to undergo parental karyotyping? The answer is no. So when a couple comes with a first miscarriage, we are sitting at the OPD and the couple says, Madam sir, why my pregnancy got aborted? We do not know the answer. All we can say is there are many lifestyle changes, that is the first thing we start. So it is proven that BMI less than 19, very lean patients, and BMI more than 25 contribute to sporadic miscarriages. So the first miscarriage, all the counseling should go in a way of lifestyle management and less caffeine intake, less than 200 mg per day, or cut down your smoking, cut down your alcohol intake, modifying your lifestyle, all that should fall for sporadic miscarriages. And when should you do a karyotyping is after the second miscarriage. You have to send your products of conception after the termination or the expulsion for testing. And if in case the products of conception show a problem in the abnormality structurally or a chromosomal abnormality, then you have to send both the couples karyotyping, and that is the time you have to do karyotyping and not for everybody. So the products of conception should be done after the second pregnancy or the third, and then if it comes out to be positive, only then we are going for a karyotyping. Secondly, screening for antiphospholipid antibodies. So we all know we do APLA testing, we do lupus anticoagulants, we do ACL antibodies and other anti-B2 glycoprotein antibodies. So I have seen in OPD many couples coming with positive reports. So usually when the miscarriage happens, it's very important for us to remember that these testings should be done at least after 6 weeks of the miscarriage happened, not immediately. Since the couple is very anxious of what happened with them, they are in a hurry, and we as physicians should counsel them that the test can turn out false positive if it's done before 6 weeks of the miscarriage. This is the first point. Second point is we should always carry 2 positive reports which is done at least 4 weeks apart to label a patient as an antiphospholipid syndrome positive. One lupus anticoagulant positive or ACL positive is never declared as an antiphospholipid syndrome. The patient will take unnecessary heparin throughout the pregnancy if it is not diagnosed properly. Thirdly, imaging. So imaging, as I mentioned, ultrasound. Ultrasound is very beautiful tool we all have, but we must remember one thing. So there are some conditions like fibroids, adenomyosis, which can easily be picked up in a 2D sonography. But we have to remember, most of the cases of recurrent pregnancy loss, it's important to evaluate the Mullerian anomalies when we are talking about it, the septate uterus or the bicornuate uterus, or things like endometrial polyp, or things like intrauterine additions, which are not visualized in a 2D sonography. So these are the cases where you should have an eye. If there is a persistent patient having thin endometrium throughout the cycle, even in the luteal phase, in the second phase of her menstrual cycle, you see that the endometrium is very, very thin. So you have to suspect intrauterine additions, and these are the cases. It's better you always do a 3D sonography, which is the gold standard now. Now laparoscopy is no more the gold standard for detecting Mullerian anomalies. It is a 3D sonography done under expert. So secondly, the other investigation, if required, is hysteroscopy. Of course, if you have a septum or a polyp or addition which is diagnosed on a 3D sonography, that is when we interfere with hysteroscopy. Again, it is not mandatory for everyone. And MRI, coming to MRI, again, when we detect the Mullerian anomaly, as physicians, it's very important to understand the other structures which are involved in anomalies. So the renal tract, which encounters almost 10% of the problems with Mullerian anomalies, is proven. So it's important to send the patient to a nephrologist also if you find a renal component, and that's the reason the MRI steps in. So coming to endocrine and metabolic evaluation, as mentioned, the thyroid, if it's there, it has to be treated before conception. We know about the diabetes. The guidelines say that HbA1c more than 10. Straight away tell the patient you are not supposed to conceive in the next 6 months. Control your sugars and only then you can get pregnant, because these cases land up in sporadic miscarriages. Diabetes is, again, it's not a direct factor for RPL, but it's a direct factor for structural abnormalities happening with high sugars, so they land up in sporadic miscarriage. And we have hyperprolactinemia, as I mentioned, so the prolactin levels have to be treated before they plan for the next pregnancy. Thrombophilia testing, again, as I mentioned, so acquired thrombophilia testing can be done in the first trimester miscarriages. One thing we have to remember here, when should the protein C or protein S or antithrombin deficiency should be done? So these testing should be done in the first loss itself. If there is a second trimester loss, do not wait for third miscarriage to happen. So I had a case who was coming continuously with 3 miscarriages happening in her 5th month. So most of the physicians think it is a cervical component and they undergo cervical cerclage, and still again the next case, next pregnancy also she lands up terminating the pregnancy at 5th month. So it's very, very important to do a cytogenetic analysis for these patients. Even in the first pregnancy, if the patient is losing her pregnancy in the 5th month, along with the cervical factor, you should consider doing thrombophilia testing, which is very important, and it is one of the very primary causes for second trimester pregnancy losses. So how do you manage? So as I mentioned, before we start the management of antithrombophilia, antiphospholipid syndrome or thrombophilia, it's important that we have 2 reports in hand which are done 4 weeks apart, and the treatment is very simple. Low dose aspirin which is started when the pregnancy is positive, not when the fetal heart arrives. So it's important you have to start the aspirin and heparin immediately once the urine pregnancy test turns positive, which improves the live birth rates. And it's very important to do a close antenatal monitoring along with titration of the heparin. So it's very important that pregnancy, we all know, the woman will put on weight. So according to the weight, the titration of the heparin dosing should be done. Secondly, we all know if you have an anatomical problem, we are correcting the problem. So when you do a septal resection or additional for cases like intrauterine additions or a septate or a bicornuate uterus, as physicians, it's very important to follow up the patient post-operatively. I recently had a patient who has undergone 3 hysteroscopic surgeries done by the best expert in Mumbai. She comes up with recurrent pregnancy loss immediately after the surgery has done. It's happening again and again and again. We were trying to find all the papers possible, but we couldn't find the cause, why the additions were happening again and again. So finally we found out is the post-operative care. So after the additional lysis is done, the surgeon leaves the patient. So the follow-up has not happened. That means that when there is a surgery and 2 raw surfaces after the hysteroscopy, it's important that the 2 surfaces should not be attached to back before 4 weeks. That means that there should be some mold or some Foley's put in there for the raw surfaces to heal. That is our part. So as physicians, it's important to make the patient understand the importance of post-operative care. Otherwise, any surgery done is a waste for her and she wouldn't conceive with any other surgical interventions done repeatedly. So progesterone support as mentioned. So in recurrent pregnancy loss patients, it's important to continue your progesterone support, preferably micronized vaginal progesterone. 200 BD is not enough. The new recommendation is 400 vaginal BD, and it's important to continue till your 34th week of pregnancy. I have seen many sheets of OPD wherein whenever the patient is having bleeding, we might continue for 15 days or 4 weeks and then we tend to stop the progesterone. No, you have to continue till 34 weeks of pregnancy. And in sporadic miscarriage cases, if there is an episode of bleeding or spotting which happened once or twice in the early pregnancy, then you can continue the progesterone till 16 weeks. But in recurrent pregnancy loss patients, it has to be continued till complete 34 weeks of pregnancy. Micronized vaginal progesterone 400 BD should be given. And as I mentioned, supportive care. The last but not the least, this is very, very important, lifestyle modification, counseling to the patient about losing or gaining weight. So nowadays we always have patients to counsel about losing weight. Nowadays we find a lot of patients asking them to gain weight. So that's also becoming a big problem. BMI less than 19 is a very problematic thing, and it's one of the causes. So cutting down on alcohol and smoking. So we had few papers initially saying this amount of alcohol is good. No amount of alcohol is good when you are trying to conceive. This is the latest evidence, and many papers are out on that. So no amount of smoking or alcohol should be entertained. And caffeine should be limited below 200 mg per day. So that's around 3 to 4 cups, small cups of coffee. So please counsel the patients about, so one of my patients tells me I don't have coffee or I don't have tea. I just have green tea. Green tea also has caffeine. So it's important to see what ingredients are going in when you're having any sips. So 200 mg is the maximum which the patient can take. Psychological support. This is the very, very traumatic thing that the patient is having 3 miscarriages, and it takes little time to counsel the patient. But we as physicians, we have to give the emotional support, and you tell them that there is always scope for a healthy pregnancy, and we just need to follow the step ladder to reach the diagnosis carefully. And as I mentioned, multidisciplinary treatment is very important. When you find Mullerian anomalies, it's important to involve your nephrologist colleagues if there is any renal parameter involved. Just give me a second, sorry for the glitch. So the take-home messages, it's multifactorial, so you have to consider each factor one after the other, and very unfortunate to say that 50% of these cases are unexplained. So all we can do is refer them to a center and test their embryos before putting them in. That means putting an euploid embryo is all we can hope, and to have a healthy pregnancies. And all the investigations whichever we are doing should be mindful. I want to highlight this, that I have seen many patients coming up with reports which are very costly, like torch infections and all. Torch is obsolete. I want to highlight this. Please do not do torch for any other patients. Yes, you can, only if you want to evaluate what happened in the last pregnancy. So then you can do a torch, but that is not the answer for the future pregnancies. So if you do torch, all you get is if it is negative or positive, that's it. You will not have any accountability for the next pregnancy. So there is no point doing torch. And so what is the conclusion? Most women will achieve successful live births if done systematically, and RPL is a very challenging clinical situation. So systemic evaluation and targeted management protocols, psychological and emotional support. And I run an IVF advanced level 2 center in Vashi sector 17. We do all the advanced IVF procedures there, including embryo biopsies. And yeah, that's it for today. Thank you. Thanks for having me. So I'm open to questions. Thank you. It seems that nobody has any questions. Thank you.
That's because ma'am, you would have, you have explained it so well that they don't have any questions, right? Thank you so much, ma'am, for such an incredible feast of knowledge on such a sensitive topic. Your insights have not only deepened our understanding but also empowered us to pick up subtle and early signs with more confidence. This knowledge will surely translate into better outcomes and ultimately saving many those tiny precious lives and giving hopes to those anxious couples. We truly are grateful for your time and expertise, ma'am. Thank you so much. So now there's an excitement and a little exciting announcement to be made by Dr. Prajakta. I request her to... Okay, yes, right. Before that, now we take the opportunity to felicitate Madam. I request our esteemed chairpersons to kindly do the honors. With a big round of applause, of course. Thank you so much, chairpersons. Now I request Madam, please stay on the stage. I request Madam to kindly felicitate our chairpersons. Yes, a big round of applause won't hurt anybody. Thank you so much, ma'am. Thank you, sir. Thank you, ma'am. Thank you so much. So moving on to our exciting announcement, I request.
He's my son. He's my son.
Okay.
Yeah, he has done all this digital.
So all this audio visuals we are seeing are due to the great efforts of Aman Yadav. I kindly request Aman kindly come on the stage, and we are going to felicitate you. And applause please. Aman Yadav is son of Dr. Yadav sir, and he has taken all this बहुत मेहनत से ये सब किया है उसने. Thank you Aman. And I now request madam to kindly, so now it is the time for what? The lucky draw. And so I request madam to pick up those lucky winners. First is Dr. Aditi Raj. Number is 141. Dr. Aditi Raj. Is she here? Oh, congratulations ma'am. And second winner is, the first winner is of gold coin, okay? Yes. The second winner is Dr. Sanket Sangle, 065. Dr. Sanket. Is he here? Dr. Sanket? Absent? So we will have another one. Okay, so the second winner again is Santosh Bharsat, 543. 543. Congratulations, second winner. And now on to our last winner. Oh, what handwriting? मतलब डॉक्टर बनने के काबिल हैंडराइटिंग है. 585. 585. Khan. Can you spell your name? 585. Okay, congratulations sir. आपका नाम जरा जोर से बोल दीजिए सर जी. नसरुद्दीन. Nasiruddin. Okay, thank you madam for all the help, and thank you all and congratulations.
So now we have a very exciting announcement, and before that I want to make sure that I have your full attention. And so I am going to lighten your mood by a shero shairi. Thank you Amar sir. महको तो यूं महको कि फूल भी ताज़े हो जाए, बरसों तो यूं बरसों कि बादलों में भी जान आ जाए, और ताली बजाओ तो ऐसे बजाओ कि सोने वाले भी जाग जाए. And I can't take the credit for this shairi. The credit for this shairi goes to Dr. Rajendra Khatavkar sir. Sir gave me this shairi. Thank you sir. So this was not the important announcement. I am now going to reveal the surprise bumper prize for lucky draw. I hope you are ready to listen to it, because we are going to give 40-inch branded TV as the ultimate bumper prize. Are you all excited? So after giving gold coins and other things, this is going to be the bumper prize, and this will be given after the last lecture is over. Delegate assured gifts. We have leather bags and other surprise gifts, which I am not going to reveal. Each and every one of you is going to get that. Along with that, we have 7 lucky draw for car refrigerators. That is also there. We have a special ladies lucky draw, and we are going to take 3 of them. First, second, third, and the gifts are Paithani Sari. This is specifically only for ladies to honor the lady doctors. Also, we have a special couples lucky draw, couple wristwatch, and many more. So don't go. Now, as you all know, you would have all visited the stalls, and now we are going to take the top 3 stalls award. For that, I would like to request Dr. Shailesh Tambe sir, the head of stall committee and a very hard-working member of NIMA MDB, to kindly come forward. I would now request Dr. Maurankar sir also to kindly come forward. Can we have Dr. Shailesh Tambe sir on the dais? Now sir will announce the 3rd prize for the best stall, and the best stall goes to
Simandar Pharma.
Congratulations Simandar Pharma. Do we have the representatives from Simandar Pharma over here? I hope you have visited Simandar Pharma. Do we have the representatives from Simandar Pharma? Yes, we have. Kindly give a big round of applause. Simandar Pharma gets the 3rd prize for the best stall. I hope you have visited the stall. If you are not, kindly visit the stall and kindly make sure that in order to get the lucky draw and also to get the assured gifts, you have to visit each and every stall and get stamped by it. So this is also a condition. Kindly give a big round of applause to Simandar Pharma. Come on, come on. I don't think the Shairi has worked because no tali are coming. Okay, so now we are going to announce the 2nd prize, and to do the honors I will ask Shailesh Tambe sir. The 2nd prize for best stall goes to
Aglomed Pharma.
Wow, Aglomed Pharma team, come ahead. 2nd prize for best stall. Aglomed Pharma representatives, do we have? I request Dr. Amar Devedi sir to kindly come forward and do the honors on the dais. Thank you sir for being with us. Kindly give a big round of applause to all the representatives from Aglomed Pharma for securing the 2nd prize in the best stall award. Kindly come forward. Thank you so much. Now we are going to announce the first prize for the best stall. Do we have any guesses? Have you visited all the stalls? For doing the honors, I would like to request Dr. Shailesh Tambe sir to kindly reveal the first prize for the best stall. Kindly reveal, sir.
Nirmay Holidays.
Areva, Nirmay Holidays stall. Do we have the representatives from Nirmay Holidays with us for securing the? Yes, we do have. Kindly give a big round of applause to Nirmay Holidays for being the best stall. See, we have to honor each and everyone, from the delegates to the students to the legends to the stall and all the medical representatives also. So, welcome representative from Nirmay Holidays. Kindly give a big round of applause. After this, we are going to immediately continue with the next lecture. Thank you so much, everyone. I would. Now I would like to call upon the next anchor, Dr. Reema Vartak, to kindly take away the dais. Thank you.
Thank you.
Thank you, Dr. Hello. Thank you, Dr. Prajakta. So moving on to our next lecture, the Knowledge Feast. I now request our next chairpersons, Dr. Pradnya Kapse ma'am and Dr. Rutuja ma'am, to kindly come on the dais as chairpersons for the next session. Dr. Kapse madam and Dr. Rutuja ma'am. And now I welcome our next dynamic speaker, the one who is going to give us a bumper feast of knowledge, brought to us by none other than the esteemed Dr. Suhas Shah sir, who will be speaking on two highly insightful topics. Those topics are first, revisiting Marma Chikitsa, and second, Russian surgery for diabetic foot. Marma Chikitsa, as we all know, is a therapeutic practice described in Ayurveda, and which is because to restore the body's life force, that is prana. And speaking about Marma, the evidence dates back to Mahabharata. And even Lord Krishna, everyone must be knowing that the death of Lord Krishna, he left his earthly body through an injury to a Marma point. So this shows us how vital and sacred these points are in our body's energy system. Moving from the ancient to the urgent topic, that is the second topic he will address, is the diabetic foot, a modern epidemic we must not ignore. To shed light on both these vital topics, it is an honor to invite Dr. Suhas Shah sir, and please give him a big warm applause. And here's a brief look at his inspiring journey. Dr. Suhas Shah sir is a MS Ortho Gold Medalist. He has completed his MNAMS MRCS from Edinburgh, UK, FJR from Singapore, and he is a consultant orthopedic surgeon in India and heads the orthopedic department at Bhabha Hospital, Bandra. And he also consults at premium institutions like Raheja, Jaslok, Wokhad and Global Hospital. Most notably, Dr. Shah has invented a revolutionary technique called as Elizaro angioplasty, an innovation that has saved hundreds of diabetic foot patients from amputation. His advanced surgery is also capable of limb lengthening, and currently only 3 to 4 surgeons in India are trained to perform this surgery. And so without a further ado, let's dive into the session where tradition meets technique and timely intervention meets innovation. Over to you, sir. Thank you. Again, sorry. A little introduction, excuse me sir, just a second, I will steal from you a moment. Yes, the mic, I'm working on it. Hello. Working, I suppose. Okay, so I forgot again the chairperson's description. Dr. Pradna Kapse madam and Rutuja Gaikwad madam are our chairpersons for today, and I would like to introduce them. Dr. Pradna ma'am is BMS, MS and PhD, MA Psychology and Diploma in Sanskrit. She has an impressive 16 years of experience, and she is currently working as assistant professor in R.A. Poddar, and she is a Senate member of MUHS Nashik. And Rutuja Gaikwad ma'am has also completed her BMS from R.A. Poddar College, her MS Sri Rog from Tilak College, and holds a PhD from R.A. Poddar. She currently serves as an assistant professor in Sri Rog department in R.A. Poddar College with a rich experience of 10 years. Over to you, sir. Thank you.
So good evening everybody. Jai Jinendra. मैं हिंदी में बात करने वाला हूँ अपने राष्ट्रीय भाषा में। पहले मैं मेरे शूज़ निकाल रहा हूँ और मैं रिक्वेस्ट करूँगा कि सब लोग अपने अगर शूज़ निकाल देंगे, क्योंकि विद्या विनयाने शोभते। आज मैं जो बोलने जा रहा हूँ वो मर्म चिकित्सा के ऊपर। ये विद्या बहुत प्राचीन विद्या है। हजारों साल पहले भारत में अगर ये कॉन्फ्रेंस होती तो यहाँ 100% मर्म चिकित्सक बैठे होते, क्योंकि 100% अपनी भारत में मर्म चिकित्सा से ट्रीटमेंट होती थी हजारों साल पहले। और आज हम इस चिकित्सा पद्धति को भूल गए हैं। हम इसके बारे में अभी थोड़े जानेंगे। नेक्स्ट माझा लैपटॉप देना, वो लैपटॉप दो इधर। हजारों साल पहले मर्म चिकित्सा भारत में की जाती थी और इसे स्पर्श चिकित्सा नाम से भी जाना जाता है। अगर कोई पेशेंट हमारे सामने आते हैं और हम उनको स्पर्श से ठीक कर सकते थे तो इससे बढ़िया ट्रीटमेंट क्या हो सकती है, जहां डॉक्टरों को खर्चा नहीं है और पेशेंट को खर्चा नहीं है। जो लोग यहाँ बैठे हैं मैं उनके लिए कहूँगा कि वो अगर अवार्ड के लिए बैठे कि लेक्चर के बाद कुछ अच्छा अवार्ड मिलने वाला है, तो मैं बोलता हूँ एवरीबडी हु इज सिटिंग हियर विल बी अवॉर्डेड बाय दिस लेक्चर, बिकॉज दिस लेक्चर नॉलेज माइट ट्रांसफॉर्म योर डॉक्टर एंड पेशेंट रिलेशनशिप फॉर फ्यूचर, फॉर होल लाइफ. So next slide please.
आपला लॅपटॉप दे.
स्लाइड नहीं हो रहा है. ये हो रहा है क्या? ये लगता है क्या? For a period I had 2 lectures. I am going to talk about first diabetic food because there is some hitch in the laptop. So you will be surprised. I am an orthopedic surgeon talking about diabetic food, but it is a very well known technique in Russian surgery for diabetic food. So diabetic food is a very rapidly progressive, complex natural history, and diabetic food patients are very vulnerable and care should be easily accessible, specialized and multidisciplinary. What are the problems in diabetic food? They are neuropathy, immunopathy, ischemia, and the signs and symptoms may be very minimal. You might get only very little chance to act, and end-stage tissue death is very quick. So window of opportunity is very limited. So what should we do? For natural history of diabetic food, if you see, the high risk food goes into ulceration, wound infection and necrosis, followed by gangrene and amputation. But we have to reverse this natural history. How we can reverse this natural history is by healing the ulcers and increasing the circulation. As the way to reverse it is a very brilliant idea by Russian people by drilling holes. As you drill hole into the earth, the water will come out. But if you drill holes into the bone, the circulation of the foot will increase. And we studied a lot of patients. This is 2006 to 2008 data, which treated with Elizaro angioplasty. All patients underwent spiral multiple drilling of femur and tibia as per the vascular block. And as you see, the patient which I am talking about is a diabetic foot with ulcer, with a neuropathic foot, with a Charcot joint, was advocated amputation. And how to save this leg? By this technique, multiple drilling technique, Elizaro angioplasty. We fused the joint, patient was not walking on his leg and he started walking, and as you can see, this patient healed the ulcer within 1 month. The wound healed completely. There is another patient who has got Charcot joint with a diabetic foot with a non-healing ulcer, and she was advocated amputation. Elizaro angioplasty done and healed within 1 month the ulcer. The patient who could not walk started walking. This is the post 2 years back after the X-ray, which healed the joints and ulcer is healed. And you can see the ulcer very well healed. Sensation came back and this patient started walking on her leg. There is another patient who has got a deformity with a diabetic foot, and you can see her deformity was crooked, ankle joint fusion was done, and her deformity corrected completely. There is another patient who has got a diabetic foot with a non-healing ulcer, and this foot is in equinus cavus varus deformity. We fuse the joint, and you can see this completely wound healed, joint is completely well aligned, and patient is walking with a normal leg. There is another patient who has got a dislocation and the ankle with an ulcer, and you can see this is a Charcot joint. We treated with a fusion. And there is another patient who has got a Parkinsonism with a vascular block with a gangrene of the foot, which was advocated amputation, but we treated with Elizaro angioplasty and wound healed completely. There is another patient whose wound is healed completely, and we achieved arthrodesis in 100%, ulcer healing in 96% with this innovative Russian surgery which I name Elizaro angioplasty. And these are the patients who healed completely with Elizaro angioplasty. And diabetic foot is associated with multiple problems like ischemia, neuropathy, infection, and principles of Elizaro and Elizaro technique increases the survival chances of foot and avoids amputation. And in our series, all patients can be salvaged from amputation and all non-healing ulcers heal completely. And up until recently, the diabetic foot has defeated every healthcare system in the world. Advances in our understanding have led to improvements in care. Ulcers are now healed and amputation can be prevented with a Elizaro angioplasty surgery. And this is the simple solution to complex problem of diabetic foot. Thank you. And with this, I will go for second lecture. क्या हुआ? सेकंड लेक्चर लगाना. वो लेक्चर डाउन नहीं हुआ है क्या? हाँ? नहीं है तो वो कंप्यूटर कनेक्ट करो ना मेरा. तो मेरा कंप्यूटर नहीं कनेक्ट होता है क्या? नहीं होता ना सर, इस वजह से उससे लग डायरेक्ट करो. चलो उससे चालू करो डायरेक्ट. कौन सा है? निमा पहिला पहिला ये वाला. ये उड़ी है ना? नहीं नहीं ऊपर का नहीं, इसमें नहीं दिख रहा है. हाले का करंट ना होता है नाही तो होता है ना. काही पीपीटी नाही. पीपीटी कुठे आहे? इसमें नहीं है ना. इसमें नहीं है. ये होता है. हे बघ माझा लॅपटॉप कनेक्ट कर. ऑडियो बना है जैसे तो ऑडियो नहीं है कनेक्शन. ऑडियो आहे काय? नाही याला कनेक्शन. मला हे माईक लागेल. माईक संत शिरोमणि आचार्य श्री विद्यासागर महाराज जी मेरे गुरु हैं और एक बार उन्होंने मुझे कहा कि आप आयुर्वेद में थोड़ा इंटरेस्ट लेके आगे बढ़ो. एलोपैथी का ऑर्थोपेडिक सर्जन और आयुर्वेदा में कैसे जाएगा. फिर मैंने स्टडी किया और मुझे पता चला कि मैं पीएचडी कर सकता हूँ आयुर्वेदा में और वो योगा में मैंने पीएचडी कर सकता हूँ. एलोपैथी के डॉक्टर खाली पीएचडी आयुर्वेदा में योगा में कर सकते हैं. और फिर मैंने मर्म चिकित्सा ये सब्जेक्ट चुना और जिसमें मैं पीएचडी कर रहा हूँ. ये मर्म चिकित्सा का हजारों साल पुराना फोटो है जहाँ हम देखते हैं कि मर्म चिकित्सा से पूरी ट्रीटमेंट होती थी. और मर्म चिकित्सा ये बहुत ही गूढ़ रोचक और वैज्ञानिक विषय है. आयुर्वेद में इसे बहुत महत्व दिया गया है और प्राचीन काल से इसे गुप्त विद्या माना गया था. ऋषि मुनि, राजा और लोग उसका उपयोग करते थे और इस काल में अज्ञानवश दुर्लक्षित होने की वजह से यह अनन्य साधारण पद्धति आज लुप्त होने के मार्ग पे है. हमारे पूजनीय महाव्रती और महाराज जी केवल आयुर्वेदा की ट्रीटमेंट लेते हैं। आप में से सभी आयुर्वेदाचार्यों को मैं पूछता हूं, कितने लोगों ने एलोपैथी का त्याग किया है? कोई नहीं होगा। मैंने और मेरे मिसेस ने एलोपैथी का त्याग किया है और हम आजीवन आयुर्वेद के लिए समर्पित है और केवल आयुर्वेद ही ट्रीटमेंट हम लेंगे, ऐसा हमने संकल्प लिया है। माइक पे हम अभी कोई पेशेंट्स के रिएक्शन, हैंड माइक, हाँ चालू करें। चालू नहीं हो रहा है। मर्म चिकित्सा के परिणामों का समप्रमाण प्रस्तुतिकरण एवं प्रदर्शन इस पद्धति के विश्वसनीयता को प्रदर्शित करने में सहायक सिद्ध होता है। आपने हजारों साल पहले जीवक कुमार भारतीय का सुना होगा, और कुमार भारतीय वॉज कॉल्ड एज अ फादर ऑफ इंडियन एक्यूपंक्चर, और उनके प्रसिद्ध शिष्य थे जो रानी बिंबिसार और गौतम बुद्ध, ऐसे लोगों को उन्होंने मर्म चिकित्सा सिखाई थी। और आप देखोगे भारत से चीन में, जापान में, अमेरिका में, हर कंट्री में मर्म चिकित्सा डिफरेंट नाम से जानी जाती है, एक्यूप्रेशर, एक्यूपंक्चर, मगर इसका ओरिजिन भारत में ही है। और ये जीवा कुमार भृत्य भारत में प्रथम वैद्य 7 साल तक्षशिला में आयुब और मर्मशिल्य चिकित्सा में काम करते थे। उनके शिष्य थे गौतम बुद्ध, राजा बिंबिसार, रानी आम्रपाली, और 15,000 पत्र है जिन्होंने मिरेकल किए हैं पेशेंट्स के ट्रीटमेंट में मर्म चिकित्सा से। माटी, पानी और हवा 100 रोगों की एक दवा, ये उपचार तो स्वतंत्र है, अपव्ययी नहीं, मितव्ययी है। इसके प्रयोग से किसी प्रकार की प्रतिक्रिया नहीं होती तन और मन के किसी कोने में। ऐसी चिकित्सा पद्धति हमारे होनी चाहिए और इससे धर्म की वृद्धि होती है, पाप नाश होता है और पेशेंट्स को रोगों से मुक्ति प्राप्त होती है। अनफॉर्चुनेटली मेरे वीडियोस वर्क नहीं कर रहे हैं, मगर मैं उनके बारे में बताऊंगा। ये पेशेंट थी जिनको लो बैक पेन था और मैंने मर्म चिकित्सा की। वो बताने आई कि 15 दिन पहले आपने मर्म चिकित्सा की और मेरा पेन चला गया, पूरे ही चला गया। अनदर आप सोचते होंगे और आपको ये प्रश्न पूछना गलत है कि क्या है मर्म, क्योंकि आप अपने बीएमएस के करियर में मर्म चिकित्सा के मर्म बिंदुओं को जानते हैं। और मार्यंती इति मार्माणी, जो मृत्यु के लिए कारणभूत होता है उसे मर्म स्थान कहते हैं। उस मर्म स्थानों के अगर आघात होता है तो मृत्यु होने की संभावना है, मगर उसी मर्म चिकित्सा से मर्म बिंदुओं को हम अगर एक्टिवेट करेंगे तो पॉजिटिव करेंगे तो बीमारी नष्ट हो सकती है। इस मर्म बिंदुओं की इस पद्धति को मर्म चिकित्सा कहते हैं। ये मर्म तंत्र मनुष्य शरीर के सबसे महत्वपूर्ण तंत्र है और अगर हम उसको उपचारित उद्दीप्त करें योग्य पद्धति से तो रोग मुक्ति हो सकती है। ये अनादर पेशेंट है जिसके कमर में दर्द था और उसको भी हमने मर्म चिकित्सा से ठीक कर दिया। आगे देखते हैं कि कितने मर्म बिंदु होते हैं। 107 मर्म बिंदु शरीर में होते हैं और जिसके माध्यम से हम एक मन को ऐड करते तो 108 मर्म बिंदु होते हैं। पहला मर्म बिंदु हम अधिपति मर्म बोलते हैं, उसको राजा बोलते हैं। और 6 इंपॉर्टेंट मर्म है, जो 3 मर्म जो हृदय, बुस्ती, शीर, और 6 महामर्म है, शीर, हृदय, बस्ती, कंठ, गुदा, नाभि, और 1000 के पास उपमर्म है और इनके स्थान के अनुसार वर्गीकरण किया जाता है। अगर हम आगे से देखेंगे तो अधिपति, स्तपनी, आवर्त, अपांग, लोहिताक्ष, नाभि, बस्ती, विटप, लोहिताक्ष, क्षिप्र, कुर्च, कुर्चशीर, तल हृदय, गुल्फ, जानू, आणी, उर्वी, इंद्रबस्ती, स्तनमूल, स्तनरोहित, अपलप, अपस्तंभ, हृदय, नीला, शंख और उत्क्षेप, इस प्रकार से मर्म बिंदु देखे जा सकते हैं। पीछे से देखेंगे तो अंश, अंशफलक, बृहति, कृपर, इंद्रबस्ती, मणिबंध, उर्वी, आणी और तल हृदय, कुर्चशीर, कुर्चशीप, शिल्प और कुल्फ, इंद्रबस्ती, जानू, कटिक तरुण नितंब कुकुंदर पार्श्वसंधि आणी उर्वी कक्षधर कृकटिका और विदुर। इस प्रकार इस मर्म बिंदुओं को हम जानते हैं। प्राणिक ऊर्जा गुरु आशीर्वाद से और नियम संयमित जीवन से और योग साधना से जो ऊर्जा होती है, उस ऊर्जा रुग्णों के उपचार करने में बहुत सहायताकारी होती है। और स्पर्श से भी हम इसको उद्दीपित कर सकते हैं, उपकरण से जिमी से भी उसको उद्दीपित कर सकते हैं। विशेष ध्यान से मेडिटेशन में अगर हम मर्म चिकित्सा के मर्म बिंदुओं पे अगर ध्यान लेके जाएंगे तो उस मर्म को उद्दीपित कर सकते हैं और जिससे बीमारी ठीक हो सकती है। रुग्ण और मर्मरोगी इन दोनों की मानसिकता का चिकित्सा पे बहुत प्रभाव पड़ता है। ये पेशेंट कहने जा रहा है कि आयुर्वेद को एलोपैथी से अगर अलग देखा जाता है तो जानते हैं कि आयुर्वेद में इमरजेंसी ट्रीटमेंट नहीं है। हर लोग ये सोचते हैं कि एलोपैथी हैज गॉट इमरजेंसी ट्रीटमेंट, मगर ये मैं डिस्प्रूव करना चाहता हूँ ये पेशेंट के माध्यम से कि जिसको एक्सीडेंट होकर फ्रैक्चर रिब्स हुआ था और वो मेरे पास आया ढूंढते हुए कि मेरे पुराने डॉक्टर बाहर गाँव गए, वो आएंगे तो मैं आऊँगा, तो एक हफ्ते के बाद आया, मगर सीवियर पेन था। मैंने उसको आपलप बिंदु दिया और उसका पेन चला गया। वो आश्चर्यचकित हो गया, पूरा ही पेन पेशेंट का चला गया। ऐसे अनेक पेशेंट मेरे पास है जिनके ट्रीटमेंट से इमरजेंसी ट्रीटमेंट, जैसे मैं ऑर्थोपेडिक सर्जन हूँ, पेशेंट मेरे पास एम्बुलेंस में आते हैं, पैर को स्प्रेन हुआ है, खड़ा नहीं हो सकता, मगर मर्म चिकित्सा से तुरंत चलते हुए घर जाते हैं। इस प्रकार मर्म चिकित्सा इमरजेंसी ट्रीटमेंट में भी काम में आती है और ये आपातकालीन चिकित्सा कहती है, त्वरित नतीजा आता है। और इसमें एक बात ध्यान रखना जरूरी है कि यह मर्म चिकित्सा आपातकाल में तो जरूर ही की जा सकती है, पर सामान्य वैद्य का उपचार से पेशेंट को वंचित भी नहीं रखा जाना चाहिए। ये पेशेंट के पिताजी को एक्यूट अस्थमा का अटैक आया था और रात को 3 बजे उन्होंने मुझे फ़ोन करके बताया कि डॉक्टर साहब मेरे पिताजी स्टेटस एस्थमेटिक इसमें है और वो श्वास नहीं ले सकते, उनको लगता है कि मैं मर जाऊंगा। मैंने कहा कि आपको तो उनको तुरंत हॉस्पिटल लेके जाना चाहिए, मगर मैंने उनका मर्म चिकित्सा कोर्स लिया था तो मैंने कहा कि रास्ते में कार में आप उनको मर्म पॉइंट्स दे दिए। जो मैंने मर्म पॉइंट्स दिए उनको, जिसमें क्षिप्र, आणी, उर्वी और अपलप, ये देने के बाद जब वो हॉस्पिटल के दरवाजे पे पहुंचे तो उसने पिताजी ने कहा कि मेरा श्वास संतुलित हो गया है, मुझे कोई ट्रीटमेंट की जरूरत नहीं, घर चलो। इस प्रकार ये इमरजेंसी ट्रीटमेंट मर्म चिकित्सा से भी हो सकती है, जिसमें स्टेटस एस्थमेटिकस जैसे बीमारी भी ठीक की जा सकती है। ये अनादर पेशेंट है जो कह रहा है इनके मदर को लिफ्ट में एक्सीडेंट हो गया। लिफ्ट में एक्सीडेंट होने के बाद उनका अंगूठा कट हो गया। अंगूठा को बेंगलोर में उनका टो ट्रांसप्लांटेशन किया गया। टो ट्रांसप्लांटेशन करके बाद उनको प्लास्टिक सर्जरी एब्डोमिनल फ्लैप से की गई और वो फ्लैप उनकी एब्डोमेन में 3 से 4 हफ्ता होने के कारण उनको थोड़ा सा झुकाव आ गया था। और मेरे पास जब वो आए तब उनके हाथ में सीवियर पेन था। मैंने पूछा, मैडम ये 2-3 महीने से आपका ऑपरेशन हुआ है मगर ये पेन गया नहीं क्या? नहीं, बोले बहुत जबरदस्त पेन है, हाथ में जलन है। आश्चर्य कीजिए, मैंने उस पेशेंट्स के केवल शिप्र मर्मों को स्पर्श किया, हाथ के शिप्र मर्मों को स्पर्श किया और उन्होंने कहा डॉक्टर पेन चला गया। 2 महीने का पेन एक क्षण में चला गया। ये शिप्र मर्म की जादू है। इस शिप्र मर्म से वो पेशेंट ने कहा कि मेरा पेन चला गया और फिर मैंने उसको कमर के जो पॉइंट्स थे वो दिए, जिससे वो झुक के चल रही थी वो सीधी हो गई। इतनी आश्चर्यचकित हुई वो पेशेंट कि जिसको एलोपैथी के डॉक्टर 2 महीने से ट्रीट कर रहे थे मगर वो पेन निकाल नहीं पाए, केवल मर्म चिकित्सा 1 मिनट में पेशेंट को ठीक कर गई। इस प्रकार इस पेशेंट की कहानी है। ये पेशेंट मेरे पास आया, उसको कमर जॉइंट्स में पेन था। घुटने में दर्द था, और घुटने के दर्द के लिए वो मेरे पास आया था। घुटने के जानू मर्म बहुत सुंदर है, जिसको देने के बाद घुटने का दर्द चला जाता है। और वो एमआरआई पूछने आया था कि मैं एमआरआई करूँगा, मगर मैंने जब ट्रीटमेंट दिया तब उसका दर्द पूरा ही चला गया। तो बोले क्यों एमआरआई करना, कोई ट्रीटमेंट की ज़रूरत ही नहीं है। ऐसे कितने मेरे पेशेंट्स हैं जो मेरे को कहते हैं डॉक्टर आप क्यों प्रिस्क्रिप्शन लिख रहे हो, क्योंकि दवा की ज़रूरत ही नहीं, मैं पूरा ही ठीक हो गया हूँ। ये शिप्रमर्म के बारे में मैं कह रहा था, और उसकी एक कहानी है। मेरे ब्रदर इन लॉ गायनेकोलॉजिस्ट है, और उनके यहाँ एक पेशेंट का सिजेरियन सेक्शन हुआ। पेशेंट बाहर आया और हाथों में बहुत जलन थी, बहुत दर्द था। पूरे सुबह से शाम तक कार्डियोलॉजिस्ट आके गए, ईसीजी हो गया, किसी के समझ में नहीं आया कि हाथ में क्यों दर्द है। ऑपरेशन तो सीजर का हुआ है। शाम को उसने मुझे बुलाया कि सुहास यू आके देख के जाओ कि शायद ये ऑर्थोपेडिक प्रॉब्लम हो सकता है। मैं गया तो पेशेंट बोल रहा था कि मुझे पेट में ऑपरेशन हुआ, कोई दर्द नहीं है, मगर हाथ में बहुत जलन है। मैंने उसके शिप्रमर्म को हाथ के लगाया, हाथ जैसे ही मैंने स्पर्श किया, उसने कहा सर ये जलन चली गई, जादू जैसे ही चली गई। और पेशेंट ने मुझे पूछा कि अगर आप चले जाओगे और वो वापस जलन आएगी तो मैं क्या करूं? तो मैंने उसको कहा कुछ नहीं, आपके जो रिलेटिव्स हैं मैं उनको बता देता हूं कि शिप्रमर्म पे 10 बार दबाइए, आपका दर्द वापस चला जाएगा। इस प्रकार शिप्रमर्म की बहुत जबरदस्त ट्रीटमेंट है, जिससे अपने हाथ और हाथ से रिलेटेड सभी दर्द नष्ट हो जाते हैं। वैसे ही पैर में भी शिप्रमर्म है, जैसे पैर के दर्द को वो भी शांत कर सकते हैं। अभी ये पेशेंट कह रहा है फ्रोजन शोल्डर में मेरे पास कितने पेशेंट्स आते हैं जिनको महीनों तक ट्रीटमेंट चलती है, मगर मैं इधर दावे से कह सकता हूँ फ्रोजन शोल्डर का पेशेंट 2 मिनट में पूरी मूवमेंट उसकी आ जाती है और पूरा दर्द चला जाता है मर्म चिकित्सा से। ये मर्म चिकित्सा का फ्रोजन शोल्डर के लिए बहुत उपकार है। कितने पेशेंट्स के जिनको अंशफलक और स्कैपुला के इनर बॉर्डर में जो पॉइंट्स है वो देने के बाद तुरंत पूरी मूवमेंट वापस आ जाती है और दर्द चला जाता है। ये पेशेंट मेरे पास आई थी जिसको सर्वाइकल पेन था। सर्वाइकल स्पॉन्डिलोसिस के कितने पेशेंट्स हैं यहाँ? हाथ ऊपर कीजिए। बहुत। सब ध्यान से सुनिए, आज के बाद सर्वाइकल स्पॉन्डिलोसिस आपकी जिंदगी से निकल जाएगा। कैसे जाएगा? सिंपल है, कीप योर हैंड ऑन द नेक, पुट योर थंब ऑन द मन्या पॉइंट। दिस इज अ मन्या, यू ऑल नो मन्या इज अ मर्म बिंदु, और इसको 10 बार दबाइए। ये सर्वाइकल स्पॉन्डिलोसिस का बहुत जबरदस्त पॉइंट है, जिसको करने से आपका सर्वाइकल पेन चला जाएगा। और आयुर्वेदाचार्य, आयुर्वेदा के लोगों को मैं एलोपैथी का डॉक्टर बता रहा हूं कि आप जीरा खाइए। कच्चा जीरा खाने के बाद आपका सर्वाइकल स्पॉन्डिलोसिस निकल जाएगा, क्योंकि ये जीरा पित्त को शांत करता है और पित्त से सर्वाइकल स्पॉन्डिलोसिस होता है। अगर आप भोजन के बाद कच्चा जीरा खाओगे तो वापस सर्वाइकल स्पॉन्डिलोसिस आपको आएगा नहीं। ये मिरेकल है, और ये पॉइंट आप दोनों तरफ राइट और लेफ्ट को देकर कर सकते हैं। बहुत कम एलोपैथी के डॉक्टर ये जानते हैं कि हम जो पढ़े हैं पेन मैनेजमेंट वो गलत है, और एक्चुअली पेन मैनेजमेंट इज वात मैनेजमेंट, और वात अगर हम ठीक करेंगे तो पेन चला जाता है। नेक्स्ट, और आपको कोई बीमारी के बारे में मर्म चिकित्सा जानना है तो आप बता सकते हैं, मैं अभी आपको करके दिखा सकता हूं। मन्या, माइग्रेन, आपको आश्चर्य लगेगा, मैं मध्य प्रदेश में कुंडलपुर शहर में था, वहाँ हमारा तीर्थ क्षेत्र है। वहाँ मुझे महाराज जी ने बुलाया कि ये पेशेंट जो आदमी है वो छोड़ के जा रहा है कुंडलपुर, क्योंकि उसको सीवियर पेन है, माइग्रेन है। मैंने बोला सर इसको जाने की जरूरत नहीं, मैं 1-2 मिनट में इसको ठीक कर देता हूँ। लेकिन कैसे? आप सब सुन लीजिए, ये एक पॉइंट आपके पेशेंट के लिए टर्निंग पॉइंट हो सकता है। क्या? कि आपके रिस्ट जॉइंट पे एक स्नब बॉक्स है। उस स्नब बॉक्स में अगर हम प्रेशर देंगे, ये स्नब बॉक्स, एनाटॉमिकल स्नब बॉक्स रेडियल स्टाइलॉइड प्रोसेस के नीचे, उस स्नब बॉक्स में आप उंगली अंगूठा रखिए और 10 बार दबाइए, दोनों साइड में, राइट और लेफ्ट। और 10 बार दबाने के बाद आप सोचिए मिरेकल होगा, हेडेक चला जाएगा, जो भी दर्द है वो सब गायब हो जाएगा। ये मणिबंध पॉइंट है। ये मणिबंध क्या करता है, अपने ब्रेन का सर्कुलेशन बढ़ाता है। ब्रेन का सर्कुलेशन बढ़ने से तुरंत हेडेक चला जाता है। ऐसे मिरेकुलस रिजल्ट मर्म चिकित्सा में है। और किसी को कोई जानकारी चाहिए? लंबर स्पाइन, मैनेजमेंट ऑफ मैकेनिकल लो बैक पेन विथ मर्मा थेरेपी, ये मेरा पीएचडी टॉपिक है और उसको मैंने योगासना से कंपेयर किया है। ये दो ग्रुप है, कंट्रोल और स्टडी ग्रुप, इनका कंपैरिजन करके मैं दिखाना चाहता हूं कि मर्म चिकित्सा इज बेटर देन योगासना। हाउ? मर्म चिकित्सा, आप अगर अपने कमर में दर्द हो तो क्या करते हैं, ऐसा हाथ रखते हो, बराबर है? ऐसा हाथ रखने पे आपका अंगूठा यहां आता है कुकंदर पॉइंट पे और यहां नितंब आगे का पॉइंट एंटीरियर सुपेरियर आइलैक स्पाइन, ये पोस्टीरियर सुपेरियर स्पाइन और ये एंटीरियर सुपेरियर स्पाइन। इसको क्लॉकवाइज 10 बार घुमाइए और एंटी क्लॉकवाइज 10 बार घुमाइए, आगे घुमाइए, आपके ये पॉइंट से दर्द चला जाएगा, कमर दर्द गायब हो जाएगा। और इंटरेस्टिंग पॉइंट आपको मैं बताता हूं, जो लास्ट टाइम मैंने लेक्चर लिया था उसमें बताया नहीं। मैंने रिसेंटली एक 80 ईयर ओल्ड मर्म चिकित्सक के पास में गया जिसने कोई डिग्री हासिल नहीं की है, उसे कुछ आता नहीं है मेडिकल का। उसके दादा परदादा मर्म चिकित्सा प्रैक्टिस करते थे और वो 80 ईयर ओल्ड ही इज प्रैक्टिसिंग इन जालना जिंतूर मर्म चिकित्सा। केवल मर्म चिकित्सा से हजारों पेशेंट की लाइन लगती है और वो ठीक करता है। उसने मुझे सिखाया, वो पॉइंट मैं आपको बताने जा रहा हूं। आप एक करके देखिए और आश्चर्य में पड़ोगे कि ये करने के बाद दर्द कमर का गायब हो जाएगा। कैसे? फिबुला अपर थर्ड से लेके फिबुला लोअर थर्ड तक जो पोस्टीरियर बॉर्डर ऑफ फिबुला है उसको आप दबाते जाइए, ये वात स्थान है। और अगर हम इसको एम्प्टी करते जाएंगे तो वो वात निकल जाएगा और कमर का दर्द तुरंत गायब हो जाएगा। ये इंटरेस्टिंग पॉइंट है कमर दर्द के लिए, जिसको मैंने अभी रिसेंटली मेरे पेशेंट्स के ऊपर यूज किया और कितने पेशेंट्स मेरे इससे अच्छे हो गए। दोनों साइड आप ट्राई कर सकते हो, राइट और लेफ्ट। फिबुला हेड से पोस्टीरियर बॉर्डर से आप दबाते जाइए, लोअर थर्ड फिबुला और एंटीरियर पार्ट ऑफ द फिबुला। इससे वात नष्ट हो जाता है और आप सब जानते हो कि वात ही दर्द का कारण है। सायटिका इज बिकॉज ऑफ साइटिक नर्व के अंदर वात घुस गया है, उसको अपने निकालना है। इस प्रकार कमर दर्द हम सॉल्व कर सकते हैं। कमर दर्द के लिए बहुत कुछ और इंटरेस्टिंग पॉइंट्स है, मगर नाभि में अगर आप ऑयल रखोगे तो भी कमर दर्द गायब हो जाता है। कैसे? 72,000 नाड़ियों का जो जंक्शन है नाभि, उसमें वात घुसा हुआ है। अगर हम उसको तेल रखेंगे तो वो वात का दुश्मन है, जिससे वात सब नाड़ियों से गायब हो जाता है और दर्द नष्ट हो जाता है। ये आप करके देखिए अपने घर में। और मैं सबको मैं क्या बताऊं, मुझे शर्म लगती है एलोपैथी के डॉक्टर होके आयुर्वेद में ये बात करना, मगर ये आप सब जानते हो और इस मेथड से हम अपने पेशेंट्स को ठीक कर सकते हैं। शुरू हुआ क्या? हाँ, स्टुडिओ सुरू झाला। हाँ,
आवाज येतो का? आवाज चेक.
साउंड नहीं है। और बहुत कुछ इंटरेस्टिंग पॉइंट्स हैं जिसके बारे में सर्वाइकल स्पॉन्डिलोसिस के बहुत पेशेंट्स हैं और वो पूछ रहे कि बार बार कि सर्वाइकल स्पॉन्डिलोसिस की ट्रीटमेंट क्या है। सर्वाइकल स्पॉन्डिलोसिस के लिए हम मन्या पॉइंट का यूज कर सकते हैं। ये हाथ रख के इसको दबा सकते हैं और इसको 10 बार दबाना है मन्या पॉइंट को, जिससे नेक पेन चला जाएगा। आप अपने हाथ से कर सकते हैं, राइट और लेफ्ट दोनों तरफ, जिससे आपको तुरंत आराम मिलेगा सर्वाइकल स्पॉन्डिलोसिस में।
हेलो, मैं तंगमणि बोल रही हूँ। मैं 15 दिन पहले डॉक्टर साहब के पास आए थे। मुझे कमर से लेके मेरा लेफ्ट लेग नीचे तक हड्डी में बहुत दर्द था, तो डॉक्टर साहब ने कुछ मेरा फिंगर एक दबाया, तब भी से मेरा दर्द वापस नहीं आया। अभी बहुत ही अच्छा है, बहुत ही अच्छा है, बोलेगा तो बहुत ही अच्छा है। मैं थैंक्स बोलने के लिए आई हूँ अभी डॉक्टर साहब के पास। आज तारीख है हेलो, मैं तंगमणि बोल रही हूँ। मैं 15 दिन पहले डॉक्टर साहब के पास आए थे। मुझे कमर से लेके मेरा लेफ्ट लेग नीचे तक हड्डी में बहुत दर्द था, तो डॉक्टर साहब ने कुछ मेरा फिंगर
एक दबाया, तब भी से मेरा दर्द वापस नहीं आया। अभी बहुत ही अच्छा है, बहुत ही अच्छा है, बोलेगा तो बहुत ही अच्छा है। मैं थैंक्स बोलने के लिए आई हूँ अभी।
ये मेरा पेशेंट था और एक पेशेंट का मैं आपको दिखाता हूँ।
मैं रविंद्र राणा, मेरे फोन के बहुत प्रॉब्लम के लिए डॉक्टर सुहास भाई शाह साहब के पास आता रहता हूँ। मैं दूसरा कोई ऑर्थोपेडिक सर्जन चेंज नहीं किया, करीब 30 साल 40 साल हो गए। अभी मैं रिसेंटली 4-5 दिन पहले बाथरूम में गिर गया। इट वॉज अनबेरेबल पेन, इतना पेन था कि रोना ही बाकी था। मैंने फोन किया तो डॉक्टर साहब नहीं मिले। फिर जब डॉक्टर साहब आ गए तो फिर मैं वहीं आया वापस। साहब ये मुझे प्रॉब्लम करो, मेरा प्रॉब्लम सॉल्व कीजिए, मैं गिर चुका हूँ। मुझे देखा कहाँ दर्द करता है। उसने कुछ अपने उंगली से ही सिर्फ मेरी पॉइंट्स दबा दिए और देखिए मैं कितना आसानी से खड़ा हो जाता हूँ, ये आप देख सकेंगे आराम से। जो मैं चल भी नहीं सकता था, जो गाड़ी में बैठ के भी मुझे दिक्कत होती थी, श्वास लेने में भी दिक्कत होती थी, वो हमारा राइट साइड दर्द कर रहा था, मेरा लेफ्ट शोल्डर दर्द कर रहा था। ये डॉक्टर साहब ने कुछ मिरेक्युलस दवाई दी मुझे, उसने कुछ पॉइंट्स दबा दिए और मैं परफेक्ट ऑलमोस्ट 90% मैं अच्छा हो गया हूँ। आई एम थैंकफुल टू डॉक्टर सुहास भाई शाह।
हॅलो, मी योगिता कुलकर्णी आणि मला पेवर ब्लॉकमध्ये पाय अडकून पडायला झाल्यासारखं झाल्यामुळे कमरेमध्ये अडकून झाल्यासारखं लोअर बॅक पेन सुरू झालं होतं. पण डॉक्टरांनी आज जे काही केलं, जे काही प्रेशर दिलं त्याच्यामुळे आता अगदी रिलॅक्स झालेलं आहे. 2 मिनिटांमध्ये खूप रिलॅक्स झालेलं आहे.
हे लो बॅक पेशंट.
थँक्यू.
अनिल जैन, अब मैं डॉक्टर साहब के पास आता, घुटने में दर्द हो रहा था तो चलने को ही नहीं हो रहा था, बिल्कुल भी उतारता था तो बहुत दर्द होता था। फिर अभी डॉक्टर साहब के पास आया और डॉक्टर साहब ने हाथ में उंगली में और पैर की उंगली में कुछ करा जादू, और पता नहीं उसके बाद 2 मिनट के बाद बोले चल के तो बाद में देखो, तो देखा तो फिर कुछ भी दर्द नहीं हो रहा था, पूरा का पूरा एकदम ऐसा जादू हो गया, पूरा ठीक हो गया दर्द। और अभी तो मैं सोच के आया था कि मैं हमारा ही कराऊंगा डॉक्टर साहब को बोल के, और अभी हमारा की जरूरत ही नहीं महसूस हो रही है क्योंकि बिल्कुल ठीक हो गया।
नमस्कार मंडळी, माझं नाव अरुण सांडगे. मी मर्म थेरपी घेण्यासाठी डॉक्टरांकडे आलो होतो आणि माझे मित्र डॉक्टर राजेश गायकवाड त्या साहेबांनी पाठवलं होतं आणि डॉक्टर शहाने अतिशय सुंदर ट्रीटमेंट दिली. गेली 2 वर्ष मला फोर्जन शोल्डरचा त्रास होता आणि आज जवळजवळ 80% एका आठवड्यात कमी झाला. असंच डॉक्टरांकडे
फिर से मैं बली मोहम्मद बोल रहा हूँ। मैं यूपी का रहने वाला हूँ और मेरे कमर में दर्द करीबन 2 साल से था और इतना तकलीफ मेरे रहती थी कि हम चल तक नहीं पाते थे। 2 मिनट के अंदर डॉक्टर साहब ने एकदम ही ऐसा कर दिया कि एकदम कोई दवा लेने की भी जरूरत नहीं है।
ये मैं कह रहा था कि पेशेंट बोलते कि कोई दवा की जरूरत ही नहीं है। ये फ्रोजन शोल्डर का पेशेंट है। एक मैं इंटरेस्टिंग पॉइंट दिखाता हूँ।
जय जैन, मेरा नाम स्वाति श्रेणी लम्बनावर है। मैं इचलकंजी की रहवासी हूँ। मैंने जुगुल में डॉक्टर सुहास शाह और डॉक्टर मोनिका शाह का कैंप अटेंड किया था, तो तब कम रोशनी में भी मैं पहले पढ़ नहीं सकती थी, तो मैंने उनसे जब मर्म चिकित्सा करवाई तो 1 ही मिनट की ट्रीटमेंट के बाद मेरे विजन में बहुत ही क्लैरिटी आ गई। अब मुझे चश्मे की जरूरत नहीं है। ये मर्म चिकित्सा बहुत ही इंस्टेंट रिजल्ट देती है।
मर्म चिकित्सा आंखों की, जिससे तुरंत ही आपका चश्मा जा सकता है। इस प्रकार मर्म चिकित्सा के हमने पॉइंट्स देखे हैं। एक मैं दिखाना चाहता हूँ सबको लोगों के लिए कि हमने नीमा के लिए कोर्स किया था मर्म चिकित्सा का, और वो कोर्स हम वापस नीमा के ऑफिस में करने वाले हैं। और वो कोर्स के माध्यम से हम 2 दिन के कोर्स में मर्म चिकित्सा कैसे करनी चाहिए और कैसे हम पेशेंट्स को अच्छा कर सकते हैं मर्म थेरेपी से, इसका पूरा ट्रेनिंग देते हैं। इसका बेसिक कोर्स है, एडवांस कोर्स है, और मैं सबको इनवाइट करता हूं, आप जरूर इसका लाभ लीजिए नीमा सेंटर को कांटेक्ट करके। थैंक यू मैडम, एंड सॉरी फॉर देयर इज सम डिस्टर्बेंस इन द प्रेजेंटेशन।
Thank you so much, sir. I request you to be here. Thank you, Suhas sir, for this mind-blowing and brain-tickling lecture. The stalwarts like Suhas sir are guiding light for us, right? So now, hereby I request our chairpersons to kindly felicitate Dr. Suhas sir. Suhas sir, please. Yes, a round of applause, please. Thank you, ma'am. And now I request sir to felicitate our both chairpersons, Dr. Gaikwad ma'am and Dr. Kapse ma'am, as a token of gratitude. Thank you, sir. Thank you so much, ma'am, and both the ma'ams and sir. Thank you so much. So now I request sir to, now there is an excitement part, right? The exciting part is remaining. So our lucky draw, our second last lucky draw is here, and I request sir to take out 3 lucky draws for today's evening. The first winner is, sir, if you can announce it yourself.
सीरियल नंबर 322 जहीद खोत। सीरियल नंबर 535 डॉक्टर विजय उजलंबे।
No, Dr. Vijay. Not there.
229 डॉक्टर सचित धुलप।
Dr. Sachit, congratulations. Your second winner, sir.
थर्ड विनर गोपाल जादव 218।
218. Not there.
डॉक्टर कुमार नेरलकर
Nerlekar.
160।
Not there.
डॉक्टर वर्षा 177।
नंबर एक्झॅक्ट सांगा ना.
डॉक्टर अंजलि चौहान 549।
Congratulations, you are the third winner. Madam Anjali Chauhan 549. आणि फर्स्ट नंबर कोण आहे?
Thanks a lot for patient hearing.
Thank you. Thank you everyone, thank you, and congratulations to the winners. So moving on. Okay. So are you enjoying this feast of knowledge, everyone? Very good. So this is our last lecture and the best one, last but not the least. There's an announcement actually. There's another exciting announcement to be made. It is a matter of pride to announce that 12,820 audience are watching us live right at present, and this is a great achievement for us. That this knowledge feast is not just bounded to four walls, but it has like crossed there's 4 walls, and so many people are enjoying and benefiting from this. Truly, knowledge has no boundaries. So now, moving on to our last lecture, I hereby welcome our chairpersons for our last lecture, Dr. Gauri Mature ma'am and Dr. Kranti Patil madam, please come on the stage, ma'am. Dr. Gauri ma'am has completed her BMS and has a vast experience of 25 years of private practice. She practices at Shahpur, Thane. And our next chairperson, Dr. Kranti Patil ma'am, has completed her BMS and then done her Masters in Educational Technology, and she is an educational technologist, and she has an experience of 20 plus years, and she currently works as a Deputy General Manager in Maharashtra Knowledge Corporation Limited. और अब बारी आती है हमारे लास्ट स्पीकर के इंट्रोडक्शन की, सो अब दिल थाम लीजिए, क्योंकि अब मंच पर आने वाले हैं दिल और धड़कन दोनों के असली जादूगर, द वन हु डजंट जस्ट ट्रीट द हार्ट बट अंडरस्टैंड इट्स एवरी बीट, a pioneer in cardiology, a healer with hands of precision and a heart full of passion. It is my honor to welcome our esteemed speaker, Dr. Lanjewar sir, a leading expert in interventional cardiology. We look forward to your insights, sir, and guidance on the role of cardiology interventions beyond angioplasties from family doctor's perspective. How primary care can play a crucial role in this new era of cardiac care. Please join me in welcoming Dr. Charan Lanjewar sir to the stage. A warm welcome, sir, with a big round of applause, please.
Good evening, and thank you very much in whole NIMA organizing team, and thanks.
I want to introduce more, sir,
nice,
about you.
Introduction.
Sir has more than 20 years of experience in field of cardiology, okay? He has done his fellowship from the American College of Cardiology and European Society of Cardiology. He is trained in interventional cardiology at the McMaster University, Canada. He has presented papers in numerous international and national conferences. He has several publications in peer-reviewed national and international journals. He is a reviewer of Indian Heart Journal, IJCCM, and Journal of Heart Valves. He is a faculty and speaker at many national and international meetings. I once again welcome Dr. Lanjewar sir, a renowned cardiologist. Welcome, sir. Thank you.
Thank you very much, and I understand that this is the last session. So you guys must have been too much, lot of knowledge is going on. So I would be very short. Maybe it's given time is around 25 to 30 minutes, but try to be in the time. So let us move on to the intervention in cardiology looking beyond coronaries. Whenever you talk about any cardiac intervention or anything, always आपल्याला वाटते की ह्या कोरोनरी इंटरव्हेन्शन अँजिओप्लास्टी लागेल, प्रायमरी अँजिओप्लास्टी लागेल, असं एव्हरीबडी थिंक्स अबाउट इट. सो कार्डिओलॉजी ओवर आय कॅन अंडरस्टँड इन ऑर्थोपेडिक्स ऑल्सो अँड डॉक्टर सुहास टू बी ऑन द लाइटर साइड. सुहास साहेबांनी एवढे मर्मचिकित्सा केले तर सगळ्यांचं दुकान आपल्याला बंद करावं लागेल. तर लेट अस मूव ऑन टू द कार्डिओलॉजी. So interventional cardiology मध्ये not only the coronary intervention, but it's a scope of from everything. As you know, in anatomy we have been trained that heart is made of 4 chambers, there are 2 septi, there are multiple communications, there is systemic circulation and pulmonary circulation. So anywhere wrong happens, either the thing which is supposed to be closed after the birth, if it is not closed spontaneously, so cardiologists can close it with our invention and the techniques. And another thing is there are a lot of things which are not existed. So if the patient is deficient of something by birth, so we create that channels. So it's like giving both way. If it is not there, to give that, and if it is there, if it is extra, you remove it. So something like that, the whole session will be like on this aspect. So thinking about the walls, come to the walls, as there are 4 walls you say, mitral, aortic, pulmonary and tricuspid. So every intervention is possible nowadays. Then coming to the septa as you can say, the interarterial septum and the interventricular septum. So even their closures is possible. Then we come to the communication like fistulas. We can see that fistulas can be at the ductal level or it can be at the pulmonary aortic levels. So these fistulas can also be closed with the interventions. So if you see the historical how the background of cardiology goes, it goes to 1977 when the first intervention by Andrews, who has done the balloon angioplasty to the coronary artery, and since that day the innovations started and cardiology has achieved its peak. Recently, with all the historical perspective, the credit goes to Dr. Andreas Grunzek, he did the intervention in the Switzerland, and he is basically a French guy. So afterward, multiple people came into the picture, and then major innovation which occurred by the Alain Cribier, who did the balloon aortic valvotomy in 1985. So after that only the aortic valve replacement occurred percutaneously. So this was one landmark which came into 1985, and then in between the innovation occurred. But in 2002 you can see first ever TAVI. I think in the afternoon you must have heard one of the cardiologists who spoke very much about the TAVI. So every intervention is very much possible. So in a categories I will categorize into 4. The valvular pathology, septal defect, vascular lesions and fistulas. Coming to the intervention which commonly can be performed like vascular obstruction in various vascular channels, intervention involving occlusions which I already told you. So coming to the septum, by birth as an atrial septal defect, like in the neonates or newborn babies we have a patent foramen oval, which is a patency which has not been closed spontaneously. When it is there, and if it is smaller to larger size, is called atrial septal defect, which allows the blood to flow from left to right. So in 20 to 23% in adult population, you can have this common anomaly. How the family physician should suspect that in the adult if there is some murmur, which is the most common defect, atrial septal defect in a murmur. And by auscultation there is a fixed split, second heart sound split, which is there, that is not variating with the respiration. These are the 2 things which are possible. Another, you can get a cardiomegaly and also some ECG changes like RBB pattern, where the family physician should suspect and refer the patient to the cardiologist for echocardiography, which can be diagnosed and the subsequent therapy can be given. So this is how the intervention occur here. So this is the device. You can see the left is like umbrella device, and we put that device across the defect, and we can see that the device has been closed. And these are number of devices which came into the picture since the innovation started. Now many are there, even the Indian devices are there, as Modi ji has done the Make in India, this thing, it's very well running in cardiology also, and we have the Make in India products for interventional cardiology, and we are using those products and they are very good. So coming to guidelines in the sense, any symptomatic patient who has this defect should be closed. Okay, that's a nutshell. If you see in this diagram, you can see that there is a defect and we are doing the intervention with that, and this is the ASD and the 2D echo, and on the left side we can see that there is a device being deployed. We are going across into the left atrium first, and then putting one device on the left atrium, then pulling out the device across the septum and then releasing the device. That's how it has been closed. And on this echo we could see that it has been, this is the defect here, we can see here. So this is a 30-year-old male. Another intervention where the septum related, like interatrial septum, the patient had a stroke, younger patient who had a stroke. So possibly stroke is not just the cerebrovascular episode because of some blockages in the cerebrovascular vessels. It could be because of thromboembolic from the heart. The reason could be atrial fibrillation. It throws the thrombi into the left, from the left ventricle into the system. That is one possibility. Another could be the paradoxical embolism which occurs across the PFO. If there is a patency of the PFO, the thrombus can dislodge from the right side and go into the left side and go into the systemic circulation, either into the cerebrovascular circulation or also can go into the coronaries and cause stroke of the brain as well as even the stroke of the heart. So both can be possible with this device. So this is the device closure has been done in such a patient who had a stroke, and this should be, again, the family doctor has a role here. Always think about if there is a younger patient and no particular reason to have a stroke. In those patients, we can have a PFO which should be investigated by echocardiography and transesophageal echo. Those patients should be referred to the cardiologist for the needful. So I am very particular on every slide. I want to give some message to the family doctors here, even the specialists, such that what can be the message from each patient. So coming to the ventricular septal defect, as such these are very found in the children, but if they are present in the adulthood, means they are very smaller defect either, or they are very larger defect with already Eisenmengerise. Eisenmengerise means it's non-reversible defect, right? Even though if you do surgery, there is not going to be any improvement. So there are two possibilities in those cases in the adult if you have the VSD. So the patient, another VSD which is more possibly is in acute myocardial infarction, where you get a ventricular septal rupture because of the MI, because of necrosis. If there is a thrombus, LAD gets suppose a necrosed, in that the muscle gets necrosed, and in the muscle the septum gets necrosed and it has a hole in the septum and it can cause a ventricular septal rupture. So this is kind of emergency. Again, this is a very dreadful complication. Whatever you do, around 40 to 50% mortality is there. Survival is very rare, 25% survival at the 1 month period. Only if you do either a device closure or a surgery. Success of the surgery and devices are rare. However, in the literature and even we are doing these cases, and we find our data is there is 70%, at least 70% survival, 30% mortality with our patients. So we have to select those patients. In the whole hall, there may be a lot of people who has experienced any heart attack, who is admitted, and we have done the angioplasty, and the patient become bad, successful angioplasty. So this is the reason, one of the reason why patient probably had died, must have got rupture into the ventricle or must have cardiac rupture, where the cardiologist or surgeon has little to do, little to offer. So nothing wrong about anybody here, because you can, and these are a missable diagnosis. You can miss the diagnosis even on the echo, because the suspicion has to be there when you do the echo. They are very differently apically located, so difficult to locate on the echo. So you need to first clinically suspect that. How to suspect clinically? The patient become acutely deteriorated, hypotension, tachypnea, require respirator, maybe requiring IBP support, and you think that ECG is fine, patient does not have chest pain, he has breathlessness only. So in that cases you may suspect. So these are the different device closures. So this is one of the closure what we did. One of the patient where I can, if it is running. So this way you can see that the whole heart is dilated, and this was an acute myocardial infarction, and where we could devise it by the advantage of interventional cardiology here is that it is a safe procedure comparing surgery. If the patient become okay within 2 days, patient can be discharged early. So that is much more important advantage. Most of the surgeon doesn't operate for a VSR because the outcome is not good, so they deny the surgery. In those cases, this is the best option to remember. Coming to the indication, again symptomatic patient having the murmur, pansystolic murmur, or cardiomegaly, or in the ECG some kind of chamber enlargement. These are the suspension where you should suspect and refer that patient to the cardiologist. Now coming to the fistula closures. I told that there are many fistulas. I am talking about only the cardiological fistulas. So one is a rupture of sinus of Valsalva aneurysm, when aorta gets ruptured into the any chamber, aortic root. And this is also common. We have the largest series of our patient from the KEM, and it's a world published series where first of all whenever we rupture occurred, we put the devices, and you've shown that, and now it became after that a very standard of therapy. Initially patient used to go for surgery, but this is the rupture of device, where surgery is high risk and we could just do the device closure in those patients. Another is a pulmonary fistula. When you suspect in a patient who is not so symptomatic, any adult patient or a pediatric patient who is not symptomatic but has a cyanosis and clubbing, so looks very stable in those, and some murmur. So here we should suspect that something, there is a arteriovenous, the venous blood as well as arterial blood is getting mixed up. That's why there is a cyanosis and clubbing. So, and the patient is quite stable with that. So where that time we should suspect, and that with different devices. And initially it was again a surgical option, but now we can very well close with the device, availability of the device, thanks to the research which has been occurring across the world and making us to close all the fistulas where possible. Coming, I think, PDA. So PDA, that is a patent ductus arteriosus. Everybody gets birth with the PDA. Maybe in the first week or the second week up to the fourth week, 90% PDAs get closed spontaneously. Whatever remains is uncommon, rare, which should be closed. Okay, so which are to be closed? When the patient has any murmur at the just infraclavicular area, that is a sign that it's a ductal area, and that should be get closed. So that can be closed with different, like a coils. You must have seen whatever we put in a pen, small coils, so very small thin coils which we close. And another the device, and this is the PDA. You can see that it's a communication between the main pulmonary artery and the aorta, and they get communicated where it need to be closed. If you don't close, what happens is, the pressure of the aorta, which is a systemic pressure, aortic pressure is systemic, means if you normal aorta, what is the normal aortic pressure? Suppose you take 120/80, and the pulmonary artery normal pressure is around less than 30 systolic, and the mean is less than 20. So much difference. If there is a communication between the aorta and pulmonary artery, the pulmonary circulation, the lung is exposed to the so high pressure that the lung gets pressurized to that pressure, and the lung gets that pathological changes in the lung, and which subsequently causes Eisenmengerization and clubbing, cyanosis, and certainly the lives in those patients, life is about 20 to 30 years of age. So that is why it need to be closed early, such that Eisenmengerization doesn't occur. And these are the different devices where we should close. So one of such patient, a 2-year-old kid, and you can see that there is a duct here, just at the between the pulmonary artery and aorta origin. Again, we have to cross, and then we put on the device, that is umbrella device, we can see, and it has been closed. So another is, I told you, when there is no communication, where some of the diseases require some communication. And that is known as like suppose there is a tricuspid arteries are very uncommon, which requires some left to right sign. So in that we maintain the duct. Okay, but naturally after the birth, the duct closes because spontaneously. So in those cases, we can make it happen to open by a stent. We put a stent, whatever coronary stent also, and we have put in such a case a coronary stent and shown the utility of that stent. I was coming to the RSOA device. So this was the same device which I was showing, which was not running in the last slide. I see if I can. So it's running here. So this is the aorta, you can see above, and these are we are coming from the vein here, RV, pulmonary artery, and then got closed. The same pulmonary AV fistula which I was talking, we go from the again from the vein to the pulmonary artery and close it. So there everywhere means every session, like coming to the obstructive lesions, like if there is an obstruction anywhere, like in the aorta, if you can see 35-year-old female who is pregnant coming with very high blood pressure, her blood pressure was not able to get control with multiple therapy like resistance hypertension. In that patient it was suspected to have coarctation because there was upper limb and lower limb blood pressure difference. So that's why you felt that there may be a coarctation, and we diagnose it on the echo, and once it is diagnosed, we have stented the coarctation segment by the stent, and subsequently she could deliver normally and the blood pressure got controlled. So again, the message in this particular patient is any patient whose blood pressure is not getting control, particularly if there is upper limb and lower limb blood pressure difference, in that patient we suspect that, and there can be a coarctation or aortitis that can be managed, and they are very treatable conditions. Coming to like valvular lesions where all four valves, there is one pulmonary valve, every valve can get stenosis and every valve can get regurg. If it is stenosis means it's not opening well, regurgitation means it is not closing well. So both are possibility. When it is not closing well, if there is a blockage, we can go up with the balloon, blow the balloon and open it. So this has been done here in this case. We can see that we went with the balloon across the pulmonary wall. Here is the pulmonary wall, pull back and we are dilating it, and you can see that waste has gone. So this is a successful balloon pulmonary valvotomy. Another was a patient who was a post-surgery, post-bypass surgery, whose intervention was done lima to the LAD. Lima is a left internal mammary artery which arises from subclavian artery. But despite that, after some years, patient got angina. So we suspected that the left radial artery was not palpable. So in that patient, as the radial artery was not palpable, we suspected there could be some subclavian artery stenosis. So in that patient, we put a stent as there was a stenosis. So here the lesson is, these are the very rare scenario, but yes, these are possible and we can come across this. These are transcatheter wall replacement procedures. Now everywhere in the literature, in the newspaper, media, this has been hyped and there is very much there. And nowadays, even the mitral wall regurgitation, severe mitral regurgitation, we can do the mitral clip non-surgically by percutaneously. However, the cost of the therapy is very high. It comes to about 30 to 35 lakhs rupees presently. But once the Indian companies come into the picture, the cost will definitely go down. And there are many Indian companies which will come maybe 2 or 3 years. Another is a wall replacement at the mitral wall, wall in wall. Again, mitral wall can be replaced percutaneously. And then coming to the very common intervention, what we have learned so far since last 50 to 60 years is a balloon mitral valvotomy. Still we face those patients of rheumatic heart disease with who require the balloon mitral valvotomy, and we save many patients with balloon mitral valvotomy in those patients. I will just take 1 or 2 minutes now, almost over. So this is the mitral wall. We went across in that patient and inflated the balloon, and subsequently, so many pregnant patient comes with that, who when you suspect, when there is a orthopnea, paroxysmal nocturnal dyspnea, very aggressive dyspnea, these are the patient who generally has a severe mitral stenosis, and when you have the mid-diastolic murmur in this, okay. Another same thing which you can see that there is a transcatheter tricuspid wall intervention. So point is, we can, in every wall, there is now a percutaneous wall replacement has come. Point is, those are very costly procedure at present. They cost more. But certainly next, I think 5 to 10 years, the cost will come down. Was initially also with the angioplasty and stenting, the cost was very high. But now it is very cheaper as compared to the maybe 10 years back. So same thing is going to happen. So in a carry-home message, family doctor and family referral, they have to detect early. You have to suspect once you see the patient depending on the symptoms and the clinical examination. Anything abnormal, maybe the patient having a murmur, maybe the heart sounds abnormal, these are the patient who you should refer to the cardiologist. And once the echo is done, the diagnosis most of the time with the echocardiography, 90% diagnosis, 90% of the time diagnosis is done. Only in 10% cases you may need another investigations, okay? Rest of the time echo is suffice. So non-coronary interventions avoid surgery, improve the quality of life and are safe. Follow-up is a paramount for all the patient, and as you all the doctors have to follow those patients over the longer period, and I think that's the end of the session. Thank you very much.
It was an absolute pleasure, sir, to listen to you. Thank you so much for the wonderful lecture. And as you all know, this was the last lecture. But don't go that because we have bumper lucky draw prizes still waiting for you. Thank you so much, sir, for the informative lecture. I would now request our chairpersons, Dr. Kranti Patil ma'am and Dr. Gauri Mathure ma'am, to kindly felicitate our esteemed speaker and dignified personality, Dr. Charan Lanjewar sir. Kindly give a big round of applause. Thank you, sir, for delivering such a knowledgeable lecture. And I would like Dr. Charan sir to kindly felicitate our chairperson, Dr. Gauri Mathure ma'am and Dr. Kranti Patil ma'am. Kindly give a big round of applause for both of them. And you all know this is the time for the last lucky draw. So who will take the last gold coin? Dwivedi sir is excited. Anyone else who wants to take the gold coin? No one? Everyone? Oh wow, Dr. Rajni Yadav ma'am, Women's Forum. No, that is Dr. Rajni Yadav ma'am, NIMA Women's Forum President. Hearty congratulations to Dr. Rajni Yadav madam for securing a gold coin. Let us take the next winner, and I would tell Dr. Charan sir to kindly do the honors.
Dr. Saili Paliwalkar, the serial number is 319. Congratulations, Dr. Saili. Where she is? Yeah. And the last one.
Dr. Saili, you have won for yourself a wristwatch, and the third lucky draw is for headphones, and the winner is?
There is no name written on the coupon, but the serial number is 094.
Do we have 94?
Dr. Vawar. Dr.
Another one. Next.
Dr. Vawar.
The another one is Dr. Rafatai, serial number 207. He is also not there. Okay, let's move.
जल्द से जल्द खत्म करो, अपना भी आने वाला है नंबर. इसीलिए चल रहा है.
One more to go. Yeah, everything is written on this. Dr. Vijay Thorat, serial number is 391. Congratulations, sir, Dr. Vijay Thorat. Thank you very much, and thank you.
Congratulations, Dr. Vijay sir. You have won for yourself a fabulous headphone. And thank you for all the speakers, and thank you for all the chairpersons, and thank you delegates for staying with us until the very end. And this is not a sight which we see often. This is a rare sight where we can see people sitting until the last row, and we all are still over here, and that means a lot to me as an organizing secretary. Now, to give the vote of thanks, I would give the dais to our conference chairman, who is dynamic, dashing, and very assertive and bold, to Dr. Prasad Pawar sir. Kindly welcome sir with a big round of applause. Thank you.
सर्वांचं मनपूर्वक धन्यवाद. काही गोष्टी थोड्याशा राहिलेत. आपल्या या निमाच्या असोसिएशनच्या ज्यावेळी रजिस्ट्रेशन होत होतं, ही सांगायची गोष्ट थोडीशी राहिली होती रजिस्ट्रेशनच्या वेळी, की 40 दिवस अगोदर आपण रजिस्ट्रेशन क्लोज केलं. निमाच्या इतिहासात हे पहिल्यांदा झालं. 650पेक्षा जास्त आपले डेलिगेट झाले. मी त्या सर्व डेलिगेट्सचे मनपूर्वक आभार मानतो. आणि ज्या डेलिगेट्सला यावेळी रजिस्ट्रेशन करता आलेलं नाही आहे त्या लोकांचं मनापासून क्षमस्व घेतो. या रजिस्ट्रेशनच्या प्रोसिजरमध्ये बऱ्याच लोकल असोसिएशनने आम्हाला भयंकर चांगल्या पद्धतीनं आम्हाला मानसन्मान दिला. त्यांनी डेलिगेट्स केले. बऱ्यापैकी आम्ही निमाच्या थ्रू काही लोकांचे पर्यंत कॉन्टॅक्ट पोहोचवले. काही लोकांना थोडीशी अडचण आली, काही लोकांना ऑनलाईन अडचण आली. मी त्या सर्व लोकांच्या ज्या अडचणी आल्या त्या लोकांचंही मनपूर्वक क्षमस्व मागतो. यामध्ये आम्हाला मदत करणारे बऱ्यापैकी असोसिएशनपैकी मी पहिल्यांदा खास करून धारावी आयुष डॉक्टर असोसिएशन दादा यांच्या PhDना बोलवू इच्छितो. डॉक्टर युसुफ खान माझे एकदम उत्तम मित्र. एका दिवसामध्ये जवळजवळ 62 डेलिगेट्स आपल्याला आलेत. मला वाटतं मी धारावीच्या सगळ्या टीमला वर स्टेजवर बोलवू शकतो तुमच्या PhDना. हा आमच्यासाठी ऑनर असेल. युसुफ सर, थँक्यू व्हेरी मच. नरेंद्र त्रिपाठी सरांना मी विनंती करतो की त्यांनी थोडंसं स्टेजवर यायचं आहे. माझे कॉन्फरन्स चेअरमन, माझे मित्र माऊली फ्रेम डॉक्टर नामदेव थोरात सरांना मी विनंती करतो की त्यांनी स्टेजवर यायचं आहे आणि हे सन्मानपत्र द्यायचं आहे. पुन्हा एकदा टाळ्या झाल्या पाहिजेत. धारावी आयुष डॉक्टर असोसिएशन दादा, नावामध्ये पण दादा आहे आणि खरोखर दादागिरी दाखवलेली आहे. उधर जाऊ, उधर सामने सर जाऊ ना. फडतरे सरांना विनंती करतो मी, तुम्ही निघायचं. सगळ्यांनी टाळ्यांनी स्वागत केलं पाहिजे. पुढच्या वेळी दादानी मला वाटतं 200च अपेक्षा ठेवली पाहिजे दादाकडून आपण. डेफिनेटली आमच्याकडून स्वागत असेल तुमच्या सन्मानाचं. धन्यवाद. थँक्यू. येस, थँक्यू सर. त्याच्यानंतर त्याचबरोबर आपल्या मुंबईमध्ये अगदी विख्यात असलेले घाटकोपर मेडिकल असोसिएशनची टीमलाही मी विनंती करतो की त्यांनी स्टेजवर यायचं आहे. त्यांचे पदाधिकारी कोणी असतील. घाटकोपर मेडिकल असोसिएशन, अच्छा आमचे माऊलीच घाटकोपर मेडिकल असोसिएशन, त्यांनाच मी विनंती करतो की त्यांनी ही ट्रॉफी घ्यावी. अध्यक्ष नरेंद्र त्रिपाठी सरांना आणि IPP आमचे फडतरे सरांना विनंती करतो की ते मान सन्मानामध्ये घाटकोपर मेडिकल असोसिएशनपर्यंत ही ट्रॉफी पोचवायची आहे. त्यांचे अध्यक्ष आदरणीय आज मला वाटतं आले नाही आहेत, सचिन भांबरे सर, अगदी डायनामिक पर्सन येऊन गेले, तर त्यांचंही मी मनपूर्वक आभार मानतो. त्याचबरोबर स्लममधून आपल्या मानखूर डॉक्टर असोसिएशनचाही चांगला सहभाग लागलेला आहे. अगदी अभिमानास्पद आहे, कारण हे माझं असोसिएशन आहे जिथे मी 12 वर्षापासून एक अध्यक्ष म्हणून ह्या ISM डॉक्टरांसाठी काम करतो. मी ऑर्गनाइजिंग सेक्रेटरी डॉक्टर प्राजक्ता पाटील मॅडमना विनंती करतो की त्यांनी डेस्कवर यायचं आहे आणि आदरणीय वावळ सरांनी यायचं आहे. मानखूर डॉक्टर असोसिएशनचे कोण पदाधिकारी, डॉक्टर मिथिलेश शर्मा आलेले आहेत, तिथं कोण आहे का? त्यांनी पुढे या. डॉक्टर शिंदे उपाध्यक्ष आहेत, मिथिलेश सर आहेत, मला वाटतं राजभर सर आहेत का गेले? राजेश्वर राजभर. सगळ्या पदाधिकाऱ्यांना मानखुर्दच्या डेलिगेट्सना मी विनंती करतो की त्यांनी यायचं आहे. प्राजक्ता मॅडम. रजिस्टर मानखुर्द डॉक्टर असोसिएशनच्या या पदाधिकाऱ्यांना ही ट्रॉफी समर्पित आहे. थँक्यू व्हेरी मच, मनपूर्वक धन्यवाद. नाही, माझी टीम आहे म्हटल्यानंतर माझी गरज नाही. घ्या. नाही इट्स ओके, इट्स ओके. नाही ठीक, बस मीच येतो. हे सगळे माझे सहकारी डॉक्टर मिथिलेश सर, डॉक्टर विजय शिंदे सर, आनंद यादव सर, या सगळ्यांच्या सहकार्याने आम्हाला यावेळी डेलिगेट मिळाले. हां 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 बोललेली की नाही. मित्रांनो, निमाने फक्त असोसिएशनला जवळ नाही केलं तर बऱ्याचशा स्टुडंटलाही जवळ केलं. बऱ्याचशा स्टुडंटचा गुणगौरव सुद्धा केलेला होता. आपल्या या असोसिएशनच्या वेळी आपल्याला जे सकाळी अर्ली बर्डचं गिफ्ट मिळालं होतं ते माझे जवळचे मित्र आपले ऑनरेबल कॉर्डिओलॉजिस्ट डॉक्टर अमित पाटील सरांच्याकडून मिळालं होतं. सर आज ॲक्च्युली नाही आहेत, तर मी सरांना विनंती केली होती की नसतानाही त्यांनी निमाच्या प्रेमापोटी ते आपल्याला स्टेथो दिले होते, तर त्यांना त्यांच्या टीममधलं कोण असेल तर मी त्यांना विनंती करतो की कृपा करून स्टेजवर यायचं आहे. अमित पाटील सर एकदम डायनामिक आणि तारुण्यपूर्ण असं हृदयरोग तज्ज्ञ आहेत. आहे का कोणी? नाही, ठीक आहे. निमाच्या इतिहासात निमाने बऱ्याच वेळा अशी कामं केलेली आहेत की ती नेहमी लक्षात राहिलेली आहेत. अशाचपैकी एक आपल्या डॉक्टर मित्रांसाठी म्हणजे आपल्या येणाऱ्या सगळ्या डेलिगेटचा सुद्धा निमाने विचार केलेला आहे. कारण प्रत्येक वेळी असं होतं की आपण दुसऱ्यांची चिकित्सा ट्रीटमेंट करतो आणि जेव्हा आपल्या घरातलं काही प्रॉब्लेम येतो किंवा आपल्यावर येते, मित्रांनो जरा शांतपणे ऐका, त्यावेळी नक्की तो डॉक्टर किंवा आपली फॅमिली ट्रीट करत असताना हॉस्पिटलमध्ये थोडंसं गिल्टी फील होतं, थोडंसं लक्षात आलं होतं. तर त्या संदर्भात निमाने मी आणि डॉक्टर नरेंद्र त्रिपाठी सरांनी IPP आमचे फडतरे सरांनी जरा बसून निर्णय घेतला की असं आपण एखाद्या हॉस्पिटलकडून घेऊ की हे जे बसलेले सगळे डॉक्टर आहेत यांना एखाद्या हॉस्पिटलमध्ये गेलं तर त्यांना कधी एमर्जन्सी कुठली ट्रीटमेंट ही त्यांच्या त्या सन्मानाने किंवा त्या लेवलनं स्टेटसने मिळावी म्हणून आपण एक हेल्थ कार्ड आज दिले, ज्या हेल्थ कार्डमध्ये बऱ्याच सगळ्या आपल्या कार्डियकच्या टेस्ट कन्सल्टिंग टेस्ट आहेत त्या आपल्या फ्री ऑफ होणार आहेत आणि आपल्या डॉक्टरांचे फॅमिलीसाठी डॉक्टरांच्या फॅमिलीसाठी जी काही ऑपरेशनची प्रोसिजर होईल ती कम्प्लिटली 50% डिस्काउंटमध्ये होईल. आणि हे आपल्याला कार्ड देण्यासाठी सर्वात मनमोठेपणा दाखवलेला आहे तो म्हणजे वेदांत हॉस्पिटलचे माझे वरिष्ठ मित्र बंधुमित्र डॉक्टर अजय सिंग सर. आणि 1 मिनिटात त्यांनी ते दिलेलं आहे. तर त्यांचे आज सरांचे चिरंजीव आहे डॉक्टर हर्ष सर, तुम्ही प्लीज वरती या आमच्यासाठी, तुम्ही वरती येणं हे आमच्यासाठी सन्मान आहे. मी सर्व आमच्या टीमला विनंती करतो की हर्ष सरांना ही ट्रॉफी द्यावी. वेदांत हॉस्पिटल हे डॉक्टरांसाठी एक त्या हेल्थ कार्डमध्ये एक चिप आहे ज्याच्यामध्ये तुमचं नाव आणि तुमच्या फॅमिली मेंबरसाठी एक त्यांच्याकडे ॲप असेल. तर त्या वेदांत हॉस्पिटलला आपण हजारो हॉस्पिटल आपण सपोर्ट केला आहे. या वेदांत हॉस्पिटलकडे सुद्धा आपल्याला जायचं, ते आपल्या फॅमिलीसाठी आपलं घर आपलं हॉस्पिटल आहे. डॉक्टर अजय सिंग सरांचे चिरंजीव डॉक्टर हर्षवर्धन आहेत. तर मी एक विनंती करतो सर, एक मिनिटासाठी फक्त बोलावं, काय बोलण्याची इच्छा असेल तर प्लीज सर.
थँक्यू प्रसाद सर. जसं सरांनी सांगितलं आता की आपण इथं एक फॅमिलीसारखं आपलं जे डॉक्टरांची टीम आहे ती आपली एक फॅमिलीसारखी आहे आणि आपण आपल्या फॅमिलीसाठी काहीतरी केलं पाहिजे. हा जो आयडिया होता ते प्रसाद सर आणि मी सोबत ऑफिसमध्ये बसलेलो आणि आमचं हे ठरलं की आपण सर्व पेशंटसाठी एवढं करतो, आपण कोणाकडे असेल तर पेशंटसाठी हॉस्पिटलला फोन करतो की बाबा पेशंट गरीब आहे त्यांना हे हेल्प करा ते करा, पण एखादा हॉस्पिटल आपली जी डॉक्टरची टीम आहे त्यांच्यासाठी पण उभा राहायला पाहिजे. तर आम्ही हे हेल्थ कार्डचं ठरवलं आणि या सर्वांसाठी आम्ही हे हेल्थ कार्ड इथे वाटप करतोय आणि हे मनापासून सर प्रसाद सर प्लीज प्रसाद सरांना खूप खूप धन्यवाद आहे की यांनी आम्हाला याच्यामध्ये सपोर्ट केलं.
नाही नक्कीच. वेदांत हॉस्पिटल घाटकोपर ईस्टला घाटकोपर वेस्ट ठाण्याचं तर अगदी ब्रँड आहे कोरोनापासून, पण अगदी मनाचा मोठेपणा आहे. बघा आपल्यालाच आपण नेहमी आपण प्रॅक्टिस करताना आपल्या सर्वांच्या आयुष्यामध्ये असा कोणता तरी एक क्षण येतो असतो की ज्यावेळी खरोखर मनाला दुःख होतं आणि आपल्याला शोधावं लागतं आपला घरातला मेंबर कुठे ॲडमिट करूया किंवा कसं करूया. तर हे सुद्धा निमानं विचार केला होता. निमाच्या ह्या संकल्पनेसाठी सुद्धा सगळ्यांच्या टाळ्या झाल्या पाहिजेत. आजच्या या कॉन्फरन्सच्या प्रत्येक डेलिगेट्सला वेदांत हॉस्पिटल हे स्वतःचं कुटुंब आहे. लवकरच आपण तिकडेही भेटतोय, लवकरच तिकडे एखादी ॲक्टिव्हिटी होते. पण या वेदांत हॉस्पिटलचं सगळं निमाच्या टीमतर्फे सर मी मनपूर्वक आभार मानतो. धन्यवाद, थँक्यू. जाताना सगळ्यांनी खाली हेल्थ कार्ड घेऊन जायचंय. सर आई
हॅलो
वावळ सर बोले. वावळ सरांना विनंती करतो थोडेसे 2 शब्द बोलावेत त्यांनी. आमचे सेक्रेटरी लाडके प्रेमळ सगळ्यावर प्रेम करणारे.
कत्ल भी ये करते हैं
दूसरों के नामों से कत्ल भी ये करते हैं। आदमी को पहचानो आदमी के कामों से, शहर भर न रास्ता है, शहर भर न रास्ता है, इनके कारनामों से कत्ल भी ये करते हैं। दोस्तों, प्रसाद साहब खामोश,
डेफिनेटली सर,
खामोश इसलिए कि हमने इस सफलता कॉन्फ्रेंस की तैयारियां बहुत खामोशी से की और सफलता का आगाज आपने नगाड़े और तुतारों से सुना। कैसे लगा आपको ये तैयारियां? उस सफलता के संघर्ष के रथ पे हम सवार थे, जिसका सारथी हमारा प्रेसिडेंट डॉक्टर त्रिपाठी थे। हम उसमें सभी सवार थे, कॉन्फ्रेंस मेंबर्स, चेयरमैन, जॉइंट सेक्रेटरी, ऑल और सेक्रेटरी तो साहब आपने सुना होगा कि हर एसोसिएशन का सेक्रेटरी एक होता है, लेकिन मेरे नीमा एमडीएस का सेक्रेटरी 20 थे। सभी ने इतनी तैयारी किया है कि मैं चाहूं कि मैंने किया है तो मैं बहुत गलत हो सकता हूं और गलत हो भी, क्योंकि इस सफलता के 1.5 महीने पहले, जिसका 40 दिन पहले अगर जिसका रजिस्ट्रेशन बंद हो जाता है तो वो तैयारियां कैसी होंगी आप कल्पना करिए। और जब मेरा रथ चलता है, सफलता की तरफ जाता है, संघर्ष का रथ, तो उसमें ये सभी सवार और एक और शख्स है उसमें, वो अधूरा रथ होगा जिसपे कि हनुमान नहीं होगा, वो अर्जुन के रथ पे, तो वो हनुमान जी मेरे शक्तिशाली है, आईबीपी प्रेसिडेंट मेरे फड़तरे साहब। मूर्ति बहुत छोटी है, बहुत खतरनाक है साहब, जहां जाती है वहां से कहते हैं ना कि जहां लात मारो वहां से पानी निकलता है, तो ये शख्स ने जहां गए हैं वहां से पैसा निकाला है। तो मैं फिर से एक आगाज करता हूँ, रिक्वेस्ट करता हूँ मेरे अध्यक्ष जी को, मेरे आदरणीय सर को, कि अगली जो भी कॉन्फ्रेंस होगी उसके चेयरमैन, उसके सर्वस्व मेरे फड़तरे सर होंगे, ऐसे मैं आपसे विनंती करता हूँ।
क्या बात।
रही बात डेलीगेट्स की, तो मैं डेलीगेट सबको प्रणाम करता हूँ, क्योंकि आपने जो साथ दिया है आपके वजह से तो हम, आपने ये सब रजिस्ट्री करके आप आए, इसके लिए आपने हमारा हौसला ही नहीं बढ़ाया तो हमको दुनिया से नजरें मिलाने की ताकत भी दी। तो मैं आपका गुजारिश कैसे करूं, कैसे आपको धन्यवाद दूं, मेरे पास इसके लिए कोई लफ्ज नहीं है और कोई भी प्रमाणित करने के लिए लफ्ज की आवश्यकता नहीं होती, भावनाओं की होती है। रात भर मौन तुम मौन हम, फिर भी रात भर बात करते रहे। एक प्रसंग ऐसा आता है, कभी कभी माँ का भी रोल करना पड़ता है। मेरे पास होता है, मेरे पास बाप बनना बहुत मुश्किल है सर, माँ बन सकते हैं। तो मेरे पास आए और मैं माँ बनी, मेरे कुंती का रोल था, मेरे पास अर्जुन भी आया और मेरे पास कर्ण भी आया। तो आप बताओ क्या अवस्था होगी, उस माँ को कैसे आशीर्वाद देंगी। तो एक को उसने कहा आयुष्मान भव और एक को कहा विजयी भव। तो वो माँ का दिल क्या करता होगा, वो ऐसा तो नहीं कहेंगे एक युद्ध में मरे और एक युद्ध में जीते, ऐसा नहीं होता। तो माँ क्या होती है, माँ से माखन माँ से मलाई, माँ की ममता जिसने नहीं जानी वो नर नहीं वो शैतान है, सबसे बड़ी है माँ रे पगले, सबसे बड़ी है माँ। दोस्तों कहाँ तक जाऊँ, कैसे कहूँ, क्या करूँ, किसकी तारीफ करूँ, बहुत कम पड़ते, अल्फाज बहुत कम हैं। मेहनत बहुत जोरदार की है। धन्यवाद। थोड़ी सी हमसे भूल भी हो जाती है, काम करना है तो भूल होगी, सभी जानते हैं। हाँ, गलती हमसे भी हुई, तो इसलिए मैं कहता हूँ मंदिर में जाके प्रणाम करता हूँ, मंदिर में जाके प्रणाम करता हूँ और मस्जिद में जाके नमाज पढ़ता हूँ, कहीं इंसान से देवता नहीं बन जाऊं, इसलिए थोड़ा सा पाप भी कर लेता हूँ। तो उस पाप के लिए मैं आपसे फिर से क्षमा मांगता हूँ। और बड़े हो आप क्षमा करेंगे। क्षमा ही धर्म है, क्षमा ही वेद है, क्षमा ही क्षमा है, उससे बड़ा और कोई भी आशीर्वाद नहीं है।
हे आमचे सेक्रेटरी, तुम्हाला खरं सांगतो, हे आमचे सेक्रेटरी कधीच बोलत नाही. आज काय झालंय, कसलं चार्जिंग निघालंय?
नहीं, ये गलत साबित होगा। नहीं बोलता ऐसा नहीं है। शांत समुंदर के ही सुनामी आती है, सुनामी शांत समुंदर को ही आती है। बट मैं चाहता हूँ कि थोड़ा सा ज्वार भाटा ही हो, ताकि सबकी गलतियाँ मैं अपने और खींच लूँ और अपने आप में संभालूँ।
नाही, खरं म्हणजे आता मला भीती वाटायला लागली. खरं आपण जरा पुढे जाऊया का सर? थँक्यू. फार हे बघा, अजून एक शेअरची मागणी करू नका, रात्रभर बसवतील इथं.
सर
मला गिफ्ट वाटायचे खाली.
सर आगे की उम्मीद तो रहेगी ना सर. और इस कॉन्फ्रेंस ने इतिहास रचा है.
हे कसं आहे, जखमी शेअर डिवचल्यासारखं झालंय. तुम्हाला सगळ्याला विनंती आहे, जरा शांत व्हा. बस सर, एक सगळ्यांच्या याच्यासाठी एक शेअर होऊन जाऊ द्या
सर. हाँ, हर किसी से उम्मीद है, हर किसी से उम्मीद है कि प्रसाद ये करेंगे. आज भी उम्मीद लगाई है हमारे त्रिपाठी साहब ने. उम्मीदें नाराज रहा करती है, ठीक फुट के जिगर से राज कहा करती है. गौर कीजिएगा, उम्मीदें नाराज रहा करती है, ठीक फुट के जिगर से राज कहा करती है. अरे भले ही ताजमहल सर कोई नहीं बना पाए, मगर दिल में हर एक मुमताज रहा करती है.
यामध्ये एक थांबूया आपण थोडंसं. 2 मिनिटं, 7 वाजलेत, बऱ्याच लोकांचे टाइम आहे. मनोहर ससाने सर आलेत का आपल्या निमाच्या या कॉन्फरन्ससाठी? कोल्हापूर साताऱ्यावरून मनोहर ससाने सर आलेत. डॉक्टरांची पूर्ण टीम आली. मी त्यांनाही जरा 2 मिनिटं स्टेजवर बोलवतो. आपण लगेच संपूया. खाली गिफ्ट आपले तयार आहेत.
सर एक आखरी बात.
अरे सर, मैं आपको
आखरी बात सर, परमिशन सर, परमिशन.
नाही नको. काय माहिती का, फार अप्रिशिएट केले. नाही तर डॉक्टर प्रसाद पवारला जाताना काहीतरी मिळेल उगाच विनाकारण प्रसाद सगळ्यांचा. नको, प्लीज नको. सगळ्यांचं स्वागत आहे. वावळ सर, आप हमारी जान हो. सवाल नाही त्याच्यात काय, पण बोलू नका आता प्लीज.
एक आखरी.
नाही आखरी नको. आता भीती वाटायला लागली आम्हाला सेक्रेटरीची. मित्रांनो, टाळ्यांनी स्वागत करा. टाळ्यांनी. कोल्हापूर आणि साताऱ्यावरून ओपीडी बंद करून आजच्या कॉन्फरन्ससाठी 2 दिवस आलेत. हे सगळ्यात अभिमानास्पद असा क्षण आहे. मित्रांनो, अजून एक गोष्ट सांगायची होती की आजच्या पेपर प्रेझेंटेशनच्या स्टुडंटमध्ये ह्या जे 73 स्टुडंट आले, त्यात 2 स्टुडंट हे परदेशातून रजिस्टर झाले. त्यासाठी टाळ्या वाजवल्या पाहिजेत. इम्पोर्टेड माल सुद्धा आता निमाकडे आहे. अतिशय अभिमानास्पद असा हा क्षण. आपल्या निमाची किमया नक्कीच सातारा, कोल्हापूर अशा महाराष्ट्रातील 257 ठिकाणी आहे. परंतु स्पेशली कॉन्फरन्ससाठी येणं म्हणजे हा आमच्या निमा मुंबईच्या बेस ब्रँडचा अभिमान आहे. या सगळ्यांचं मनपूर्वक आभार. शेवटचा आणि एक फक्त इनॉग्रेशनचा प्रकार राहिला आहे, सन्मानाचा प्रकार राहिला आहे. आमच्या सगळ्यांचे सर, थँक्यू सर, थँक्यू. भेटूया नंतर सर. तर एक शेवटची ट्रॉफी राहिले, बस संयम ठेवा. आमच्या सगळ्यांच्या मुंबई ब्रँचचे मार्गदर्शक, आपल्या सगळ्यांच्या ISM 92,000, आता ते 96,000 झाले, तर 96,000 डॉक्टरांचे MCM मेंबरचे सदस्य, माजी सदस्य, आता ते मला वाटतं CCचे NCMचे पदाधिकारी, सिनेटचे, आमच्या सगळ्यांचे लाडके डॉक्टर विष्णू भाऊने सर, ज्यांनी बऱ्याच अशा कॉन्फरन्स या कॉन्फरन्सचा आपण जर त्याचा मुख्यतच धरला तर आयुष एक्सपोसारखी 5 ते 8 हजार डॉक्टरांची कॉन्फरन्स सांभाळणारा एकमेव नेतृत्वाचा माणूस खंबीरपणे सांगतो मुंबई ब्रँचचा आहे, मुंबई निमाचा आहे. मी सरांना विनंती करतो, बावणे सरांना, स्टेजवर यायचं. बावणे सर, तुम्ही कॉन्फरन्सचं प्रत्येक मार्गदर्शन असो, एका दिवसात 100 डेलिगेट करणारी एवढी ताकद असणारे, छोटा मुंह बडी बात. आणि हे बॉम्ब, ह्या बॉम्बनी अशी बरीचशी नेतृत्व घडवलेली आहेत. ह्यांनी वैद्यकीय क्षेत्रातली नेतृत्व घडवणारा आमचा सगळ्यात मोठा सन्मानाचा मान डॉक्टर विष्णू बावणे सरांना मी निमातर्फे मनपूर्वक आभार देतो. एक निमा कॉन्फरन्सचे चीफ कोऑर्डिनेटर म्हणून त्यांचा सन्मान मी आदरणीय नरेंद्र त्रिपाठी सरांना सांगतो की प्लीज सर, विनंती करतो की हा सन्मान करावा. आपलं कुटुंब, आपला अभिमान, हा फोटो हेच सांगेल मला असं वाटतंय बावणे सर. आणि पुढची ही कॉन्फरन्स अशाच पद्धतीनं सुंदर पद्धतीनं आपण करू. मित्रांनो, सगळे सन्मान संपलेले आहेत. मी अजून एक विषय राहिलेला आहे. आपल्या क्रिटिकेअर मल्टी स्पेशालिटी हॉस्पिटलने आपल्या सगळ्यांसाठी निमासाठी 7 रेफ्रिजरेटर दिले होते आणि त्यांचंही मी मनपूर्वक आभार मानतो. इथे ज्या स्पॉन्सर लोकांनी आम्हाला मदत केली, ज्या स्पीकरनी आम्हाला मदत केली, ज्या डेलिगेट्सनी इतर लोकांचे कॉन्टॅक्ट केले, वैद्यकीय किंवा वैद्यकीयमध्ये नसलेल्या लोकांनी जी मदत केली, ज्यांनी आम्हाला सहकार्य दिलं, ह्या हॉलच्या सगळ्या स्टाफने आपल्याला सहकार्य केलं, वरिष्ठांनी आम्हाला कॉन्फरन्स कशी करायची याबद्दल मार्गदर्शन केलं, या सर्वांचं मी एकमतानं मनपूर्वक आभार मानतो, धन्यवाद मानतो. आणि माझे जेवढे कमिटी मेंबर, माझे वरिष्ठ कमिटी मेंबर, त्याचबरोबर माझी कॉन्फरन्सची सगळी टीम, खास करून माझे सहकारी आदरणीय नामदेव थोरात सर जे सायंटिफिक सेशन बघत होते, प्राजक्ता मॅडम ज्या ऑर्गनाइज सेक्रेटरी होत्या, या सगळ्यांचं मी मनापासून आभार मानतो. आम्हाला हे सगळं बळ दिलं त्याबद्दल नरेंद्र त्रिपाठी सर, तुमचं मनापासून अगदी आभार. इतक्या वेळा मला झापलंय तुम्ही, हे नाही काम झालं, ते नाही काम झालं, पण आज या सगळ्यांचा ह्या 7:15 वाजताचा हे माप बघितल्यानंतर तो सगळा मनातला तुमच्या रागाचा आमचा हे निघून गेला. अशीच कॉन्फरन्स आपण कंटिन्यू करू. आणि मला वाटतं इथे हे आहेत क्रिटिकेअरचे मॅनेजर आहेत, त्यांनी जरा याच्यावर यायचं आहे, डायसवर यायचं आहे 2 मिनटं. आपलं हे कार्यक्रम झाला का खाली आपण गिफ्ट ठेवलेले आहेत आय थिंक, हां, तर त्या गिफ्टमधून 2 गिफ्ट ते घेऊन जायचे. थोडंसं लेट होतं आहे. बंपर प्राईज राहिला आहे आपला अजून. सर आइए प्लीज, सरांना एक सन्मान द्या. सरांना ट्रॉफी तिकडे. कॅटरिंगवाले, ऑडिओव्हिजनवाले, त्याचबरोबर या सगळ्यांचं आभार. टीव्ही बाकी आहे ना अमर सर? टीव्ही बाकी आहे. भगवान सर, अरे बोला करो ना, ऐसे कैसे? अरे पैठणी, तरी म्हटलं आवाज काय येतो महिलांचा एवढा? पैठणी यस, लगेच काढू आपण 2 मिनिटात.
मी फक्त 1च मिनिटं घेणार. क्रिटिकेअर हॉस्पिटल हा बाकी सगळ्या कॉर्पोरेट हॉस्पिटलपेक्षा थोडासा वेगळा हॉस्पिटल आहे. कॉर्पोरेट हॉस्पिटलमध्ये डॉक्टर्सला पगारवरती ठेवलं जातं, टार्गेट्स XYZ. आय डोंट वॉन्ट टू टॉक अबाउट दॅट. क्रिटिकेअर हॉस्पिटल निमासारखं पूर्ण स्प्रेड आहे आणि मुंबईमध्ये 4 ब्रांचेस आहेत. क्रिटिकेअर हॉस्पिटल इज अ हॉस्पिटल विच इज ओन्ड, फाउंडेड बाय वन अमॉंग्स यू, डॉक्टर दीपक नाम जोशी अँड हिज वाईफ डॉक्टर मासुमा नाम जोशी. सो तुमच्यातलाच एका व्यक्तीचा हॉस्पिटल आहे. निमाचं एवढं मोठं जी असोसिएशन आहे आणि क्रिटिकेअर जे सर्वात स्प्रेडेड हॉस्पिटल आहे मुंबईमध्ये, एवढं जे ऐकलं आणि जे आपण आपले वेदांत हॉस्पिटलचे जे कलिग बोलले, ॲब्सोल्युटली मेक्स अ पॉईंट. क्रिटिकेअरकडे सध्या 550 बेड आहेत. वी गिव्ह यू अ कमिटमेंट that in case if you reach out to Criticare as a doctor family member, you will be always given a bed and you will never be refused. We will also give you a dedicated helpline number which will be called as NIMA Eye Care number, and this NIMA Eye Care number will be reached out to you for all the 4 Criticares only. Criticare is a NABH accredited hospital. We do renal transplant, bypasses, everything. Feel free to get in touch with us. My team members are also there, Mahendra and Fauzan. They have contributed in the discussion, and they agreed to be 24-hour support to the doctor family. Criticare is running 25 years and we are thankful to you. Thank you very much. Thank you.
Thank you so much. And now we are going to give the special gift only for ladies, and we are going to get 3 winners. Number 1, 2 and 3. All 3 will get Paithani sarees. So kindly tell the first winner. Dr. Neelpanna Khedkar will take the treat.
पैठणी हा
A first lucky draw winner for Paithani is Dr. Iram Ansari.
आहेत
Do we
का?
have Dr. Iram Ansari?
नहीं है ना? नेक्स्ट नहीं है,
Next.
नहीं है ना? एक मिनट, गलत नाम नहीं बताने का, पहले बता रहा हूँ. हाँ चलो नेक्स्ट. अरे नेक्स्ट बोलते कितना जोर से आवाज आ रहा है भाई. हाँ.
So the first Paithani goes to Dr. Kranti Patil.
अरे yes.
Congratulations.
क्रांती पाटील मॅडमनी पूर्ण स्टेज सांभाळले सकाळपासून.
I would request now Rajni madam to take the second winner. Kindly tell me
मला
the
वाटतं
second
गणपती
winner.
बाप्पांनी क्रांती मॅडमला ती
Second
पैठणी
Paithani
दिली.
goes to Dr. Shomali Shah. अरे वाह, congratulations.
आहेत का?
Second Paithani winner.
या द्यायच्यात आता. आता देऊन टाकूया.
And the third Paithani winner is, I would request Dr. Rima to kindly do the honors. Third Paithani. Let's see who gets the third Paithani. Dr. Pratibha Hatarkal. Are wow, congratulations. Congratulations to all ladies who got beautiful Paithanis.
अरे पण किती जोश वाढलाय बघा ना. हा महिलांचा जोश एकदम वाढलेला आहे. हा
I hope you enjoyed the lucky draw, but don't forget we have the bumper lucky draw still remaining, which is 40-inch TV. Who is ready to get the bumper lucky draw?
अरे वो टीवी कार अपने पास हाँ ना क्रिटिकर ने दिया हुआ.
I would request Dr. Rajni Yadav madam to kindly give first Paithani to Dr. Kranti Patil.
ओपन करा. हाँ ऐसा हाँ बस. अभिनंदन क्रांती मॅडम. सकाळपासून स्टेज सांभाळलं त्याचं कदाचित बाप्पानी गिफ्ट दिले, आणि आम्हाला अभिमान आहे की क्रांती मॅडमनी फार बारीक गोष्टीसाठी आम्हाला मदत केली. धन्यवाद मॅडम. थँक्यू.
The second Paithani winner, kindly come forward.
टाळ्या झाल्या पाहिजेत.
Yes, definitely. I would now request Dr. Shailesh Thorat ma'am to kindly felicitate the second Paithani winner. Third Paithani winner, kindly come. I would request Dr. Jaimala Pawar ma'am to kindly give the third Paithani.
पैठणी म्हणल्यावर टाळ्या वाजलेत.
Yes.
इतक्या उशीर तो प्रसाद पवार आम्हाला निघू दे असं तुमचं चाललं होतं. आता एकदम टाळ्या चालू सोड. हां ते हे घ्या आणि हे काढा. ते रेफ्रिजरेटर काढून टाका. हां.
Now we are going to take 7 winners.
5 minutes. 7.
Now we are going to take 7 winners. All of them are going to get car refrigerators. Are you all ready for getting the car refrigerator? There is no excitement in the audience. Shall we go forward or not? Yes.
अरे 7 ते 8 हजाराचा एक कार रेफ्रिजरेटर. टाळ्या तर होऊ दे ना यार.
टाळ्या होऊ द्या. Perfect.
क्रिटिकरनं आपल्याला दिलेलं आहे. पुढच्या वेळी 15 बघा. आनंद भाऊ माझे कसे पुढच्या वेळी 15 आहे.
I would request our honorable president.
त्रिपाठी सर काढा ते.
I would request our honorable president to kindly take the first winner who have won the car refrigerator.
नहीं.
And the winner is Dr. Vinod Yadav.
एक ही मेरे को बाजू में कान में बोल रहे थे.
Congratulations, you got the car
भावने सर तुम्हाला
refrigerator.
विनंती आहे.
I would request
बावणे सरांचा
I
आशीर्वाद
would
कोणाला लागतो
request
बघूया.
respected Dr. Vishnu Bhavne sir to kindly take the second winner for the car refrigerator. Let's see who gets it. And the winner is?
अहो थांबा.
No, the winner is Dr. Yusuf Khan.
अरे युसुफ आहे.
Delegate number
दादा अध्यक्ष,
565.
दादाचे अध्यक्ष गेले का? अरे ट्रॉफी दिली आता मी लगेच गेले. आलेत ना ते काय आहेत?
Yes, we have the winner for the second car refrigerator.
मी डॉक्टर अमर द्विवेदी सरांना विनंती करतो की त्यांचं एक हात गुण कुणाला तर लागावा
Yes,
आणि
definitely.
छानपैकी आशीर्वाद मिळावा. प्लीज सर स्टेजवर या आणि एक लकी ड्रॉ काढावा.
Let us see who gets the third car refrigerator. Kindly do the honors, sir. Sir, देखो आपका नाम भी आ सकता है. The lucky draw winner is delegate number 300, Dr. Parag Arekar.
आलेत का?
Congratulations.
यस मिळेल, खाली मिळेल तुम्हाला.
I would now request our Honorable Secretary, Dr. Mangal Vavar, sir, to kindly take the fourth winner of the car refrigerator. And the winner is? Sir, card.
वावळ सरांना तर कुणाला आशीर्वाद दिलाय?
Dr. Seema. Unfortunately, she is not there.
सीमा मॅडमला ती
Seema, no, sorry, this is different Seema. Dr. Seema Nevarekar. Do we have Dr. Seema Nevarekar? Yes. Congratulations, ma'am. Now moving on to the fifth
एक मिनिट, मी
lucky
डॉक्टर
draw.
भगवान गायकवाडांना विनंती करतो.
Yes.
भगवान सर जरा वरती या. आता बघूया. अरे पण निमाच्या एकाच्या पण टीम वाल्याला लागे नाही हो काय. मी उशीर व्हायला बसलोय.
Let's see who gets the fifth gift for the car refrigerator. Dr. Bhagwan Gaikwad sir will do the honors.
ए माझं नाव असणार होतं. अरे
Dr. Sonal Pawar, delegate registration number 318.
पवार सेम आला पण पुढे सोनल मॅडम आली.
Do we have Dr. Sonal Pawar here?
प्रसाद पवार नाही.
No, we don't have Dr. Sonal Pawar.
Next.
So next.
नाव करेक्शन करून प्रसाद पवार टाका ना. अहो म्हणजे असं म्हणलं मी, होत असेल तर.
Dr. Darshana Sharma 363.
दर्शना आली होती, गेली का? नेक्स्ट.
Actually sir has taken two.
मी डॉक्टर मंजू मॅडमना फोन विनंती करतो, तुम्ही जरा वरती येऊन तुमच्या हाताने काढा. भगवान सर 2 मिनिटं. भगवान सर 2 मिनिटं. सर अध्यक्ष 2 मिनिटं. मंजू मॅडम तुम्ही एक हे काढा. भगवान सर थांबा. भगवान सर मंजू मॅडमला काढा.
Manju madam.
एक
Dr. Manju Yadav is the treasurer of NIMA MDB Women's Forum. Kindly give a big round of applause. And let's see who is going to become lucky. Delegate
अजून
registration.
बंपर बाकी आहे आणि बंपर हे आमच्या गुरुवारी आदरणीय दुबेवर सरांच्या हस्ते आम्ही काढणार आहे. त्यामुळं माझा नंबर 100% लागणार असं मला वाटतंय.
सर हे तर पहिला कंप्लीट
अच्छा,
करूया.
उद्या.
डेलिगेट रजिस्ट्रेशन नंबर 571 मोहरम अली. कॉंग्रॅच्युलेशन्स.
जपून ठेवा सगळी ते हे नाव झाले. आता काय बाकी?
ओके सो द नेक्स्ट टीव्ही डायरेक्ट टीव्ही.
दुबेवर सरांना माझी विनंती आहे, सगळ्यांनी टाळ्या झाल्या पाहिजे ना, ते टीव्ही देणार ना.
I would request our honorable mentor and Lifetime Achievement Award or Jeevan Gaurav winner for today in this 36th annual NIMA Medical Conference, and our mentor and guru Dr. Dubewar sir to kindly do the honors of revealing the ultimate bumper prize of 40-inch TV. As you can all see, someone over here is going to walk away with this 40-inch TV. Are you all ready? Yes.
थांबा, लगेच हे करू नका, अनाउन्स करू नका. धडकन बघा कसे चाललेत.
आय विल टेक माइन ओनली. ओके, डोंट वरी.
प्राजक्ता मॅडम 1 मिनिट माझ्याकडे द्या, तुम्ही वाचून माझ्याकडे द्या. 1 मिनिट.
चालेल.
हां आपण कपल वॉच पण राहिलेला.
Oh, so I will hand it over to Dr. Prasad Pawar sir.
TV.
TV.
नहीं रिसीट दे रहे कि टीवी हैंड ओवर कर रहे हैं?
Not TV sir, the receipt.
ओके. दिल की धड़कन बढ़ गई है. कोण असेल? अरे तुम्हीच नाव सांगायला लागलाय. कमाल आहे. अरे कोणतरी प्रसाद पवार म्हणले यार. थोड्या वेळानं भेटा नक्की, 100%. दुबेर सरांनी आशीर्वाद दिलाय. ह्या वर्षीचं आपलं सर्वात मोठं गिफ्ट TV 43 इंच आणि तेही ब्रँडेड. डॉक्टर, अरे काही टाळ्या बिळ्या आहेत का नाही? अच्छा, डॉक्टर दत्तू वेंगंडी.
Congratulations, congratulations. Kindly come on the stage.
दत्तू सर, मी
Heartiest congratulations sir.
थांबा थांबा, कपल वॉच आहे. एक
हाँ,
मी फक्त
couple
1
watch
मिनिट
बाकी है.
घेतोय. 1 मिनिट फक्त, सिंगल वाले पळू नका. कपल वॉचचं एकच आहे आणि त्याला काही ही नाही. एकच फक्त मिनिट थांबा, एकच
Yes,
मिनिट.
yes, yes. Couple watch. Congratulations for taking the bumper.
नीमा,
Sir, दे द्या.
क्या नंबर बोले बघा. नरेंद्र त्रिपाठी सरांना माझी विनंती आहे, ते पटकन काढून घ्या. कपल वॉचचा बंपर प्राइस काढून घ्या पटकन. इधर आता नाही यार. हा,
एक मिनिट. सगळेजण या आजूबाजूला.
क्या दिखाय मेरे को दिखाओ. कपल वॉच साठी एक, किती आहेत कपल वॉच?
Couple watch
एक लास्ट
साठी
कपल
एक
वॉच,
winner आहे.
एक लास्ट कपल वॉच फक्त. त्रिपाठी सर, अध्यक्षांच्या हस्ते काढावं अशी माझी विनंती आहे. लास्ट कपल वॉच, लास्ट गिफ्ट ऑफ दिस कॉन्फरन्स. आमचे हॅलो, कुठे कुठे अहो काढा की. काय झालं? नॉर्मल कपल वॉच आहे. अरे मेरे को भी नहीं यार. हां, त्यातलीच काढा एक कुठली तरी दिन ना. त्यातलीच काढा.
कपल नाही राहतो.
अच्छा,
नाही कपल नाही.
असं सांगा ना अगोदर.
त्याच्यामधलंच काढू.
काढा एक त्यात देऊन टाका त्याला. काय गरज नाही. हो अध्यक्ष काढा.
Now I would request our
हे
honorable
बघा, कपल काय नाही,
president.
जे गिफ्ट जे चिठ्ठी निघेल त्याने ती कपलसाठी घरी घेऊन जावा. एकदम छान.
This is the last gift of the day, so kindly stay. The winner of the couple watch is Dr. I.P. Jain, delegate registration number 17. Do we have Dr. I.P. Jain? Gele? Okay, the next one now.
अच्छा,
Let's see who gets the last prize.
क्रिटिकेअर एशिया यांचा एक नंबर आहे डॉक्टरांसाठी. त्यांनी आता हे सगळा आपला उत्साह बघून जस्ट आनंदबाईंनी हे केलंय की क्रिटिकेअरचा एक ते नंबर देतात जिथे डॉक्टरांच्या फॅमिलीसाठी कधीही बेड आणि सगळी सुविधा विदाउट वेटिंग हजर राहील. तर हा नंबर मी आपल्या ग्रुपवर टाकतो. ओके मॅडम, काढला का?
आता लास्ट गिफ्ट जे आहे ते जात आहे डेलिगेट रजिस्ट्रेशन नंबर 39 डॉक्टर शरद सावंत.
नेक्स्ट
Okay, next. Come on, next. I would request Dr. Dubewar sir to kindly take the last gift of the day. Let's see who gets the last gift. Dr. Harun Khan, 616 delegate registration number.
गए नेक्स्ट. अरे पिक्चर एंड में है, थोड़ा रुको यार, एग्जिट में मत जाओ.
Do we have the delegate or no?
अरे नेक्स्ट
No.
Next.
Okay, next. I would request again Dubewar
आपण
sir to
gift
take the last delegate.
एक लेदरची ICTCचं सगळ्या ग्रुपचं मी मनपूर्वक आभार मानेन की त्यांनी या नियमाचा आमचा पूर्ण स्पॉन्सरचा खर्च घेतला होता बऱ्यापैकी. आणि
Okay, the last winner is Dr. Preeti Santosh Thorat, delegate registration number 542.
एक कॅन्सल करूया ना यार, किती झाले?
Nice.
अरे काय कमाल आहे.
Okay, let's see who will win this last. Dr. Sheikh Akhtar.
जाने दो बस. ऐका, ते गिफ्ट आपल्याला दार्जिन नाही, सोडून देऊ आपण.
Yeah, we are now going to cancel the gift because. Okay, let's take the next one. Let's see who gets it.
अरे ये सवेरे जैसे आप आए थे ऐसा उत्साह दिख रहा है यार.
Dr. Drishti Jaiswal, 405 registration delegate number.
त्रिपाठी नहीं नरेंद्र त्रिपाठी सर ने क्या क्या लगाया है सर त्रिपाठी सर
Now I would request immediate past president Dr. K.V. Phadatare to kindly do the honors. Let's see who gets the last gift.
ये हमारे प्रेसिडेंट की चाल है, आपको रुकाने की ध्यान रखना। नरेंद्र त्रिपाठी सर की चाल है ये।
Do we have Dr. Bhavin, registration delegate number 467 in the house? Dr. Bhavin Derashri.
गया नेक्स्ट। ए यार एक काम कर देता हूँ, नाइट का खाना भी मंगा देता हूँ इधर ही रुको। अरे खाली थर्मास लेदरची बॅग आहे
I think I am going to take I would take a delegate. Let's see if that delegate is here. Dr. Prashant Kurde.
अरे बाबा बरं झालं।
Congratulations, Dr. Prashant.
अरे माझं संध्याकाळचं जेवण वाचलं बाबा।
Dr. Prashant, you are going to get a couple watch, one gents watch and one ladies watch.
सर्वांचं धन्यवाद।
Thank you so much.
अरे एक मिनिट आपण वंदे मातरम तेवढं करून जाऊया तेवढं फक्त प्लीज सर्वांना हात जोडून विनंती आहे तिथेच थांबा जागेवरती एक मिनिट फक्त वंदे मातरम आपल्या देशाला
वंदे मातरम घेऊया
आज ज्या देशामुळे ज्या लोकशाहीच्या ह्याच्यामुळे आपण एकत्र आहोत प्लीज एक वंदे मातरम चालू करा प्लीज शांत फोटो सब लोग आ जाओ
वंदे मातरम सुजलां सुफला मलयज शीतला सस्य श्यामला कुसुमित द्रुमदल शोभिनी सुहासिनी सुमधुर भाषिणी सुखदां वरदां मातरं वन्दे मातरं वन्दे मातरं।
सर 14 आपले गोल्ड कॉइन्स होते ते प्रत्येकाला आपण जे गिफ्ट्स दिलेले आहे त्यांना ते भेटणार। आपण आताच ज्यांना लकी ड्रॉ नाही भेटला आहे त्यांचे अशोर्ड डेलिगेट्स गिफ्ट फर्स्ट फ्लोर वरून तुम्ही कलेक्ट करू शकता। ज्यांना लकी ड्रॉ लागलेला आहे त्या लोकांनी थांबायचं आहे कारण की त्यांना आपण स्टेजवर बोलून लकी ड्रॉ देणार आहोत। ठीक आहे
लकी ड्रॉ ज्यांना लागलेला आहे त्यांना विनंती आहे 2 मिनिटं फक्त थांबा स्टेजवरती या तर टेक ओव्हर करून जावा। खाली आपला एक थर्मास आणि आपली सुंदरशी बॅग आपली वाट बघते। मित्रांनो काही आजच्या कार्यक्रमामध्ये जर काय आमची भूल चूक झाली असेल तर विनम्रतेने सगळ्यांचं क्षमस्व मागतो। मी कॉन्फरन्स चेअरमन डॉक्टर प्रसाद पवार तुमच्या सर्वांची मनपूर्वक आभार मानतो। असंच प्रेम भरभरून द्या लकी ड्रॉ वाले प्लीज मॅडम।
तर आपण आता ज्यांना लकी ड्रॉ भेटले त्यांना पटकन बोलूया। पहिल्या स्पीकर टायमाला गोल्ड कॉइन भेटलाय डॉक्टर अनिता एस मॅम। डॉक्टर अनिता एस मॅम डेलिगेट रजिस्ट्रेशन नंबर 291। ओके नेक्स्ट डॉक्टर ए चौधरी अब्दुल चौधरी यांना भेटले आहे रिस्ट वॉच। ओके आता ना फक्त गोल्ड कॉइनचे जे विनर्स आहेत ते इकडे डायस वरती या। एक सेकंड Dr. Anita S. ma'am, Dr. Mangla ma'am, Dr. Niketan Zorpe, Dr. Rajendra Khatavkar, Dr. Pradyot Chavan, Dr. Srirang Kumbar, Dr. Anil Jain. हे लोक फर्स्ट इकडे साईडला डायस वरती या आणि बाकी पण लोकांची मी लिस्ट सांगणार आहे. एक सेकंड मी आतापर्यंत फक्त 7 लेक्चर्सची लिस्ट सांगितली आहे, अजून 7 लेक्चर्सची सांगणार आहे मी.
चलो ए गोल्ड कॉइन
डॉक्टर अनिता एस. एक आपण करूया म्हणजे चांगल्यापैकी फोटो पण येईल. डॉक्टर अनिता एस, काइंडली कम फॉरवर्ड. विनर ऑफ फर्स्ट लकी ड्रॉ गोल्ड कॉइन फर्स्ट लेक्चर. अनिता एस मॅम, काइंडली कम अहेड. Winner of the second gold coin, Dr. Bangla ma'am, 445. Kindly come ahead. Second gold coin. Winner of the third gold coin, Dr. Niketan Zorpe sir. Kindly come ahead. Congratulations sir. आता बोलताना पण फोटो काढा. डॉक्टर राजेंद्र खटावकर सर. डॉक्टर राजेंद्र खटावकर सर. जय निमा. नेक्स्ट गोल्ड कॉइन विनर. Next gold coin winner, Dr. Pradyot Chavan. Kindly come forward. Next gold coin winner, Dr. Srirang Kumbar. Dr. Srirang Kumbar.
नमस्कार आणि हार्दिक स्वागत. वैद्यकीय
नेक्स्ट गोल्ड कॉइन विनर डॉक्टर अनिल जैन
आज एका व्यासपीठावर एकत्र आले आहेत. निमा मुंबईच्या या ऐतिहासिक अधिवेशनात आपले मनपूर्वक स्वागत करताना आम्हाला अत्यंत अभिमान वाटतो. नॅशनल इंटिग्रेटेड मेडिकल असोसिएशन निमा याची सुरुवात झाली 1948 मध्ये.
नेक्स्ट गोल्ड कॉइन विनर डॉक्टर राजस्विनी खटावकर मॅम. काइंडली कम फॉरवर्ड डॉक्टर राजस्विनी खटावकर मॅम. अदरवाइज यू विल नॉट गेट द गोल्ड कॉइन.
राष्ट्रसेवेचा संकल्प. पुढील दशकात विविध राज्यात बॉम्बे, मैसूर, मद्रास. 1967 मध्ये सर्व संघटनांना एकत्र आणण्याचा ऐतिहासिक निर्णय झाला.
ओके, नेक्स्ट इज डॉक्टर शालिनी मिश्रा.
निमाचे संविधान स्वीकार.
शालिनी मिश्रा. नेक्स्ट इज डॉक्टर नीता वाघमारे.
जनरल काउन्सिल मध्ये
डॉक्टर शालिनी मिश्रा
अध्यक्ष आणि डॉक्टर KS पोटदार हे जनरल सेक्रेटरी झाले. 1991
डॉक्टर नीता वाघमारे.
निमाची अधिकृत नोंदणी झाली. निमा ही संस्था बनली. संस्थात्मक शिक्षण घेतलेल्या आयुष पदवीधरांची BAMS, BUMS सिद्ध, ज्यांनी आधुनिक वैद्यकशास्त्रही अभ्यासले आहे.
नेक्स्ट इज डॉक्टर अर्चना गुराटे
आणि मुंबई दिल्ली नगरात कार्यरत आहे.
कॉंग्रॅच्युलेशन्स मॅम.
एकच डॉक्टरांचा सन्मान, अधिकारांचे रक्षण आणि सर्वसामान्यांना आरोग्य सेवा या वाटचालीत निमा सतत.
नेक्स्ट इज डॉक्टर अदिती राज मॅम. कॉंग्रॅच्युलेशन्स मॅम.
BAMS डॉक्टरांच्या प्रिस्क्रिप्शनला नकार दिल्याने आंदोलन केली. 2014 मध्ये पंजाब मेडिकल काउन्सिलनं डॉक्टरांवर कारवाई केली.
नेक्स्ट इज डॉक्टर
ठाम उभी राहिली.
Zahid Khot.
आयुष डॉक्टर
Congratulations
म्हणण्यास
for the gold coin.
कारण त्यांना फार्माकॉलॉजी, शस्त्रक्रिया, भूलशास्त्र यांचे शिक्षण मिळते.
Okay, next gold coin is Dr. Rajni Jadhav ma'am. Kindly come forward, ma'am. Where are you?
IMA च्या आक्षेपांवर कायदेशीर नोटीस पाठवली.
Gold coin जाणार हा.
2020 मध्ये BAMS आणि
टाळ्या थोड्या वाजवा. Okay, now we are going to distribute regarding the wristwatch. Yeah. First winner is Dr. Abdul Chaudhary.
विद्यार्थ्यांवरील अन्यायकारक परीक्षेच्या मर्यादांविरोधात संघर्ष केला. महाराष्ट्रात आज 200हून अधिक शाखा कार्यरत आहेत. अमरावतीचा निमाथॉन आरोग्य मॅरेथॉन, बुलढाण्याचे हेल्थ कॅम्प, कोपरगावचे CME कार्यक्रम आणि मुंबईतील म्युच्युअल बेनिफिट स्कीम व विद्यार्थी संघटना या सर्वांमुळे निमा महाराष्ट्र आणखी मजबूत होत आहे. आणि आज आपण मुंबई शाखेच्या त्या थोर संस्थापक सदस्यांना आदरपूर्वक स्मरतो. डॉक्टर SP
Okay, the next is
डॉक्टर SI नागराल,
next is Dr. Saili Pahurkar.
डॉक्टर उषाबेन पारेख,
Dr. Saili Pahurkar, Dr. Faruqi. Come.
48 ते 2
Come, आइए. Dr. Saili and Dr. Faruqi kindly come ahead.
आणि सेवाभावाची.
Yes. Congratulations.
एकच सत्य सांगते की प्रत्येक BAMS,
Dr. Faruqi
आणि आयुष डॉक्टराला सन्मान, मान्यता आणि रुग्णसेवेचा अधिकार मिळालाच पाहिजे.
The next is
वैद्यकाची वाटचाल, सेवाभाव हाच श्वास.
Dr. Kishan Kapse.
मिळालेली
Kindly come ahead.
आपल्या सर्वांच्या कार्याला
Dr. Anup Sharma.
हीच आशा व्यक्त
Dr. Dastagir Chaudhary. Do we have?
धन्यवाद.
आपका नाम?
जय हिंद, जय महाराष्ट्र.
अमित चौधरी. Do we have Dr. Anup Sharma? Do we have Kishan Kapse? Okay. Dr. Shahid Khan. Shaheen Khan. Yeah. Congratulations. Dr. Ravina Boir. Dr. Ravina Boir, kindly come forward. Dr. Preetam Saugure, kindly come forward. Dr. Pradnya Samant, kindly be ready. Dr. Pradnya Samant, kindly come forward. Dr. Shraddha Mane, kindly be ready. Dr. Shraddha Mane, kindly come forward. Dr. Santosh Barsad, kindly be ready. Dr. Santosh. Dr. Santosh, kindly come forward. Dr. Sachit Golab, kindly be ready. And Dr. Saili, kindly be ready. Dr. Sachit, नहीं लिखा है उसमें, नहीं लिखा है डियर, एक सेकंड ना. Dr. Saili. Dr. Saili. Okay, now moving ahead to the earbuds. Dr. Avinash Tiwari, kindly come forward. Dr. Avinash Tiwari. Dr. Okay, Dr. Avinash Tiwari, Dr. Salman Faruqi, Dr. Afroz, Dr. Vijay Shinde, kindly come on the dais. Dr. Salman, Dr. Afroz, kindly come forward. Dr. Afroz, yes. Next is Dr. Raghunath Dangi sir. नहीं. Dr. Jambelkar sir, kindly come forward. Dr. Praveen, kindly come forward. Dr. Busav Raj, delegate registration number 112. Come. Dr. Chirag Shah, kindly come forward. Dr. Sunanda Patil, kindly be ready. Dr. Sunanda Patil, kindly come forward. This ma'am was the ex-secretary of Doctor Associations of Worli. Kindly give a big round of applause. And the next winner is actually me only. So thank you to me. Okay, Dr. Nasuruddin, Dr. Anjali Chavan, Dr. Vijay Thorat, Dr. Anjali Chavan, Dr. Nasuruddin, kindly come forward. Dr. Vijay Thorat.
Sachin.
Hello. Now,
Sachin.
Our main anchor and organizing secretary, Dr. Prajakta Patil.
Sachin.
Earphone. She got earphone. Big. Clap. Earphone.
Chin. कसं करू सांग मला आता. हा अनिल हा मध्ये उभा आहे, हलत पण नाही. काय माहित हा हे तर हा कुठे आहे आपला रशीद. अरे ते लॉगआउट करायचं होतं ना. कोण आहे तो गाडा कुठे लॉगआउट करायचं झालं तर.
सर्व कमिटी मेंबर लवकरात लवकर स्टेजवर यावे. एक फोटो सेशनचा कार्यक्रम होणार आहे. भगवान सर सर्व कमिटी मेंबर स्टेजवर या. एक फोटो सेशन करण्यात येईल.
अनिल
त्रिपाठी सर जल्दी आप ये फोटो सेशन लेते हैं कमेटी मेंबर का।
अरे हो पण ते तिथे चालू आहे ना, याला चालू आहे मग, म्हणून तर मी थांबलो अडकलो.
सब कमेटी मेंबर का फोटो सेशन होगा अभी,
सर्वांचे
जल्दी जाना नहीं, प्रेसिडेंट ने कहा है. पडते रे सर, लवकर उभे राहा फोटो सेशन साठी.